Then it's on. Push the button and you can talk into it.
Good morning, everyone. We're going to get started. Welcome to the March 12th Human Services Public Hearing. We have a lot of folks signed up and we're looking forward to hearing from you all. I'm going to turn it over at this point to my good co-chair for any opening remarks.
I will be very brief because 160 people signed up to testify. Excited to hear people speaking about all of the many important bills we have here today. Thank you, Madam Chair.
Thank you. And our distinguished ranking member, Senator Seminar.
Good morning, everybody. What a docket we have today. So with some great bills and also looking very much forward to hearing the public. So let's get started.
Great, thank you. And without further ado, we'll invite up Commissioner Andrea Barton-Reeves and her team from the Department of Social Services.
Good morning. Good morning, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. I am Andrea Barton-Reeves, and I am the Commissioner of the Department of Social Services. I am pleased to appear before you today to offer testimony on several of the bills on today's agenda. I'll start with Senate Bill 307, an act concerning Medicaid coverage of biomarker testing. This bill would require the Department of Social Services to provide Medicaid coverage for biomarker testing for the purposes of diagnosis, treatment, and appropriate management or ongoing monitoring of an enrollee's disease or condition. This testing includes but is not limited to single analyte testing, multiplex panels, and whole genome sequencing. We currently cover biomarker testing under Medicaid. In addition, biomarkers that are not explicitly covered can actually be approved and reimbursed on a case-by-case basis when such services are actually deemed medically necessary for an individual in accordance with the statutory definition of medical necessity under our Medicaid program in Section 17B 259B of the Connecticut General Statutes. Prior authorization is in fact required for biomarker testing, and we maintain these established policies, including specific criteria that is used for providers when they're requesting that kind of coverage, which also includes prior authorization. The prior authorization is important so that we can ensure and continue the validity of the clinical utility of the service being requested so that it meets each person's individual clinical needs and conditions. So although the department does welcome continued conversation on this topic, there would in fact be a significant fiscal impact to develop, implement, and oversee a process for prior authorization acceptance that do not currently exist and is not funded in the governor's recommended budget. Next, I'll offer testimony on Senate Bill 308, which is an act implementing task force recommendations for wheelchair repair. We strongly value the importance of Medicaid members receiving timely and high quality, what we call complex rehabilitation technology, wheelchairs and repairs. We actually do already cover wheelchair repairs to CRT, to cover repairs to CRT wheelchairs under Medicaid, but there are certain constraints that are necessary to comply with federal law, to ensure members receive clinically appropriate CRT that they need, and to ensure that the program's limited resources are provided for medically necessary. That means that we have prior authorization that is consistent with our federal Medicaid requirement under the Medicaid statutes, and that is required under the statute. And that statute also requires that a prescription be issued for all repairs, including CRT wheelchair repairs that require prior authorization. Just so we know that in calendar year 22, and in reference in our report submitted on October 4th, 2023 and October 18th, 2023 to the Wheelchair Task Force, that prior authorization was really only required for 11% of CRT wheelchair repairs. We require prior authorization only for wheelchairs whose components cost more than $1,000 or where those components need to be manually priced. Prior authorizations are processed by our Medical Administrative Services Organization, an ASO, Community Health Network of Connecticut, and that takes about 6 days for the wheelchair prior authorization to be approved, and we will expedite any requests that are submitted as urgent. While the bill proposes several recommendations related to PRT that include requiring us to adopt regulations, establishing standards for CRT, changing prescriptions for prior authorizations and repairs for CRT wheelchairs, expanding Medicaid coverage to cover annual maintenance and establishing penalties, and we appreciate the intent of 308. The bill does broaden our scope beyond the administration of the program to include not only the regulation of customized wheelchair providers, but the development of regulations in conjunction with the Department of Aging and Disability Services to impose penalties. Right now, we see our role as the administrators of the program and the payor, and do not see our scope beyond that role, capacity, or expertise. And it's not right now within our funding or staffing to regulate customized wheelchairs beyond the scope of covering customized wheelchairs under Medicaid. The bill also includes specific provisions that are very detailed for inclusion in a statute and will also result in significant increased costs and administrative burden, which is not really the focus here. The focus here is that the increased costs are not part of the governor's budget. We respectfully ask for the flexibility to implement and update prior authorization requirements, which may include reducing or removing those what we call PA thresholds, depending on relevant data. And that can also be focused on standards of care, common clinical practice, and other pertinent information that DSS regularly reviews. Finally, this bill proposes to expand coverage of CRT to annual maintenance and repairs for backup equipment. We currently do not reimburse for such services, and we anticipate that the expansion of the service will result in significant costs. The annual maintenance, based on our estimates, will cost about an additional $4.5 million, $2.2 million in state share in FY 2025, and $1.8 million, and with $9.9 million in state share also in FY 2025. These costs are not budgeted in the governor's budget as it stands. So it's for these reasons that we're unable to support the bill at this time. Moving on to House Bill 5374, an act concerning annual inflationary rate adjustments for nonprofit human services providers. This bill would require DSS to annually increase Medicaid rates for nonprofit human service providers by the increase in the Consumer Price Index for all urban consumers in the Northeast region. While we appreciate the underlying intent of this bill to promote access to services, it does conflict with other initiatives, and it will result in significant state costs that are not included in the governor's budget. But pursuant to Public Act 23-186, we are in the process of conducting a comprehensive rate study. We recently finished our first phase, and phase 2 is underway. And the purpose of that study is to enable us to engage in a comprehensive analysis of all rates of the Medicaid program, which can then allow us to inform coordinated decisions regarding potential investments of the state's limited resources. So at this time, we are unable to support this bill. Senate Bill 367, an act concerning a study to maximize Medicaid reimbursement for UConn Health. This bill calls for an establishment of a task force in which DSS will participate to study ways to maximize Medicaid reimbursement for the University of Connecticut Health Center, with a report due by January of 2025. UConn Health is actually already working with a consulting firm to evaluate its operations, including exploring potential opportunities to maximize available Medicaid revenue. So depending on when that study will be done, there will be an opportunity to review those efforts. From our perspective as an agency, we would like to not replicate those efforts or interfere with them in any way. So we're respectfully asking if we could postpone any involvement that we might have as the Medicaid agency until that study is complete. Senate Bill 8, an act concerning drug affordability. This bill requires DSS to consult with the Office of Health Strategy on a variety of issues, including Canadian drug prescription importation programs, and it adds DSS to a newly created Prescription Drug Affordability Stakeholder Council. And while it's not entirely clear from the bill's language, it also seems as if DSS would be required to implement the Canadian drug import program, under the state's, thank you. Under the state's Medicaid program and CHIP, our Children's Health Insurance Program. And Section 2 would also require OHS in consultation with DSS and the Department of Public Health and Consumer Protection to provide for the importation of prescription drugs for Canada. So to the extent that this bill does apply to what we call CMAP, which is the Connecticut Medical Assistance Program, we are concerned that the bill as written does not provide for enough time or opportunity to study the impact of this importation before any statutory adoption, and it may have some significant unintended consequences. In short, or in sum, federal Medicaid rules require that drug manufacturers participate in the Medicaid prescription drug rebate program. And so that means that states reduce costs by invoicing for and collecting rebate dollars for eligible drugs. There are also other federal rules, such as being FDA approved, that also complicate the analysis. So at this time, absent a full analysis and study, we're unable to project the actual impact of the bill, and we are concerned that some of these provisions as adopted before a full analysis might potentially be problematic and may increase costs to the state. And we do have similar concerns regarding sections 3 and 4 as well. So at this time, we would ask that there be an opportunity to more fully explore what those challenges might be before we actually fully adopt this particular bill. So moving to House Bill 5456, an act concerning federally qualified health centers. DSS values the important work of the state's federally qualified health centers. They provide primary care, behavioral health, and dental services to many Connecticut residents, regardless of their income, and especially for many of our Medicaid and Children's Health Insurance, our CHIP members. So in addition to the standard categories of payment, FQHCs were in fact awarded one-time funding last year of $32 million in this fiscal year in support of the excellent care that they provide to Medicaid members. And we are still working with FQHCs to find ways to improve the quality of services provided to Medicaid and CHIP members to ensure the quality of the services that they need. As for context, FQHCs do have unique rights under federal Medicaid law, and those rights include having their rates initially set based on documented costs. Those rates are required to be adjusted every year based on a specific measure of inflation, and they have the ability to request an adjustment to their rates in a change in scope. For illustration purposes, beginning in federal fiscal year 2010, we have provided in our testimony a table that represents the impact of MEI increases and amounts paid due to MEI increases, which began with the 2001 rate year in accordance with federal regulations. And those charts are there. I can't really testify to the charts, but you do have them in your testimony. But given the current payment process, implementing the proposed changes in the bill would dramatically increase the funding requirements, which are currently unfunded and would have a significant impact to the Medicaid budget. Section 1 of the bill would repeal subsection B of section 17B 245B of the general statutes, which states that FQHCs may not provide non-medical periodic dental services on different dates of services for the purposes of billing on separate encounters absent medical emergency. Such prohibitions on unbundling of certain non-emergency periodic dental services by FQHCs are established in a number of other states, including California, Florida, Oregon, New York, and Pennsylvania. So repealing this section would also increase the Medicaid cost by $2.7 million annually, which is not enacted in the governor's budget. So while the department supports the general concept of making adjustments to encounter rates, also known as rebasing, the approach called for here poses a number of challenges. So I skipped that. Have now moved to section 2. I apologize for that. I just kept reading. So I'm now moving to section 2 of the bill. So accordingly, we cannot support actually section 1 for MEI. Section 2 of the bill proposes significant changes to section 17B to 45D of the general statutes, which requires regarding adjustments to FQHC encounter rates. So I'll say again, while we support the general concept of making exceptions to encounter rates, which is also known as rebasing, the approach called for under the bill does pose a number of challenges to implementing a rate change process that would align with federal law and the state's desire to develop a planful rate setting process. First, section 2B calls for rebasing encounter rates based on each of the FQHC's 2023 costs, provided that no rates are decreased. Rebasing using 2023 cost reports is infeasible for two reasons. First, the 2023 cost reports have not yet been filed, and second, they have to be audited as well. And filing and auditing cannot be completed within the time frame that's proposed in this bill. We are required to ensure the validity of the costs used in any rebasing for federal claiming purposes. So relying on the yet to be audited reports for rebasing would in fact jeopardize the state's ability to claim federal matching funds. The department does support the general concept of rebasing in the context of an alternative payment methodology as recognized under federal law. An APM model, as we call it, is used by many other states, and that would allow for the use of a facility's Medicare costs reports to capture data. In contrast to the 2023 cost reports referenced earlier, the Medicaid cost reports are fully audited and vetted by CMS, and they would be, we believe, less burdensome on the FQHC since the facilities already provide this report to the federal government. As written, the rebase would increase the medical costs, the Medicaid costs by approximately $133.8 million, which is about $67 million in state share. So that funding is not included in the enacted budget, nor the governor's proposed budget adjustments. Instead, we strongly recommend that it be permitted to complete phase 2 of the rate study, the department that is, which would include a full review of FQHC reimbursement as part of a holistic approach to Medicaid reimbursement. Second, the bill would, Section 2C in particular, would in part eliminate Section 17B 245D current requirement that FQHCs timely notify DSS of changes in scope or project approvals by the Federal Health Resources and Services Administration, which is commonly known as HRSA, by repealing subsections B through E of the current statute. The reason that we have this in place is so that we can avoid unpredictable and large requests for rate adjustments for changes in scope that may have occurred many years prior, potentially totaling over $100 million annually based on recent requests. These would be in addition to the requests already included in the annual MEI. This section would also prohibit DSS from considering several important factors in evaluating changes in scope requests that are important in evaluating the context of a requested change in scope. It would also increase Medicaid costs by making it very challenging to adjust requests that are currently modified based on these and other relevant factors. For these reasons, we do oppose Section 2 of the bill, but I would like to repeat that we continue to want to have what we hope will be more constructive and longer dialogue with the FQHCs as to how we can change encounter rates and have more conversation about how rates can be adjusted. Right. So let me go to my last section. I know I've been talking a lot. I feel like I've been talking a lot, so I'm moving. Well, regarding Section 3, I hadn't really mentioned that very much. We were not going to talk very specifically about that. I will actually leave that to my written testimony because it is long and rather complicated. So I won't spend any more time on that. Really, what I'd like to say about this is that we really would like to suggest and recommend that any broad discussion about rates happen. Okay. Yes. It's all right. Okay. I needed a little break. Thank you. So, okay. So what we would like to do is this. We'd like to continue to have what we think is the start of a very productive dialogue with our FQHC partners. And in parallel to that, we'd also like to continue our work in phase 2 of the study so that we can ensure that the analysis that we have aligns with the needs of our FQHC partners and also allows us to do a more thorough and comprehensive study to look at the status of rates across the entire Medicaid program. And also perhaps, as we did in phase 1, do comparisons of rates in other states and come back with a planful approach to rate adjustments, not only for FQHC partners, but for others that will be studied in the phase 2 of the study as well. So moving on to House Bill 5459, an act increasing rates for Medicaid reimbursement for certain providers. In administering Medicaid and the CHIP program, we do care deeply about finding ways to ensure our members have access to the very best care. It's for this reason that we are proud to be working on the rate study that was required under Public Act 23-186 so that we can look at rates comprehensively across the entire program. And while we do appreciate the overall intent of this bill to provide resources to providers within Medicaid and CHIP, The approach to the bill is troubling for us. Specifically, as written, it is in conflict with the coordinated program-wide approach that DSS supports through the rate study and continues the ad hoc process by selecting specific provider types for increases without coordinating the level of rates currently paid to providers and the increases these providers may already have been receiving. Specifically, we know that the rate study was one that was leading us as a state away from that approach. So the bill would actually limit the department's necessary flexibility to be able to adjust rates on a careful, analyzed basis for each rate and access to services. So we cannot support Section 2 of the bill, which would increase the per diem rate for chronic disease hospitals by $200. Instead, we suggest using the pending results of Phase 2, again, of the rate study as an opportunity to develop more holistic recommendations regarding reimbursement for chronic disease hospitals. Moving to Section 4 of this bill, Section 4 of this bill would, within available appropriations, increase the underlying birth-to-3 reimbursement rate from $120 to $169 per hour. So increasing this rate from $120 to $169 per hour would increase the Medicaid costs by approximately $9.3 million annually, and that would be $4.7 million in the state share. So rather than specify a specific figure, we would need to conduct an analysis in coordination and on the basis of existing analysis of birth-to-3 rates recently conducted by the Office of Early Childhood. After that analysis is complete, we would be able to provide some direction regarding a potential adjustments, though in the absence of funding right now, that increase could not be supported. Section 6 and 7 of the bill would require separate rate increases and a separate rate study specific to medical equipment devices, supplies, orthotics, prosthetics, and podiatrists based on particular criteria listed in the bill. Instead, as referenced above, DSS will be analyzing these rates in context of the Phase 2 of the rate study. Finally, Section 8 would require DSS to develop studies and procedures for electronic consultations, commonly known as e-consult, and amend the Medicaid state plan as if necessary. We do support the concept of the positive impact of e-consults on Medicaid and CHIP members. We did previously cover them until we were directed by CMS to no longer do so. But based on new and more recent CMS guidance, we are actively exploring the feasibility of resuming coverage under e-consults. And I will take just a small moment of privilege here to say that our FQHC partners did give us quite, I would describe it as a very thorough and complete review of the value of e-consults, and we are in alignment with them that e-consults really do bring great value to the array of services that Medicaid and CHIP members will get. So as a result of this bill, we believe a lot of the work is already underway, and we would require and request the flexibility to implement these policy changes administratively based on specific federal improvement requirements and the latest clinical recommendations. Finally, offering some remarks on House Bill 5455, an act concerning the efficiency of the Department of Social Services in determining eligibility for medical assistance and responding to requests for information or assistance. This bill would require the department to study its efficiency in making eligibility determinations for medical assistance and responding to telephonic requests for information and assistance. We do constantly monitor and evaluate efficiencies in these two operational areas, and we already report this information publicly. So therefore, we respectfully believe that this bill is unnecessary. With regards to the proposals to produce a report on 3 metrics to the Human Services Committee, the department respectfully notes that we routinely produce this information publicly and for public consumption through state and federal websites, as well as to bodies such as the Medical Assistance Program Oversight Council, commonly known as MAPOC. We also routinely exceed federal benchmarks in timely medical eligibility processing, and we publish and share this information publicly. We do carefully watch these and other critical operation performance metrics, and we are constantly evaluating new technologies, processes, and opportunities for improvement. This work is already routinely performed, and the data that has been proposed to be collected is already collected and is widely available. And there are already existing avenues in which the department regularly updates it already provides regular updates on operational performance, such as MAPOC, and the department does not believe that this bill is necessary. And the final thing that I will say on Bill 5455 is I do have my Deputy Commissioner, Isha Canada, here today, who runs all of our eligibility operations. She also was the person who was responsible for data and creating essentially our data platform for the state of Connecticut before she left to go to the private sector, and she's agreed to come back to the public sector, and that is the work that she's doing. So I don't believe that there probably are other people that could do the work, but she's outstanding, and she's specifically, it's 4 bills like 5455 that I asked her to rejoin state service specifically with this agency. She will be able to answer any very specific questions you have about data, but that does finish what I have to say today about all of these bills. So thank you.
Thank you, Commissioner.
Thank you.
Thank you for being here and for your testimony.
Sure.
I'll start with some questions. I'm gonna begin with House Bill 5456, an act concerning the federally qualified health centers.
Certainly.
And wanted to speak about what I believe is Section 2, but the timelines for the scope of service review.
Yeah.
If moving forward, the bill were limited to that provision, what is the department's stance on that? What we heard from folks,
Mm.
what we're hearing from folks and will likely hear today, is that when they appeal, it can take a year, year and a half, 2 years before they get that response.
Okay.
Then they submit a response and then again can take another year. Someone described 2016 all the way to, I believe it was 2022. So just wondering, what would it take to be able to speed up that process?
Yeah. Thank you for your question. I am not familiar with our timelines running into years. They do run into months, and that part is true. We do have a limited number of staff who have the educational background and the subject matter expertise in order to review the changes in scope. So that is part of our limitation. I would be happy to get more specifics around the specific case that you raised, or if there are others, so that I can dig into those more deeply. Certainly, it is up to the legislature to determine whether or not a timeline should be set. I would say that if that timeline is set, that we would need more resources to meet that timeline. We certainly could not do that with the current resources that we have. And it does take quite a bit of time to review the changes in scope. I am very much aware of the frustrations that our FQHC partners have around the changes in scope. They've been very open and very vocal, and I have heard those, and we're trying to do our best to be responsive to that. I will also say that I recognize that there is quite a bit of history. As you'd mentioned, it goes back to 2016 regarding the frustrations and the concerns around how long it takes to engage in a change of scope. We are sensitive to that. And I would say that the staff that we have now are really doing the best that they can to review those as quickly as they can and to turn them around within a reasonable period of time, knowing that a decision is important. And an opportunity to be able to act on that decision is also important. So as I said, that would pretty much be my response. I would also say that we cannot underestimate the complexity of determining a change in scope. The number of people that we have to do that, as I mentioned before, is quite small. It does require subject matter expertise. And they do want to make the most reasoned and fair decisions that they can. We do know that there is improvement to be made in that area, so we are working as hard as we can to do that. Nicole Godburn, who runs our Certificate of Need program and also is responsible for reviewing changes of scope, is here today to answer any questions you have. But that would be my response.
Great, thank you. Would love to continue those conversations.
Certainly.
The other piece in that same bill, with regards to the Medicare Economic Index, and how that is adjusted annually,
Yes.
just want to understand that process a little better. When does the federal government come out with the annual adjustment to the economic index?
They do come out in October of each year.
And so then is Connecticut's current practice to apply that the following October to the FQHCs?
So I'm hesitating to answer the question because I want to answer correctly. I actually may ask my Medicaid director to come if you don't mind, because there may be more details behind that I don't know. So Guy, do you see my, you have Nicole, okay.
Good morning. I'm Nicole Godburn, Director of Reimbursement and Certificate of Need for the department. So just to back up a step, the MEI, the index is issued by the federal government at the start of a calendar year. What states do, according to BIPA, the federal requirement that states are required to follow when establishing FQHC rates under the encounter, rates were established based off the 1999-2000 cost reports in accordance with federal law. States at that point then began applying the MEI, and states applied the MEI in a variety of ways. Some states selected to start it at the start of the federal fiscal year. Some states applied at the start of a calendar year. Some states applied at the start of their state fiscal years. And then the states just carried that forward in accordance with their state plans, in accordance with the pattern that they had selected when they started the PPS system. We in Connecticut, years ago, back when I was an undergrad, we applied it at the start of the federal fiscal year and have just been following that cadence forward.
Okay, thank you. And then back to the question. So by starting it though, by Connecticut starting at the federal year, we are doing it like a whole year later when we finally apply it.
No, rates are issued every 10/1 at the start of the federal fiscal year for FQHCs. So at the start of the federal fiscal year, the FQHCs are issued their new rates for the federal fiscal year.
But is it based on the year's prior's MEI?
It's based off of the calendar year MEI that came out in that January, so the January of that calendar year
Okay,
to the October, which would be the start of the federal fiscal year, is when the
Okay.
rate is updated.
okay, thank you. And in the testimony, which I'm trying to remember what you said, looking at it, in the testimony, you said it would be a fiscal issue.
That's right.
But the proposal, I believe, before us would do an initial cost to adjust it if we were to move the date, and then there wouldn't be a fiscal impact after that first initial year when we change it, correct? Or would there be ongoing?
There would be, I'm sorry, Nicole, go ahead. Yeah, please go ahead. Yeah.
Yes, correct. So there is an initial cost that is unbudgeted to make the adjustments, but then the way that the federal requirements work around the encounter rate is that the rate can never decrease or adjust downward. So that cost would then be built in going forward for every year after.
And that's not currently the case?
Currently, it's accounted for in, I don't want to speak for our fiscal division, but they account for that adjustment when they're budgeting that line item. But it's budgeted based off of how we're applying the index today. So making that adjustment to the index going forward would require there to be an adjustment when our fiscal division is calculating the adjustments going forward. It has to be baked in every year after.
Okay. Okay, thank you. I might have more follow-up questions. All right, thank you. Shifting gears to, what number is this one? Senate Bill 307, the biomarker bill. Have been having some conversations, and it looks like there might be discussions over including language that would establish medical necessity. Would that change the department's position? Is medical necessity one of the key pieces that brings the opposition to this proposal?
So thank you for your question. I guess I'm hesitating because I don't know if we would describe it as opposition, right, I think that's what that's why being a lawyer just always just ruins your life. So I wouldn't really focus on opposition. I think our position here is that we already cover it. And so in order for us to maintain the appropriate policy and fiscal guardrails, we would like to continue to administer the coverage for biomarker testing in the way in which we have it. We're certainly open to continuing to analyze what medical necessity means, knowing that any expansion of the definition of medical necessity would mean an expansion of coverage, which obviously means an expansion in the amount of money that we would spend, which is not in the budget. Yeah.
Okay, thank you. Senator Lesser?
Yes, thank you, Madam Chair, and good to see you, Commissioner.
Same.
We missed you at our last hearing, but Deputy Commissioner Barnes did an
Yes.
excellent job.
I did see that. She did do an excellent job. Yes.
But it's good to see you.
Thank you.
So, just piggybacking on, just clarifying the question I heard from my co-chair a second ago about the biomarker bill. It did seem like the bulk of the concern, I don't want to say opposition from DSS, was about the medical necessity definition. And so if we were to move forward with your definition, does that resolve most of the, I mean, you may not think this is necessary, but would that resolve those outstanding issues?
It would expand the definition of medical necessity, which, as I mentioned before, Senator, would also expand the budgetary impact. And that's also, in our minds, understanding that we, as one of the largest agencies with respect to budget, have to balance those considerations. That is really what we're trying to do. I would say that we are open to determining what medical necessity is. We also find that our current definition of medical necessity does require, and it does encourage our providers to determine when biomarker testing really is an appropriate thing to ask for. We're not suggesting that providers ask for unnecessary tests, and they may have patients that come to them with significant concerns. They may have, patients with family histories that may raise concerns around, hereditary types of conditions that they may have, biomarkers for cancer and the like. But we find that the guardrails that we currently have really allow for the provider and the patient to have those kinds of conversations. And so expanding the definition of medical necessity in our view does take away some of that authority from the provider to be able to have those discussions and really determine from their perspective under what circumstances having the test would be appropriate.
And I'm sorry, I may have
I'm
been
sorry, maybe I didn't
inarticulate.
answer your
I was
question.
suggesting that we could amend the language that's before us to adopt the DSS language on medical necessity.
Oh,
That
I'm
would
so
be-
sorry.
yeah.
Yes, I did misunderstand you. I think that is a possibility, yes.
Okay, great. And then with regard to the wheelchair recommendations,
Yes.
it did seem to us that there was a precedent for this, that DSS currently regulates the marketplace, for example, with regard to nursing homes.
Mhm.
And I just wanted to make sure that, in fact, that my information was correct, that do you currently regulate nursing homes?
Well, we regulate, if we want to call it, regulate nursing homes only with respect to our role as a payor, right? The actual development of policies and procedures with respect to the quality of care is left to our partner, our sister agency, the Department of Public Health. We do have an acuity program that is in place right now that we've spoken of in prior testimony that does allow us to make adjustments for the quality of care and the acuity of care that a particular nursing home may provide. So in that respect, we do have some leeway in those regards, in that regard, but not necessarily, I think, to the extent that this bill might be calling for, which is actually imposing penalties. We do not have that authority under our current statutes and regulations when it comes to nursing homes.
And then with regard to the potential cost of expanding coverage for wheelchairs, do you see potential savings as well in terms of providing coverage for regular maintenance? If you're able to do preventative maintenance, in theory, that could reduce. I am not a wheelchair repair tech, so I'm speculating here, but do you understand? I didn't see any accounting for potential savings if we're able to increase preventative maintenance.
Yes, we have not engaged in that analysis, Senator, so I wouldn't be able to provide you those numbers with respect to any savings. But, I would imagine that any kind of preventative maintenance obviously would help to avoid a catastrophic repair. So you can imagine theoretically some savings could be realized under those circumstances. But we haven't done any fiscal analysis.
With regard to Senate Bill 8, it's a major priority of my caucus, and I know that, the Canadian drug importation piece is something where we looked to our sister state, to Florida. We don't usually copy their policies, but we'll make an exception potentially this time. Governor DeSantis is not on my speed dial, but
Understood.
things happen.
Yes.
But in the instance of Florida, are you okay, Representative? Okay. In the case of Florida, your sister agency there, I know, was interested and has moved forward and sought and actually received federal approval for
Yes.
bringing in Canadian prescription drugs as a way to lower costs for the Medicaid program there. And so I would hope that you could work with us and also potentially look to them to find ways to make it work, because they've certainly found value or seem to think that there's value there. So would ask that you work with us and potentially look to Florida if you haven't had conversations yet about how that could potentially
Right.
work.
Thank you. We will do that. We're also in pretty regular communication with Dr. Gifford at OHS around drug affordability. We find that that partnership actually works quite well. So I will circle back with her and have more discussion about how we can engage in a more robust and proactive conversation around drug affordability. I know it's at the top of her agenda.
Absolutely, and that's also why the bill directs her to take the lead on it, but we wanted to make sure that you were certainly in the room on that as the lead Medicaid
Yes.
agent, sole Medicaid
Yes.
agency.
She
not the
does
lead.
include us regularly, so yes, thank
And
you.
then just with regards, Representative Gilchrist asked a lot of questions about the FQHC bill. But just to clarify something that Ms. Godburn said earlier, is there a barrier to decoupling from the federal fiscal year to moving that a little bit earlier in the calendar? Is that just a fiscal issue or what? I mean, I know we can't do calendar year, but is there a way to do it earlier in the calendar to provide a little bit of relief?
So right now, the way that we currently have it structured, the primary barrier is fiscal. So we've had our budget, and I would also not speak for Secretary Beckham, but I do know that the way that we have had those payments structured is in alignment with the way that he's built our budget generally across the board for all state agencies. So there would be a significant, as we noted in our testimony, there would be a significant fiscal impact to making that adjustment.
And then with regard to the Medicaid rate study, the Medicaid bill, I don't know that we got it exactly right. I think we're looking to get out of the business of setting Medicaid rates and get the department, as the phase one analysis found, into the business of developing and implementing these rates internally. We just found a massive amount of need, and we're trying to figure out how to get there. So, you and I have had these discussions privately, publicly, everywhere. But we do need to move forward on Medicaid rates this year. This bill is an attempt to do that.
Yes.
We're trying to get the department back in the business of developing its own systems internally so that, the viability of the Medicaid program is not determined on who's able to hire a good lobbyist to persuade all of us,
Yes.
but really figuring out how we can empower the department to develop a rational basis. My fear, if we keep on having studies on top of studies, is that we'll never get there. And that meanwhile, we've got some real acute needs. We saw that in the analysis that's been done so far that really say that we are way behind our sister states already on the areas that we've studied, and know that there are other areas that we haven't studied yet that are probably the case as well. So I'm hoping you'll work with us on that, and I'm hoping our friends at the Office of Policy Management will particularly work with us on that, since
Yes.
this is a fiscal question.
Agreed.
And then the last thing is just the 5455. Glad to hear that it's a jobs program and you've been able to hire an additional person to work with bills like that. We'll work with you on that as well. And I think we'll hear from the proponent about that in a few minutes. Thank you so much,
Thank you.
Commissioner.
Great. Thank you, Senator. Senator Seminara.
Good morning. How are you today?
I'm doing well, Senator. How are you?
It's so good to see you and,
Thank you.
your whole team.
Yes.
My apologies for missing some of your testimony. So if this has been covered already, please excuse the repetition. I will go back later and see the whole thing. But I did want to ask you a question. As of right now, it isn't in the wheelchair bill currently.
Mhm.
And I do anticipate we'll be having further discussions about that bill and making some changes. But there's nothing in the bill right now about transportation. And you and I spoke about transportation.
Yeah.
So one of the issues in speeding up repairs was the idea that consumers would be able to get to the repair facilities. And it was discovered during the process of the task force that non-emergency medical transportation does not cover for those in wheelchairs to go to the facility to have their wheelchair repaired. And I wanted to get your pulse on that. I know you and I had a private discussion about it, but wanted to hear your feelings on that, and if you think that under certain circumstances that would be appropriate.
Thank you for the question. So our position is this, we always think it's appropriate to support Medicaid members in getting access to services and supports that they need. So that I don't think there's any argument there, and none of the amazing people that are sitting behind me that I work with, I think would argue that. There are always limitations around our fiscal ability to meet all of the needs, and that's part of the challenge that we have. And we can explore further what that impact might be. The other challenge is that with transporting those who use wheelchairs and their wheelchairs, those require specific types of vehicles in order to be able to do that. In part so that you don't cause more damage to the wheelchair itself, right, where you're going for regular maintenance and support, or if you're going for a repair. And also we want to make sure that the person who's being transported is also comfortable in that transport. And we know that that's part of the challenge. So we are certainly open to exploring further how and whether NEMT can be part of that solution. And if it can't be, if there are other solutions that might be feasible in order to provide better support and also to bring back what the fiscal impact might be.
Terrific. I'm so very happy to hear that. I again know the majority of wheelchair users are looking to have repairs done in their home, and I understand the necessity of that. But I also would love to explore that for those who do desire to go into the facility, that we be able to transport them. It was actually mind-boggling to me that we didn't do that already.
Yeah.
So I look forward to further conversation around that. Thank you so very much.
Sure.
Thank you, Senator. Representative Dathan.
Thank you very much, Madam Chair, and thank you, Commissioner, for being here and bringing your army of wonderful Medicaid experts today. We
Thank you.
appreciate it. Just really wanted to kind of follow up on the Senate Bill 308. I just had one question following the good senator's questions on the wheelchair. I noticed in your testimony, you said you were talking about the ASOs, and you said ASOs will expedite an authorization request that is submitted by the DME provider as urgent.
Yes.
What is determined to be urgent? Because I just want to get an understanding if wheelchair users actually know when they're submitting their request, if theirs is determined to be urgent.
Yeah. There aren't specific criteria, and I may ask my Medicaid director to join me, but there aren't specific criteria for urgency. It really does depend on the circumstance of the person in their wheelchair. So for example, if they were to come in and let's say that the wheelchair was at the point where it might be close to beyond repair, or the person very urgently needs to have it repaired that very same day and can't wait for the 6-day time period that it usually takes for prior authorization, that might be determined as urgent. If it is the only way in which a person can ambulate and they're living alone, for example, or they don't have any additional help or support, that might be determined as urgent. So we specifically don't define urgency as with specific criteria all the time, because we really want to be able to give the DME provider the flexibility to respond to that person's need.
So in theory, we could legislate that and determine either through this committee or regulation review, the criteria which could be determined as urgent to ensure that people get their wheelchairs fixed faster and it's not so subjective.
So, well, certainly, Representative, you could in fact legislate it, but I would recommend that we not do so. I would say that the flexibility that the DME provider and that our Medicaid members have to decide often together what that means seems to be working quite well. And I can tell you that this ASO that we have is really quite a responsive ASO. And if there's any question as to whether or not the need is actually urgent, we do have staff within our Division of Health Services, which is run by our Medicaid Director, Guy Woolston, that can act as a second set of ears and eyes to make that determination. I can tell you, always err on the side of making sure that the person has the access that they need at the time that they need it. So I'm not sure. Obviously, you have the power to legislate, but we wouldn't recommend that under these
Does
circumstances.
CMS have any requirements in regards to this?
I'm not necessarily sure if they do. I don't know. Do they be?
Phone a friend.
Yes.
Woolston, DSS, nice to see you. And the commissioner got everything completely right. The only thing I'll add before addressing your question, Representative, if it would be useful for you to see literally like the form that the DME providers submit or something like that, we can obviously happy to provide you with those details. To my knowledge, CMS does not have a definition of urgent in the context of wheelchair repairs.
Okay, thanks. One of the things I was thinking about when looking at the wheelchair legislation as well as when we talked about House Bill 5455, just in reporting for MAPOC, if we were to look at any of the MAPOC subcommittees to include maybe looking at these metrics to ensure responsiveness for our wheelchair repairs, is that a possibility? And in your opinion, which subcommittee would you want to keep that in?
I'm not sure which subcommittee I would keep it in. I would actually leave that to the MAPOC chairs to determine where I wouldn't presuppose to make that decision for them. We could certainly provide that information on a regular basis to MAPOC. We provide lots of information. And as I said before, with respect to 5455, we're very transparent and we would be happy to do that. And the final thing I'll say is that if there's a specific concern with respect to anyone getting access to getting their wheelchair repaired on an urgent basis, they feel that that's been improperly denied, that can be elevated immediately and we can address it right away.
Thank you very much. I just think it might be appropriate for us to look at. I'll speak to the MAPOC co-chairs on it, but I know we look at like transportation issues regularly, medically needed transport. This might
Yes.
be something else that we want to look at. I might be happy to include it in my subcommittee
Exactly, yeah.
as something that might be interesting.
Certainly.
So thank you very much on that. In terms of the one of the big concerns that I had in your responses for 5456 is, you know, we had this wonderful rate study that you all conducted last year, and thank you for all your hard work on that. The thing that really kind of got me concerned along, and I know it was highlighted several times, was behavioral health under where we were very behind the benchmark. And I'm concerned that we really haven't addressed that at all within the governor's budget. And I understand that the rate study kind of came out about the same time as the governor's budget. So that's probably why we aren't there. But one of the concerns I had is, you know, we're so behind in behavioral health. And, you know, Section 1 and Section 2 would really help us be able to deal with those, particularly with inpatient behavioral health. I know, you know, all over the state, and you would think, I come from Fairfield County, you would think in our neck of the woods, it would be something that there would be a lot of access to. And I know, for instance, in my district, I hear from Medicaid recipients who are not able to access behavioral health, you know, either within the school system if they're children or within the FQHCs and other areas. And I just have some concerns that we're not addressing that, particularly within patients. So, you know, I'm just going to reiterate my support for that. One of the questions I had, I think my last one really is around the discussion that we were having about MEI in House Bill 5456. And I know, again, we're kind of talking about the rate study as part of that. I wanted to get an understanding, because there was such a big fiscal note in, I think it was section 2 of the bill. How are other states managing that in terms of MEI? And are they in that same sort of realm, or is this an issue that FQHCs around the country are facing?
So I'll answer that question anecdotally, and I'll be able to get you some more information more specifically. Some states follow the pattern that we do, and other states issue their MEI on October 1. As Nicole Godburn had testified earlier, our state has established the pattern of issuing the MEI when it does, and the ability to shift that would mean that we'd have to make a substantial fiscal investment in order to make that happen. But as far as I know, as I sit here right now, and again, I can get you more details, we are not alone in the way in which we do it, but it would take some adjustment in order to move it to the timeline that is outlined in the proposed bill.
Okay, that's very helpful. I'm looking forward to kind of carrying on that discussion, because we do know that there's access issues and we need to address that. And I think the best way to address that is through improving our rates, which I understand has a major fiscal impact to our budget, but would like to continue to explore. Thank you so much. And thank you, Madam Chair.
Thank you, Representative. I don't see any other hands. Thank you so much, Commissioner, for your
Thank
time
you.
today and to your team. Next, we will hear from President Pro Tem Martin Looney. Just need to push the button. Thank you.
There we go. Thank you so much, Madam Chair, and Senator Lesser and Representative Gilchrist and distinguished members of the Human Services Committee. My name is Martin Looney, Senator from the 11th District, representing parts of New Haven and Hamden. Here today to testify before you on one of our Senate priority bills for this session, Senate Bill 8, an act concerning drug affordability, which tackles an issue which is familiar to altogether too many families in Connecticut, and that is the cost and availability of prescription drugs. At a 2022 study by Healthcare Value Hub found that 28% of respondents who earn less than $50,000 a year with household income of less than $50,000 had rationed medication in the past year due to cost. That's not something that should be happening in the state of Connecticut, and it is a hardship and a threat to public health. And that Connecticut has the fourth highest estimated per capita expenditures on prescription drugs, costing the average person about $1,788 in 2020. Now, Senate Bill 8 builds on a number of pieces of legislation from previous sessions, including capping the outpatient cost of insulin at $25, allowing pharmacists to prescribe birth control, authorizing the Array RX drug discount program, prohibiting pharmacy benefit managers from imposing gag orders on pharmacists when in some cases putting their prescription costs through their policy would involve paying a higher copay than the low-cost generic might have been if the person had paid cash. So Senate Bill 8 establishes four major prongs here. First, establishes a prescription drug advisory board reporting to the Office of Health Strategy that's empowered to explore and understand all aspects of the prescription drug ecosystem. And secondly, building on the out-of-pocket cap we recently passed, Senate Bill 8 would add a provision that requires certain insurers to offer the lowest cost insulin available as part of their plans. As more and more high-quality generics come on the market, pharmacy benefit managers are increasingly turning to convoluted rebate programs and obscuring what the true cost of insulin might be while maximizing their profits. Third, Senate Bill 8 seeks to decrease the overall cost of prescriptions in the state by increasing market competition through a Canadian drug importation program. This is something we've been waiting for a long, long time to have an opportunity to do by seeking a waiver from the U.S. Centers for Medicare and Medicaid Services as Florida was recently able to do. And as Chairman Lesser said, we don't often cite Florida as a model, but in this case, I will. The state will be able to purchase safe equivalent medications from a wider array of manufacturers, ensuring that we're getting the best deal and using our limited Medicaid funding as efficiently as possible. And finally, in the hospital setting, SB 8 seeks to curb shortages of vital medications, which sometimes endanger patient safety and delay treatment. Hospitals rely on dozens of common injectable drugs to provide life-saving care, and unfortunately, all too often we hear of chronic shortages caused by manufacturing and supply chain issues, and it's important for us to focus on this issue, and this bill does. Senate Bill 8 addresses this issue by requiring hospitals to put in place and periodically review a drug shortage mitigation plan and to include provisions in their supplier contracts that mandate access to a 6-month supply of their most vital medication. So all of these 4 components of the bill will be important, I think, in making good healthcare policy, good insurance policy, and good patient protection policy in our state. Thank you very much to this committee, on which I was very happy to serve as a junior member of the House of Representatives many years ago, and learned a great deal during my service on the committee.
Thank you, Senator Looney, for your advocacy on this important issue. Senator Lesser?
Thank you, Madam Chair, and good to see you. Senator Looney, thank you for your leadership over many years on this issue. We may have lost you as a rank and file member of this committee, but it's good to have you back and fighting for families across the state. And, I think you're absolutely right that the thing that's changed this year is that the Biden administration has really opened the doors for a lot of what we're seeking to do on providing relief on prescription drug prices, approving Florida's waiver to bring in Canadian drugs, negotiating the price of prescription drugs through the Medicare program, which we're seeking to piggyback off of with a prescription drug advisory board, and capping out-of-pocket costs as well. So I just wanted to thank you for your leadership on this. This is certainly a human services issue, and it will benefit the Medicaid program, but also benefit people who are not on the Medicaid program as well. I don't have a question for you other than I look forward to working with you, and hopefully we can move this bill forward.
Thank you, Mr. Chair, and thank you for all of your work on this issue over the years. Every single year, you bring back creative bills to deal with this ongoing problem and crisis for many families.
If we don't pass it this year, though, we are going to make people sing "O Canada" next year when we do it. So this is our one freebie year, so we can hopefully get this through without inflicting that on our CTN viewers.
I'll have to start rooting for the Canadian hockey teams.
Thank you. Representative Dathan?
Thank you so much. Senator Looney, thank you for your leadership on this issue. It's really appreciated. Drug prices are such a kitchen table issue that folks are always talking about. I know there's been some press around some of the issues in the lobbying efforts of some of the Canadian drug wholesalers. And they're talking about not exporting medicines, especially those that are in higher demand. Do you envision that there's going to be any relief with that, or could that affect people in our state getting access to those drugs?
Well, I think it's too early to tell, but I think it's important for us now under this bill to have the option of doing what Florida's already done, to seek that waiver and then see what the prices might be on the Canadian market, which are so much lower than ours in so many areas. And it's important to keep in mind that the manufacturers are still making a profit at the Canadian price, which is infinitely lower than what they charge here.
Absolutely. I lived in the UK for over a decade, and the prices that we'd pay for medications there, even through the NHS, a single payer, were significantly less than you see here. And it's shocking that here in the States, we are actually paying for the R&D of all of our, pharmaceutical developers, which is important. One of the things that I wanted to ask about, DSS just said that they're unable to project the actual impact of this bill, and that they have some concerns that it might actually have adverse effects. I know I read that Florida is estimating about $150 million savings with doing this. Anecdotally, you don't have to, I know you're not OFA, but do you have any idea what you think the impact could be here in Connecticut?
No, but I think that just the positive impact on customers and patients is going to be so significant, because I said at the beginning that there are so many people in Connecticut who are rationing their medications. They're taking less than the standard dose to make it last until they can get their next refill. Because and in some cases they have to make it last a little bit longer than that because they can't afford their next refill and have to save up for it. And that's just not a position we want people to be in.
Absolutely, 100% agree with you. Again, thank you for your leadership on this. Thank you, Madam Chair.
Thank you, Representative.
Thank you, Representative. Thank you so much, Senator Looney.
Thank you, Madam Chair. I wanted to do a shout out to Representative Heffernan, my neighbor from West Haven, our newest member of the General Assembly. Congratulations to you.
Thank you very much, Senator. Great to see you.
Good. Great to see you.
We have reached the first hour of our public hearing, so that means we're going to be going between the public and state officials. And so next we're going to hear from Autumn Bouchard, who is joining us on Zoom.
Let's see. Can you see me?
Your screen is black. It does appear to be turned on, but we cannot see you.
That is, I don't know. It's turned on. I'm sorry.
That's okay. Go right ahead.
I tried to fix it, but it didn't work. Good afternoon. Good morning, Madam Chair and esteemed members of the Human Services Committee. So I submitted a written testimony, which is different. It's really my personal experience as far as nonprofit human services resources such as substance abuse treatment and mental health treatment that I've experienced in my lifetime. And that's, something really close to me. I'm really passionate about what I do. So I'm one of 3 recovery coaches that works for Reliance Health, a nonprofit agency in Norwich. And 3 is really, we do the work, I think, of more than 3 people because we're supposed to have, I believe, at least 4 full-time. So my boss, who is going to speak later, will talk about the ripple effect that the flat funding has on nonprofits. So I'm here to support the annual rate adjustments for human services providers. It's really something that, so as a recovery coach, I'm someone who has lived experience, someone who's, been through addiction, who is in long-term recovery. God willing, next month will be 10 years in recovery from drugs. And so that gives me a different angle to be able to support these individuals in the community. I'm able to help them from a different perspective. And I really feel like that's unique, and it's kind of been a missing piece for a while because it gives a person the hope. Not saying others can't help, it's just unique. And so in this recovery coach program, I go out with the local police and I follow up on overdose survivors and give resources and Narcan and, like I said, a little bit of hope. And there's been some pretty big statistics that, again, my boss will talk about later when it comes to the decrease in the overdose deaths that we've had in this community, which are pretty significant, because we're not going to stop overdoses, unfortunately, but to prevent the deaths is really big. Unfortunately, my position it's not 40 hours anymore. I'm down to 32 hours, which as a mother of 3 young children is really, really difficult to come into work and help when I have to take extra shifts at night to continue doing my job like I want. So I'll wake up in the morning, I will get my kids ready for school, I'll go to work, I'll work my first shift job, and then I will go home, get them off the bus, do dinner, put them to bed, and then I'll leave again for another shift. And by the time I get home from that second shift, it's about 1 a.m. So I usually go to bed around 2 in the morning, and then I get up again around 6 or 7 and do it all over again. You could imagine the impact that has on young children when I'm walking out the door at night and they say, I don't want you to go to work. Or when I'm so exhausted and I have to get up and do it all over again, but I want to because I want to help. I want to help. It's a big part of my recovery also.
Ms. Bouchard,
Um,
your time has
yes.
expired. Can you please summarize?
Yes, I just think it has a huge ripple effect. If we continue flat funding, it has a devastating ripple effect on the employees, the members, the community, and their families.
Thank you so much, Ms. Bouchard,
Thank you.
for sharing your experience. It's very helpful for us to hear as we make our decisions. I don't see any hands. Thank you for your testimony today. Next, we're going to hear from Representative Frank Smith.
Good morning, chairpersons, Representative Gilchrist, Senator Lesser, Ranking Member Senator Seminara, Representative Case, and distinguished members of the Human Services Committee, and distinguished members of the Wheelchair Repair Task Force and our staff, Chandra. My name is Frank Smith. I'm a state representative for Milford's 118th District, and I appear before you this morning to voice my support for Senate Bill 308, an act implementing task force recommendations from the Wheelchair Repair Committee. As a member of the reference task force, I was witness and participant to the substantive, if sometimes spirited, exchanges between industry suppliers and CRT users and advocates. The stated objective of the task force, as well as the legislative intent of this resulting bill, is very simple: establishing requirements to ensure consumers' right to timely wheelchair repair. Obviously, the loss of one's personal mobility and often the ability to move about one's own home or domicile poses a fundamental limitation most of us will never need to contemplate, let alone experience. The debate largely centered around staffing adequate to provide more timely response and the relative cost difference between in-home and in-shop repair. During the nearly 8 months of task force deliberations, the two leading suppliers, National Seating and Mobility and New Motion, both about the same size with a very active presence here in Connecticut, were both able to increase their comparable tech and repair staff from something like 13 to 17. This is just during the deliberation of the task force. We've made some progress in that regard. I'm asking the committee to adopt Raise Bill 308, but with the following proposed change amendments. 1, rather than affirm an impractical 10-day limit from request to repair, limit wait times to 4 days from request to assessment, and then 4 days from assessment parts and prior authorization as needed to repair. This is more, I think, reasonable and practical than the 10-day limit that was in the original bill. Mandate expedited communications and response time for emergency repairs where a consumer has immediate risk of injury, which is something we just spoke about a little earlier. Allow wheelchair dealers to limit spare parts shop inventory if they have overnight or expedited delivery available for all parts. Establish a wheelchair advisory council of community stakeholders to monitor the effectiveness of wheelchair repair reform. Require wheelchair dealers to share repaired timeline data with consumers and monthly reporting to state and the aforementioned Wheelchair Advisory Council. And then something here that was brought up earlier, provide Medicare coverage as needed, Medicaid coverage is needed for 1, repairs to backup wheelchairs, which is very critical. 2, consumer transportation for repairs that Senator Seminara brought up a little earlier. And 3, overnight and expedited delivery of wheelchair parts, seeking maximum federal reimbursement for these policy changes. I'd like to thank and commend my task force colleagues. This is the first task force I ever served on, and it was very beneficial, both of us in experience, and also I think we made a lot of practical progress on this particular issue. And I'd like to commend my colleagues, including our peerless chairwoman, Beverly Brakeman, user advocates, Jonathan Sigworth from Connecticut Wheelchair Reform Coalition, and Sheldon Taubman with Disability Rights Connecticut. Also, and significantly, I think the industry representatives, Gary Gilberti with New Motion, Diane Rassicot with NSM, and Wayne Grau with NCART, all who demonstrated, I feel, a good faith commitment to their customers and a genuine desire to improve the industry and service to its stakeholders. I think the recommendations they met are sound. I realize they're going to be up to some discussion and deliberation by your committee, but I hope we would seriously consider these amendments and suggested changes to the resulting bill. And if you have any questions, I'd be happy to answer them. Three minutes, I did that.
No, it sounds,
Oh, here we go. I'm
oh,
back.
you're good?
Sorry, wasn't working. Thank you so much, Representative Smith, and thank you for bringing this issue to our committee and having the conversations that led to this task force with us. Any questions or comments? Senator Lesser.
I just wanted to thank you, Representative, for agreeing to serve on the task force and for helping bring this issue to us in the first place. I was a little appalled, though, when you mentioned that this is the first task force you've ever served on, because they're not all. This was a particularly difficult one, so I think you know some of them are easier to serve on than this one. So thank you for that, and thank you to yourself and to all of the members for really a spirited discussion and a good faith effort to improve services for wheelchair users. And I'm hoping that work will be translated into legislation.
Thank you, Senator. And some of the people following me to the witness are going to be able to expand on some of those points. Thank you.
Thank you.
Thank you very much. Next, we'll go to Athena Sophides on Zoom, followed by Sarah Egan. Go right ahead.
Thank you, Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. My name is Athena Sophides, and I'm a resident of New Haven, Connecticut. I was diagnosed with insulin-dependent diabetes in October of 2022, just shy of my 25th birthday, and right after moving to Connecticut to pursue my master's at Yale. In my research on how stress and the environment impact chronic illness, and as legislative lead of the Connecticut Insulin for All chapter, as well as in my own lived experience as a type 1 diabetic who cannot live without insulin, I'm deeply passionate about cementing access pathways for people who need medications, and as such, I'm grateful to SB8 sponsors for taking a step in this direction with this bill. For years before my diagnosis, I experienced painful and stressful chronic symptoms, a gamut of things from fainting and weakness and fatigue to anxiety, a fear felt by nearly the 8.5 million Americans who rely on insulin to stay alive every day. Unless you personally have had to worry about accessing insulin for yourself or a loved one, you can't understand the feeling of constant looming fear that hangs over our heads when we wonder whether we'll be able to access and afford our next batch of insulin. Along with that being very distressing, it also can lead to long-term complications which burden the healthcare system, as well as impacting our ability to show up to school and work fully, as well as to just live full and meaningful lives. Inadequate diabetes care in the US, including lack of adequate insulin access, leads to about 1 death every 5 minutes. This is not just a health justice issue, but a racial and housing justice issue as well that disproportionately impacts Black, low-income, middle-income, underinsured, and uninsured communities, as well as children living in Connecticut. I urge the General Assembly to support Senate Bill 8 and to extend its language to cover uninsured and low-income individuals as well. The successes of such legislation in states like Minnesota, as well as the impacts of life-saving emergency access laws that have already been passed, thanks to you all in Connecticut, should underscore the potential of this bill to create a truly comprehensive access pathway for people who depend on insulin. With this bill, the GA has an opportunity to stand firm in protecting our communities from bureaucratic hurdles, exorbitant insulin costs, and the pharmaceutical pricing regimes that drive them, and to give its constituents a chance at not just staying alive, but living without constant stress and fear. Thank you.
Thank you, Athena, for being here and for your testimony. Don't see any hands. Have a great afternoon.
Thank you.
We'll hear from Sarah Egan, followed by Elaine Balsley.
Good afternoon to the committee. My name is Sarah Egan, and I run the state's Office of the Child Advocate, which is an independent state agency charged with overseeing publicly funded services for vulnerable children and making recommendations for improvement. And I don't think I came here to testify in anything that you don't already know. But it is our job to come here. It's our job to help families and answer that phone. And when we see systems issues, bring those concerns to you and make recommendations for improvement. So we are here to testify in very, 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 all caps, underlined, bold, support of House Bill 5459, an act increasing rates of Medicaid reimbursement for certain providers and support. And you have our written testimony where we highlight the stories of some of the families that call our office every single day. And I come here every year and I share these stories with all of you. And I think what I want to underscore today is that this is a 5-alarm fire. It was a 5-alarm fire last year. It was a 5-alarm fire the year before. Representative Dathan's question earlier about what does the recent preliminary study say about behavioral health? Well, I think it says what we've all known it was going to say. And if anything, and I think it was Senator Anwar's question in the informational hearing a week and a half ago or so, that said, if anything, it's worse than we thought it was, but we knew it was bad. And there is a direct correlation between the dramatic decades-long underfunding of our behavioral health system and the workforce crisis and the access crisis. And we hear it every day, as I'm sure you do too. And I do think it's important to highlight some of those stories, because what does it look like when we don't fund Medicaid appropriately? It looks like 30 children sitting in the CCMC emergency department. That department for behavioral health is built for 12, not 30. What it looks like is a parent brings their child to the emergency department. And I just want to pause on that for a second, because what it takes for a parent to say, I can't manage on my own. I don't know what to do. I've done all the things I can think of. I've called the school, I've called the doctor, I've gotten medication, I've done all those things, and I need more help than what I can manage as a parent for my child. That is an enormous leap for a parent to take. But I know something that they don't know. I know that they think that leap is what's going to connect them to care. That is they get their child in the car, or they get them in the ambulance, and they get them to this hospital with all these wonderful professionals, and they are, and if parents feel their child is unsafe, they should still do that. But what I know that they may not know is that their child may stay there for that day, for 2 days. One hospital reported to us last week that of the 30 children in their emergency department, many, if not half, had already been there for a week. A week. Some of the data we included in our report, 3 quarters of 2023 in Connecticut, we had 1,200 children stuck, not coming to an emergency department, stuck in the emergency department, which means after they have been cleared for discharge or a different level of care, stuck. And over 400 of those children stayed more than 4 days. So going back to that family that finally got their child to the hospital, only to be told they may have to leave them there. I'll never forget the dad that I talked to and said, the situation you're in is unmanageable. You have to bring your child to the emergency department and say you need more help. And he did. And his son stayed there for 10 days on a mat, in a room. His son was 10 years old. And add intellectual disability and autism to that profile, which that child had, you could be waiting even longer. Just in the last couple of weeks, we had a teenager 40 days in the emergency room, 40 days with autism and ID, until the hospital socially admitted the child because he can't live in the emergency department. And why are they there? Because there's no place to go. The children running through the STAR shelters, the girls now starting to fill up our juvenile justice facilities for one reason and one reason only: the treatment and support they need is not available. The last thing I want to underscore, because I know you have a long day, and thank God that there are so many people that care and are making time to testify. the last thing I want to emphasize is that this is not just the moral and policy obligation of the state of Connecticut to these children, to these families. It is a legal obligation under federal law. The mandate under Medicaid for children is very broad, and it is an entitlement, early periodic screening, diagnosis, and treatment. The state must, to comply with Medicaid, must screen, which we do kind of, refer, which we do, connect, which we don't do well, and ensure access to services is in a reasonable time frame, which we do not, and which has been emphatically established through data, through the waiting list. If you've got 1,200 children stuck in the emergency department, the system isn't working, and it cannot be incrementally moved with a $7 million investment, with all due respect. And I love, my colleagues in state government. I love them. And the commissioner of DSS is a tremendous and wonderful commissioner and an asset to the state, right? But the system needs an infusion of support now. We know that. And it is a legal necessity that we do that. And that's what I wanted to underscore today. Thanks very much for the opportunity.
Thank you so much, Sarah, for your continued work and for your testimony. And agreed, I have much respect for those at DSS, but $7 million is an insult based on the information we know and have been provided. Thank you for your testimony. Senator Lesser?
And thank you, Madam Chair. Just building on that, the commissioner has indicated that, and OPM has as well, that the $7 million figure that we have in the budget seems like it's likely to be prioritized for behavioral health. You don't, I don't think we've gotten a fiscal note yet, but you don't think that $7 million will meet the need just in the behavioral health side?
I don't think it's going to come close to meeting the need, would be my guess. I mean, autism alone.
I don't either. Yes.
Is
Okay.
big. Yeah, no.
Thank you.
Representative Dathan?
Thank you so much for your testimony. I don't have any specific questions for you, but I know personally that this is a major issue, and I appreciate you highlighting it for so many folks in our state.
Thank you, Representative Dathan. Representative Leeper, who is on Zoom.
Thank you, Madam Chair, and thank you, Sarah, for your incredibly powerful testimony, as usual, but particularly in regard to this issue. Our state's children are really lucky to have an advocate like you who is so passionate and thankfully also persistent, because you're totally right. It was a 5-alarm fire last year and the year before, and I fear $7 million is what I recently heard referred to as budget dust. And the intensity of need deserves far more than that. And I said it last year and I said it this year, and I know it's shared by many, many members, both of this committee and otherwise, that raising our Medicaid reimbursement rates is an absolute top priority. So I'm looking forward to working in any way we can to make that a reality. And I just wanted to thank you for your work.
Thank you.
Thank you, Madam Chair.
Thank you.
Thank you, Representative Leeper. Representative Fortier, followed by Representative Johnson.
Thank you. And thank you very much for your work and your testimony. I don't have any questions for you, and I'm not a big sharer here. I'm new here in the legislature, and I don't know a lot of the numbers and the facts, so I'm not able to comment as much as others. But I do want to say I raised 6 children, and 2 of them had very serious mental health issues as teenagers. And I've spent overnights in emergency rooms waiting for care. I've never spent 4 days or 10 days. And that was about 15 years ago that I was navigating that system. I was a state employee at the time, so I had state employee health insurance, and it was still difficult to find providers that dealt with teenagers. And we know the need is even greater for even younger children now. And when you said it's a 5-alarm fire, for an individual family, it's a 5-alarm fire for a 1-night wait. These children are in crisis, and it impacts your family in ways that I don't have time to explain. But this is unacceptable. And again, thank you for your advocacy.
Thank you.
Thank you, Representative. Representative Johnson?
Thank you, Madam Chair, and thank you so much for your work. And I know how diligent you are in terms of making sure we understand a lot of the things. And I know that now I'm very thrilled to see us do the study for Medicaid reimbursement rates, and that this is something that I'm hoping we'll be able to apply. And these are things that we need to work on together to make sure that our young people are adequately addressed, whether it's in the school system with special education, which has not been really addressed properly, or whether it's just getting access to care. And one of the things I wanted to ask quickly, see if you had this information. If not, I need to work on it. But I remember during the Sandy Hook horrible tragedy, that the student who who ended up committing suicide after he shot his mother and the children there in the school. Um, um, he was not able to access special education in that system back in those days. One of the things that we studied when I chaired public health was the fact that we did not have that many people in the state for psychiatrists, for psychologists, for APRNs that do behavioral health work. And I just wondered, have we got any way to analyze where we are today in comparison to back in those days?
Just make sure I understand the question, where we are in terms of workforce.
Yes.
Well, I think it's an excellent question, right? And the
Thank you.
workforce crisis is much worse
Yes.
than where it's been. And CHDI, I think some folks are familiar with that organization, issued a report and recommendations to the public and to the legislature in the last year on the workforce crisis, right? Which is directly tied to investment, right, in the services. And I just wanted to lift up quickly, because I know sitting behind me are some of my colleagues and from ICAPS, right, which is the state's go-to in-home behavioral health service, a service that keeps kids out of the emergency department and supports them when they are coming out, right? And my understanding is, and I think you'll hear more from them today, that we're pushing a 600 family waiting list. And let me be clear, there is no alternative, because any other tinier service that families might access, though probably not through their insurance, right? They have the same problems, whether they can carry a wait list or not. I talked to a provider in Eastern Connecticut just the other day, turns away just from one program that works with families and their parents. They turn away 2 to 3 families a week. Where do those families go? They go nowhere. They struggle, right? And that's what it looks like. And it impacts every level of care we have. And our system is not too strong to say, collapsing. And it's got to be fixed. And this bill is a big step to do that.
Just quickly following up, and thank you for that. The fact is, I've been working with our homeless shelter executive directors in the last few years. One of the things that they've told me is that we have students who didn't get the proper special education, and now they're homeless and they're going to the shelters. So I didn't know if any of that had been part of your analysis.
Well, I think there is a definite overlap, right? I think, as you well know and have worked on for so many years, between the quality of the educational supports for kids with disabilities and then their outcomes. In fact, our office, just to plug, released today a report on a program for children with disabilities that we found was dramatically underserving those children. These are some of the same children we see in the deeper end of our mental health and correctional system, right? So that's, when we don't meet the needs of kids early, we're forced to meet them later.
Thank you so much for all your work, and thank you for being here. I appreciate it. Thank you, Madam Chair.
Thank you, Representative. Thank you so much, Sarah. Next, we'll hear from Elaine Balsley, followed by former Congressman James Lanigan. You just need to push the button. It'll turn red. There you go.
Good morning, Senator Lasser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Elaine Balsley. I am the director of a Birth to 3 program in the state of Connecticut. I am one of 18 programs. I am also a member of the Birth to 3 Interagency Coordinating Council, and I'm the co-chair of the Legislative Fiscal Subcommittee. Thank you for this opportunity to offer testimony today in support of House Bill 5459. During this past year, the Office of Early Childhood commissioned and completed a comprehensive cost and rate study by the Public Consulting Group. The outside study was requested because birth to three businesses could not keep up with rising costs since our rates have been stagnant since 2017. The Public Consulting Group completed their review and determined that the current rate is significantly lower than the cost of actually providing the services that we do. Per the cost study, 44% of the birth to three programs were running in deficit the year of the study was completed. In state fiscal year 23, birth to three programs provided services to 13,000 children and their families, actually over 13,000 children and their families. The number of evaluations since 2017 has increased 49%, from 7,500 children in 2017 to over 11,000 currently. While the referrals are rising, the ability for us to recruit and retain the professional level staff that we are required to have, and our ability to offer competitive businesses is very difficult. We are a mandated program under the federal IDEA law, so there can be no waiting lists. All infants and toddlers who are eligible for services, who have a significant developmental delay in one domain or a moderate delay in two domains, are required to have services. So with no waiting lists and a very difficult time hiring and retaining staff, the staff that we currently have are feeling overwhelmed. And I cannot offer them as an employer, I cannot offer them any increases in pay or benefits because I am not receiving any more income. The service hours for children with autism have actually decreased by half since 2017 because of this difficulty in retaining and hiring staff. Just this past year, Easter Seals, which is has been a birth to three provider for, as far as I know, 30 years since the inception of birth to three in Connecticut, it's ended their contract with birth to three because they were not able to meet the fiscal needs. And we can't really afford to lose any more programs. We have an RFP coming up. We need to attract more programs. It's going to be really hard to attract more programs if 44% of the programs are.
Would you be able to summarize?
Yes, I'm sorry.
That's okay.
3 minutes is really
I
short.
know, it is.
I think we're a big cost savings. 55% of the children that we see do not need preschool special education, and we know how expensive that is. Just as an example, 723 children in Hartford received birth to three services last year, and about half of them did not need to go on to provide early special education services. Thank you for your time.
Thank you. I do have a question, then I'll turn it over to Rep. Fortier. The service hours for children dropping, that's in the birth to three programs, and it's a direct result of not having enough staff?
Yes.
Thank you. Representative Fortier?
Just because I talked about my daughter a little while ago, I want to also say that she participated in birth to three programs and they were highly successful, and she did not require special ed services in preschool or going forward. I can't say enough about birth to three and how effective they are. So thank you for your work and for testifying today.
Thank you. And thank you for being here. I mean, we have a lot of people signed up and it will be a long day, but I appreciate everyone because I think it's going to illustrate the breadth of the impact of Medicaid rates on so many people and services in the state. So thank you for being here.
Thank you.
Next, we will hear from former Congressman James Langevin, who is joining us on Zoom.
Very good. Can you hear me okay?
Yes, we can. Go right ahead.
Very good. Chairwoman Gilchrist and Chairman Lesser, distinguished members of the committee, thank you for the opportunity to testify on the wheelchair service and repair bill. And before I begin, let me just say In my prior elected life, I had the distinguished privilege of serving with the outstanding members of the congressional delegation from Connecticut, some of my closest friends, including my brother to the south, Joe Courtney, and of course, Representative DeLauro, John Larson, Jim Hyams, and Johanna Hayes. I can assure you that you are all very well represented in the United States Congress because of your delegation. So I had the privilege of serving in the Congress for 22 years, and but more importantly, I've been a power wheelchair user for over 40 years as a result of a spinal cord injury when I was a teenager. My chair is custom configured to my specific needs. I rely on it for my mobility and independence, and it helps me do my job effectively, to socialize with colleagues and friends and family, and to live a more active and independent life in my community. And of course, when my wheelchair needs to be repaired, I want it. No, I guess more accurately, I would say I need it repaired as soon as possible. So I really appreciate the intent of the legislation before you. As always, with anything, the legislation, the devil is in the details, and of course we have to be mindful of unintended consequences. So again, having served in public life and for really more than 3 decades, I've come to rely on my mobility device to be effective at what I have done in public life and now in private life. And it was a privilege to serve as a public servant. I now have the privilege of serving in several roles, including in academia, but also now as a director on New Motion's board of directors. And I've been able to do a more deep dive on the service and repair issue. I assure you, and I agree with the sponsors of the bill, of course, and those who are concerned about the bill, the service and repair problem is real. And of course, it is an important role for policymakers in finding a solution. I would just encourage that any solution, though, really does need to be comprehensive, or it risks making the situation worse for consumers. Of course, as legislators, we know that the art of compromise is absolutely critical to sound public policy. And this legislation, though it's certainly well intended, doesn't really effectively build off all of the areas of common ground found via the months of the working group discussions, it's things like authorization and adequate travel reimbursement and penalties still remain in the bill, along with unworkable timeframes. So I would just encourage legislators to focus on the areas where all stakeholders found agreement through the extensive working group meetings and discussions. And I would encourage you to pass a bill that's focused on those areas of agreement. Let consensus drive the policy and continue communication and analysis moving forward. Thank you, and I'll yield back the balance of my time if there are any questions.
Thank you, former Congressman, for your testimony. You encourage us to focus on the areas of consensus. My reading of the bill attempts to adopt the recommendations of the task force, but looking at I didn't serve on the task force, but looking at the report, it doesn't seem that there were any areas of consensus agreement between all the parties. Am I missing something? Because I didn't remember seeing any of that.
Right. Things like an unworkable time frame of, I think it's 10 days for service repair is not what I would call common ground. While you're leaving in the paperwork required, things like not addressing the root causes and not providing getting more practical solutions and timelines. Things like burdensome administrative requirements, like medical documentation and prior authorization, in my opinion, should either be really shortened or done away with. In trying to get a prescription, for example, from a doctor, I'm sure we've all tried to get in with our medical providers, and you realize that they move at their own pace, and it may be impossible to get a prescription or the documentation that's needed in the time frame that the legislation might require And I would say that we need to either do away with that or have a time frame that's much more realistic. There obviously also needs to be more suppliers performing repairs so that those that sell the equipment are actually required to repair it. It really is unfair to have a company sell a piece of equipment and then tell consumers, you're on your own, down the road when it comes to the chair getting repaired. And it doesn't also address for those that do repairs, the remaining ones that are there, not getting reimbursed for travel time from the shop to a person's house, having the assessment done, and then the servicers, as I understand it, are not compensated in any way. Unfortunately, we need to address that as well, including not even getting paid for fuel to get out to the repair site. So again, I think there's a lot of common ground we could find in addressing these problems, and I would encourage members to look at that.
Okay. Thank you for that. I guess my only quibble is it may be a consensus for your company, but it wouldn't be a consensus for all the parties. We heard from the DSS commissioner earlier. And so, in terms of getting everyone on the same page, you might like some recommendations, but there's no particular recommendation that I think had the support of all the parties. And I wish that were the case, but what we have are what was voted on by the task force, and that's what we're looking at today. Are there questions from members of the committee? Representative Johnson, I think your microphone is on if you.
Oh, so sorry.
Okay. And with that, I want to thank you for testifying here today. Appreciate your input. Actually, I have one last question. If you don't believe that, you said that you don't agree with penalties for noncompliance with the standards established by the bill. I guess nobody wants to be forced to do something, but what do you see as pushing the industry to comply if we don't have any teeth to the bill?
Yeah. So let me clarify in saying that having a heavy-handed approach and imposing penalties with an unrealistic time frame is more the concern. I think if many of the other areas of common ground, I understand the issue of having teeth, but trying to get blood from a stone, so to speak, it isn't going to all of a sudden make it happen. And that's why it's more effective to focus on areas where there's more areas of common ground that would get to the root causes of why do repairs take so long, including, by the way, not always having enough people doing repairs. And I had the privilege of serving as co-chair of the Career and Technical Education Caucus. And here, by the way, is a real opportunity for legislators to work with local schools on things like developing more talent that can go into good paying jobs in the repairs in this field. And I certainly would encourage to work with you, Senator, on increasing the supply of talent that could actually do the repairs, because that's one problem. Again, just saying we're going to do it in 10 days, if you don't have enough people to do it, or there are unrealistic paperwork burdens in there, we're trying to get all the providers in a reasonable, in a 10-day time frame. It's not going to just make the issue go away because there's a 10-day period in there and all of a sudden a penalty gets imposed. That's what I'm saying. It's not realistic.
Thank you.
Great. Thank you so much, former Congressman. I don't see any hands. Thank you for your testimony and your time today.
Thank you, Madam Chair.
Next, we'll hear from Thomas Avery, followed by Beverly Brakeman.
Good afternoon, Senator Lesser, Representative Gilchrist, Representative Johnson, who's my representative. My name is, and I'm sorry, and other members of the Human Services Committee. My name is Tom Avery, and I'm a retired occupational therapist and a board member of Horizons, a nonprofit agency that provides essential services for over 1,200 Connecticut citizens with developmental disabilities. Horizons has been providing these essential services for the past 44 years. 92% of community-based services for this population is provided by nonprofits. Thank you for the opportunity to testify today in support of HB 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers. This bill would help community providers stabilize our budgets and continue to provide essential services to the state's most vulnerable populations. The increases that the legislature has provided over the past few years are appreciated, but they haven't been enough to meet the needs of the people we serve. We continue to be hit by crushing increases in our cost, due in part to increases in inflation that far outpace the ratio increases that the legislature has provided. Hiring and retaining qualified staff has been a continual problem. Horizons has a 20 to 25% vacancy rate. In the past year, we've had 187 job inquiries, though after hearing the job responsibilities, only 38 of these people actually completed the application. 33 of these people were hired, but within 6 months, 8 of these new hires had left. Training new staff takes time and money. When experienced staff leave, it's nearly impossible to replicate their expertise that they've acquired over many years. Relationships that staff have built with the folks they serve are vital in supporting them, and frequent changes in staffing are often disruptive and damaging. Wage compression is another factor that causes experienced staff to leave. When wages don't reflect the value of seasoned staff, they often become understandably frustrated and resentful in spite of their love for the work and the people they serve. Expecting staff to continue to provide high-quality care year after year for essentially less money makes no sense, and it's unsustainable. A responsible budget takes into account predictable expenses such as inflation. Ignoring this reality just creates misery and frustration. Since 2007, the cost of nonprofit services has increased by 45% due to inflation. The legislature has only been able to provide increases equal to about 13% in the past few years. There's no way to provide the needed services given that reality. I urge the committee to support HB 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers. Thank you for your time and consideration.
Thank you, Mr. Avery. Mr. Avery, could I ask you to just share one or two of the job types, like the title and then what the starting pay is currently?
I can't provide that for you, but our CEO will be here
Okay.
and giving more information later, and she can give you that information. I'm sorry. She's right here.
Yeah. You just need to state your name for the record, please.
Chris McNabo, CEO of Horizons. So the job titles are support coaches or job coaches that work with our folks with intellectual disability. And the starting pay right now for we're funded through DDS is $18 an hour.
Thank you.
Thank you.
Thank you both. Representative Johnson, don't go away yet. Representative Johnson has.
Thank you so much, Madam Chair. And thank you both for being here and sharing the great work that you do. I know everyone in Wyndham is really impressed with all the amazing work that goes on and your help. People not just in Wyndham, but all over the state of Connecticut. And I think maybe you'll reach even beyond that at some points. But anyway, I appreciate that. But going back to a little bit about how occupational therapy works to make sure that help people who have the capacity to have a job. How is what you do work to make sure that people that have the capacity that can maybe go to work, how does that work in with what you're doing at Horizons?
Well, in my past experience, I worked for over 30 years at DDS in Massachusetts, and we provided a range of, occupational therapists provided a range of services, including looking at wheelchairs, looking at people's ability to function in a variety of ways. And if they were working, we would go into the work setting and provide modifications to jobs that they were doing and so forth.
Mm-hmm. And so we have the same thing going on at Horizons today.
Yes.
Go ahead, Chris. You can speak as well.
Yes, we do. And one of the things that Tom has been really helpful with in his retirement and working with us at Horizons is helping our staff learn how to modify food consistencies, which are a critical component when we're supporting people that have a variety of medical needs and require different food consistencies. And he's an expert in that, and he's brought his expertise to our folks on a volunteer basis here at Horizons, and it has changed the way people look at eating, because when you have a liquid diet or a ground diet, sometimes it can look very gray. And Tom is a master at making it look like food again, and has shared that technique with us, and so we're able to make those changes. But in terms of people having occupational therapy to be learning different jobs, it's a lot of job modifications, and job coaches are the staff who learn those modifications, and they're out in the field using those on a daily basis so people can be gainfully employed.
Thank you so much for that. And thank you so much for being here today. Thank you, Madam Chair.
Thank you all.
Thank you, Representative. Thank you both. Beverly Brakeman, followed by Maureen Emerald.
Hi. Good afternoon, Senator Lesser, Representative Gilchrist, Ranking Member Seminara, and Ranking Member Case, and distinguished members of the Human Services Committee. My name is Beverly Brakeman, and I served as the chairperson for this task force appointed by Senator Lesser, and I'm here to testify in support of Senate Bill 308. I'm here with Jeff Metesky, who was my inspiration for getting involved in this. He has some short testimony that's going to be far more interesting than mine, but I want to talk a little bit about the process of the task force. First, I want to acknowledge the extraordinary commitment of Senator Seminara, Representative Case, Representative Smith, the consumers, the disability advocates, insurance representatives, industry representatives, and state agency personnel. The overarching goal of the task force was to make recommendations designed to reduce the period of time wheelchair users wait to have their equipment repaired and serviced when it breaks. The task force met a total of 13 times between August and January, and the resulting recommendations were approved for transmittal to the committees of cognizance in January. The recommendations were born out of serious dialogue, education, debate, and often serious disagreement. While none of the recommendations, as you said, Senator Lesser, are consensus recommendations, we included verbatim responses from every stakeholder group in the report in order to be fair and transparent. You will hear from most of those people today. While all task force members agreed the timeline needs to be reduced, there was wide disagreement on how to do that. In particular, task force members disagreed on how to reduce these timelines. As I have said in the report, I favor regulations as a way to provide consumers with the assurances they need when their wheelchair breaks. But I do understand the complexities and the dynamics that you all have to deal with in making those decisions. More importantly than anything I can say today, however, will be the testimony from full-time wheelchair users whose quality of life, mobility, independence, and access to the world around them is reliant upon their wheelchair. A broken wheelchair can mean days of uncertainty, fear, and isolation. The recommendations of our task force and of the bill before you are designed to establish a more informed and reliable infrastructure for wheelchair users faced with broken equipment. And I want all the legislators to keep something in mind as they grapple with these really hard decisions. According to the 2023 World Health Organization Wheelchair Provision Guidelines, there are 4 guiding principles that I'm asking you to underpin your work. An appropriate wheelchair is a human right. Wheelchair provision services and systems should place people at the center. Wheelchair provision should be an integral component of universal health coverage, and access to appropriate wheelchairs should be equitable. It is my hope that you will keep these guiding principles in the forefront as you move this bill through the legislative process. While I'm sure you all stayed up all night long to read the report, I want to briefly summarize the recommendations, not to be repetitive or anything, but there are 12 of them. CRT equipment must be assessed and then repaired either in the consumer's home or in a service location of the consumer's choice within a set period of time that is less than 10 business days after all prior authorizations and parts have been received, with exceptions to assessment and timeliness requirements in cases where the consumer is not available or cancels. And I read that one fully because that was and is the biggest sort of area of disagreement in terms of how we do that. And the bill actually needs to be amended to reflect that, I believe. I'll just go through the other ones. Eliminate prior authorization and prescription for repairs of CRT. Payers should cover annual preventive maintenance of all CRT. Consumers must be offered and provided in-home assessments and repairs within a comparable timeline to that of in-shop. Transportation to the CRT location, should a consumer choose, should be a covered benefit. And payers should cover the repair technician traveling to and from the consumer's home. That's a huge cost that is not currently covered. Annual preventive maintenance of consumer-owned backup equipment should be a covered benefit, and Jeff's story will attest to that quite clearly. Expand the number of CRT repair facilities in the state that provide services and repairs. Allow consumers the option to purchase parts from CRT suppliers directly. And CRT suppliers licensed to sell equipment in Connecticut must also be required to repair those chairs. Establish a wheelchair advisory council and require insurance payment for overnight and expedited delivery of urgently needed parts. And lastly, it is my strong recommendation that the proposed bill be amended to include all of the task force recommendations, as I know was your intent. As I read the bill, the transportation for the wheelchair user, transportation for the technician, overnight delivery of parts, and the advisory council recommendations are not included. In addition, the language around the number of days would need to be changed to be reflective of the report. And I'm going to stop there. And if you want, Jeff can do his testimony and then we could see if there's any questions. Okay,
Yes,
thank you.
please, go ahead. Thank you.
Okay, thank you. And thank you to the committee. My name is Jeff Mateski. I live in Essex, Connecticut, full-time manual wheelchair user. I want to thank the committee for the opportunity to testify today in support of Senate Bill 308. I've been reliant on a wheelchair for my mobility for the past 40 years after becoming paralyzed from the chest down from a motor vehicle accident at age 19. Despite my impairments, I went on to finish college. I've enjoyed a 30-year career as an IT engineer. I own a house. I've had a wife or two. Have a wonderful partner and even children. And basically I've been, fortunate to lead what appears to be, the normal happy slice of the American dream. And to say that this is due in no small measure to the mobility afforded to me by my wheelchair would certainly be a true statement. However, if I'm to be 100% honest, no small measure would be a gross understatement, because all this was possible only because of my wheelchair and my wheelchair alone. As a manual wheelchair user, my mobility needs fall on the less complicated side of complex rehab technology. After all, it's just a seat, a couple of big wheels on the back, and two smaller wheels in the front, right? But I can attest that nothing could be further from the truth. In fact, this seemingly simple collection of aluminum, plastic, fabric, and rubber is as uniquely fitted and fabricated to my body with its strengths, weaknesses, and quirks as one's own legs are to a non-disabled person. For example, the frame is constructed at the precise angle to compensate for my lack of sitting balance. The dimensions allow me to negotiate tight spaces and also allow me to lift it in and out of my car successfully. The lightweight rims and high pressure pneumatic tires allow me to go up inclines, navigate all kinds of uneven pavement and various obstacles. And the rigid backrest lasts for years versus the stock fabric one, which will be torn and useless within a mere 6 months of rigorous daily use. In effect, these innovations aren't just these fancy nice to haves. They are essential link in allowing for everything I've been able to accomplish in my aforementioned life. This is why a wheelchair, be it manual or powered, simple or complicated, is unequivocally a basic human right. Without it, well, I guess that's the end of the whole human life experiment. The recommendations before you, as challenging as they are to implement, would give those of us whose lives depend upon CRT assurances and at the very least expectations when these inevitable breakdowns occur. Recently, on a trip to San Francisco, we landed greeted with the news that my wheelchair had been run over by a runway vehicle and completely destroyed. Add to that the indignity suffered by the independence-crushing drugstore chrome behemoth wheelchair offered as a loaner designed to be pushed only by a caregiver, which wouldn't allow me to safely traverse any typical sidewalk, let alone the extreme angles and topography of San Francisco. Luckily, at home, I had my 15-year-old backup chair that was miraculously still in usable condition, which was a good thing, for it would be a full 3 months before my replacement for the destroyed wheelchair arrived. And that was what I was told was the fast track. So thank you again. Again, I only highlight that because, the fast track, 3 months. This has to improve, and I believe these recommendations can do that. Thank you again for hearing this testimony, and I hope it illustrates the vital importance of Senate Bill 308.
Thank you both. Thank you, Jeff, for being here and for sharing your experience and for being an inspiration to Bev and to others. And then Beverly, thank you so much. We heard nothing but kind and positive things about your leadership style. And so thank you for leading this important task force. Senator Lesser?
Yes, I want to just echo what my co-chair just said, and thank you, Bev, for agreeing to serve as chair of the task force. I know it was a lot of sleepless nights, a lot of long meetings, and just grateful for your service, free of charge to the people of the state of Connecticut. And Jeff, thanks for telling your story. You're verged on the poetic at times, and about why this is so important to people, how essential to dignity and just ability to live a life, to have access to mobility. And so appreciate it. Bev, you just talked about some of the things we may have made some mistakes. We looked at your report and we tried to translate it into language. And so that's always an imperfect and exact art. So it sounds like we missed a few things in the report, in the legislation.
Yeah.
And then we also tried in other places to fill in the blank spaces. You'd asked us to find a regulator and come up with enforcement mechanisms, and we attempted to do that. I guess I will ask on that firsthand. Do you support, we identified DSS and a specific mechanism. Is that something that generally aligns with what the task force was getting at?
Yeah, it seems to me, I mean, I'm not an expert on this kind of stuff at all, but I think it's like 40% of all wheelchair users are on Medicaid. So DSS plays a critical part in this. So it seems to me that it makes sense. And, I listened to the commissioner, and I certainly understand and respect their concerns about how to actually do that. But it does seem between DSS and maybe DCP that those would be the state agencies that would be most involved in making this happen.
Okay. And so what did we get wrong? What did we not do? What did you not include that we ought to have?
Well, I don't think you all did anything wrong. I mean, look, I've been around this building for longer than I care to admit. So it's not easy writing legislation and getting it. So the things I think that were actually very important to most of the people, well, I should say, when we talk about consensus, it's a lot really the two major parties are really the consumers and the industry, right? So there were some very key areas of agreement between those two parties, which are the most impacted, frankly, by this, although the insurance industry also obviously is. But of course, those agreements were around what the insurance payers, Medicaid, Medicare, would have to do. And that was transportation for the technician. It's my understanding, and the industry will testify to this, they have to send text to people's homes. They offer that, and that is not covered at all. Also for consumers, there's my understanding of non-emergency medical transportation for the state is they will not take people and their broken wheelchairs. The advisory council, I do think actually everybody agreed that that was important, although I don't think that they want to meet that often, because I do think we were probably the task force that met more often than any other task force ever in the history of this legislature. I decided that because I'm only a little bit competitive. So, and we came out with 12 recommendations that weren't consensus. Like, how often does that happen? And we still got everybody to agree to send it all to you. So I'm gonna take credit for all of us in the room who worked our asses off on this. Oh, excuse me. That was not proper decorum. So, so so the transportation, the advisory council, the way that the timeline is written, and the expedited delivery of parts. I think those were the things that stood out for me, but I'm sure that there'll be some consumers here who will have more to say on that than I do.
So obviously there were a bunch of recommendations around insurance coverage, and we did not implement those recommendations
Right.
because we're not the insurance committee.
Correct.
But we did forward those recommendations,
Yes.
as I think you did as well, to our colleagues on the insurance committee with the request that they look at that, but trusting their judgment as a separate standalone.
Yeah, and that's a big problem actually that we talked a lot about, because, if you do something here and not in the insurance committee, you have wheelchair users and a real disparity within that population. So I'm hopeful that the insurance committee can do something.
And then with regard to, there's been some confusion about how the task force ended. And, there was a discussion you heard probably with Mr. Langevin earlier about, the lack of consensus recommendations. But I've also heard some folks say that there were no recommendations at all, that there was a, cacophony and nobody could agree on anything. But there were recommendations, right? Just where you ended up, you did make recommendations. Those were voted on. They may not have been unanimously approved, but you did make recommendations to us. Is that?
Yeah, the report, if you look, contains 12 recommendations, and I'm very clear in there that they were not consensus recommendations. And as such, the way we countered that was to allow every stakeholder group to provide verbatim responses contained in the report to respond to that. And then on the last meeting, I believe we'd have to look at the minutes, but the motion was something to the effect of people approved the report as representative of the discussions and the debate for transmittal to the committees of cognizance, with but the understanding was they weren't all consensus. We just weren't able to get there. But they were recommendations.
And in terms of acknowledging that those recommendations had been made and in that final vote, it was a vote by all of the members of the task force vote in support of sending this to us?
If memory serves me, everybody, a lot of the state agencies, some of the state agencies actually voted yes. I think some abstained. I know the insurance industry also abstained, but did provide feedback in the report. And I believe everybody else voted yes to have it be transmitted. Yeah, I think Chandra would have the minutes from it, but that's how it went down.
Including, and did that include industry representatives who are today testifying in opposition to this bill?
Yes.
Okay, thank you. That's all I have, Madam Chair.
Thank you, Senator Lesser. I don't see any other hands, so thank you both for being here today.
Thank you.
Next, we'll hear from Maureen Amaralt, followed by Kathy Ludlam.
Can you hear me? Okay. Okay. Thank you, Senator Lesser and Representative Gilchrist and members of the committee. My name is Maureen Amiro. I am a resident of Weathersfield, and I am speaking in favor of SB 308. As a customer of New Motion, I've had to wait 5 months for new tires, 8 months for a seatbelt, and 11 months for a cable to be replaced on my joystick. None of these were due to supply chain or insurance authorization issues, as they would like you to believe, but rather due to a broken system of an understaffed company. Countless times I've called to check up on the status of a repair, only to discover that nothing's happened since I last spoke to them. I find out that there are no updates in the system, or that we received approval 2 weeks ago, but no one's ordered parts. Or worse, the parts were ordered and have been sitting in the warehouse for weeks, but no one has been updated or has done anything. I've had repairs disappear in the system or be marked complete and then have to start the whole repair process over again. Overworked techs are often late for appointments or miss them altogether. They come to appointments with missing parts or wrong parts, and they run out of time and leave the repair unfinished. Now, 33 months ago to this day, I requested a repair to my foot plates. My feet are not sitting properly on the foot plates, and my ankles are rolling, and all my weight is on the sides of my feet. After the initial consult visits, the tech never returned or answered my phone calls. Thus began a 2.5-year process of my trying to get this issue fixed while watching my condition worsen. In September of 22, I had this and a list of other outstanding repairs that were not being processed. I was so frustrated and desperate at this point that I even called my insurance company to try to help, and they couldn't even get New Motion to send the forms over for authorization. I finally I mailed a letter to CEO Mike Swinford. He assigned me to a vice president to oversee the repairs, and with his help, it still took another 2 months to get these repairs fixed, and he was not able to help with the footplate issue. So I was left on my own to continue to call and email, and I finally made headway this past summer. So at this point, the problem had grown and the repair became more complex. Because of the deformities on my feet, I can no longer wear my custom shoes. And because I'm unable to elevate my feet, my lymphedema has caused great swelling, and I have sores on my feet and legs that need medical attention. So as of last week, I am just waiting for a new cushion and minor adjustments, but the repair is considered complete. However, so much time has passed, we cannot fully correct the issue, and there seems to be no solution available to me. By their own admission, the solution to these repair delays is to hire more technicians. Yet New Motion states it's too costly to do so. But what about the cost to us, to our health, to our safety and well-being, to the 5,000 Connecticut residents who are waiting months in unsafe situations, sometimes completely bedridden, for their wheelchair to be repaired? New Motion and National Seating and Mobility will not fix this problem on their own. We need your help. Please adopt this bill as amended. Thank you.
Thank you, Ms. Emerald, and I'm sorry for all the problems you've gone through, but thank you for being here to share your experience. Senator Lesser.
Yes, thank you. The industry seems to be most concerned about potential penalties if they fail to meet the standards that are in this bill. Do you have any thoughts on that?
About their fear of the penalties, or about the
Do you
about
think,
having penalties?
do you think penalties are necessary, or is it a more
I-
collaborative approach?
I do, because I have not seen any real efforts in this past year while the task force was going on to make any significant changes. I've only seen a little change. I've seen a lot of backsliding. So without penalties and without strict regulations, I don't see any change happening.
Thank you very much.
Thank you. Thank you for your testimony today. Next, we'll hear from Kathy Ludlam, followed by Jonathan Sigworth.
Now, September, go to sleep. Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Chase, and members of the Human Services Committee. My name is Kathy Ludlam, and I am here to support SB 308, but also to support the recommendations, the amendments being included by the Connecticut Wheelchair Reform Coalition. I am a consultant and an advocate. I have spinal muscular atrophy, and I have used a wheelchair all of my life. While many of my professional activities have evolved to virtual after the pandemic, I still enjoy hiking, attending concerts, and going places with my friends. I used a power wheelchair for 40 years. When it broke down over the years, my locally owned small repair company quickly got me moving again. But then they were bought out by National Seating and Mobility, and nothing has been the same since. In 2021, my wheelchair stopped, and it kept stopping. And unless there was someone here to turn it off and turn it on again, I was just stuck. So never knowing where it would die next, in the hallway, in the corner somewhere, I started sitting by my desk so I could at least use my computer and phone, even if I couldn't move. MSM sent a technician that was a waste of time. He was nice enough, but he didn't know what to do. So I waited for him to come, and then I had to wait for another technician to come later, weeks later. The second technician actually bothered to run a diagnostic on the chair and said I needed new motors. 5 months later, someone came out to install the motors. That's when we discovered that the hubs that are supposed to always be ordered with the new motors were never ordered. So more delays. And it was a total of 7 months before my wheelchair was finally fixed. But by then, I had been sitting in one place for so long that I could no longer operate the chair safely. Not long after the chair was finally repaired, I crashed it. So I have been using a manual wheelchair ever since.
Ms. Ludlam, your time has expired. Can you please summarize?
Thank you so much. So I am generally supporting SB 308, but also the amendments. I encourage you to read my full testimony and to see the testimony by Jonathan Sigworth for more about the amendments. Let's make Connecticut a model of best practices for keeping people active and productive rather than bedridden and sick. Thank you for your time today.
Thank you for your time and thank you for sharing your experience with us. I don't see any hands. Have a great rest of your day. Thank you.
Thank you.
Next is Jonathan Sigworth, followed by David Morgana.
Thank you. Good afternoon. Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the Human Services Committee. I have been a manual wheelchair user for 18 years, half of my life. This wheelchair is not just a device, as you've been hearing, but it is a part of me, enabling my freedom and independence every day. As a leader and spokesperson for the Connecticut Wheelchair Reform Coalition, who is also a member of the Wheelchair Task Force, every wheelchair user who has been informed about what has been going on in the task force and the recommendations that have come out of it from the consumer advocate position have agreed that these changes need to be made and have agreed with the proposed amendments that I've submitted in my testimony, on behalf of the Connecticut Wheelchair Reform Coalition. The national wheelchair repair industry, as led by New Motion and National Seating and Mobility, cannot be trusted to resolve the ongoing wheelchair repair delay crisis on their own. They have been making a choice to perpetuate extreme wait times for in-home assessments and repairs while pressuring consumers to travel, which would be in my case, up to 100 miles for an in-shop visit for faster service. I was intending to come to the Capitol today, which is the same distance as the repair shop, but my car broke down this morning, just as an example of some of the challenges. 90% of the roughly 5,000 wheelchair users in Connecticut rely on in-home assessments and repairs because our wheelchairs are broken. The industry reported to the task force on November 2nd that the average wait time for being assessed remotely or in shop is within 4 days. It is perfectly reasonable to get an assessment within 4 days, while it is nearly a month to be assessed at home. After prior authorization and parts have been received, the wait time for in-shop is again 4 days, while it is nearly a month to have a repair conducted at home. At that time of the presentation, both companies simultaneously claimed that they were fully staffed with 16 in-home technicians total to serve 5,000 customers, and admitted that more staff is the solution. Why didn't they do anything to resolve this issue? It has only been through the relentless pressure from the task force discussions that each recently announced to hire 3 new technicians. This is not enough. Task force recommended a timely assessment and repair mandate to ensure that proper staffing levels are maintained, which SB 308 includes in part. You will hear that, of course, it costs more to hire staff, buy vehicles, pay for gas, etc., to conduct in-home repairs and assessments. But this is the cost of doing business for people with broken wheelchairs. Is it a suitable, cost-effective business practice in Connecticut to hold hostage a wheelchair repair for a month in order to pressure consumers to travel, putting their health and safety at risk for faster repairs?
Mr. Sigwith, your time has expired. Can you please summarize?
Yes, prioritizing cost effectiveness and profit over consumer safety is not acceptable. And I'm happy to answer any questions on our consumer advocate proposed amendments, which incorporate most of the missing recommendations from the task force, as well address some of the concerns about additional regs needing to be developed by DSS, among other things. Thank you.
Great, thank you. And thank you for your participation on the task force. Senator Lesser.
Yes, I want to echo my co-chair's comments and just thank you for your service on the task force. I know you had a big hand in it, and I'm grateful for it and your work to help the entire wheelchair community in the state. But just understanding what the task force did, it's my understanding that that I think you and others dissented from some of the recs because you thought they should be stronger. So what we have are some recommendations that were adopted by the task force, but then there are also additional. But then you also dissented from some of them as well. Is that correct?
We supported, so the first recommendation was for the timeline mandate of a range of less than 10 business days for assessments and repairs. We supported that there was a timeline mandate. We did not agree that the outer limit of that range of 9 business days was acceptable. If that is indeed what is mandated, that would still mean that wheelchair users are waiting a month total. If you take the assessment time and then the repair time, you're still waiting a month for a repair. If 2 months is bad, 1 month is still bad. We want to get it down to 2 weeks, as well as our recommendation is 4 business days. That would be similar to the wait time for in-shop assessments and repairs, which would also accomplish, I think, the task force recommendation number 4 which makes them equivalent, right? So that people are not being manipulated to do something that is unsafe and dangerous and impossible for them in order to get a faster repair by going into the shop. Again, there's just 3 shop locations in the state across 2 companies. So that is the main point where we disagreed.
Thank you. And I assume you're in support of the language in here that has penalties and regulations for compliance or non-compliance.
Yes, absolutely. I mean, without any kind of mechanism for compliance, there's no way that the industry will voluntarily impose upon themselves the additional cost that would be needed. So in addition to that, I think another important part is the advisory group, no matter how it meets, getting regular reports on data for delays, because that's something that we need to continue to monitor and track and have a mechanism to do that easily.
Thank you. Thank you for your testimony. Thank you, Madam Chair.
Thank you, Senator. Let me just check. See. No other hands. Thank you so much, Mr. Sigworth, for being here today. Next, we'll hear from David Morgana, followed by Marianne Langdon.
Hello, can you hear me?
Yes, we can. Go right ahead.
Hi. Hello, members of the Human Services Committee. My testimony today is about SB 308. My name is David Morgana. I had a car accident 27 years ago, which resulted in a spinal cord injury. I currently use a manual wheelchair. I'm a longtime disability advocate and recently served on the wheelchair task force. In the last 27 years, I've relied upon a durable medical equipment company for my wheelchair and repair needs. First known as the Connecticut Rehab, then the company changed into ATG and most recently transformed into what is now known as New Motion. There's also a second company currently known as National Seating and Mobility. So in practicality, a duopoly exists in the state. Ever since the private equity controlled company New Motion has come into existence, customer service has dropped off a cliff. It went from the customer being able to call in locally and setting up an in-home appointment that worked for the consumer, and this happened in a very short period of time, compared with now, when you call in,
Mr. Morgana, are you still with us? We can't hear you.
oh, hello?
Now we can.
Oh, sorry about that.
That's
Sorry,
okay.
call in locally and setting up an in-home appointment that worked for the consumer, and this happened in a very short period of time, compared with now when you call in, you get a call center in another state, and in some cases, even out of the country. You're not given a choice of a time for an in-home appointment anymore, and you're told the window of time the day before. You either take what they tell you or you leave it. Wait times have increased dramatically as well. Currently, it's a month or more to get an in-home appointment for an evaluation and or getting your wheelchair fixed. In addition to that, it's several weeks for parts to come in. So in total, a wheelchair user could be waiting 3 months to get something fixed in the home. New Motion has been manipulating wheelchair users by offering in-shop repairs in a much shorter time frame, within a week versus a month for an in-home appointment. And out of desperation, some wheelchair users go into the shop. New Motion even says it out loud in the wheelchair task force meetings and put it in print in their task force responses. Not everyone has a vehicle. Not everyone has the gas money. Not everyone can get out of their wheelchair unassisted if they could get to the shop, or the wheelchair is not able to be transported to the shop because it's just not possible. I just went through a repair myself. I was lucky enough to get an over the phone evaluation. This cut 30 days off my process. I waited over 3 weeks for parts to come in. Then after they got the parts, I was told if I wanted an in-home repair, it was going to take 33 days. I repeat, 33 days. So in total, it would have been about 2 months for me from the time I started the process if I would have waited for an in-home repair. This is absolutely unacceptable. It's ridiculous. But then I was told if I came into the Rocky Hill shop, it would be a week. So I could pick the time. I waited about a month already, and I couldn't wait another 33 days. to get my wheelchair repaired, so I picked to go to the in-shop appointment. This is what New Motion is counting on to increase their profit, the desperation of the wheelchair users that have already been waiting a month or more who can't wait another month for an in-home appointment. We need our wheelchairs and for them to be fixed in a timely manner. When the DME companies make us wait months to get our wheelchairs fixed, they are stealing our freedom away, they are stealing our independence away, and are robbing us of the ability to live our lives to the fullest potential. Wheelchair users in Connecticut need your help. SB 308 in its current form simply doesn't address the issues identified in the wheelchair task force in our or our urgent needs. That's why our group of advocates came up with new language for SB 308 to address the
Anna,
issues
your
and
time has
concerns.
expired. Can you please summarize?
Yes, I'm wrapping up right now. We have proposed common sense, reasonable changes and amendments. That language has been sent to this committee by Jonathan Sigworth. I urge the Human Services Committee to adopt the advocates' proposed changes and for all legislators to support our efforts to make life easier for the thousands of Connecticut wheelchair users and their families. Thank you.
Thank you. Thank you for being here and thank you for serving on the task force. Don't see any hands. Thank you for your testimony today. Next, we'll hear from Mary Ann Langdon, followed by Sheldon Taubman. Hello, welcome.
Hello, Chairs Gilchrist, Lesser, and members of the Human Services Committee. My name is Mary Ann Langdon, and Jill Bentavango, who is my personal assistant, will be reading my testimony that I have written for today's hearing. I am in support of SB 308, an act implementing wheelchair repair task force recommendations with the amendments proposed by the Connecticut Wheelchair Reform Coalition. A crucial amendment that should be a requirement is that wheelchair companies conduct an in-home or remote assessment within 4 business days of a request for service. Then within an additional 4 business days, they actually come to the home and make the necessary repairs. Within these 8 days, any necessary prior authorization and needed parts should be obtained. Power wheelchairs are an essential independent living adaptation that supports people with disabilities, including myself, to have independence and control over our lives. I have been a productive citizen because I have been using power wheelchairs for over 40 years. I am stuck with New Motion because the National Seating Mobility refused to work with me. They denied me the right of trying out various power wheelchair models before I ordered a new power wheelchair. My life stops when my power wheelchair breaks down. The length of time a service person takes to come to my home, obtain insurance authorization, and orders parts is way too long. The miscommunications begin at the start of the process since the service person who accesses and determines the needed parts does not communicate this to the appropriate department. I have waited a year for a new control box. I cried when I received my control box because the joystick was different and now I am not able to control my wheelchair well. The service person told me that the joystick came with the control box and that is nothing that they can do. In conclusion, I hope you will find how imperative supporting SB 308 is with the amendments. Thank you.
Thank you. Thank you so much for being here and sharing your experience. Next, we'll hear from Sheldon Taubman, followed by Jeffrey Mateski.
Good afternoon, Representative Gilchrist, Senator Lesser, Senator Seminara, Representative Case, other members of the committee. My name is Sheldon Taubman, and I'm the litigation attorney at Disability Rights Connecticut. We're the PNA for Connecticut, serving individuals with a full range of disabilities. I'm here to testify about the impact of 3 bills on people with disabilities, 307, 308, and 5455. I have 8 pages of written testimony. You don't want to hear that, and I can't do it. So I'll just answer a few things I heard today. On 307, I think the commissioner's concern can be fully addressed by just adding language to the bill as you have it, that just says that, or another consideration could be in deciding medical necessity, or the sources set forth in our existing medical necessity statute 17B-259B that covers everything in Medicaid. Second, with regard to 5455, the commissioner testified today that you don't need this report because we're already producing this data. That is not true. And in fact, one of the pieces of data in the bill specifically is wait time for the call center. They stopped reporting it. They stopped reporting on their website when advocates raised concerns that the data was inadequate. We need much more data. Attached to my testimony is an amendment, a friendly amendment to that bill, which will require regular reporting, not once, regular reporting on all this. Lastly, the wheelchair repair bill. The testimony about that the days would be unfair because they're waiting for prior authorization. No, that was the intention right from the task force, and the advocates substitute bill language attached to Jonathan's testimony says after prior authorization has been obtained. And in fact, the bill as drafted doesn't provide an out for waiting for parts. There's also an out for that. But assuming both of those things are met, 4 business days and 4 business days is reasonable, and it's basically the same as 10 calendar days. The Department of Social Services has all kinds of objections to this bill. It seems to be they were in 2 buckets. One was about the costs, and the other was about their ability to regulate, and it's outside their scope. On the costs, this is really relatively small stuff. And of course, anything that costs money in Medicaid, they always come and object and it's not the governor's budget. But one of the things I think Senator Lesser asked about this was this thing about assuming that preventive maintenance is going to have this huge cost. Well, actually, preventive maintenance, like preventive maintenance of cars, saves money. And when asked about it, they said, oh yeah, they actually didn't even think about that. So I think the cost issues are really not relevant, but I think the big one maybe is the enforcement piece. Enforcement is critical. Without enforcement, this is not going to happen. The industry has demonstrated that. So how can we do that? I think this bill is a really good way of doing it, saying DSS can regulate. The data in the task force report says 4,800 of the 6,500 custom wheelchair users in the state are on Medicaid. I'll just wrap up. And so basically it would cover most people, but DSS, there's several statutory schemes right now in which DSS has regulatory authority over private entities outside of being a payer. And in the nursing home industry, there's at least 3 different examples of that. But the point is that there's no reason DSS can't be charged with that. And the bill's written to say in conjunction with ADS, and the testimony from ADS, by the way, was rather supportive, I thought. So there's really a way forward. I think there's some work is needed on this bill per the advocate's suggested language change, but also some discussions are necessary. But I think this bill can really make a difference. And with enforcement, we can change this. Thank you.
Great. Thank you, Sheldon. And thank you for your participation on the task force and all your work on this. And good points about the nursing home. That came to my mind as well. So thank you. Any questions? Okay. Thank you for being here today.
Thank you very much.
I misspoke before. We already heard from Jeffrey, so we'll go to Jennifer Paradise. Is she with us on Zoom? Okay. Moving to Kristen Whitney Daniels, who I do see. Go right ahead.
Good afternoon, Chairwoman Gilchrist, Chairman Lesser, Ranking Member Case, Ranking Member Seminara, and distinguished members of the Human Services Committee. My name is Kristen Whitney Daniels. I am the co-lead of T1 International's Federal Working Group. We are a group of volunteer advocates raising awareness about the insulin price crisis and fighting for affordability in Connecticut and nationally. I think in this context, it's really important to note that we don't accept any pharmaceutical funding or any funds that would compromise or influence our ability to advocate. I'm also a Shelton resident, someone who lives with type 1 diabetes and other chronic illnesses, and also serve on the state of Connecticut's Healthcare Benchmark Steering Committee and co-chaired the pharmacy work group. I'm testifying today in support of Senate Bill 8 while asking for some improvements to the bill. I want to first discuss the PDAB, which I think really represents transformative policy. I'd like to refer the committee to my written testimony. I have some more technical details in there. But many of my suggestions are for improvement on ensuring patients are treated as experts. Patients are often appreciated for our feedback, but we're not given any power in any of these processes. Connecticut can change this. It should be mandatory that a patient sits on the actual PDAB board. The PDAB does not work if it does not work for patients. Their expertise and experience is really critical to the success. I want to talk a little bit more about my life as a type 1 diabetic, because I think it is one of the most egregious examples of pharmaceutical manufacturer greed. It's no secret that insulin has been the poster child of the drug pricing crisis. Insulin just celebrated its 100-year anniversary of discovery in 2022, yet a Yale study found that 1 in 4 patients with type 1 diabetes has had to ration their insulin. I am one of those 1 in 4, and I will never forget the day I searched trash cans for empty vials of insulin, looking for mere drops to prolong my life. I frantically searched for solutions and was denied, including Novo Nordisk's prescription assistance program. I'm one of the lucky ones. I found help, yet many diabetics died waiting for solutions from manufacturers. In response to this crisis, they've told us it's a shame people have lost their lives, yet refuse to acknowledge their part and complicity in this crisis. No one's willing to take a cut in their billions of dollars of profit. But people still cannot access patient assistance programs, and patients cannot access $25 generic insulin. And I really want to reiterate this because I know exactly what the talking points are going to be about the PDAB. But I know more people who are denied from the patient's assistance programs than being able to access them. And I have personally not been able to find the $25 Lispro anywhere in my area in Connecticut. These are not solutions, and we need transformative change like the PDAB, and we need it now. I also want to talk just a little bit about the language on insulin in this bill. I really applaud the committee for working to ensure people in the state plan have the most affordable insulin. However, they are one of the few groups of people who already have access to the state's copay cap. Roughly 70% of the plans do not have access
Ms.
to our
Whitney
copay cap.
Daniels, your time has expired. Can you please summarize?
Sure. And you can look at the bill language in my notes of having a program for uninsured and uninsured folks to have a safety net. And again, just reiterating that if patients can't access their basic medication to live, no amount of innovation matters. Thank you.
Thank you. Thank you for being here. Senator Lesser?
Yes, thank you, Madam Chair, and thank you, Kristen, for your work and over many years. It's noted and appreciated. I certainly understand and support what you're trying to do in terms of making sure that we've got patient representatives, in the bill, and I think we can certainly do that. I think that's a very reasonable suggestion. It'll be a little harder, but I think it's also important to expand support for uninsured residents, and I think we just have to get creative. I'll take a close look at your language, appreciate that as an issue. We certainly have sort of a parallel problem with folks who are insured but who are underinsured or have high deductible plans that prevent them from getting access to the benefits that we've already tried to institute. So more work to do, and just appreciate your thoughtful testimony on the PDAB and the importation and the insulin portions of the bill.
Great. Thank you, Senator. Thank you, Kristen. Have a great afternoon.
Thank you.
Is Julie Hall with us? All right. How about Ginny Hanbridge?
I'm here. Good afternoon, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Service Committee. My name is Ginny Hanbridge, and I'm the Executive Director for the Alzheimer's Association Connecticut chapter. The Alzheimer's Association leads the way to end Alzheimer's and all other dementia by accelerating global research, driving risk reduction and early detection, and maximizing quality care and support. Thank you for this opportunity to comment on the following bill, Raise Bill 307, an act concerning Medicaid coverage of biomarker testing. The Alzheimer's Association is very proud to support this bill as part of ACS CAN Coalition, along with other organizations. Additionally, this is a top priority in several other states now. As a daughter of 2 parents who lost their battle with cancer, I believe an earlier diagnosis would have had an impact on their quality of life and the choices they had for treatment and care. I believe this coalition represents the best interests of all families here in Connecticut who are dealing with a devastating disease and the impact it has on all our families. For the 80,000 people in Connecticut living with Alzheimer's disease or another dementia, an early and accurate diagnosis of Alzheimer's can also have great impact. There are now treatments available to those in the early stage of this disease that slow progression of the disease, and there are many more being developed. Early detection and diagnosis of Alzheimer's is even more critical to ensure individuals receive the most benefit at the earliest point possible in this disease progression. We know that this provides individuals with critical time they need to plan for the future, access care and support services, and reduce the financial impact of this disease. I have heard from countless families over the years and those who are living in the early stage of this disease about how hard it was to receive an accurate diagnosis and that it can be a grueling experience. This is largely in part because the diagnosis of Alzheimer's disease relies heavily on documenting cognitive decline, at which point Alzheimer's has already caused brain damage. The current FDA-approved biomarker tools, when applicable, can be used to aid in the diagnosis of people with symptoms of Alzheimer's or other dementia. For example, brain imaging or spinal fluid, a spinal fluid tap. But they're often used when this disease has already progressed. Experts believe that biomarkers offer one of the most promising paths to improving dementia early detection, diagnosis, and treatment. Thank you for the opportunity to provide comment today. I have submitted written testimony.
Thank you so much, Ginny, for your testimony and for the work you do. Seeing no hands, have a great afternoon.
Thank you.
Next, Jennifer Chadakowicz. I'm sorry.
Okay, that's usually my cue card.
Okay.
I'm up. People try to say my last name. Good afternoon. Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Heffernan, Fortier, and Comey. All right. Thank you so much for your service. My name is Jennifer Chudukowicz. I'm a registered voter in Cromwell, so thank you, Senator Lesser. I'm the Chief Strategy Officer for SCAD, which is Southeastern Council on Alcoholism and Drug Dependence. We are a substance use treatment provider with 8 locations, serve over 3,000 individuals a year throughout our continuum of care, and have nearly 200 employees. We are the trusted provider of treatment for substance use disorder for the vulnerable populations in Connecticut for over 57 years. My subject matter expertise spans organizational leadership, public policy, but most importantly, I'm a woman in long-term recovery. And for that means that I have been in recovery for 36 years. And a nod to Representative Fortier, I came into recovery when I was 18 years old, and my parents had access to treatment at that time, which was 1988. I'm almost 54. Just don't have to do the math. All right. So I want to thank you for the opportunity to testify for House Bill 5374, an act concerning annual inflationary rate adjustments and indexing them to our budgets for the nonprofits. We're primarily a DEMAS-funded agency at SCAD. I'm going to skip all of the thing. I'm going to go to 2 issues, and they've been covered unilaterally today, whether we were talking about other House bills or Senate bills. These are the 2 issues that keep coming up: aging properties and the cost of repairs, and the national staffing crisis. And especially in the state of Connecticut, I want to speak to our staffing crisis around licensed clinicians. There is a structural problem that I think needs to be addressed, and that's the discrepancy in licensing requirements between Department of Social Services and DPH. So DPH allows an associate's level license to provide telehealth counseling, and then you have residential treatment providers like SCAD, and we must have, to comply with DSS and Medicaid, master's level licensed clinicians providing care. So we really do, we would like to see some addressment of that issue as well, but we can't compete with the state of Connecticut. We can't compete with some of the private providers. I did hear the question earlier, and I texted our office and said, what's our frontline staff recovery tech entry-level position? We just increased that starting wage is $18 an hour, but that's not a living wage. So we'd like to focus our energy as subject matter experts treating your partners, your spouses, your children, your neighbors, your loved ones for treatment. We'd like to focus our energy on that. We'd like to focus on emerging technologies and innovation in the recovery field, not on the cost of 2x4s and whether we're going to repair a doorway or a threshold this week. We want to talk about the cost of healthy, nutritious food for our clients at a time in their life when that really matters. We want to talk about the workforce development and training of our staff so they can advance their careers and take care of their families. I'm summarizing. I see you reaching for it. Therefore, let us do the vital work that we are educated and called to do that not a lot of people want to do, but we want to do it. So take advantage of the surplus this year and implement the indexed inflation increase going forward so we can all get back to this work that we're called to do rather than spend our time coaxing our already burdened staff to testify. Thank you.
Thank you. Thank you for your humor. Thank you for being a woman in recovery who helps others in recovery.
It's my gift and privilege. Thank you.
And when you said the 18 an hour, are those the master's level folks?
No, God,
Okay.
that's entry level.
That's entry level.
But,
Okay.
and we did just reevaluate and restructure all of our pay bands last year, but we are still can't even come close to the benefits of the state of
Yeah.
Connecticut and the wages the state of Connecticut. And listen, we love Commissioner Navarrete. She knows I've testified about this before. But we, as a little nonprofit out in southeastern Connecticut, and I have very collegial partners right behind me that are going to testify in a few minutes, we work together to make sure that we've got overlaps and no gaps. So really important that we're able to offer a living wage, a thriving wage, a competitive wage. And we're just not able to do that unless we can stay with inflation.
Yep. Agreed. Thank you. Any other?
Thank
Okay.
you.
I don't see any hands. Thank you so much.
Thank
Next, we'll hear from Aaron Saylor, followed by Joanne Bordeaux.
Thank you. I'm excited I got the chair right this time. Sorry about before. Good afternoon, Representative Gilchrist, Senator Lesser, and members of the Human Services Committee. My name is Aaron Saylor, and I serve as the Chief Operating Officer at Child and Family Agency of Southeastern Connecticut. Our agency provides behavioral health, medical, and supportive services to over 10,000 children, families, and adults annually across New London, Middlesex, and Windham counties. Our team of over 260 professionals works tirelessly to deliver high-quality services to those in need. Thank you for the opportunity to testify in support of House Bill 5459 and Act increasing Medicaid rates for certain providers. In Eastern Connecticut, a service gap persists driven by the growing number for behavioral health services. Emergency department visits for mental health related concerns in children aged 5 to 11 have increased by 24%. And children aged 12 to 17, there has been a 31% increase. Our comprehensive service array is inadequate due to the workforce shortages that my colleagues have spoken about and the need outpacing our capacity, resulting in wait lists for critical services. The stagnant Medicaid rates and funding constraints have forced us to make difficult decisions, including the closure of our intensive in-home child and adolescent psychiatric services program and the reduction of our intimate partner violence and reunification programs. ICAPS, a fee-for-service funding ICAPS has a fee-for-service funding structure which predominantly bills Medicaid insurance, led to steadily increasing deficits and ultimately program closure in 2022. This has had a profound impact on families with children aged 6 to 11 in crisis, leaving them without a vital resource. Currently, we have 3 clinician vacancies in our outpatient clinics due to our inability to offer competitive salaries. Our deficit budget leaves us with no room for negotiation. Our dedicated staff, despite their passion and commitment to our mission, are seeking better paying opportunities elsewhere, jeopardizing our ability to retain top talent. A recent study by the executive branch underscores the underfunding of Connecticut behavioral health services. The state's Medicaid program spends less than half of what comparable states allocate, resulting in operational deficits for us and leaving many underserved or worse, unserved. An increase in Medicaid rates would not only help us retain our skilled staff, but also attract new talent, allowing us to respond to community needs and reintroduce essential services like ICAPS to our region. I urge this committee to support House Bill 5459. Thank you for your time and consideration.
Thank you so much for your testimony and for being here today.
Thank you.
I don't see any hands. Have a great afternoon.
Thank you.
Thank you. Joanne Bordeaux, And then we're going to go to Julie Hall, who's on Zoom.
Good afternoon, Senator Lesser, Senator Seminara, Representative Gilchrist, and Representative Heffernan. Thank you for the opportunity for my testimony today in support of House Bill 5456. My name is Joanne Bourdois. I am the CEO for Community Health and Wellness Center and FQHC with locations in Dorrington, Winstead, and North Canaan. I appreciate the time today to have to be speaking with you, so that there is an understanding of how Medicaid rates impact access to care and the patients and the populations that we serve that are the most vulnerable in our states. Our health center has been established over 20 years ago. We provide, like our colleagues and other FQHCs in the state, a safety net for those that are underserved, uninsured, and most vulnerable, excuse me. Our health center services 30,000 visits annually. 65% of those patients are at or below 100% of poverty level. 51% of our patients are enrollees of Husky, making up 3,000 patients, and 13% of our patients are uninsured. In Section 2 of the bill, we need to address Medicaid rates for Connecticut's community health centers, which were set initially in 2002, based on allowable costs from 2000 and 2001. Since that time, we have only received minimal annual adjustments required by federal law through the MEI index. Only a small number of health centers have been successful in achieving rate increases through the Department of Social Services change in scope process. Healthcare delivery and costs have risen dramatically since 2002. While we appreciate the concerns around fiscal solvency for the Medicaid program, we can no longer be the solution to absorb those costs. I appreciate, as do my colleagues, the committee's recommendation to rebase rates based on our current 2023 costs and to clarify and improve the change in scope process. Regarding Section 2B, community health centers cannot set caps on the number of Medicaid patients like other private practice providers. And we are happy, and our staff is happy, to serve those patients, and we are dedicated to doing so. 60% of all health center patients in Connecticut are Husky enrollees. Health centers cannot cost shift by charging commercial providers more to make up for low Medicaid rates, causing a higher impact on operational costs for the health centers. Our statewide association, CHC Act, has recently hired an expert in both Medicaid and federally qualified health centers to do our rate study instead of waiting till next year for that to happen. His research shows, excuse me, on average, that health centers lose $85 for each medical visit and $122 for each dental visit. As a result, in aggregate, health centers lost over $75 million in 2022 from those two services. My organization's payment gap annually is $1.6 million. I know I'm out of time. The last thing I wanted to address was to please consider our language regarding the change in scope process. It is flawed, it is a broken system, and we need to start fixing things instead of another 20 years of discussion. Thank you very much for your time. I'm happy to take questions.
Great. Thank you so much, Senator Lesser, followed by Senator Seminara.
Yes, thank you for your testimony. Thank you, Madam Chair. I have a question about something a little bit different, which is
Sure.
about 340B contract pharmacies.
Yeah.
Is that something that you would encourage us to incorporate language protecting patient access to 340B contract pharmacies?
Yes, so we have some of my colleagues will be giving some more detailed testimony on 340B, but yes, we have an issue with the restrictions that are being placed on contract pharmacies. It is also something that is creating a barrier for patients in terms of being able to afford medications, especially those high cost medications.
Okay, well, I don't want to jump the gun and I want to hear what they have to say, but I did know that we were sort of treading water for a while because there was legislation that was moving forward in other states in litigation around that. And I believe today the 8th Circuit Court of Appeals in Arkansas ruled to uphold Arkansas's law regarding contract pharmacies. And so it's possible that that legal development that just happened a few hours ago may clear the way for similar legislation to at least be considered in this state this year. So
Yeah.
thank you for that, and
Thank
appreciate
you.
your comments on the rest of the bills.
Thank you so much.
Thank you. Senator Seminar.
Hold,
Wait, oh, I'm so sorry.
Hi, Joanne. So
Hi,
good to see you.
Nice to see you.
And thank you for everything you do. I have visited the facility and so always impressed by all of the services you offer.
Thank you.
I did have two questions. Do you currently have a waiting list for any of the services?
We do. We have a larger waiting list for dental, which right now is currently first available appointment is, I would say, about 6 weeks, primarily because of the workforce shortages in that industry. We finally were able to bring on another hygienist and a second dentist, so we're hoping that we'll be able to shorten those timeframes. Medical is also a challenge, primarily because we are challenged with recruiting providers. The workforce demands on salaries have increased since the pandemic. As an FQHC, we try our best to be competitive with other providers in the area, especially hospitals. But financially, it is sometimes not possible for us to meet those demands. So our vacancies for providers ebb and flow. And unfortunately, when we have a vacancy in providers, it causes appointment and access times to be pushed out.
Sorry about that.
Okay.
So is there a waiting list currently for the medical?
There, right now, we have about a 3-week wait list for medical. We've done some strategies around shortening that up, even though we do have some provider vacancies. So we've looked at increasing our open access time, same-day appointments. We just recently tried to, we're piloting open later hours so that we have some additional access in the evening to try and get folks in. But medical is experiencing about a 3-week wait, and behavioral health at this point is about 2 weeks.
Okay. All right. Thank you so much for letting me know that.
You're very welcome.
All right.
Okay, thank you.
Okay, thank you.
Great. Julie Hall, followed by Dante Britis. Dr. Dante.
Good afternoon, Representative Gilchrist, Senator Lesser, and committee members. My name is Julie Hall. I'm the Chief Program Officer at Sarah Inc., and we operate the Kid Steps Birth to 3 Early Intervention Program. I'm testifying today in relation to HB 5459, and we want to thank you for including birth to 3 providers in those that would be seeking adjustments in Medicaid rates. We're talking about funding for birth to 3 services that comes from not only the OEC and DSS, but also Federal Part C and CMS, and all sharing in how we support programs. But recently, as Elaine Balsley shared, our OEC commissioned a rate study where the results confirmed that the cost of birth to 3 services were not meeting were not matched with reimbursement. And that loss is of 29% deficit in the budget already. So for every dollar we expend to provide services to children and their families, the reimbursement rate is 71 cents. This is so unacceptable on so many levels. And so I know that not anyone here is arguing about whether birth to 3 services are effective. We know they are. Elaine spoke to the benefits related to special education costs in the school system and how we reduce those. There's a lot of other areas and parts of the economy that we help stimulate as well. But I just want to talk to you about the biology at the moment. And that I'm not sure if you're aware that between the ages of 2 and 3 years old, that's when the most number of neural synapses are forming in the brain. And it peaks, I should say, the number of peak. And what happens is those synapses that are strengthened through experiences, they continue to adhere and grow and form deeper connection. And those that aren't, they weaken and they get pruned out. So after that age 2 to 3, when that peak is hit, the brain starts pruning out those things that are not getting used. That sort of use it or lose it. piece. And that's why early intervention is so important. In the first 3 years, we have the opportunity to make the biggest impact. And here's the problem. We have shortages that are making it difficult to hire new staff and recruit new staff. It's also making it difficult to keep the staff that we currently have, because those that are staying are getting burned out. They're tired, they're absorbing the caseloads. As Elaine had shared with you before, there's been an increase of 49.5% in the number of referrals since 2017 when these rates were first implemented. And they were implemented as a best guess, because these are not the same rates that you pay for physical therapy and occupational therapy and speech therapy, et cetera. These were based on early intervention and the work that happens. And I liked hearing Sarah Egan's speech today in her testimony, calling this about the fire. This is a 5-alarm fire. Well, in Bertha 3, it's very similar. We have been talking about the challenges and not
All your time is
budget.
expired. Can you please summarize?
Yes, thank you. So I guess the bottom line is we can't wait. We can't wait another year for rates to be implemented or changed. And it really needs to happen now for the kids and for the programs. And so we don't lose this great service that's in the state of Connecticut. Thank you.
Thank you so much. Thank you for your testimony and for being here. Is Dr. Dante Britis with us? I don't believe so. How about Jesse Sargent? Oh, yes, Dr. Britis is with us. My apologies. Go right ahead, sir.
Good afternoon. Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. Thank you for the opportunity to provide testimony on behalf of the 240 orthopedic surgeon members of the Connecticut Orthopedic Society concerning HB 549, an act increasing rates of Medicaid reimbursement for certain providers. Our society members appreciate the commitment by the members of this committee to address abysmal reimbursement rates to physicians and other providers caring for Medicaid patients. My name is Dante Britis, MD. I'm an orthopedic surgeon in Fairfield. I'm the president of the Connecticut Orthopedic Society. The Medicaid program is the most important safety net for at least 25% of our state's population for healthcare access. There has been no increase for reimbursement for physician specialty services since 2008. This is an egregious oversight that threatens the access to healthcare for our most needy patients and citizens. This committee has recognized this problem and taken the important steps in moving the issue to the forefront of the legislative agenda. The current bill addresses the $7 million allocated last year for specialty rate adjustments. Unfortunately, this sum just does not address the problem. The committee also has in its hand the Phase 1 report, Studies of Medicaid Rates of Reimbursement, which highlights Connecticut's woefully inadequate reimbursements when compared to Medicare, as well as 5 other direct state comparisons. As we previously reported, the current state Medicaid reimbursement for common procedures is 40 to 60% less than Medicare reimbursement. To highlight the disparity between reimbursement levels, we have provided previously a chart showing the difference between Medicare and Medicaid reimbursement. Basically, for an office visit, Medicaid reimburses $40-something, Medicare, same type of visit, $90. $40 doesn't open the lights. This is not sustainable. Medicaid reimbursement needs to be elevated to Medicare fee schedule. There's no need for further studies to provide this information. Another area that's not been considered in Medicaid reimbursement arena is appropriate payments to ambulatory surgical centers. A two-part problem exists. Facility fees have not been updated for over a decade. In addition, implants, which are important for orthopedic care, anchors, joint replacements, are not covered by the Medicaid fee schedule in an ambulatory surgical center. This results in the fact that ASCs can't do these cases. It deprives Medicaid patients of a cost-effective, high-quality care at ASCs, and it forces the state to pay more for higher costs of the procedures to be done in the hospital. The COS would like to work with the committee to add language to this bill that would provide for cost-only reimbursement policy for implants to treat Medicaid patients. We'd also like to institute a pilot program to perform joint replacements in Medicaid patients in an ambulatory center. We believe a program like this can help provide access for our underserved patients while saving the state significant dollars. We realize that these matters represent a budgetary challenge for the state. This
Dr. Burness,
challenge-
your time has expired. Can you please summarize?
Yes. This challenge can't be ignored. It's not a political problem. It's a human problem. We're creating a two-tier system which disadvantages 25% of our state. Not addressing the issue now after 15 years is neglect of an active vote to support systemic prejudice against our most needy. The orthopedic community and physician colleagues support you in correcting this flawed system.
Thank you so much, Doctor. And we will be sure to go back and look at your testimony with your recommendations. I appreciate it.
Thank you very much.
Have a
Appreciate
great
it.
afternoon.
Thank you.
Next is Jesse Sargent, followed by Elaine Kolb, both on Zoom.
Hi, my name is Jessie Sargent, and today I'd like to share my perspective as a developmental therapist and quality support manager for Sarah Inc. at Kids Steps Birth to 3 program. As you imagine, I'm sure you're aware that the families that we support are facing unbelievable challenges. Not only are they providing the care and support for their own children, their grandchildren, their foster children during the day-to-day hardships of life, but they're doing this while caring for children with developmental delays or complex needs at a critical time of development. I'd like to tell you a quick little story about a family that I worked with to give perspective regarding the scope of our work and the need for ongoing support to focus on funding for not only the work that we do, but the additional training necessary to support the families that we work with. I met with the caregiver who was appointed a guardian for their oldest grandchild living in this tiny apartment. The guardian was working full-time, caring for elderly adults while the grandchild was at school. The guardian had recently become a foster parent to 2 additional younger children under the age of 3 when I started working with them. They shared with me that the Department of Children and Families had recently removed the children from their home, and the father was currently incarcerated. They explained the traumatic event that had taken place in the home a few weeks prior to them being removed. It involved finding their mother in the home with a newborn baby. And this was not only the guardian was visibly shaken from this experience, but she was most concerned with what the children saw in that moment and the impact it would have on them. As a developmental therapist with 15 years of experience at that time working in birth to 3, I was without words. Not only did this guardian support in figuring out how they were going to help the current grandchildren in our care, but also asking, how is she going to keep the job that they had and continue to live in the apartment and provide a place for them to live. They were concerned about they might not have the energy to care for the 3 grandchildren and possibly a newborn baby that might be placed with her. But nothing prepares you for these types of situations. As a birth to 3 provider like me, trained as a developmental therapist, we face these things in homes while we're building relationships with families. However, with the additional training in areas such as trauma, infant and family mental health, and more, we can utilize the tools that we've acquired to do our best in the moment to support these families and help them to begin to rebuild no matter what the situation may be. Whether it be finding a daycare with multiple spots for their children to go so they can continue to be on the same schedule, the caregiver can go to work, or finding mental health supports, finding diaper banks and food banks, finding housing. The list goes on and on. I'm sure you're well aware of that. But we meet the families where they are, where their needs are, and we support them in becoming confident and competent in their skills to help their children. Not only regarding their children's developmental needs, but also to advocate for themselves and the children that they care for. The trainings I'm speaking about come at a cost, which is challenging with the current funding structure that has been flat for years. So I asked you to support the bill and the funding for birth to 3 services moving forward as they're recommended to implement the recommended rate for services provided to children and families in birth to 3. Thank you.
Thank you, Jesse. Thank you for being here, for your work, and for your testimony.
Thank you.
Next is Elaine Kolb, followed by Bill Garrity.
Hello, I'm Elaine Kolb, and I have been actively involved in human and civil rights struggles for over 50 years now. I was one of the people who helped to get the Americans with Disabilities Act passed over almost 34 years ago now. And we're still fighting for everything every day. I applaud all of you, the officials, the workers, and the consumers, the people with disabilities with lived experience, who are the true experts on who it is we are and what we need. I encourage all of you to do whatever you can to help fix this broken system and help people survive in the meantime. I was injured 46 years ago. I was literally stabbed in the back when I was 28. And in 1978, I had to allow myself to be institutionalized in order to get accessible housing and transportation. We've come a long ways, but right now there are thousands of people right here in the state of Connecticut that are trapped in institutions or their own homes because of services that we need. I know I have a limited time, and I'm going to sing. Have you been among the people that hardly go anywhere at all? Do you try to forget us and pretend that we're not suffering at all? Now, some could be your family, your neighbors, or your lovers, or someone who has been a friend to you. The roots we find are all entwined. They hold the world together, bringing forth the gift of love, still shining through. But the rolling freedom riders are rolling onto freedom in this land. Some chairs are pushed by motors and some by the strength of arms and hands. Yes, we need to repair wheelchairs. We also need to provide them more effectively. It is still very hard for some people to get a wheelchair, although they desperately need it. And other equipment and adaptive equipment readily available. The technology is available. It's right there. It's right there, just beyond reach. We can correct this. We can raise. I support everyone who is supporting raising the Medicaid payments.
Ms.
and
Cole,
helping all
your
of-
time
yes,
has expired. Can you please summarize?
This is a human rights issue. Ableism is a public health crisis. Our lives are precious. We are not expendable.
Thank you so much for being here and for your years of advocacy. Senator Seminara.
Thank you, Madam Chair. Good afternoon. Elaine, I just wanted to thank you very much for your enthusiastic endorsement of what we're trying to do here. I very much appreciate all of your years for advocacy, and it is not lost on any of us. So we thank you again, and keep working at it, and we will as well. Thank you.
Well, I'd just like to say that I'm 74 and I'm becoming more medically fragile. So, like lots of people in the state of Connecticut, I need more services that I don't qualify for right now. So please do whatever you can to raise things up. And I appreciate your efforts. Thank you.
Thank you. Thank you very much. Have a great rest of your day.
Thank you.
Is Bill Garrity with us? And following Bill will be Brenda Bryant.
Elaine's going to be tough to follow. I'm tearing up. I think I've taken care of her before. I'm an emergency room nurse. I think I've actually taken care of her before. Good evening, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. I'd like to take this opportunity to speak in favor of Raise Bill 367, an act concerning a study of maximizing Medicaid reimbursements for UConn Health Center. I am by no means the expert, and I've enjoyed listening to a lot of testimony today. I think you're going to learn a lot just listening. My name is Bill Garrity. I'm a registered nurse of 34 years with 20 years invested in state service. I'm the president of University Health Professionals, AFT Local 3837. I represent 3,200 members in education, research, and healthcare at UConn Health. I'm also the divisional vice president for public employees at AFT Connecticut, representing 30,000 members. This year, the Medicaid reimbursement issue has really come to the forefront for me at UConn Health. One line that I heard from the UConn Health CEO, Dr. Bruce Liang, has haunted me since I first heard it. We are undercompensated by $104 million annually due to Medicaid reimbursements. Where is this money? That was my original thought. Is it not coming from the federal government? Is it coming and being held up at the state level? Are we at UConn doing something wrong? What do we need to do to see these $104 million? If this proposed study is going to help find that missing funding, I'm a full-throated supporter. If we find that $104 million, would that turn our deficit into a surplus? My math says it would. We're fighting for funding every year at UConn Health. Our clinical and research enterprises are growing at a rapid pace. If you don't know, we had to be on diversion again not too long ago. We've got an emergency certificate of need ask going on. There are patients everywhere that need the help, as you can hear from all these other people. I lost my place. We care for more uninsured and underinsured Connecticut residents every year. This funding could make the difference in everything at UConn Health. I cannot come up here to testify, no matter what committee I'm in, and not say something about privatization at UConn Health. Again, we are growing. Please do not let UConn get carved up and sold off. I'd like to again thank you for your time and ask if there's any questions.
Thank you so much, Bill, for being here today. I didn't realize it was that big, so the 104 million annually is quite a number. Any question? Senator Semino.
I just wanted to make a comment. You are very, very correct that we learned many, many things from hearing testimony. And I'm so glad that you came to provide yours. So thank you so much for coming and waiting. And I know we have a room full of people waiting, and we say this all the time, but your testimony means very much to us, and we appreciate you taking the time out of your busy day.
Thank you very much.
Thank you. Thank you so much. Have a great afternoon. Brenda Bryant, followed by Dr. Frank Vesci. Brenda is on Zoom.
Good afternoon. Good afternoon, Representative Gilchrist and members of the Human Service Committee. Thank you so much for taking the time to sit and listen to all of the people who are here today. My name is Brenda Bryant. I'm a licensed clinical social worker, and I'm employed as a high school social worker at Raymond Hill School in New Britain, Connecticut. We are a small part of the larger Klingberg family in the same area. And I'm here to support the act concerning the annual inflation rate adjustments for the nonprofit sector. One of the greatest challenges we're facing at the school that I work at is the recruitment and retention of qualified employees. This doesn't come as any surprise, as I've heard over the morning about the similar state that many of my peers are in. In a report released by the Connecticut Education Association regarding shortage details, there was a 16% increase in students needing special education services between 2014, 2015, and 2019 to 2020. My school services primarily all special education students. Alternately, the data in the same time frame indicated that only a 3% increase in special education endorsements for qualified educators. So we are getting this huge influx of students who are coming in looking for and needing this extra support. We just don't have the resources to be able to provide it in many cases. This data doesn't include what's transpired since the pandemic. And what information I was able to get from the Connecticut.gov was that the enrollment of students who are classified as needing special education services has increased almost 5% since the 2015 school year. Again, I heard from so many people today, much earlier, about the state of our special education system. The low pay scale for credentialed teachers and paraprofessionals in the private sector continue to be an enormous barrier to recruiting qualified long-term employees. And ultimately, this is leading to a workforce that is financially undercompensated and consistently managing the needs of our students while so understaffed. I'll tell you a little bit about my personal caseload. I work primarily with teenagers who are involved with the juvenile justice system, who are chronically absent from school. I have one particular student right now of many, but one student who was just released or discharged from a residential facility and is at home because we do not have the staff to be able to properly support him in the classroom. This is a kid who I speak with every single week to make sure that he knows we're still thinking about him and we still want him here, and who wants to come to school. We simply do not have the resources to support him. These students who return to our school because of the amazing people that I work with, we are a trauma-informed small clinical school. These kids come here because they know who we are, they know our system, they know the caring education that we provide, but we continue to be woefully understaffed with our paraprofessionals, our direct care staff, and our special education.
Thank you, Brenda. Time has expired. Can you please summarize?
Sure. Really just to say is that we are looking for support in the rate adjustment so that we can bring about staff who are not only qualified and looking out for these children's best interest, but who can be compensated equitably to our, public school and state employees. So thank you so much. Appreciate everything you guys are doing and taking the time to listen to us.
Thank you so much. And thank you for taking your time to testify. Next, we'll hear from Dr. Frank Vecchi, followed by Diane Rakakot.
Good afternoon, Representative Gilchrist and Senator Lesser. My name is Dr. Francis Vecchi. I'm a past president of the Connecticut Chiropractic Association, and am representing the association today with my testimony in favor of Bill HB 5459, an act increasing rates of Medicaid reimbursement for certain providers. I've been a practicing chiropractic physician in Britain since 1994 and have had the opportunity to treat a variety of patients with a variety of insurance benefits. During this time, it's become increasingly evident that treatment of a patient with Medicaid as their only insurance is woefully under-reimbursed as compared to a patient covered under Medicare. The chiropractic physician treating a Medicaid patient will typically bill the CPT code 98940, which is a 1 to 2 area spinal manipulation, or 98941, which is a 3 to 4 area spinal manipulation. These codes are reimbursed by Medicare at $23.14 and $35.60 respectively, while Medicaid reimbursement is $15.12 and $20.72 respectively. Additionally, because evaluation and management codes, also known as E&M codes, are considered a non-covered service, the cost to a new or returning Medicaid patient's evaluation is shifted to the patient. My office estimates that over 40% of new Medicaid patients who call our office will decline making an appointment when they learn that they must pay for their examination. As a result of these disparities in reimbursement and non-coverage of services, many chiropractic physicians opt not to accept any new Medicaid patients or not enroll in the program altogether. This results in the patient population either paying for services out of pocket or seeking treatment that is more costly to the program and or provides a less effective outcome for the patient. So introducing a more equitable fee schedule for chiropractic manipulation, as well as evaluation and management codes, will likely incentivize those practitioners who have not enrolled or who have disenrolled from the Medicaid Husky program to reconsider their position on participation in the program. Cost-effective treatment with documented positive outcomes is a win-win for all. So with this in mind, I strongly encourage you to vote in favor of HB 5459. Thank you very much.
Thank you very much, Dr. Becci. I don't see any hands, so thank you so much for your testimony today. Next, we will hear from Diane Rakakot, followed by Aaron McCleary.
Good afternoon. Thank you, Senator Lesser and Representative Gilchrist. I'm here to speak today on some opposition to SB 308, just primarily in regards to the language, how it is currently written. My name is Diane Rakakot. I am the Vice President of Payer Relations for National Senior Mobility. In my role, I work with all the insurance plans, including CMS, Medicaid, advocacy groups, and understanding the negotiation improvements and policy coverage for our members. In turn, I work with our field operations team to understand and execute those policies and those agreements that are in place. In addition, I did work with the wheelchair task force on the repairs, and I urged what Beverly spoke to earlier in her testimony to re-review those recommendations that were brought up during those meetings and recommendations. Some key points I just want to oppose of why we're opposing some of this is in SB 308, Section 1, Notation 5. The timeline is not really clearly defined as to the 10 days for the request of repairs. It's the 10 days after approval, once received from the insurance, as these do take a little bit of time. Also, what's not addressed, when a PA is not required, but we still need to get an RX, a script on file, that could take time. When does the clock start on those? Please note, when we're looking at these type of things for a provider, we need to make sure we're succinct to be compliant. These things often take a little bit of time when we're waiting for authorizations to come over, 8 to 10 business days, typically, depending on which one's reviewing. In addition, once we do that, we'll order the parts, or if we use a standard easy fix, we'll get that on a calendar to do it in a home, because over 90% of our repairs are done in the client's home, which are typically already scheduled 2 to 3 weeks out. So we really do need clarification on that section. And Section 2B, Part 2, we need a little bit of better clarification on what sufficient parts are for inventory. Keep in mind, we work with over 8 to 10 different manufacturers. Each of those chairs, if it's a highly configured chair, can have 25 to 30 what we call HCPCS codes. And each of those chairs from the manufacturers are individually configured in proprietary parts. So to outline what is sufficient, we typically have routine repairs, which is tires, batteries, armrests, swingwear, hardware. We'll have those, but we need a better understanding of exactly what is the requirements around this. Section 2C, we do not have the authority to impose fees and acquisitions, as was shared by the commissioner at the first speaker. These insurance plans, including Medicaid, we can't do these things outside of our labor charges and payments for the parts that we do. This is part of the struggles that we're dealing with at this time. Those are something we have no power, and that's part of the disagreement probably within the committees and from the insurance during our time. The last two sections that are in this written policy is line 187C, prior authorization, as was already shared by the other insurance plans spoken today. We don't have the ability to remove that. That needs to be done to help save some time. Again, the script saves some time, but again, as much as the committee wanted this to happen, this is still in the hands of the Medicaid and the insurance policies. Preventive maintenance, which is not currently covered, nor is it covered by CMS or anybody else. Again, is another thing that's a great thing that we both agreed upon from the consumer and provider side. This needs to be put in and mandated. Again, these are the struggles I think we're going to run into with the current way 308 is written. Please note, we know there's an issue. We've been addressing these policies and these challenges over the past couple of years. COVID didn't help, as everyone heard during the hearings, but I urge the team to kind of relook at the things, and to the point that Beverly Brakeman stated earlier, relook at what the recommendations of some of the challenges we're going to do as a provider. And I do thank the committee's time. We do care about this getting solved. We do want it to get solved. We don't want anybody waiting longer than absolutely necessary for repairs. And I do thank you for your time.
Thank you, Diane, and thank you for your participation on the task force and for your testimony here today. I don't see any hands. Thank you. Have a
Thank
great
you.
afternoon. Next is Erin McCleary, followed by Suzanne Lagarde.
Hello, good afternoon. Good day, Senator Lesser, Representative Gilchrist, and other members of the committee. I'd like to thank the entire Human Services Committee for the opportunity to speak with you today regarding raised House Bill 5459 with regards to increasing Medicaid reimbursement for providers. I am Dr. Erin McCleary, a board-certified optometrist who is licensed and has been practicing advanced optometric care in Connecticut for the last 17 years. I'm a past president of the Connecticut Association of Optometrists, live in West Hartford, and currently own and practice at Clear Horizon Eye Care in Plainville, Connecticut. First of all, I'd like to applaud the committee for seeing the benefit and the need of raising the reimbursement rates for Medicaid providers in the state. Medicaid coverage is providing critical care to a notable amount of adults and children in Connecticut, yet the number of providers who are willing to provide this care is dwindling due to stagnant reimbursement rates. By showing the providers within our state that you see them as providing a valuable service to those who often need the most care, you're indirectly paving the way to potentially expanding the number of providers in the future. As an optometrist, I subspecialize in pediatrics. I can tell you that the decreasing number of providers accepting Medicaid is directly impacting the care of our youngest constituents in the care that they receive. There's a perfect example in my own practice happening right now, last week and this week. Some children are born with cataracts, which subsequently need to be removed very soon after they're born or when it's identified. Since these babies are so small, surgeons are unable to insert a new artificial lens at the same time as the surgery. This leaves the child something that's called aphakic. It means that they do not have a lens in their eye that can focus the light clearly. If this is not corrected, ideally with specialty contact lenses, these children have a very high likelihood of becoming visually impaired. While there are pediatric ophthalmologists in the state who provide the surgical care within their institutions, notably think places like CCMC and Yale, their very own optometrists are not fitting these Medicaid-covered children with these sight-saving specialty lenses because the institution loses money on the reimbursement for their time, the materials, and their expertise. This is where I come in. Somehow, my ophthalmology colleagues around the state have discovered that I'm willing to fit these children, even at a loss, because I care more about their vision than my bottom line. But this is untenable. I cannot be the only provider in the state who is willing to see these children to take care of their needs and also accept Medicaid. This is where increasing Medicaid reimbursement rates is so needed. By valuing providers' time and expertise, you'll help keep existing Medicaid providers, like myself, but awfully hope to add to our number. However, this is where I would specifically ask to make sure that optometry is included in the first round of increases. I'm a specialist, as demonstrated above. While I subspecialize in pediatrics, all optometrists are specialty providers in the eye care space. We are treated as physicians within Medicare, and we use the same examination and surgical codes as our ophthalmology colleagues. Moreover, not only should optometry be included in the first round of increased reimbursements, but we should be at the same level of reimbursement as our ophthalmology friends and colleagues. In my example that I spoke of, the surgeon and myself are providing two halves of the whole visual care for these children. They have to take out the cataract, but I have to subsequently fit that child with specialty lenses to ensure that they'll be able to get adequate visual development. My role in these children's lives is no less important than the surgeon. I would even challenge that I am more important in this scenario because while they take out the cataract, that child will never develop vision without my subsequent care. In closing, I thank you for seeing the need to increase Medicaid reimbursement for providers. Please ensure that optometry specifically is included in the first round and that we receive equal reimbursement levels, fee, pay parity to our ophthalmology and medical colleagues. I thank you for your time for today.
Thank you. That's very helpful. And I'll be sure, I think many of us will, to go back and look at your testimony. So thank you for being here, Erin.
All right. Thank you.
Next, Suzanne Lagarde, followed by Kara Capone.
I don't see Senator Lesser here, but other members of the Human Services Committee. My name is Dr. Suzanne Lagarde. I'm the CEO at Fairhaven Community Healthcare and FQHC in New Haven. We serve over 34,000 unique individuals annually, providing primary care, behavioral health, dental, substance abuse treatment, and extensive care coordination services. There are so many important bills before this committee today, but I'm going to devote my 3 minutes or less to speaking in strong support of 5456 and 5459, specifically on the issues of Medicaid reimbursement, and I'll touch briefly upon the issue of e-consults. In defiance of CMS statutes, DSS has repeatedly denied FQHC requests for rate adjustments. Health center leadership has tried repeatedly over years to ensure that federal statutes are followed and that our patients have access to the care and resources that they deserve. To date, our efforts have been unsuccessful. And as you all know, we are paid on a prospective payment system method, and this is intended to be a cost-based system with a methodology in place for us to submit changes in scope, that is, changes in the volume, quality, or type of service that are associated with incremental cost increases. And the state is required by federal statutes to adjust rates based on these requests. Unfortunately, rate increases are rarely agreed to by DSS. In the past year alone, at least 6 health centers requested rate increases with legally appropriate support, and they were all denied. I know that a state-funded Medicaid rate study, phase 2, is currently underway with results due in early 2025. However, CHC Act engaged an outside consultant to compile a comparison of Medicaid medical rates across the country. A copy of that study is attached to my previously submitted testimony, but Connecticut is by far the lowest in New England and ranks among the lowest nationwide, just above Georgia and Florida. And I'm truly sorry that Senator Lesser is not here, because I do want to refer to his comments this morning around Governor DeSantis in Florida. And if you could share with him that when it comes to FQHC Medicaid rates, we're in close competition with Florida, but Florida is beating us out barely. I also want to just say that you heard this morning testimony from the commissioner about the cost of rebasing would be so high. I don't disagree with that. It's a lot of money, but the reason it is so high is for 23 years since BIPA was passed in 2001, there have been very, very, very few rate increases done by the state of Connecticut. Had those been acknowledged when they were appropriately submitted by health centers, we wouldn't be having this conversation today. So yes, rebasing is high, but it is because of the action of the state over the past 20 plus years that this is in fact necessary. I also want to refer to her comment about the lack of subject matter expertise. We appealed one of their decisions, and we were accorded a hearing. And in that instance, we brought in our own, at our cost, a subject matter expert. They fought us furiously against submitting his testimony. So it's clear that it's a question of the type of subject or who's providing the subject matter expertise, not just subject matter expertise alone. In closing, I just want to say I am thrilled that finally DSS is acknowledging the true value of e-consults. You heard that this morning from the commissioner. E-consults are a win-win-win. They're a win because referrals are done within 24 to 72 hours, improving access enormously. They're a win because specialists are seeing patients who need their precious time for more complicated issues. And they're a win because they save the state large sums of money, millions. So I am thrilled that we have support from DSS on this, and I encourage the legislature to continue to pursue this option during the current session. Thank you so much for all you do. There's so much on the table, so much that's so important, but I truly appreciate all that you do for us today and throughout the year. Thank you.
Thank you, Dr. Lagarde, and right back at you. Thanks for all that you do and for always using your voice up here to educate us. Thank you.
Thank you.
Representative Hughes.
Thank you, Madam Chair. Thank you, Suzanne. So 2 things. One is your testimony is that subject matter expertise is subjective. And 2, how many more folks do you think you could be serving if we brought the Medicaid reimbursement rates up for federally qualified health centers? Can you talk about that a little?
Hard to give you a number. I can tell you that the rate limiting step right now in our health center is capacity, and it's capacity of providers. Providers are expensive. They're also, as you know, there's a workforce shortage, so the 2 go hand in hand. one feeds the other. But certainly if we could pay our providers a more competitive rate, I think there are many out there who would opt to work with us because it's a wonderfully holistic system whereby we're not only caring for diseases, but we're trying to really promote wellness. So I don't really have a number that I can give you, but I am absolutely confident that it would be significantly greater. The other thing I just would urge you to consider is it's not just also the number of patients that we would see, but the breadth and the depth of services that we would be able to provide. I mean, every day I have to make decisions about I'm going to do this, but I can't do this, right? And, you know, and I recognize that we can't be everything to everybody, even to all of ourselves who are more fortunate to have more conventional coverage of healthcare. But some of the decisions are really hard. I'll just give you the example of dental. I would put before this group that the crisis on dental is as bad as the crisis on behavioral health. The number of people clamoring for dental services is enormous. Yet last year, just my little health center, I only have 5 dental chairs, 2 dentists. We lost over $400,000. And my service is entirely a combination of Medicaid and uninsured. I can't, if I doubled, I could easily fill twice that number of chairs, if assuming the workforce issues weren't problematic, I could fill them, but I would lose twice $400,000. It's just not tenable. So there are, it's both numbers of people served, but it's also the quality and the breadth of services we already offer.
That's super helpful. Thank you. Thank you, Madam Chair.
Thank you. Senator Simon.
Now you've piqued my interest to ask you a question. Over and over and over, I've heard about the dental issue. And I'm wondering, do you too have a waiting list, and how long does it take for one to get an appointment?
So that's a complicated question. So it's in the hundreds for sure. But we have a policy where if somebody calls and says they're in pain, we see them, right? We don't turn away someone who's in pain, whether they have Medicaid or whether they're uninsured. And that sort of makes life a little more difficult because we see a lot of those patients. You know, the piece of dental legislation that's in one of these, I forget which one it is, one of these bills has to do with our ability to see patients and provide both prophylaxis, you know, exams, hygiene, and dental exams at the same time. It's very, very complicated. And I guess I would just say to this group that our ask to overturn the way that policy was written 2 or 3 years ago is because of how it was subsequently interpreted in a provider bulletin, which not only doesn't pay us, which is one issue to be sure, but also really has made it clear that not providing coupling those services in the same visits is somehow we are providing inferior care. And I just want to tell you, I'm a physician. I've devoted my life to trying to make things better for people. And to be told that I'm providing inferior care when in fact, I have a patient who can't sit there any longer and has to leave, and I only have one other provider. Or I have somebody who doesn't speak English. I'm fortunate. I have bilingual, both dentist and hygienist, but I'm seeing people now from Afghanistan and speaking Pashto and Darcy, and we're dealing with phone translation, which by the way, DSS used to cover and no longer covers, but that's another story. So it's complicated, right? Lives are complicated and it's not black and white. So long-winded way of saying dental is a huge problem. It is a huge problem and I can't fix it under the current system.
How much do you think you're losing on an annual basis with your dental services?
So for us, our dental services, which is small, 5 chairs, 2 dentists, and I also have 2 hygienists in the schools. Last year, we lost around $400,000. And that's, again, combination of Medicaid and uninsured. And that's why I can't expand, because I don't see a way that expand, you know, sometimes expansion gives you efficiencies that makes you be able to be more cost effective. I don't see a path that increasing services will do that. It will simply multiply my 400,000 if I double it to 800,000.
Okay. Thank you very much. I really appreciate your testimony.
Great. Thank you.
Senator Lesser had texted me a message for you, but he's here now.
Good afternoon. So I'm just disappointed that you thought I might not be listening to your testimony. That certainly would not be the case, and appreciate it. Just with regard to the dental issue, and I may have missed it if this was just asked, but the report obviously on the Medicaid first phase rate study on dental at first glance found that compared to peer states, we're actually doing well, which I think it's just that Medicaid programs across the country don't invest sufficiently in dental. And I was just trying to figure out how we look at, if you have any thoughts about, as we look at the rate study as it comes back and we have the first phase and we're going to get a second phase subsequently, how do we disentangle, all right, how are we doing compared to other states that are also not doing a good job of this versus where should we invest our critical resources to ensure access? How do we get to that second question, given the data that we're getting back? Because just looking at the chart, it says huge problem for behavioral health, huge problem for physician specialists, but hey, dental is great. But that's not really what your boots on the ground experience is. That's not what I'm hearing.
So I think it's a bit complicated, and I, your numbers may differ when you look at the FQHC world as opposed to Medicaid reimbursement in general. As you know, it gets complicated when you look broadly because Medicare doesn't cover dental as well in other states. So that's an issue that I think, we should feel okay about on our end because we do, or at least we cover adults. And all I can tell you is that based on our Medicaid cost report, this is Fairhaven's cost report for 2020, for fiscal year 2023, which ended June 30th, 2023. We lost an average of $121 on every Medicaid dental visit. I think the problem is because we see such advanced pathology by the time they get to us. And but again, I wish I could give you more hard data. That's as much hard data as I have. I know that we're losing money. I know that the demand is great, and hopefully we can work together to solve the problem.
Thank you.
Thank you. Thank you so much for being here.
Thank you all so much. Appreciate it.
Next is Kara Capone, followed by Matt Blondin. Oh, Kara, you're speaking, but we can't hear you, even though you're not on mute.
Hold on one second.
There we go. We can hear you now.
Okay, got it. Great. This is what happens when I try and plug my headphones in. It's an absolute crapshoot. So good afternoon, Senator Lesser, Representative Gilchrist, and the distinguished members of the Human Services Committee. My name is Kara Capone. I'm the CEO of Community Housing Advocates, an affiliate organization of both Mercy Housing and Shelter and My Sister's Place. Thank you for the opportunity to testify in support of HB 5374. I did submit testimony, so I'm just going to go through a couple of things. As the head of an organization serving approximately 4,000 people annually experiencing homelessness and housing instability, both in Hartford and Middlesex counties, and employs about 130 staff, the impact on chronic underfunding has been incredibly difficult, to say the least. Our state contracts have not kept pace with inflation and therefore have contributed to our inability to pay staff what they deserve, with some of our staff even qualifying for the services that we provide. We're having problems with recruitment and retention. People are leaving for state jobs, or they're just leaving the field in general because of burnout, because there's so much chronic understaffing happening right now. It's hard to hire qualified staff who want to work with incredibly difficult people to serve, who are struggling with housing instability and homelessness, and trying to bring them an appropriate level of care has not been easy. And so because of the turnover, we see the negative impact on people that it's our mission to serve. And it's hard to have constant turnover and then our staff kind of trying to, build relationships with the folks that we serve. And it's just not good quality of care for us. So I did want to say I appreciate the increases that we've had. It's just not enough to keep up. And now that wage has been indexed to the rate of inflation, that's absolutely going to impact us down the road sooner, probably rather than later. if our contracts aren't indexed as well. So one of the things that wasn't in my testimony that I want to talk about, because I've heard the questions asked, is, what are we paying for our positions? And so according to the National Low Income Housing Coalition in Connecticut, in order to afford a 2-bedroom apartment as a head of household, you would need to make about $32 an hour, which comes out to around $66,412 per year. So our maintenance staff, for example, start off at $16 an hour at entry. Our residential aides who work in our residential buildings on second, third shift weekends, they make around $17 an hour. And our case managers, who are the ones really doing the case management services, care coordination, they do a lot of the clinical services, although they're not considered clinicians. They're making around $20 an hour. So I just wanted to put it in perspective, because ultimately, one of the things that if we didn't have to come back year after year to ask for these increases, it would be wonderful. It would be fantastic. We would be able to have a stable staff who would be able to help folks. We'd be able to serve more people. And as you guys know, we're seeing record increases in homelessness in Connecticut. And the truth of the matter is that it would be great not to have to spend so much of my time fundraising for 25% of my budget, or figuring out how to be 3% more efficient every single year. And after having to do that since 2007, that's 17 years, we're kind of tapped out on the whole efficiency thing. So I just wanted to thank you for your time, and I'm happy to take any questions if anybody has any.
Thank you so much, Kara, and thank you for sharing that information. I think it's just really helpful when speaking with folks to actually know what the starting pay is, because to your point, it costs a lot to live here. Representative Hughes?
Thank you, Madam Chair, and thank you so much for your from the trenches testimony. Having worked in human services my entire professional life, I feel you. Talk to me a little, two things. One is I wondered where you're losing staff to, what sectors, and secondly, you talked about really cutting funding since 2007 and trying to create a leaner budget. Is that largely due to our failure as a government to really keep up our end of the bargain with the community development block grants?
So two things. So I'll answer the first question. We're losing people to private sector. So folks are leaving the field in droves. It's hard. The work that we do is hard. We're dealing and working with and trying to problem solve housing for folks who have chronic mental health issues, substance abuse issues, have lived in and currently living in poverty situations. We're working with people who are on the streets, who are living in places not meant for human habitation, and it's hard. So if somebody's going to start off making $17 to $18 an hour, they can do that or make more at Amazon. They could do that or make more at Target without the aggravation, without having to mentally bring the job home in your head like a lot of us do. And so we're not finding people who are interested in these jobs. So we're not even doing the recruitment that we need. I think there's been an underinvestment on the state education system to try and at least figure out a way to provide scholarships for people who are interested in going into human services. I think that goes back to, if I've got to get a college degree to do the work, and for a lot of our case management positions, we do require at least a bachelor's degree, that the cost of college is so exorbitant that you're not going to pick a field where you can't even pay off your student loans, let alone your rent. So we have a problem with the inflow of people coming in, and that's causing the employment shortage. And then we have an outflow where either people are going to state jobs because we can't compete with the benefits, we cannot compete with the pay. And so we're seeing that, or they're just leaving just to do something else. They figured out, this is not for me, I'm going to go do something easier. So that's what we're seeing on the front lines of human services. The second question is around, pay rates and increases. And yeah, I mean, the federal government hasn't kept up with inflation. We realize cuts there for some of the HUD funding that we get in to do housing. And also that, you know, we have an administrative rate that we need to keep up that nobody ever pays. So we're always trying to fundraise for that as well. And just the contracts have not won. A lot of our housing contracts haven't been annualized, right? Especially around cold weather shelter. So that would certainly help solve a problem there. But you know, in general, it hasn't kept up what happened for us is after 2007 was 2008, which was the housing crisis. And so it was, okay, do more with less, do more with less, do more with less. And so within my organization, which is Community Housing Advocates, we're an affiliate organization, meaning we have 3 organizations merged under this one CHA umbrella. And so we've tried to become efficient. We have one HR department, we have one IT department, we have one suite of chiefs, you know, so we're not duplicating executive salaries. We're being absolutely as efficient as possible. And we're to the point where we're so lean, we're at the bone. And that means cutting services. So ultimately, if we continue to see this increase in minimum wage, we can't keep up. We've either got to hire people at higher rates and then just decrease significantly the number of people we're going to be able to serve if we have to take those types of steps.
Thank you. This is really helpful. Thank you, Madam Chair.
Thank you. Not seeing any other hands. Thank you, Kara, for being here today. Next, we'll hear from Matt Blondin, followed by Anita Aurora.
Hello, my name is Dr. Matthew Blondin, and I'm here to speak in favor of House Bill 5459. I've been an optometrist practicing in Torrington, Connecticut since 1979, and I'm also an adjunct professor of law and public health at the University of New Haven. I currently serve as the chairman of the Connecticut State Board of Optometry, a position I've held for more than 10 years. I practice with my son-in-law, Dr. Michael Shea at Blondin Shea Eye Care, with offices in Torrington and Kent, and more than 50% of our optometry practice services Medicaid patients. We are essentially the only remaining large private optometry practice serving Medicaid patients in the entire northwestern part of Connecticut. Over the last 5 years, our payroll and other operating costs have almost doubled, while the Medicaid reimbursement rates have remained the same for more than 2 decades. This is no longer viable or sustainable, and I'm here to ask for your support for this bill on behalf of all optometrists throughout our state that service Medicaid patients. I'm also asking that within the bill, optometrists be recognized for what they are as optometric physicians, providing physician specialty services to Medicaid patients across Connecticut. Optometrists have long been considered physicians by Medicare and use the same ICD-10 codes for billing services with ophthalmology, including treatment for glaucoma and external ocular disease. In addition to being included in the first round of proposed reimbursement increases, I'd also ask your support in adjusting and updating the reimbursement rates for optometrists to the same reimbursement rates as ophthalmologists, as optometrists are currently receiving only 90% of the fees that ophthalmologists are receiving for identical billing codes and services rendered, which is completely unjust and unfair. And that is not the case. That is not the case with Medicare, only Medicaid. The issue not only concerns the fairness and need to increase Medicaid reimbursement rates for optometrists, as well as bringing them optometric billing parity with ophthalmologists. It's a social justice issue, preventing the creation of provider eye care deserts for those most in need. That would happen here in this part of the state and certainly in a lot of the metropolitan areas. Without our Medicaid provider services, thousands of patients from the very young to the very old would essentially be denied their right and entitlement to eye care services as providers such as myself and my son-in-law find it no longer economically feasible or possible to care for them. You know, I'd like to thank you for your time and consideration and all the good work that you do. And I ask for your support for bill number 5459. Thank you very much.
Thank you, Dr. Blondin, for your testimony and for being here today. Seeing no hands, have a great afternoon.
Thank you very much.
Next, we'll hear from Anita Aurora, followed by Stephen Girelli.
Hi, thank you. Can you hear me?
Yes, we
Looks
can. Go
like-
right ahead.
Thank you. All right. Senator Lesser, Representative Gilchrist, and members of the committee, thank you for the opportunity to express Yale Medicine's support for Section 8 of House Bill 5459, enact increasing rates of Medicaid reimbursements for certain providers. I'm Anita Aurora, Assistant Professor of Medicine and the Associate Chief Pop Health Officer for Yale. And I'm joined by Erica Spatz, Associate Professor of Cardiology and Associate Professor of Epidemiology at Yale University School of Medicine. And we're testifying on behalf of Yale Medicine, which is a large multi-specialty practice for the School of Medicine, which has been committed to providing care for patients in our community. Section 8 of House Bill 5459 would instruct the commissioner to develop policies for authorizing electronic consults and to provide Medicaid coverage for them. It would, we believe, improve the quality of healthcare for patients enrolled in Medicaid, and we encourage the committee to advance the bill. Our Yale eConsult program was developed in 2018 to address 3 priority areas for patients and clinicians. 1, to increase access to specialty care. 2, to make care more efficient and patient-centered. And 3, to reduce specialty care burden brought on by curbsides or staff messages within the electronic medical record that take time, are uncompensated, and do not become part of the patient's electronic medical record. In our experience overseeing the completion of more than 7,000 e-consults, we have found that e-consults are a vital component of care, supporting primary care providers with timely specialty expertise. The tool maximizes the capacity of primary care providers to manage low complexity specialty care problems, replacing the need for in-person consultation. We also note that e-consults replace the need to wait to see specialists, take time off from work, and to find transportation for those visits. Through surveys of primary care providers and specialists engaged in the program, we note high satisfaction and a reflection that the tool improves quality of care. For these reasons, for more than 4 years, Yale Medicine has supported e-consults for the New Haven population, with specialists completing e-consults regardless of insurance coverage. In the long run, this approach may not be sustainable. Since we launched our program in 2018, Medicare and many private payers have started to reimburse for e-consults. In addition, in a letter from CMS in January 2023 to state officials, they allowed coverage of Medicaid for e-consults. The letter specifically noted that allowing direct payments to consulting practitioners improves access to specialty care that may not otherwise be available, supports patient-centered care, and holds the potential to maximize the capacity of the existing workforce. They go on to note that CMS encourages states to take advantage of this flexibility in their Medicaid and CHIP programs. In conclusion, we strongly recommend that the committee approve House Bill 5459, which will help to improve the quality and efficiency of healthcare provided to patients enrolled in Medicaid. Thank you.
Thank you, Anita, for being here today and for your testimony. Next, we're going to hear from Stephen Girelli, followed by Kelly Memphis.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, and distinguished members of the Human Services Committee. My name is Stephen Girelli, and I'm the President and CEO of Klingberg Family Centers, a multi-service agency based in New Britain, whose mission is to help build healing relationships that empower children and families to reach their full potential. We pursue that mission through over 20 programs and services that last year helped 5,000 children and families from 118 municipalities. Thank you for the opportunity to testify in support of House Bill 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers. This bill would help community providers to stabilize their budgets and provide much-needed additional services to the state's most vulnerable populations. Without it, further reductions in the availability of services are a foregone conclusion. While I'm grateful for the increases you have provided over the last few years, they have not kept pace with inflation, nor been nearly adequate to meet the dramatically growing needs of the people we serve. Specifically, since 2007, we have experienced inflation of 45%. The legislature provided increases equal to about 13%. That delta of 32% has had devastating consequences. Our escalating costs due to inflation, exacerbated by the current workforce crisis, far exceed those funding increases. As a result of inadequate funding, we are facing unprecedented staffing shortages that threaten our ability to provide much-needed services. Klingberg currently has 30 vacant positions out of 320 employees, a vacancy rate of nearly 10%. Many of those positions have been open for months. Also, inadequate funding has contributed to staff turnover rates exceeding 1/3 over the past several years. These shortages seriously reduce the specialized services we can provide at a time when the need for them is growing exponentially. For example, we are currently serving 25% fewer families in our outpatient clinic. Our trauma specialty service has a 2-month waiting list. Our after-school clinical program is operating at only 65% of its normal capacity. The capacity of our visitation program has dropped by 20%, and 2 recent inquiries for one of our group homes had to be declined. If our funding over the past 17 years had predictably and reliably kept pace with inflation, Klingberg would have been able to expand services in a strategic and planful manner to meet the dramatically increasing needs of Connecticut's children and families. For the reasons I have cited, I urge this committee to support House Bill 5374. Thank you for your time and consideration.
Yep, sorry about that. We were having a little difficulty here. Thank you so much for your testimony and for the work you do, and definitely going to go back and look at your testimony for that information you shared, in particular the trauma. Did you say the trauma services are a 2-month?
Yes.
Wow.
Yes. Thank
Senator,
you.
Yeah, Senator Seminara has a question.
Oh.
I too was going to comment that while you were speaking, I was writing down, you said if this funding wasn't provided, there would be reductions, but clearly there are reductions happening now. So I will go back and look at your testimony. Do you foresee further reductions, or what areas, I should say, would you see further reductions being made as a result of that?
I want to be clear, when I say reductions, I mean not program elimination, at least not at this point, but reductions in the capacity of the existing programs. Those programs that rely on licensed or unlicensed psychotherapists are the most at risk, because the for one, there's a lot of need for that in our programs. For another, there's a lot of competition for those people. We lose staff and we lose candidates to the local school systems, who pay much better, to the state, which pays much better, to private practice, because now that that telehealth is permissible, it's much easier for someone, and much more affordable for someone, to work in private practice than it had been prior to COVID. So those are all threats. Additionally, because of the nature of the work we do, the training and experience of our staff, as well as the longstanding relationships that they develop with clients, is especially critical in doing trauma recovery work. And when we have a high turnover of clinical staff, those relationships are repeatedly disrupted, and they forestall the healing process for our survivors of trauma.
Okay, I appreciate your clarity. Thank you so very much. And thank you for everything that you're doing.
Thank you. I appreciate the opportunity.
Yeah, thank you so much for being here today. Next, we will hear from Kelly Memphis, followed by Jim Malfoy. Is Kelly with us? Okay, Kelly is not with us. Is Jim? No? Oh, there he is.
Hello.
Hello, go right ahead.
All righty. Good afternoon, Madam Chair and members of the committee. My name is Jim Matthews. I'm the CEO of the Children's Center of Hamden. We have a 190-year history of meeting the unique behavioral health, educational, and emotional needs of Connecticut's children and families. On average, we employ about 200 Connecticut residents at any given point in time. I thank you for the opportunity to testify in support of HB 5374 and HB 5459. These important bills would immensely help community providers stabilize our budgets and provide additional services to the state's most vulnerable populations. Inflation, as you heard Steve just say, on the cost of our services since 2007 is 45%, while the legislature's only been able to provide increases equal to about 13% in the last few years. Throughout today, you have heard, and I'm confident will continue to hear, numerous providers and individuals express their concern about the state's behavioral health system and the devastating impact inadequate funding has had on providers and patients alike due to the lack of annual contract COLAs and Medicaid rates that don't cover the cost of services. Each year, my agency faces numerous challenges just regarding continuing to be able to provide services. This past year, we saw a 25% increase in our medical insurance alone. That's a $700,000 increase. And many of our incredibly caring and compassionate staff are deciding to leave children's services in the nonprofit sector to take, for them, less rewarding jobs, but jobs that allow them to provide for themselves and their families, many of whom have worked for us for more than 10 years. And fitting with our mission, we choose to be part of the state's behavioral health service system, a system designed to provide access to care for the most needy, and a system that is primarily funded through state contracts and Medicaid reimbursement. But while my colleagues and I operate our agencies with sound business principles, the fact is we don't get to set our rates and our fees as one would in a typical free market. Our service rates are set by Medicaid or a contract with one of the state's agencies, and the rates are significantly below the cost to provide the service. It's not only unreasonable, but unsustainable to place the burden on individual agencies to fund the difference. For 30 years, I've sat in rooms and heard my colleagues express concerns that inadequate funding would one day impact Connecticut's behavioral health system. Earlier today, I heard the Child Advocate and others express that this is a 5-alarm fire. My analogy is the behavioral health system ship in Connecticut is at serious risk of sinking. What you've heard today is about a system in crisis. Our funding deficits are real. They impact real people with real emotional and behavioral challenges. It's time for the state to take real action to properly fund nonprofits. Please support HB 5374 and 5459. I thank you all for the opportunity to testify and for your time today and all your efforts throughout the year.
Thank you, Jim. Thank you for being here and for your testimony.
Thank you.
Next, we'll hear from Stacy Lawton, followed by Richard Albrecht.
Good afternoon, Madam Chair and members of the Human Services Committee. My name is Stacy Lawton, and I am the Chief Executive Officer of the Southeastern Council on Alcoholism and Drug Dependence, more commonly known as SCAD. SCAD is a nonprofit agency that provides mental health and substance use treatment for individuals who may not be able to afford treatment otherwise. Our programs are located in Norwich and New London and Lebanon, but we serve residents from all areas of the state. Our target population are folks who have very little resources. They are not the privately insured patients that are seen in the for-profit sector. Altogether, our agency provides 176 beds, outpatient services, community outreach, and education. Last year, we admitted just under 3,000 people into our programs. We have 185 employees, and we are seeking to fill 45 open positions within the agency. Thank you for the opportunity to testify in support of House Bill 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers. I want to start by offering our appreciation for the support that you've provided to nonprofits over the last few years. Your actions offered validation and acknowledgement that the services that we provide are necessary and critical, and that the people that we serve matter. I'm here today to tell you how important this bill is for SCAD. This bill will help to stabilize our planning and our program development year over year. It will help us to stabilize our workforce and the benefits that we can offer to our employees. We help people manage the crisis in their lives every day. Our budgets should not be part of the crisis that we have to worry about. We continue to experience crippling increases in our costs, food costs, fuel costs, insurance costs, the cost of simple repairs and maintenance, never mind the astronomical costs of bigger projects and keeping up with our technology. These are not luxuries, but they are absolute necessities. And speaking about absolute necessities, you may have heard about the workforce shortage. For us, the shortage of clinical staff has had a direct impact on the services that we provide. We have had to delay admissions to our withdrawal management program because of staffing shortages. We've had to reduce our capacity in our residential programs because of staffing shortages. Imagine that you're a family in crisis and you finally get your loved one to agree to go into a program, and that program says, "I'm sorry, but we can't take you today." In our work, timing can literally mean the difference between life and death. The behavioral health needs of the state are growing and the demand for our services is increasing. We are just not going to be able to meet the need unless there is sustainable change to the way that the state approaches funding. I strongly urge this committee to support House Bill 5374 and to enable agencies like SCAT to planfully meet the needs of our community. Thank you very much for your time and for your consideration.
Thank you, Stacy. Thank you for being here today and for your testimony. Next, we'll hear from Richard Albrecht, followed by Kelly Memphis.
Good afternoon. Can you hear me?
Yes, we can. Go right ahead.
Great, thank you. So Senator Lesser and Representative Gilchrist and distinguished members of the committee, my name is Richard Albrecht, and I'm the Telehealth Network Director for the following 7 federally qualified health centers: Generations Family Health Center in Willimantic, Charter Oak Health Center in Hartford, Staywell Community Health Center in Waterbury, Fairhaven Community Health Care, Cornell Scott Hill Health Center, Optimus Healthcare, and Southwest Community Health Center, both of the latter in Bridgeport. I'm pleased to be here today to offer additional remarks in support of Section 8 of House Bill 5459, which, if enacted into law, would enable vastly improved access to specialty care for Medicaid patients and save the state Medicaid program millions of dollars annually. Section 8 of this bill calls for the Commissioner of Social Services to develop policies and procedures authorizing e-consults as a means to improve timely access and cost-effective specialty care for Medicaid enrollees. The 7 community health centers that I represent have a significant interest in e-consults. These centers provide integrated primary care to approximately 200,000 Connecticut residents, the majority of which are enrolled in the state's Medicaid program, and who often must wait months to get an appointment with a specialist. These delays occur across Medicaid and represent a significant inequity that e-consults can help mitigate. You see, without a policy and coverage to enable primary care providers to utilize e-consults, they have no choice but to refer a patient to a specialist for an in-person visit. This results in millions of dollars in unnecessary, you can call it wasted medical costs annually, as low complexity medical conditions that could have otherwise been resolved in the more efficient primary care setting with some timely advice from a specialist are instead referred to that specialist for an in-person visit, resulting in much higher cost to the state. These lost cost savings were clearly quantified in 2018 when, at the request of DSS, actual Medicaid specialty claims data from 2016 was analyzed to determine the financial impact of the use of e-consults for just 8 of the most commonly used medical specialties. Now, I assisted in that analysis, and that's partly why I'm here today. It was found that with reasonable reimbursement to PCPs and specialists, just for their time and effort to perform the e-consult, the state could realize an annual net savings of $6 million in year 1. Now, that was only for 8 of the 40 plus medical specialties that are generally referred from primary care. And also consider this, that analysis was done in 2016 dollars. today, that figure of $6 million in savings is probably at least double. And it's important to note, there is no weight on the investment or the return on the investment for e-consults. It's immediate. That analysis we did with DSS showed that for every $1 spent on e-consults, there was a $6 savings to the state in that same year.
Richard, your time has expired. Can you please summarize?
Sure. Simply stated, a good e-consult policy saves the state money and improves access to care for those who most need it. And for this reason, we strongly urge the committee to advance House Bill 5459. Thank you.
Thank you so much for your testimony, and we'll definitely go back to look at those numbers. Representative Johnson has her hand raised.
Thank you so much, Madam Chair, and thank you for your testimony today. When we think about e-consult, I just wanted to have you help us out a little bit with the, is he still there?
Yes.
Okay. Help us out a little bit with the e-consult problems that you have in terms of making the referral immediately versus having the patient go directly to the specialist. Sometimes we run into difficulties, say for somebody trying to get an analysis from a specialist based on trying to help the person with, say, get disability benefits through the Social Security Administration. I just wondered, you know, some of the difficulties that you're faced with now, the delays, and also the delays probably exacerbate medical conditions. If you could help us out with that.
So what we typically see is that for Medicaid patients, there's often as much as a 6 to 12 month delay in some specialties, just because of, I would say it's likely because of two primary problems. One is the limited number of slots that many specialists keep in their schedule for Medicaid specialists, or for Medicaid patients. And I believe the other contributing factor is that a lot of those slots end up getting scheduled with patients who probably could be seen in a primary care setting if we had access to an e-consult policy.
Thank you for the clarification. Thank you, Madam Chair.
Thank you, Representative Johnson. Thank you again, Richard, for being here today.
My pleasure. Thank you.
Next, we're going to go to Kelly Memphis, followed by Aaron Nielsen.
Good afternoon, Senator Lesser, Representative Gilchrist, and members of the committee. Thank you for your patience with the technical issues earlier. My name is Kelly Memphis. I am with the Healthcare Distribution Alliance, HDA. HDA is the trade association representing the nation's wholesale pharmaceutical distributors. Wholesale distributors are unique entities in the supply chain. We don't set list prices or bring drugs to market or play a role in what patients are paying at the counter. Rather, we are the conduits. Our members are the conduits who ensure over 10 million pharmaceutical products are delivered to over 360,000 sites of care nationwide every single day, including over 3,200 such sites in Connecticut. I'm here today to share some concerns with SB 8. We do appreciate the intention of the bill to address some of the costs that patients see for drugs, but we have some concerns regarding the wholesale importation section of the bill, which we wanted to note for the committee. We are concerned about the potential of such drugs to open the U.S. supply chain to counterfeit or substandard drugs. We are also concerned about the ability of such programs to work together with federal law, specifically DSCSA, which is a law that is going into effect now, which would require every single pharmaceutical product to be traced from the individual level all the way from the lot down to the patient. This has been a 10-year process to implement this traceability law. And right now we're in a stabilization period. FDA pushed back their enforcement of the law for a year to try to allow the US supply chain to get on board with this new track and trace requirements. And it's not clear to us how a Canadian importation program could work together with these very secure and very specific track and trace law that's going into effect now. We also would like to note Canadian opposition to the program. Both the distribution counterparts in Canada, as well as the Canadian government itself have stated that they do not want to participate in such a program, that there's not enough supply. So we do believe a state like Florida will ultimately spend a lot of money trying to meet a lot of very strict standards that FDA has put forward as part of their approval, and not really be able to access enough supply to bring savings to their patients. So we do oppose that section of the bill at this time. There's another section of the bill I'd like to just address quickly, which is the Prescription Drug Affordability Board section. We just want to raise some concerns regarding an upper payment limit, a UPL, which would be part of the purview of such a PDAB. Upper payment levels applied at the state level don't reflect the fact that drugs are largely bought and sold at the national level. So Medicare Maximum Fair Price is a national program that will achieve the savings through a number of means. And we're concerned that trying to replicate that at the state level may ultimately disrupt the supply chain in Connecticut and disrupt patients' timely access to it. I know it's been a long day and I'm running out of time, so I outlined my concerns in a letter that's posted online. So just would like to request the committee to review those before moving this bill forward to see our concerns. And thank you so much for the time today to speak to them.
Thank you, Kelly. Thank you for being here and for your testimony. I don't see any questions. Have a great afternoon.
Thank you.
Next, we'll hear from Erin Nielsen, followed by Kyle Kramer.
Good afternoon, honorable members of the Human Services Committee. My name is Erin Nielsen. I'm a lifetime resident of Connecticut. I'm also a mother of 2 beautiful girls, cancer survivor, and I'm here today to share my testimony and encourage you to support Bill 307, an act concerning Medicaid coverage of biomarker testing. 5 years ago, I was diagnosed with breast cancer. And as you can imagine, for any mom, and it has nothing to do with me being a mom, but for anyone to be receiving a cancer diagnosis, it's overwhelming. There's a lot that runs through your mind. That was what was happening for me. And one of the things that helped me along my journey was the blessing of being afforded the opportunity to have biomarker testing done on my tumor. Had I been diagnosed just years before, the standard of care for my type of cancer would have been chemotherapy, radiation, surgery, followed by 10 years of hormone therapy. Because I was blessed to be, covered by insurance and to have biomarker testing covered, the biomarker testing looked at the DNA of my tumor and identified that chemotherapy wasn't going to help me. That was a huge, huge game changer in my experience going through cancer. For me, for my children not to have to watch me lose my hair or to see me get sick or go through some of the awful side effects that go along with chemotherapy, that gave me a lot of peace of mind. In addition to that, it saved me personally lots of money. It saved my insurance company lots of money. And I think that down the road, the opportunity is there to save this when we're granting people the opportunity to receive this much needed test. This type of test can look at that specific DNA of someone's cancer cells and tell them exactly what type of treatment will and will not benefit them. Right now, people like me are lucky we can have access to this test, but others are not so lucky. So I'm here today to encourage you to support Bill 307, supporting Medicaid's coverage of biomarker testing.
Thank you so much, Erin, for being here, and glad you're healthy and doing well. And thank you for sharing your experience with us.
Thank you.
Next is Kyle Kramer, followed by Naomi Libby.
Good afternoon, Chair Gilchrist, other distinguished members of the Human Services Committee. I'm here advocating support for House Bill 5459. My name is Kyle Kramer. I am the President and Chief Executive Officer for UConn Health in Putnam, Connecticut. We are a small 104-bed, 22-bassinet hospital in a rural and small market community in Northeast Connecticut. Our market is vastly different than many other parts of the state in that we immediately abut the Massachusetts and Rhode Island borders, and that creates its own unique sets of challenges. Our focus is on healthcare access, equitable distribution of services, as well as the affordability of those services. We base our services in what our market needs, which largely include specialty services such as cardiology, orthopedics, oncology, digestive health, pulmonary respiratory services, with a foundational element of primary care, inclusive of obstetrics for many of the women that we serve. And we are also a behavioral health provider. 70% of our payer mix is federally derived, either Medicare or Medicaid. For those Medicare patients, we roughly break even, and for Medicaid, we lose roughly 40 cents on every dollar of care that we provide. This is especially significant within the realm of behavioral health and obstetrical care because women and others needing behavioral care are not able to go other places. In particular, what is FAR? FAR is being stuck behind a double wing hay mower on Route 44. The realities of our market are significant for that. So our being able to provide access locally becomes even more important for our population. But we need to be able to do so at a level that gives us the capacity and the opportunity to break even on the care that we provide. Behavioral services obviously have become even more significant, especially in our younger population since the pandemic. And obstetrical care is an ever important service, and we have been steadfastly committed to continuing those services. But that becomes a challenge when you consider that for the ability to provide those services, we lose roughly $3.5 million a year. Untenable for a small hospital like ours, and challenging for any hospital nonetheless. So we advocate strongly that you consider moving Medicaid payments to a more cost-based program. Simply moving to break even on Medicaid would put us in a position where our ability to continue to invest in vital services for Northeast Connecticut and ultimately the survival of our facility, which is the only facility in Northeast Connecticut serving this population, can continue moving forward and providing those vital services. Thank you for your time today, and we encourage your continued support of House Bill 5459.
Thank you so much for your testimony. Truly, your data is very helpful. And I used to work out that way, so I can picture the hospital as you're talking.
Beautiful part of the country.
Yes. Thank you. Have a great afternoon. Next, we'll hear from Naomi Libby, followed by Bright Johnson.
Good afternoon, Madam Chair and members of the Human Services Committee. I'm Dr. Naomi Libby, and I am the Chief Medical Officer at the Children's Center of Hamden. Our agency of 200 employees provides behavioral health services across multiple levels of care, from outpatient mental health to short-term residential care. We serve youth and families from across the state who are suffering from trauma and serious mental illness, as well as those with autism, intellectual disabilities, and substance use disorders. I'm here to testify in support of two bills, HB 5374 regarding inflationary rate adjustments for nonprofits, and HB 5459 regarding increasing Medicaid reimbursement rates. These bills are essential to ensuring much needed services to Connecticut's most vulnerable populations. State contracts are a major source of funding to nonprofit providers, covering services not reimbursed by insurance and offsetting losses due to Medicaid reimbursement rates that fall short of provider costs. However, nonprofit providers across Connecticut are facing severe funding shortages due in part to the failure of state funding to reflect the rate of inflation. This funding shortfall is affecting your constituents. Dedicated employees are working long hours in challenging jobs for wages that barely exceed minimum wage. They do so because they are committed to the work, but when they cannot pay to feed their families, many make the decision to leave for higher paying jobs outside the social service sector. We hear from parents who have lost their jobs because of the time off they needed to take to care for family members struggling with mental illness. These families rely on the state's nonprofit behavioral health providers for literally life-saving services. Instead, they find themselves on extensive waiting lists, cycling in and out of emergency departments and inpatient hospitals. Our state regulations require medical oversight over behavioral health services. This is appropriate, but it is also costly. As a child and adolescent psychiatrist, I know that the rates set by Medicaid and through state contracts not only fail to cover the cost of these services, they do not account for the medical oversight that providing them requires. This places a burden on nonprofit organizations, but most importantly, it disadvantages those who rely on these services. If funding for nonprofit organizations had kept pace with inflation and Medicaid rates adequately covered the cost of services, we would be looking at a dramatically different landscape, one where dedicated employees could continue doing mission-driven work, knowing they are valued and will have the means to support their families, where parents and caregivers across the state could access high-quality services for their children in a timely fashion, and where emergency rooms could exist to care for acute medical needs and not as extended holding areas for those facing crises. I urge this committee in the strongest terms to support HB 5374 and HB 5459. Thank you for your time and consideration.
Thank you, Dr. Libby, for being here and for your testimony. Next, we'll hear from Bright Johnson, followed by Arden Parrish.
Good afternoon. My name is Bright Johnson. I'm the State Director of Government Relations for the American Cancer Society Cancer Action Network here today in strong support of SB 307, an act concerning Medicaid coverage of biomarker testing. We have submitted longer written testimony and background materials in support of this legislation. So I just would like to touch upon a couple of points. The intent of this legislation is to help level the coverage field by ensuring patient access to post-diagnosis biomarker testing when supported by medical and scientific evidence. A biomarker is a sign of a normal biological process, disease, or abnormal function that can be measured. These markers are often gene mutations or protein expressions. Biomarker testing is the analysis of a patient's tissue, blood, or other biospecimen for the presence of a biomarker. Information gained from a biomarker test can then be used to help guide medical treatment, often called personalized or precision medicine. Precision medicine has become a standard practice for most patients with advanced disease, with multiple FDA-approved targeted therapies across several cancer types, as well as numerous other disease spaces. With respect to cancer, these types include breast, lung, colon, cervical, prostate, and others, replacing the historical one-size-fits-all chemo treatment. Biomarker testing is really sort of the gateway to many of these therapies, helping connect patients with more effective treatments with fewer side effects, longer survival, and allow patients to avoid treatments that are likely to be ineffective or unnecessary. This is about making sure access across the various coverage platforms, including Medicaid, is keeping up with the science so that patients get the testing they need to get the right treatment at the right time. This legislation aligns coverage and further enumerates medical necessity and cost containment with strong sources of scientific and medical evidence. The bill includes various specific sources of evidence to guide coverage, and those sources will flex with future innovations and applications, making sure all plans are playing by the same rules and that we won't have to come back here year after year every time the FDA approves a new biomarker test for use. And if I could take just a very quick moment to comment about the concern relating to prior authorization. Our intent is not to touch prior auth, and we'd be more than happy to amend the language to enumerate that prior authorization will remain exactly as it has been. All we are trying to do is make sure people have access to these tests when they need them. The cost guide rails that currently exist, we're not looking to touch those. And in fact, this bill actually adds specific sources of medical evidence to, again, further make sure that these tests would be available when they're medically necessary. Thank you.
Great. Thank you, Bright, for your advocacy. We'll definitely follow up with you to make sure we get that language correct.
Great.
Wonderful. Thank you. Have a great afternoon.
You too.
Next, we'll hear from Arden Parrish, followed by Rose Gerber.
Good afternoon, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Arden Parrish, and I'm the leader of the Connecticut chapter of Insulin for All. I'm grateful to have a chance to testify today about Senate Bill 8. I was diagnosed with type 1 diabetes when I was 7 years old. I'm now 21 and a Yale student preparing to apply to medical school. I pay more for a month of my insulin than for a month of my Yale tuition. But that's not why I'm testifying today. In my time as Insulin for All chapter leader, I've met countless Connecticut residents who have struggled to afford their insulin. My chapter members tell stories about meeting strangers in parking lots to get black market insulin, skipping meals because they can't afford to dose for them, and giving up on buying a home or starting a business because their insulin costs were too high. And of course, many have been forced to ration, taking less than their body needs in an effort to make their supply last longer. None of us would ever willingly ration. It's a last resort, a desperate move that isn't made until it's time to decide between paying for insulin and paying for rent or food or childcare. Rationing takes a toll on the body, sapping us of our strength, often leading to painful and life-limiting complications like blindness, nerve damage, and heart and kidney disease. It can lead to ketoacidosis when the body cannibalizes itself in a frantic search for energy, causing unbearable pain and, if untreated, certain death. These stories are not rare exceptions to the norm. As much as we'd like to pretend otherwise, this is the reality that far too many of us face. 1 in 4 Connecticut residents living with type 1 diabetes, relying on insulin to survive, are unable to reliably afford the amount that their body needs. This has an incalculable impact not just on their lives, but on our already overburdened healthcare system. Expanding insulin access will save and change countless lives. SB 8 is a wonderful step forward in the fight for affordable and accessible insulin. We're so grateful to Senator Lesser, Senator Looney, and Senate Democratic leadership for their commitment to this issue and their willingness to listen to patients. However, we ask the committee to consider who will be helped by this bill and who will be left out. People on Medicare and people who are uninsured are in urgent need of relief from the overwhelmingly high insulin prices that shape their lives every day. Any measure that expands insulin access will save lives. But so many more lives could be saved if the language of SB 8 was expanded to be more inclusive of our most vulnerable populations, those who are already disproportionately impacted by rationing. We can do better than small steps. Prices are continuing to rise to unsustainable levels, and the time for bold and urgent action has long since been upon us. We thank the committee for your commitment to protecting the rights of Connecticut residents to access life-saving insulin, and ask you to pass SB 8 with the most inclusive provisions possible. Thank you.
Thank you so much. Thank you so much, Arden, for being here and for your testimony and your advocacy. Seeing no hands, we'll go to Rose Gerber, followed by Megan Gorman.
Good afternoon, Representative Gilchrist. Thank you for the opportunity to testify in support of Senate Bill 307. My name is Rose Gerber, and I represent the Community Oncology Alliance, COA, and the COA Patient Advocacy Network, CPAN. I am also a long-term cancer survivor. COA is the only nonprofit organization in the United States dedicated solely to independent community oncology practices, which serve the majority of Americans receiving treatment for cancer. Our members in Connecticut and across the country deliver high-quality cancer care, often at a fraction of the cost of treatment delivered in other settings. That is why we share the Assembly's enthusiasm for biomarker testing, a focused and cost-efficient approach to patient care. In recent years, biomarker testing has emerged as a crucial tool in the modern fight against cancer. These tests empower healthcare providers to identify unique genetic mutations or biomarkers in individual patients and allow care teams to make more informed decisions about treatment options. This in turn enhances the effectiveness of cancer therapies while greatly reducing the risk of adverse reactions, leading to improved patient outcomes and lowered healthcare costs. If passed, this bill will provide coverage for biomarker testing in Connecticut's Medicaid program, ensuring equitable access to advanced healthcare solutions for the state's underserved patient populations, while decreasing the overall economic impact of the disease. By focusing on early interventions and tailored therapies based on genetic insights, Connecticut will combat the rising cost linked to cancer care, creating a more cost-effective and equitable healthcare landscape. Ultimately, this legislation benefits both patients and taxpayers alike. The Community Oncology Alliance urges you to support and pass Senate Bill 307. Thank you.
Thank you, Rose. Thank you so much for being here and for using your experience to help others.
Thank you.
Next, we'll hear from Megan Gorman, followed by Michael Van Blenderen.
Good afternoon, all. Senator Seminar, Representative Gilchrist, Representatives Hefferson, Hughes, and Fortier. Thank you for being here and for listening to our testimony today. I'm here to speak on HB 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers. I neglected to say my name first. My name is Megan Gorman. I am the Community Engagement Coordinator for CMHA, Community Mental Health Affiliates. We are a leading nonprofit provider of behavioral health and addiction services in Connecticut. When properly staffed, we employ nearly 300 health professionals of varied sorts, and annually we serve over 7,500 individuals, children, families, adults, you name it. We are also the local mental health authority, the authority for mental health in our area, and we serve individuals and families from New Britain, Bristol, Waterbury, Southbury, Torrington, Watertown, and basically everywhere in between. We offer housing support, community-based care, medication-assisted treatment, family therapies, school-based services, and even operate crisis teams in conjunction with our local police departments. Now, I'm here to testify in support of HB 374, and I encourage you to listen to what many of my colleagues have said before me already here for nonprofits. We know our services are vital to the well-being of this state. At one point, we were called essential workers, but what's essential now is that we work together to turn around what has historically been abysmal funding trends for critical nonprofit services. Many of my colleagues have quoted the inflation statistic you've heard today, that since 2007, inflation rates have increased 45%. And while we appreciate all legislative efforts that have been previously made these past few years, that really only equivocates to a 13% adjustment in light of that 45% difference. Now, that doesn't take into account the increase in the volume of clients that we see across this state, the increase in the severity of their concerns, behavioral health or substance use, and combine that with the reduced staffing that many of us are facing. We are in a perfect storm. Others have equated it to a fire or a sinking ship. And in both of those situations, a fire, you don't ration water. When the ship is sinking, you don't tell people to wait for more lifeboats next fiscal year. Nonprofits are going to continue to care for your constituents and the state's most vulnerable populations every day without fail. But without serious changes to how we fund nonprofits, we are ultimately setting ourselves up for failure. I implore this committee to support HB 5374, as while it won't fix the issues overnight that are currently afflicting nonprofits, it will establish a significant and long overdue precedent in how this state financially support nonprofits and shows that they truly do care and wish to support the individuals that we serve. Thank you for being here today. Made it in 3 minutes.
Thank you so much, Megan, for your testimony and for, again, painting the picture of what's going on out there for the services we know people need.
Thank you.
Thank you. Michael Van Vlenderen, I don't know if I could do it 2 times in a row, but, and followed by Dr. Thomas Farquhar.
Good afternoon, senators and representatives of the Human Services Committee. My name is Mike Van Vlanderen. Well done, Representative Gilchrist. I'm a lifelong resident of Norwich, Connecticut, in the southeastern part of the state. I've worked with Reliance Health, formerly Reliance House back in the day, covering Eastern Connecticut. I've been there for over 32 years. I started as an outreach worker in 1991, and today I sit before you as the Chief Operating Officer. We have over 250 staff serving 1,500 individuals. Annually, our primary funding is from Department of Mental Health and Addiction Services and Department of Disability Services. Thank you for the opportunity to testify in support of House Bill 5374, an act concerning annual inflationary rate adjustments for nonprofits, indexing. We make t-shirts. This critically important bill would be a huge help to community providers to stabilize budgets for services for the state's most vulnerable populations. Nonprofits, as you've heard from prior testimony, and you'll, I'm sure, hear throughout the rest of the afternoon, have been hit very hard, especially since 2007, where for 10 straight years we suffered without a single dime in any sort of increases. In 2017, we were hit with a 5% cut. And to be clear, the exercise was we were going to be hit with a 10% cut, and we were asked to lop off 2.5% of our budget as a regular exercise until the state was able to meet its shortfall. And luckily, after 2 rounds of doing that, it stopped. So it ended as a 5% cut. Could have been a 10% cut. What's the reason I mention that, and it's worth considering, is because what we're asking you to do here today is to sort of tie money into future years, where I know it's sometimes difficult to do, but I point that what happened in 2017 out as an example that the state is willing to and can claw back money if it needs to balance the budget. So anybody that tells you not to tie the hands of future legislators or not to put the state in a bind in future years, there's a mechanism for that. And let's be honest, we have a $3.7 billion surplus. We all understand the fiscal guardrails, but the ship is sinking, the house is on fire. Any analogy you want will do. You've heard the losses, a 45% CPI increase with only about a 13% realization in additional dollars over the last handful of years. The waiting lists are long, the starting salaries are low, people are leaving to go do other things. My time is up. If you have any questions, I'm happy to address them, and if not, thank you for listening.
Thank you, Michael. So did you say you've been at this organization 31 years, started as a case manager?
Yep, I started right out of college. I started in 1991 as a homeless outreach worker.
So what would you say, what does it look like today versus when you started in terms of that role, the pay? Would you do it now today would you be able to do it?
I wouldn't be able to do that job today. I was fortunate enough to work my way sort of up the ladder, if you will. But if I were starting in the field today as a direct care worker, you've heard the starting wages, $17, $18 an hour. Ours are no different. We started $18 an hour. Back then on $18 an hour, back then I was only making about $12 an hour.
That was good.
I was able to buy a home and start a family. I couldn't do that now if I were starting at $18 an hour. And I can tell you, we have direct care staff that still live with their parents, live in their parents' basement, that can't buy homes, can barely afford their rent, that some qualify for the very things that we're here advocating for in terms of insurance and such. It's scary. And as administrators of programs, we feel awful that that's the landscape that we have to set for the staff that work for us.
Great. Thank you. Don't see any other hands.
Thank you.
Thank you for your testimony today. Next, we'll hear from Dr. Thomas Farquhar, followed by Kristen Winters.
Dear Representative Gilchrist, Senator Lesser, Senator Seminaria, Representative Case, and members of the committee. My name is Thomas Farquhar. I'm the president of the Radiological Society of Connecticut, which is the state chapter of the American College of Radiology, and I'm a practicing physician in Connecticut. And on behalf of the society, I appreciate this opportunity to offer comments in support of House Bill 5459, an act increasing rates of medical reimbursement for certain providers. So the increased rates proposed in this bill are a long overdue start to bring Connecticut Medicaid provider reimbursement back in line with neighboring states. In 2015, DSS made some drastic payment reductions to the provider component of Medicaid payments for imaging examinations, from mammograms to MRI. And these cuts targeted only independent radiology offices, not hospitals or hospital-based physicians or hospital-employed physicians. Keeping in mind that radiology practices are small businesses that employ hundreds of employees with good paying jobs in communities across the state. Unfortunately, we saw one of the two private radiology practices in the city of Hartford close shortly after that Medicaid cut took effect. And these low rates have continued to put pressure on outpatient imaging services that provide the full range of services from mammograms and x-rays to CT and MRI to all patients regardless of insurance. These outpatient radiology offices allow patients to get the radiology studies that they need more conveniently than going to a busy acute care hospital, especially for routine outpatient and screening exams. So Section 1 of House Bill 5459 will mandate the start of reimbursement increases in the fiscal 2025 budget adjustment, and Section 5 backs that up with a $10 million appropriation. So the Radiological Society of Connecticut strongly supports these provisions and will advocate with the Appropriations Committee to make these increases a priority. And I wanted to thank all of you on the committee again for your hard work on behalf of the patients and citizens of Connecticut. Thank you.
Thank you, Dr. Farquhar. I don't see any hands. Thank you for your testimony today.
My pleasure. Thank you.
Next, we'll hear from Kristen Winters, followed by Dawn Holcomb. Is Kristen Winters with us? I don't see her, so we will move on to Dawn Holcomb, followed by Sharon Tierney. Dawn, you're muted. If you could just unmute.
Sorry, greetings. Thank you very much. I appreciate the ability to speak before the honorable members of the Human Services Committee. My name is Dawn Holcomb, and I'm here as the Executive Director of the Connecticut Oncology Association, which represents the Connecticut physicians and cancer centers that treat patients that have cancer. I am here to support the passage of Raise Bill SB 307, the act addressing concerning Medicaid coverage of biomarker testing. I am a resident of South Windsor, Connecticut. I have submitted written testimony. I will not read that verbatim, but I also, in sitting in this hearing, realized that Senate Bill 8 had been modified from the original format, and I will be submitting written testimony opposing that bill as it is written for several very valid reasons. But speaking back to Raise Bill 307, I understand the concern and that there even has been concern from some of the Connecticut departments about, do we need to establish legislative coverage for biomarker testing? And I'd just like to say that Connecticut cannot afford not to legislate such basic coverage. The bill is so simple. It establishes coverage for biomarker testing for the purpose of diagnosis, treatment, or monitoring of a Medicaid enrollee's disease or condition. Then it conditions that coverage on medical and scientific evidence that supports it. One could not want more from a piece of legislation, except maybe to extend this coverage protection to all the citizens of Connecticut, not just Medicaid enrollees. And to me, that's the biggest flaw in this bill. Others have already very well talked about the disparity in access to care, the communities being left out. I fully support their testimony and emphasize that as a strong reason to pass the bill. My other concern, it relates to the concern in Connecticut about the total cost of care. If we do not enact this bill, we are denying the fact that medicine has moved into a new world where precision medicine therapies are approved for a variety of tumors, and patients can benefit from biomarkers, regardless of the tumor location or histology or their other conditions, to improve clinical decision-making and the outcomes of patients with cancer. So even if a particular treatment may seem to be more costly than the alternatives, if it is the right one, that overrides the financial and the health costs of struggling with less appropriate treatments that now may be forced on a patient without access to care. And I know that someone is going to say, we already follow guidelines, so we already approved this, so we don't need to have legislative coverage. But the reality is it's not happening. We need to create a standard for medical care in this country and in this state that says, if this is deemed appropriate to make appropriate good medical decisions and there's science and evidence behind it and it's in national guidelines, it should be followed. That is not happening. It's not happening with commercial entities, and it's not happening necessarily with Medicaid patients. We do not need to have prior authorizations and put those patients through delay of care, waiting for approval of something that is already standard of care, which in the entities that are very well defined in the bill. So if coverage policy either deliberately or through omission, don't keep pace with technology and today's medical care. They're letting down their enrollees, and they're increasing their own total cost of care by failing to do and support doing the right thing the first time. So there's no reason not to pass this, and we fully support it. Some of my major concerns with Senate Bill 8, as it's modified, are that a prescription drug advisory board is basically, if they're using their legislative authority to set forth and decide on drug substitution and not allow medical access to other drugs, because they've decided to set a limit or say, we're not going to have this drug, even if it's a branded drug, available in our state, that's non-medical decision-making. They're forcing a medical decision upon a patient with no medical knowledge of that patient, without regard to the challenges that may access limitations or access to that drug. And that is going to contribute to adverse health impacts and possibly even the life of the patient with a complex medical disease. The criteria for composition of the PDAB doesn't include actively treating providers. There's considered to be that they may have a conflict of interest. Well, their bigger conflict of interest is not being included because they understand the medical decision-making. And the foreign importation of drugs. I know everybody's jumping on that. I know the FDA created a pathway to that.
Dawn, your time has expired. Can you please summarize?
Okay. Florida has started to go down that pathway, but the reality is those drugs aren't going to be allowed to come out of Canada. And we don't have a way to well track the cold chain. We can't have a pedigree. And I don't want to take drugs that I don't know where they've come from. I don't want my mother to. I don't want any of my neighbors to. So there are a number of concerns with the bill number 8, as it is written, and I will submit detailed testimony following my presentation here. Thank you.
Thank you. Senator Lesser.
Yes, thank you, Madam Chair, and thank you for your testimony. I'm a little confused about your testimony on SB 8. First of all, with regard to drug shortages, I've read in the press a number of stories about shortages affecting oncology medications. Is that something that you see as a problem that we should be paying attention to?
Yes, drug shortages are a problem, but quite often the problem is caused by issues that we as a state don't have control over. There may be a factory that closed due to a fire, etc. There are risks of any drug that is brought in from outside of our borders. The FDA cannot get to manufacturing facilities to inspect them. You run the risk that it may have come in and been relabeled as a re-engineered drug. Yes, I'm worried about the cost of care here. I think our dealing with cost of care are going to be better spent looking at, are we getting the right patient, the right treatment the first time? Drug shortages are a horrible problem. I myself do not have a solution because quite often there is no solution that if there's a shortage, you can't import from somewhere else because you just can't trust it.
Well, we have, with respect, I don't know if you've read all of SB 8, but it does contain a number of suggestions about how we might plan and work with our hospital partners to make sure that we're planning for exactly that, for interruptions to drug supply and identifying particular.
I am all for collaboration, and I'm all for working, and I'm all for conversation. What I get frustrated with is I see states across the country looking at foreign importation as a solution to a number of different problems, and it really isn't. Quite honestly, I don't think we're ever going to see drugs imported into Florida, which is the only one that has applied successfully to the FDA, because Canada's not going to let them go because the volume, even just to supply Florida, is such a high percentage of the whole volume used in Canada. So I see us looking at a bunch of solutions that are not really going to go anywhere eventually, and I think we can use our efforts elsewhere.
Excuse me, ma'am. But just specifically, I was in the process of asking a question when you started to respond.
Okay.
Have you looked at the provisions in the bill related to drug shortage planning?
I only started reading the bill just before getting on here, so I have not read every detail of it. But no, I didn't read about drug shortages. I just saw the PDAB and I saw foreign importation, and I know that there are very viable concerns about those. I will go back and look at it for drug shortages and add any comments to my written testimony.
That would be helpful. And then with regard to the Prescription Drug Advisory Board, you referenced the section of the bill that would allow the board to determine what drugs are medically appropriate for patients. I don't see that language anywhere in the bill. Can you point to a specific line where they would be able to?
Yes, if there is an upper payment limit set, and if it is decided that the board is going to set an upper payment limit and say this is the only price that anyone in the state of Connecticut is going to be allowed to pay for it, it completely ignores the construct of how drugs are acquired and purchased and assumes that everyone else is going to drop their price all along the way. What it really is going to mean is that that's not going to happen. Physicians are not going to be able to afford to purchase the drug because the cost is going to be higher than this upper payment limit. Then the patient is not going to be able to access it. And basically, there's a provision in the bill that says if a manufacturer does not decide to accept that upper payment limit, they have a certain amount of time to notify the state that the drug is no longer going to be available in the state. That is control of access to a drug within the state. You have a 5-person board saying, we're going to set a price and we don't care if no patient in the state of Connecticut is going to be able to access that drug as a result of our decision. To me, that's outside the bounds of what's appropriate.
I appreciate it. That's not my read of it. I don't think that's what we would be looking at.
I think you have to look at what would lead to that because it really would happen. I'd be happy to talk offline.
Okay. Thank you for your comments this afternoon, and thank you for the time, Madam Chair.
Thank you.
Thank you, Senator. Thank you, Dawn, for being here. Have a great afternoon.
Bye-bye.
Next is Sharon Tierney and then Kristen
Marissa
Winter.
Park 1, Marissa Park 1.
Senator Lesser, Representative Gilchrist, Senator Seminara, and members of the Human Service Committee. I'm here today to support House Bill 5374. My name is Sharon Tierney, and I'm providing my perspective as a parent on behalf of my son and in support of Horizons, who collaborates with me to provide my son with a quality of life through supportive living and employment. Please help support the indexing of wages for the nonprofit sector, as now is the time to reimagine how to do things differently. Horizons is a private nonprofit agency who provides essential true person-centered services to 1,200 people with developmental disabilities and has been established for 45 years. Without annual inflationary rate adjustments for nonprofit human service providers, Horizons and nonprofits alike cannot expand upon the services required to serve the most vulnerable population, nor maintain or hire new talent when they're given 3% across the board. As leaders of our community, we are counting on you to create awareness with your esteemed colleagues and begin meaningful conversations conveying that nonprofits require additional financial resources available to hire quality trained staff who provide the valuable support so our loved ones have a quality of life, care, safety, shelter, food we all deserve as citizens. It's alarming to learn that 92% of this private sector who provide community-based services for people with intellectual and developmental disabilities are facing an astonishing workforce shortage due to the lack of financial resources required to attract talent in direct competition with retail and the state's direct service employment. If the salaries of private nonprofits were indexed, Horizons could at least stabilize and grow their services to support additional people, as well begin to offer competitive wages and well overdue salary increases. At Horizons, they continue to have a 20 to 25% vacancy rate, which impacts my son, who needs consistency and quality trained support staff to provide my son with the opportunity to build the trusted relationships that are the foundation of his individualized plan that leads to success he is proud of, a positive mindset, and growth to meet his annual goals. It is demoralizing, frustrating, in some cases can be damaging to my loved one's mental health to have a revolving door of staff filled with inconsistencies. A qualified intensive training program requires the financial investment, dedication, time, and commitment not only by Horizons and all nonprofits, but also the applicant's time, dedication, and commitment. The power of positive people and collaboration who serve our community. I believe in the value of the acronym of TEAM. Together, everyone achieves more, and I hope that you do too. Please make the right decision to support the indexing of wages for the nonprofit sector and join the support of the power of the positive people at nonprofits who serve our community. Thank you for the opportunity to testify.
Thank you for your testimony, and it's great to hear of the good work that's done at Horizons. Thank you.
Yes, absolutely. Thank you.
Next, I'm sorry, Senator Seminara has.
I really don't have a question. I just have a comment. It's so nice to see you. I'm a huge supporter of Horizons. I've been there a number of times. I agree with you. I do think they do incredible work with a very special population, and I'm hopeful that we're able to address their needs in the near future. Thank you.
Yes.
Thank you for taking the time out of your day to testify.
You're welcome. My pleasure. Thank you.
Oh, thank you, Senator. Any other comments? Oh, nope, we're good. Thank you very much. Next, we have Kirsten Winters, followed by Mark Vaselli.
Can you guys hear me okay?
We sure can.
Great, wonderful. Thank you, Senator Lesser and all of the members of the Health Services Committee for allowing me to discuss Bill number 5459. And that is an act concerning Medicaid payment rates. I'm a podiatric physician. My name is Kristen Winters, and I've been in practice here in Connecticut for 24 years. I'm the president of the Connecticut Podiatric Medical Association, and I am in support of this bill. The Medicaid program currently provides insufficient payments. Low payments quite simply discourage provider participation in the plan. To give you an example of this situation, we will treat a diabetic foot ulceration, which requires an enormous amount of energy, time, resources, materials, supplies, and repeat visits. This left untreated leads to amputation, morbidity, and mortality increases. So just to give you an example, Medicaid reimbursement for a simple ulceration treatment is $32.39. Medicare reimbursement for the same code is $111.32. So there's definitely a discrepancy, and we are trying to make awareness to just cover costs for these patients so that we can continue to encourage all of our podiatric surgeons and physicians within the state to provide care for Medicaid patients. As I understand, the bill will expedite increases in payments. We should be included in those increases for two reasons. One, we are podiatric physicians, and two, we obtained fee parity by statute for those who practice in Chapter 370. So we're just trying to make awareness that I have a list of other codes that are certainly similar in terms of just trying to get the costs similar to that of Medicare. So thank you for the opportunity to testify today. And can I answer any questions?
That's a good question. Thank you for your testimony. And let me ask my colleagues, do you have any questions for Ms. Winters? Dr. Winters, apologies. I just have one quick one.
Sure.
You have fee parity with physicians. Is that correct?
Yes, by statute. That's correct.
Got it. Well, thank you so much for your testimony this afternoon, and we appreciate hearing from you.
Thank you very much for the opportunity. Thank you.
Terrific. Okay, next up we have Mark Maselli.
Yeah, greetings, Co-Chair Senator Lesser and Representative Gilchrist and members of the Human Service Committee. I'm Mark Maselli, and I'm President and CEO of Community Health Center, Inc. I'm here to support House Bill 5456, an act concerning federally qualified health centers, and to recommend some additional changes that I think might improve the bill. Just a quick overview, health centers were really started by Congress in the late 1960s. Because there simply wasn't a network to provide primary care to people who live in poverty or have been historically discriminated against. In 1989, Congress realized that the grant dollars they were sending from Washington back to the states through the health centers were not going to the expansion of services, but rather to subsidize low Medicaid payments that states were making. So they came up with legislation that provided cost-based reimbursement, allowing us to receive our full cost of services. And yet, despite the clarity of the federal law, Connecticut's FQHCs really have systematically been denied legitimate rate adjustments
based on expansion of services. And I really thought maybe just take a moment and shine a light on how this system works. The current process requires that health centers first raise and spend the funds necessary to expand a service. So if a health center is building a new primary care facility, we have to raise the money to pay for construction, purchase the equipment, hire the staff. And once we're ready to start providing services, then we actually have to go back to the federal government to get a mother may I for a scope of change for our services. If that's approved, then within 90 days, we have to commence providing services. But it's only at that point, after we receive that, that based on Connecticut regulations, are we able to request an adjustment from DSS for our Medicaid reimbursement. So you really can see that we're out on a limb financially. And when DSS does not follow their own regulations, the limb is really cut off from us. So I wanted to give you one example from the health center. Back in 2016, we have lots of these over many decades. CHC was asked by the Connecticut Children's Medical Center to take over the largest pediatric practice in the state and probably in New England, which was facing economic challenges. And the practice located on New Britain Avenue in Hartford cares for 13,000 children. It was also the teaching facility for all of UConn pediatric residents. We made a substantial investment in the expansion, applied to the federal government, got approval, received approval, started services, and then made our request to DSS. Given their regulations, we fully expected a rate adjustment. However, this qualified request for an adjustment was denied, really leaving us high and dry after doing, I think, the right thing. And I think this story has probably been told to you by other health centers in different iterations, but all with the same results. We'd also like the committee to consider changing the inflation adjustment rate, which is called MEI, from October back to January, which is really what almost all other states in the country do. We also support the full funding of this bill at 10 million in the first year, 20 in the second year, and 30 million in the third year. This trajectory would slowly get us closer back to true cost. We're also in support of the dental regulation rollback. I do want to say, though, while we've had over the years a contentious relationship with DSS, in my many years going back to the early 1970s, this is really an incredible group of leaders we've encountered. My sense is with the right policies from the General Assembly, they will work in partnership with the health centers all across the state. You know, Connecticut has been a national leader in supporting FQHCs, but we've really fallen behind. And I think you've seen an earlier testimony or testimony coming, a list of all of about 20 states. And from Maine to New Jersey, Connecticut is the lowest reimburser payer for federally qualified health centers. I think we can just do better. We also have some technical changes that we'll submit along with this. And again, thanks to the committee for your historic support for the work that health centers all across the state do, and for taking the time to listen to all of our pleas from various parts of the state. So thanks so much.
Thank you, Mark.
A lot.
Go ahead.
Sorry.
So I was going to say thank you for your testimony. Now, we did have a conversation very recently with DSS that disputed some of the change of scope assertions that we've heard from yourself and from other directors, and they alleged that, in fact, they approved 2/3 of the change of scope requests, and they do it in a fast clip. How do we? I mean, we asked them to back that up with data. We haven't yet gotten that, but
yeah, we look forward to it. I mean, I gave you one example. The other larger example is we went out to expand and build new facilities, raised $50 million, built a new facility in Stamford from the ground up, built a facility in Middletown, purchased that building I was talking to you about in Hartford and fully renovated. Huge capital expansion, absolutely denied. And really, again, previous administrations, right, So I think this administration, I really think, is trying to find ways to make things work. But if you look historically, that's simply not true. And we all can recount many more cases like that. Those are large ones, that we've submitted that clearly meet the standard of the law, but they have creative interpretation of that. And again, I think it's a policy matter of clarity around the regulations and implementation.
Okay, thank you. And I don't know, I didn't see any commentary about 340B contract pharmacies. I
Yeah.
know some of the health centers looking for us to include that language to that effect in SB 8.
SB 8 really makes much more sense to put that language in there. We've long historic, we're a statewide health center, 200 locations across the state. And the regulations that the big pharma would push out has us select one location where we can deliver 340B drugs. So from Stanford to Groton, East Haven to Enfield, where do I pick? And how do our patients actually get there if they're in Groton and the only place we have is in New Britain as the one location? It simply doesn't make sense. And it denies people access to the care they need.
Right. And appreciate your suggested language changes. I think we'll look at those closely. Any questions from members of the committee? Seeing none, thank you very much. Have a good afternoon. Next up, we have Dr. Liang. And following Dr. Liang, we have, understand that Alan Kukl has a plane to catch, so we're going to skip ahead to him. Dr. Liang, are you there? No, Dr. Liang. Okay. Mr. Kukl? After Mr. Kukl, we have Simon Wells, then Lori Pasqualini. Good afternoon.
Good afternoon, Senator, members of the committee. Thank you for the opportunity to be here. My name is Alan Kukl. I'm a pharmacist and I lead public policy for Civica RX, which is a nonprofit generic drug company. Civica was created to address the problem of drug shortages in the United States. We're also developing affordable insulin for the benefit of the 8 million Americans who need it. My comments today are in support of sections 17 and 18 of Committee Bill 8. I'll start with section 18 on drug shortages by pointing out that shortages have now been with us as an ongoing problem for more than 15 years in the US. And at any given time, there are hundreds of drugs on the shortage list. This disrupts patient care, puts patients at risk, and creates an enormous burden for hospital staff. Civica is the only pharmaceutical company established specifically to address shortages of sterile injectable drugs, and we supply 80 products now to more than 1,500 hospitals. Because reliability of supply is our core mission, we do some things that are different. We enter long-term contracts with hospitals and suppliers that bring stability to the market. We hold a buffer stock of 6 months of inventory. We prioritize US manufacturers and carefully select for quality manufacturers to reduce the risk of a failure to supply. This approach has been shown to work. It's a more reliable source of supply than the traditional wholesale model, and it actually produces savings over time. Unfortunately, despite the success, the ongoing challenge is that many hospitals have yet to put in place a comprehensive prevention strategy with elements like those that I've described. Section 18 would require just such an approach, would require hospitals to have a robust risk management program, and yet leave them flexibility on implementation. It will create effectively an insurance policy, reducing drug shortages and helping to ensure that Connecticut residents have access to the medicines they need when they need them. Turning now to insulin in section 17. As I mentioned, Civica is developing affordable insulin. That's part of our mission. We'll make the 3 types of insulin that account for about 80% of use in the US. As we know, high insulin prices too often cause people to ration their insulin or make painful economic trade-offs. Civica insulin will be available at no more than $30 per vial and no more than $55 for a box of 5 pens. A significant discount compared to prices on the market today. And our intent with this pricing strategy is twofold. First, we want to create competition to encourage other insulin manufacturers to drop their prices. And secondly, we want to eliminate a common pricing strategy that exists in the market, where manufacturers set high list prices and PBMs negotiate non-transparent rebates, and that ends up harming the consumer who has to pay out of their own pocket based on that inflated list price. Unfortunately, financial incentives in the supply chain sometimes drive purchasers, PBMs and other entities, to choose the higher price, highly rebated drugs over products with lower net cost. Section 17 would ensure the coverage of the lowest net cost insulin, and simultaneously ensure that beneficiaries of the state health plan face no co-payment or out-of-pocket cost. It's an approach that will ensure that competition works the way it should to benefit consumers. Thank you for your work, and I welcome any questions.
I thank you for your testimony. So first, with regard to your work on drug shortages, my understanding is that you're a partnership of many of the, were initially set up by many of the nation's hospitals. Can you talk about your partners?
Thank you, Senator. Civica was founded by initially 9 health systems, a mix of for-profit and nonprofit systems, as well as 3 philanthropies. Today, our membership includes 1,500 hospitals around the country and more than 50 health systems.
1,500. So that's a what percentage of the hospitals in the United States?
I should know that, and I don't. It's a big number, but it's not nearly all of them.
Okay. And so you're a nonprofit established by these partners and philanthropies that manufactures or procures the drugs for specifically to address drug shortages.
Exactly, Senator. The hospitals actually choose the drugs that we supply. So we have a quarterly meeting of advisory committee of pharmacists and physicians from member hospitals. They look at what are the products that are in shortage or that are high risk of going into shortage, and they ask us to manufacture or source those products. So we chose products based on risk of shortage. They tend to be old, low cost, but essential medicines that are used every day in every hospital.
So, we've been focusing a lot about the most expensive drugs and the impact on affordability, but here we're talking about drugs at the other end of the scale but just the drug company isn't taking it seriously, or they don't see a lot of margins. So is that the major driver of shortages? And
yes,
right?
Sometimes we have to keep 2 problems in mind at the same time, right? Some drugs are too expensive, but then at the other end of the market, you've got products that have been around for years and years and years. They often sell for less than $1 a vial, almost all of them for less than $4 a vial. The margins are really small. Manufacturing shifts overseas to Asia. We have a lot of quality problems. Manufacturers drop out of the market, and we have this problem of chronic shortages.
And can you discuss the impact on patients and hospitals?
If drugs aren't available, patients don't even always know it, but it causes procedures to be delayed or rescheduled. Hospitals have to choose alternative products, and anytime you're changing an established protocol, you're adding risk to the system. And then there's just an indirect cost to the health system, where every hospital in the country practically has staff and pharmacists who spend their time trying to find these products that are in shortage.
So can you discuss the planning process, the process that's available in Section 18 of the bill, and how it, what we're asking, and then how it would differ from the way things are done now, to the extent that you know?
Thank you. So I'd like to say that every system produces the results that it's perfectly designed to produce. Right now, the driver for generic drug purchasing is to get the lowest cost product, no matter what. What Section 18 recognizes is that we need to take quality and buffer stock into account, as well as price. Price matters, but it says, let's make sure that when you're doing your generic procurement, that somebody upstream of you is holding 6 months of extra inventory, so that if there's a supply disruption, you don't have a shortage. And also, let's choose our suppliers based on really going out to their facilities, inspecting them, and ensuring that they're less likely to have a quality failure, which would then lead to a shortage.
And then with regard to insulin, this is a subsidiary of Civica that's going to be making insulin.
So the insulin will be funded. We have a 501c3 foundation which is funding the development of these insulins, and they will be manufactured in the Civica manufacturing facility here in the U.S. and then distributed to pharmacies through our operating unit that we've established specifically to lower costs for consumers, and that's called Civica Script.
And that was capitalized by the state of California, is that?
So the funding to develop insulin has come from a mix of private philanthropy, including the major diabetes organizations and some individuals who care about diabetes, as well as funding from the state of California.
And are you looking?
And I should say, as well as the Civica member health systems and health plans.
And at this point, are you seeking funding from the state of Connecticut?
We would welcome it, but it's we're not seeking it.
Okay, so your intent is to bring the insulin, the insulins that you're developing to market in Connecticut, even without any investment from the taxpayers of the state.
That is correct. And the legislation that you're considering isn't in any way specific to Civica Insulin. It just recognizes that if we want the market to work for consumers, we have to shift towards covering the low-cost biosimilar insulins when they're available.
And so if we don't do this, what's the concern? Is that a health plan may decide not to make this available, even though it's the lowest cost product on the market?
The risk would be that there are incentives for stakeholders in the system to prefer $1 in rebates over $1 in net cost. And so the market share would stay with the brand insulins, even if there's a lower cost insulin available.
Because you don't provide rebates.
Correct.
The way a PBM would.
Correct.
Or a drug company working with a PBM typically
Correct.
does. Are there questions from members of the committee? Yes, Representative Hughes.
Thank you. This has been really fascinating. Tell me about how is this a proposal to kind of compete with PBMs, and how does the hospital system deal with that when you're providing the lower cost biosimilar alternative and supply?
So when we're talking about hospitals, we're really talking about shortage drugs, and PBMs aren't a part of that story.
Right.
When we're talking about insulin, we're talking about retail pharmacies, health plans, and that's where PBMs perform several functions. They create the formulary and decide which drugs get covered.
Right.
They pay the pharmacy when a prescription is dispensed, and those are important functions that would continue. They also negotiate rebates with pharmaceutical manufacturers. That brings costs down and in general is a good thing, but it can create these distortions, including not necessarily moving to the lowest cost drug when a low cost drug is available. So this really says whatever the lowest cost product is based on list price, but allowing that maybe rebates will push a cost even lower, but we should cover that lowest cost product.
So your under your functioning, I'm trying to understand, it would work complementary to the way PBMs already work for those pharmacies
So our goal is
for like insulin.
Yep. Our goal with insulin is to make insulin available at a lowest possible and completely transparent price. So we won't have a rebate on Civica insulin.
Got it. But PBM still could do that, right?
With other manufacturers, sure.
Yes, but not with you. Not with you. Got it. Okay, I think I'm clear on that. And it sounds like a win-win for everybody, even if we don't have the state invest in finding that low cost generic. Yeah, I'm sold. Go ahead.
Well, that was easy. Are there other questions or comments from members of the committee? If not, thank you very much for your testimony.
Thank you.
Still no Bruce Liang? Okay. Then Simon Wells, followed by Lori Pasqualini.
Good afternoon, Senator Lesser and honourable members of the Human Services Committee. Thank you for your time. My name is Simon Wells. I'm Chief of Staff at Horizons Programs, Inc. We're a non-profit in South Wyndham serving person-centered support to people with intellectual disabilities. I'm here to just give my full support on House Bill 5374. I've already submitted testimony, so we'll go off script a little. Stagnant funding has really crippled nonprofits, coupled with inflation costs, the increase in the minimum wage. It's really been very difficult to attract and retain quality people that fulfill our mission. you've given us increases in the past to raise employee wages. Unfortunately, and they've been very welcome, don't get me wrong, but it's caused some incredible wage compression that has led a lot of our staff attrition. I was listening in today and there were some questions about rates of pay, and I wanted to share these facts with you. So a support coach that we hire, which is a very professional position, they must learn how to perform CPR, they need to know certain medical procedures, they are trained to give medications. Their starting wage is $18 an hour. The average wage for our employees from 1 to 5 years is sadly $19 an hour. We have employees who've been with us beyond 10 years, and their average wage is $20 an hour. And I looked this up because I have 2 employees in mind. One has worked for us for 24 years, one has worked for 25. They are both amazing people. And on average, they earn $21. One earns a little less, one earns a tiny bit more, but on average, that's $21. So I did some more digging today, and the DDS has a custodial position, and their starting wage is $20.61. So the starting wage for a custodian almost matches that of a 25-year veteran. DDS, let's compare apples to apples. DDS service worker, their starting wage is $22.83, and that rises to a wage of $30.95. We just cannot compete with that. And unfortunately, we've got many people leaving because they love the job. Not everybody's leaving for that reason, but many are leaving because they need to have a viable career pathway, excuse me, with the correct financing available. Over the past month, we've had 5 employees leave. 4 were full-time, 1 was part-time, and that was collectively 18 years of experience. We are bringing in about 4 or so employees every month, but we're losing about the same. So we're treading water. We're about 25% down on where we should be in terms of full capacity of employees. And that's the rub, right? We cannot keep and attract people. And so our services get cut. We cannot provide service. Sorry, go ahead.
No, please summarize. Your time has expired.
Absolutely. So I think, even the governor has acknowledged that, with his efforts to raise the wage of PCAs, I think we need to do the same for nonprofits. We've done the bulk of the state's work for many years, and we really need to have financing and funding that really reflects the great work that all nonprofits do for the state. Thank you.
Thank you for your testimony. Any questions from members of the committee? Seeing none, thank you for being here tonight.
Very good.
Next, we have Lori Pasqualini, followed by Rick Markello, followed by Erica Spatz.
Good afternoon. Thank you for letting me speak today. My name is Lori Pasqualini. I'm the Chief Financial Officer for Ability Beyond. We're a provider of services to almost 1,900 people per year west of the Connecticut River. And we appreciate the efforts made in the past by the legislature, but we cannot continue without ongoing cost of living increases. Just as an example, over the last 4 years, our property and liability insurance has surged by 80%. Our maintenance costs have increased 56%. Our utility expenses have gone up 66%. Food costs have seen a 69% increase. And I can go on and on. You just heard Simon talk about the wage issues and our ability to get staff. Those same issues that he has, we have, and I would say multiplied, because we are mostly in Fairfield County, not only the most expensive county in Connecticut, but also one of the top most expensive counties in the country. Without a cost of living increase, we will continue to have to close programs and turn people away. We cannot sustain flat funding as we've sustained for almost the last 30 years. And if we're unable to get that, you're going to see costs in the state of Connecticut grow significantly higher than the cost of living increase that in some cases is regulated by CMS and the legislature or the governor. cancels that. We have people doing the same work in various programs, making $2,600 less because they're not funded. That would be the Department of Mental Health and Addiction Services, as well as the Department of Social Services through their acquired brain injury grant and waiver. And the Bureau of Rehab Services, which is funded through the Department of Aging and Disability. I implore you to support House Bill 5374 and this inflationary adjustment. It's really the only thing that makes sense in this budget is to pass this and to continue to allow the most cost-effective providers in the state to continue to do that. Thank you.
Thank you. Any questions from members of the committee? Seeing none, thank you for your testimony tonight.
Thank you.
Next, we have Rick Markello, and followed by Molly Melbourne.
Good afternoon, Chairman Lesser, and if they're listening, Chairwoman Gilchrist, Ranking Member Seminara and Case, other distinguished members of the Human Services Committee. Thank you for the opportunity to provide testimony regarding House Bill 5456, an act concerning federally qualified health centers, which I support. My name is Rick Markello, and I'm the CEO of the Charter Oak Health Center. Charter Oak is a federally qualified health center in Hartford with 18 licensed locations providing over 80,000 healthcare visits annually, and over half of our patients are Connecticut Husky, the state Medicaid program. Today, I'll focus my oral testimony on House Bill 5456, Section 3, which deals with the federal Medicare Economic Index. I stand with others in strong support of this bill, and we've also attached substitute language to clarify the intent of Section 3. The Federal Medicare Economic Index, or MEI, serves as a cost of living adjustment for health centers across the country. MEI is announced each September for the upcoming calendar year. Most states implement this increase in January. Connecticut is one of the only states that implements this increase 10 months into the calendar year in October. This keeps health center rates lower than necessary for longer than necessary and leaves millions of federal dollars on the table in Washington each year. In essence, the state is keeping state money and foregoing federal money that was earmarked for health centers and is not paying it back. Sadly, Connecticut has the lowest FQHC reimbursement rates in all of New England. In addition, the rates at Charter Oak are lower than the statewide average due to the fact that our rates were established more than 20 years ago and have only been increased by small annual cost of living adjustments. Because our costs are higher than our rates, we lose on average $65 on every Medicaid visit and over $2 million a year on all Medicaid services. We lose over $200 a visit on dental services, and while some have suggested just shut it down, I'm not willing yet to withhold services to our patients because of inadequate Medicaid funding. We did file for a change of scope rate adjustment, and 6 months ago, and I had not heard from DSS until just this morning, coincidentally, when I got an email asking for some more information. When I started at Charter Oak Health Center last year, I discovered that our employee recruitment and retention rates were extremely low. In addition, I found that our employee turnover rate was 40%, our vacancy rate was 25%, and that it was primarily due to our salaries being well below market rates because that's all we thought we could afford. So to ensure that we could hire and maintain a viable workforce, I increased salaries and invested in our employees, which will cost us about $250,000 annually. If the state had updated the 2024 MEI in January instead of keeping the money for 10 months, it would have paid for half of that investment. This change alone would have placed us in a much more positive and sustainable financial footing. FQHCs are not asking for a handout or special provisions. Rather, we're asking for the committee and the legislature to recognize the challenges that the current system creates for us, and please consider our modest request to modify the existing language. Thank you for your consideration. I'm happy to answer any questions.
Thank you for your testimony. I don't know if you happened to hear the commissioner a few hours ago talking about the MEI piece, or actually, I think it was Ms. Godburn from DSS talking about it and the history of how we came into this date.
No, I missed her testimony.
Okay. All right, I'll save that then for someone else then advocating the same issue. Thank you very much.
Mr. Chair.
Yes, Representative Hughes.
Thank you for your testimony. Do you know when you said the
we're the lowest rates of all of New England. Do you know if they also change their rates in January?
Most of them do.
Uh,
There's very few states in the whole country that don't.
And with this bill, in your experience, to tie it with CPI or inflation and automatic review or renewal of rates, address the problem once adjusted?
Well, the MEI is set by the feds.
Right.
So it's whatever number they publish is.
But if that was automatically implemented at regular intervals, would that partially
help.
it would
Help,
help? I
sure.
mean, it wouldn't make the
They wouldn't solve
jump
the problem.
to address a equitable reimbursement rate, but I think your most compelling argument, unfortunately, to this part of the process is that we're leaving federal money on the table, and I think that is a huge concern that we can't afford, especially when you're already delivering these services, to leave federal money on the table. So thank you for underscoring that. I appreciate it.
Thank you.
Thank you, Representative. Are there questions? If not, thank you for your testimony. Next, we have Molly Melbourne, followed by Sean Frick.
Thank you. Good afternoon, Chairman Lesser and distinguished members of the Human Services Committee. My name is Molly Melbourne, and I'm very pleased to speak with you today in support of House Bill 5459, an act increasing rates of Medicaid reimbursement for certain providers. I am the President CEO of Southwest Community Health Center, a federally qualified health center in the great city of Bridgeport. We serve approximately 28,000 patients from Bridgeport and beyond through 150,000 visits at one of our 23 locations. We provide medical, dental, and behavioral health services, substance use disorder treatment, limited specialty care, and enhanced care coordination. Approximately 56% of our patients are on Husky. That means that nearly 15,000 patients with Husky walk through our doors each year. I have submitted written testimony on HB 5456 and 5459. Today, I'd like to focus my remarks specifically on Section 8 of House Bill 5459, which relates to e-consults. You have heard and will continue to hear from several other health center leaders who will speak to other sections of these bills. E-consults are asynchronous electronic consultations in which a primary care provider engages with a specialist who provides guidance for treatment of a specific health condition. Southwest implemented e-consults in January 2020. Since that time, we have requested 1,983 e-consults for our patients. 89% of these e-consults influenced the way that we cared for our patients, and 38% resulted in a new diagnosis. Most commonly requested specialties include pediatric and adult dermatology, pediatric hematology oncology, rheumatology, cardiology, pediatric GI, and endocrinology. Southwest strongly supports the addition of e-consults to the Medicaid program. E-consults lead to quicker treatment. Depending upon the specialty, it can take months to get an appointment. This can lead to poorer health outcomes, frustration for both our patients and our providers, and a lower quality of life. At Southwest, our data show that our patients who received an e-consult got the care they needed 68 days sooner because they didn't have to wait for a specialty appointment. We also know that e-consults save money. Many cases are easily resolved through e-consults and do not require the expense of a specialist appointment or result in duplicate lab or radiology services. We found that 66% of our patients who received an e-consult did not require a specialty visit to manage their health condition. This translated to over $49,000 in savings in just the past 6 months at Southwest. E-consults also reduce barriers. They offer more accessibility to individuals who may face barriers such as transportation and a non-traditional work schedule. Health centers are specifically designed to care for our patient population. We speak their language, we understand their culture, patients know our staff, many of whom come from their neighborhoods. We are truly in and of our community. Lastly, e-consults free up specialists' appointment schedules. When specialists conduct e-consults, instead of seeing patients who can appropriately be managed at the primary care level,
Expired. Can you just please summarize?
Yes, Southwest firmly believes in the value of e-consults. In the past year, we have found it to be an invaluable service for our patients. Please lend your support to this bill. It will strengthen our healthcare system, support community health centers and other critical healthcare providers, and most importantly, will improve the health of our patients.
Thank you for your testimony. And I don't know if you were here how many hours ago, 5 hours ago, but six hours ago now. But Commissioner Barton Reeves did say one of the few concepts I think that she liked that we're looking at was expanding, developing an e-consult policy in DSS. And she did say that they were actively exploring doing that. So
Yes, I was thrilled to hear that.
that's great. Thank you so much for your testimony. And any questions from members of the committee? Seeing none. Thank you.
Thank you.
Next, we have Sean Frick and accompanied by Deb Pullen. Good afternoon.
Good afternoon, members of the Human Services Committee. My name is Sean Frick. I'm the CEO of the Community Health Center Association of Connecticut. We are the statewide trade association for Connecticut's community health centers, also known as FQHCs. I'm here today along with several health center leaders to provide support to Senate Bill 8, House Bill 5456, and House Bill 5459. We have submitted written testimony on all three of these bills. I'd like to focus my remarks on Section 2C of House Bill 5456. This proposal relates to the process by which health centers and other healthcare providers seek Medicaid rate changes through DSS. The community health center for community health centers, this process is known as the change in scope. Last week, I was in front of the committee to speak about the change in scope process. You may remember the DSS is seeking to remove the option of binding arbitration from that process, and we came out to strongly oppose that change. Today, the process for change in scope goes like this. A health center applies for a change in scope based on a change in service type or duration, duration, or intensity. DSS almost always denies these initial rate change requests, often for arbitrary reasons. The health center can then appeal the decision for a second review by DSS, which is also typically denied. At this point, a health center can continue with its request either by going to binding arbitration or by suing in Superior Court. For context, in 2023, 7 of our health centers applied for a rate change, but none have completed the process thus far. The change in scope process is broken, and the proposal in Section 2C is designed to repair it. The language before you clarifies the change in scope process, laying out timelines as well as factors that may and may not be considered in the review. Most importantly, this new language would comply with federal law and regulations. The current misalignment has been the basis of our frustration for over 20 years. For example, in this proposal, you will see that DSS may not consider that a health center is receiving grant money when determining whether it deserves a Medicaid rate increase. Further, DSS may not consider the rates of other health centers in its determination. Both reasons have been frequently cited by the department in denying legitimate rates and are contrary to the process outlined in federal law. Passing this legislation will fix the broken system, ensuring a fair and transparent process for both DSS and the health systems in the health centers seeking rate reviews. We ask for your support and are happy to discuss this proposal with you further. Thank you.
Great, thank you. And I'm going to jump right in. Also say thank you for your patience and willingness to listen to everybody for such a long time today. And I know that we're only about halfway through everybody. I wanted to add some remarks focused on Senate Bill 8, and we support this piece of legislation, which has a lot of different components to help make prescription medication more affordable for people, as well as to help the state garner information about the cost and availability of medications. I want to thank you for bringing this proposal forward, and we have a suggestion to strengthen the bill even further, and it relates to 340B pharmacy program. This is an opportunity that was identified in the 340B work group report, and you may remember establishing that work group in legislation last year. Just as some quick background, the 340B program was established by the federal government. It's a little bit complex, but essentially what it does is it allows covered entities like federally qualified health centers, Planned Parenthood, and certain hospitals to purchase prescription drugs at significantly reduced prices. They can then sell those drugs over to their Medicare and commercial patients or to the insurance companies at the same price as other non-340B medications. And the revenue is used to expand access to healthcare services. Notably, here in Connecticut, Medicaid is not involved in this process. So I just want to make sure that you know that piece. The other benefit of 340B is that the covered entities like health centers are able to pass along the low costs to their uninsured and underinsured patients. And I want to tell you how significant these low costs are. Here are a few examples. You may know the Advair disc inhaler. That is available for $25 through 340B versus about $48 through the discount Array RX program. A 30-day supply of Eliquis is under $8 through 340B, compared with $300 through Array RX. And a 30-day supply of the diabetes drug metformin is 30 cents through 340B versus $48 through Array RX. So you can see the significant value of 340B. So what's happened in the past couple of years is that a number of pharmaceutical companies have endeavored to shrink this program. And how they're doing it is they're requiring health centers to choose one contract pharmacy to do business with. So if you think about the breadth of geography that some of these health centers serve, telling them they can only go to one pharmacy or else they will not be able to access the prescription medication at that price. So what we're asking you to do, and I know we're out of time, is to codify in state statute that this practice is illegal, that there is not to be any restriction on the number of contract pharmacies that health centers can engage with to assist their patients in getting these drugs. It's really about access to these medications. We know without these 340B prices, our patients are going to go without and they're going to get sicker. It doesn't cost the state of Connecticut any money to do a program like this. It has found to be legal. In fact, just today, the 8th Circuit Court of Appeals determined that Arkansas's law, very similar to this one, is constitutional, and we're asking you to do the same here in Connecticut. Thank you.
Thank you for your testimony. I will turn it over to members of the committee if they have any questions. I do not see any.
Yes, we did. We submitted testimony on all 3 bills.
Great. Thank you very much.
And we have suggested statutory language as well attached.
Terrific. Thank you. We'll take a look at that.
Thank you.
Next up, we have Kathleen Garrity, followed by Kathy Riley, followed by Heather Gates.
Thank you, Senator Lesser, Representative Gilchrist, and members of the Human Service Committee. My name is Kathleen Garrity, and I'm the Executive Director of the Connecticut State Dental Association. I'm honored to be here today representing the oral health care providers in Connecticut and ultimately the patients that we serve. My comments today are focused on support of Bill number 5459. A few weeks ago, I sat in that very room and listened to the presentation by the DSS on phase 1 of the Medicaid fee study. I was struck by the number of comments and insightful questions raised by this committee regarding the dental segment of that report. Obviously, you're all well informed on the issues that plague our profession in trying to provide the best patient outcomes for our Medicaid recipients in Connecticut. In order to keep my comments brief, I will not repeat those points, but please remember my prior statements for the record about oral health care is essential health care. As was said at the DSS presentation session by several of you, we knew the rates were low, but we didn't realize how low. And it is a wonder that the system has not failed us already. While dentists wish to ensure that those who are in the most vulnerable receive the care they need, the reality of the situation is that most dentists are small business owners, and the current reimbursement rate is not nearly enough for dentists to run dental practices. As a result of this, many dental providers are now not accepting new Medicaid patients, or they are dropping out of the system completely. Our FQHC providers and other public health sector providers are also struggling. One of our members spoke to the media recently about the hard cost of seeing Medicaid patients. Even when she donates her professional care, every Medicaid patient that enters her practice for a basic routine cleaning costs her $63 after a Medicaid reimbursement. What other small business would we ask to welcome people into their business knowing it would cost you money? Retail, food service? Of course not. The only reason the system has not failed is that you have providers who generally care for their patients and are trying to provide critical care. This is not sustainable. Reimbursement rates for adult care should match pediatric rates at a minimum. The language in line 23 has that intent, but should be worded better to avoid ambiguity. Parity between the rates is ideal if that means raising the adult rates to meet pediatric. Ultimately, we'd advocate for reimbursement rates across the board in the area of dental care to allow patients to receive the maximum care that they need and deserve. But we'll hold that discussion for the off session and deal with it next session. We would also like to request that there be a benchmark set so that, as much as I like seeing you, we are not here every year talking to you about reimbursement rates. A benchmark that automatically adjusts the economies of scale within Connecticut and provides the level of reimbursement necessary to keep somebody in their oral health care home should be that benchmark. I know that this discussion balances patient care and economic realities. Failing to raise rates will increase the long-term cost of caring for patients. Deferred care compounds the cost of treatment and leads to unfortunate outcomes. We agree with the language on e-consult, assuming that it would include teledentistry as well. We are not asking for a handout. We are asking for an investment in our patients. We thank you very much for this hearing today. I welcome your questions, and we will be submitting a written statement shortly.
Great. We'll look forward to that. And as much as we love seeing you, likewise, I think we would prefer not to if we have a system that works. Are there questions or comments from members of the committee? Seeing none, thank you very much.
Thank you.
Next up, we have Kathy Riley, followed by Heather Gates, followed by Wayne Graham.
Good afternoon, Senator Lesser and the representatives of the Human Services Committee. My name is Kathy Riley, and I'm the Director of Healthcare Advocacy and the Legislative Liaison at Gaylord Hospital. Thank you for the opportunity to testify in support of the $200 per patient per day Medicaid rate increase for Gaylord in Section 2 of House Bill 5459. We appreciate the committee's support and recognition of a Medicaid increase that would create payment parity for all of the state's long-term acute care hospitals. Gaylord is a 137-bed long-term acute care hospital known as an LTAC that cares for patients from the short-term hospital whose stay is measured more in weeks than in days. Our patients are either severely ill or have suffered a catastrophic injury. They are often still on telemetry, a ventilator, and in need of IV medications. They also need intensive rehabilitation due to the complexity of their medical issues. We are supporting the request for the $200 per day increase for the hospital. This increase will help us better serve one of the most vulnerable populations in the state. Currently, our Medicaid rate is about $950 per day, which is much less than the average cost of care for a patient at Gaylord of $1,700 per day. This limits our ability to provide care for so many Medicaid patients from our acute care partners. The $200 will not cover the entire cost of care, but the lower difference in coverage of cost will allow us to accept more Medicaid patients. And it at least puts us on par with the other LTAC in the state. This will also help patients who are sitting in short-term care hospitals unable to get the care they needed for their illness or injury. Inpatient rehab facilities, which are a lower level of care than Gaylord, and work with patients that are much lower acuity than we work with, are paid at a significantly higher daily rate. On average, the Medicaid rate for an inpatient rehab facility is about $1,483 a day. So that means lower level of care that works with patients who are less acutely ill than the ones we serve here at Gaylord are getting almost $550 a day more than we do to care for our patients. Not only are we able to maximize a patient's function and allow them to return to their community and life, we are also help to reduce rehospitalizations for one of the highest risk patient populations. When patients can't go to one of the two long-term hospitals in our state, they are often sent out of state, where the cost is significantly higher. And it's not only higher for the state, it's higher for the patient and their family as well. Gaylord appreciates the committee's consideration of a rate increase and inclusion in legislation this year. Our written testimony provides you with more details on the issues I spoke to today. Thank you very much.
Thank you for your testimony. Are there questions or comments from members of the committee? Yes, Representative Heffernan.
Oh, Kathy, thank you very much for all you do. I just want you to know that my father and my wife are both long-term patients in Gaylord, and you guys do a great job. Thank you.
Thank you very much. I'm glad we could service them.
Thank
Anything
you.
else?
Any other questions? If not, thank you for being here tonight, and I think we all echo Representative Heffernan's appreciation.
Thank you, Senator Lesser and the committee. Bye-bye.
Next, we have Heather Gates, followed by Wayne Grau, followed by Rosanna Ferraro. Hello.
Good evening. I'm good to see everybody. I am Heather Gates. I'm the president and CEO of Community Health Resources. We provide mental health, substance use, foster care, housing services to over 25,000 children, families, and adults throughout the state of Connecticut. Our workforce is almost 1,000. We're a local mental health authority, a CCBHC, and part of the state's crisis response system. And we have contracts with pretty much every state agency that works in the area of health and human services. I thank you for the opportunity to testify on HB 5374, an act concerning the an annual inflationary rate adjustment for nonprofits. You've heard me talk in other hearings about the impact of inadequate funding on our services and the challenges of hiring staff to meet the needs of those who come to us for help. The combination of the pandemic and inflation have been devastating to our ability to keep our programs fully operational. It's a vicious cycle of staff turnover due to low salaries, increased stress on the staff who are working, and less service being provided. We never know from year to year what our funding will be like, and so it makes long-term planning nearly impossible. Every spring, we put our budget together, and we are plugging holes and keeping our fingers crossed that we will be able to get through another year with a break-even budget. We work closely with our state agencies to address issues, but it doesn't always work, and there are times when cuts result in changes that they make as well. If our funding had kept pace with the rate of inflation over the last 10 years, we would have been able to adjust salaries to keep up with it. We would have been able to compete in the market with a more even playing field. Our vacancy rate and turnover would not have been so high, and that means we would have been able to serve more children, more families, and more adults, and that is why we exist. We would have been able to absorb the increased costs of health insurance instead of passing this along to our staff. And most critically, we would have been able to plan and anticipate increases in all areas of our budget instead of always begging for funding from our state agencies, the legislature, and the governor's office. The combination of grossly inadequate Medicaid rates, which you all have heard about, with behavioral health leading the charge in that area, and grant funding, which has not kept up with the cost of inflation, have led to a crisis in the behavioral health system for all ages, and that is just really shameful in a state that has so many resources. So I urge the committee to please support this bill and institutionalize increases so that we don't have to do this every year. I've been doing this a long time, and I will say that I'm kind of tired of it.
Thank you. Are there, and I hear you, are there questions from members of the committee? Seeing none, thank you for being here.
Thank you.
Next, we have Wayne Grau, followed by Rosanna Ferraro, followed by John McDonough.
Yes, good afternoon, Chairwoman Gilchrist, Chairman Lesser, and all the distinguished members of the committee. My apologies for my camera. My name is Wayne Grau, and I'm the Executive Director of the National Coalition of Assistive and Rehab Technology. I would like to thank Senator Seminara, Representative Case, and Representative Smith for participating in the Wheelchair Task Force. I would also like to thank Beverly Brakeman, the participating agencies, and the consumer who also participate in the task force. We appreciate the opportunity we were presented to work together to come up with solutions, and I'm glad to say we agreed on the vast majority of the task force recommendations. While we do support the majority of the task force recommendations, we have concerns with the bill's current status. So with great regret, I testify in opposition to SB 308 as written. The CRT industry recognizes that keeping wheelchairs in good working condition is vital. There were many recommendations about the consumers in the industry agreed upon would speed up repairs. And while many stakeholders participated, we were a little bit disappointed that even after hearing the consumer stories, the insurance industry was not willing to step up and remove the red tape of their creation to speed up repairs. I will tell you, during the task force creation and before the recommendations, the CRT suppliers hired additional service technicians. We expanded the inventory of common parts we keep in stock and added software to identify parts in other locations to speed up ship times. We also invested in remote technology that allows service technicians to partner with consumers to possibly identify a repair issue over the phone. Now, it doesn't work for all consumers, but in some cases, we can fix or assess the problem to speed up the repair. I will tell you that we were disappointed that some recommendations that would speed up repairs were not included in the bill, while other bill language was modified not to reflect what the task force recommended. We all agreed, the consumers and the industry agreed, that providing transportation for consumers to travel to store locations if they choose to get their wheelchairs repaired at our shop was a good idea. We shared that we could do 7 to 8 repairs per technician in the shop versus 4 to 5 in the consumer's homes. Sometimes we could even assess or repair the wheelchair the next day if the consumer could come into the shop. So it's not going to work for everybody, but we're hoping we can have some of the consumers be able to allowed to come in so that we can focus our travel service technicians, keep them available to give better and quicker service for those that simply cannot come into the location. And as always, we've always continually stated that we would always provide service in the consumer's home. Consumers in the industry also agreed that travel time and repair assessment needed funding. Presently, we provide in-the-home service 82% of the time. Time we spend traveling to consumers and assessing the repair need is unpaid. Task force recommended repairs within 10 business days after receiving all prior approvals and parts. The bill ignored this recommendation and included a deadline of 10 calendar days after the prior authorization was received. Many repairs for CRT products require parts from different manufacturers, and we did share our concern with the original language, but unfortunately, this language is not reasonable and we won't be unable to meet those stated deadlines. We'd also like to see the advisory group be developed. I want to thank the committee for your time. We stand ready to work with the committee, the consumers, and all stakeholders to finalize the language of this bill and speed up repairs for consumers who use complex rehab wheelchairs. So thank you very much. Senator Lesser, I'd also like to let you know that the committee has an incredible staffer in Chandra, and she has been great to work with. So thank you for that opportunity as well.
Thank you for all of that, except the last part. We were trying to keep things, keep Chandra under wraps, so you don't want to, word gets out, she'll get poached by someone real quick.
I'm not going to say anything else, sir. I'll keep it quiet. I'll keep it between us.
But just between you and us and the 8 people watching on CTN.
Right.
At the 12 in the room. Are there, and thank you, sir, for your service on the committee, although, or the working group, although I am disappointed that you're not in support of the bill today. Are there
just as written, sir. We want to work with you. Trust me.
Understood. I think I see Senator Seminara has her hand up.
Hi, Wayne. How are you?
Hi, ma'am. How are you?
I'm good, thanks. I wanted to thank you for all your work and your attempts to work collaboratively with us during the task force. I'm not surprised by your testimony, and but I reassure you that we're working alongside with the chairs to modify the language in hopes that it will bring maybe all of us in a better place at the end, okay?
Yes, ma'am. And I will tell you this, I commend all of you. You're leading the nation on this issue, okay? We appreciate it, but most of all, I know the consumers appreciate it. So thank you very much.
You're welcome. And I wholeheartedly agree with you regarding Chandra, too.
Okay. Any other comments or questions from members of the committee? Seeing none, I suspect this isn't the last we're going to be chatting. Mr. Grau, Wayne, we will, I think, be talking very soon. Thank you for your testimony and appreciate you being here tonight. Next up, we have Rosanna Ferraro, followed by John McDonough, followed by Kathy Klimzik. No Rosanna. Okay. By the way, we have just hit the halfway point, so. John McDonough. No, John? Oh, he's on. Okay. John, you're on.
Hello.
Yep, we can hear you, John. Go ahead.
Great. Thank you so much for your time. Just want to highlight some elements of the consulting that I've been doing for the last several years. I have the luxury of being able to send e-consults for patients that I've treated at Fairhaven Community Health Center for the past several years, and very grateful for the opportunity to assist the patients that I see receiving this benefit in a very timely timely evaluation with specialists. There's a number of benefits, but I'm just going to want to highlight just a few of them that are just I find important. One is just the quicker connection that patients will have with their specialists, which minimizes delays in diagnosis. Several days versus several months. So when we refer patients somewhere, certainly there's just automatically a delay in that process, but the e-consults we have answers within days. The specialist access facilitates the medical workup. So sometimes when we are questioning which tests to order or not order, or labs to order or not order, imaging tests to order or not order, the specialist kind of helps guide us there. So in some way, it's saving unnecessary tests that we're not ordering, as well as ordering the appropriate tests that do need to be ordered. Number three, the primary provider and the specialist are working in the same electronic platform. So the electronic or the specialist has that ability to go in and look at the whole chart and look at all the relevant information. It's not simply just the focus question from the primary, but they're actually able to see all of the medications previously prescribed, things along those lines. Number four, just when there's communication between the specialist and the provider, it kind of allows the provider to kind of get a sense, the primary care provider to get a sense of what the mindset is of the specialist and helps direct future workups for patients that come that they see in the future with similar medical problems. The next one is that there's actual knowledge transfer, right, from the specialist to the primary care provider to help make our skills improve and more efficient. And I think the other thing is that the questions that are answered, it's not always just one type of question that's answered. It can be an undifferentiated chief complaint, and they can help guide the whole differential possibilities. It can also be a very narrow focus question. Simply, I have an abnormal test, and what would you recommend I do at this point? Just examples, I've had the pleasure to work with cardiology consults and great cardiologists and dermatology and excellent dermatologists and neurology. And I think the patients certainly have benefited from their intervention, certainly just cutting down that time while they're waiting, right, to get appropriate testing and treatment. So we just want to thank you for the time and allowing me to testify on behalf of the e-consults.
Thank you for your testimony and for being religiously observant of our bell. Really appreciate it. Are there questions and for sharing your experience? Are there questions from members of the committee? Seeing none, thank you for your testimony here tonight. Next, we have Kathy Klimzik, followed by Kathy Flaherty, followed by Mike Dwyer.
Good afternoon, Senator Lesser and members of the Human Services Committee. My name is Kathy Klimzak, and I personally appreciate the opportunity to testify today. I'm a physical therapist at Sarah Inc. Kid Steps with over 40 years of birth to 3 experience, 30 of which I've done here in the state of Connecticut. And I'm here in support of House Bill 5459. I've seen and served thousands of families throughout my career, and I could talk at length about the impact birth to 3 has had on the lives of children and families in our own state. But today I'd like to focus on one family that stays in my mind, and it's a family that I went to do an eligibility evaluation for over 10 years ago. And it was a child with a rare genetic disorder and multiple complex medical issues. The mother was basically told to take the child home and love her because she wasn't going to live very long. Needless to say, this family was in a very difficult situation, and as a birth to 3 provider with a team of professionals from the agency that I worked at, we came alongside this family to support them as they waited for their child to die. I can testify today that this child is not only still alive, but she is thriving and engaged in a public school setting. And as I think back to how Birth to Three made an impact on this family, I'm reminded that we were able to support this child and family during very tense and difficult medical emergencies. We were able to coach these parents in activities to help their child grow and develop. And we were also able to give this family the information and skills to become advocates for their medically complex child. They would use those advocacy skills constantly in the medical and educational world. They would continue to be immersed for years to come. The scope and the role of a Birth to Three provider is deep and wide. We are called to support families in areas beyond our typical professional training. And we work not only with children that have developmental issues, but also with those who have many other challenges, including trauma, domestic violence, homelessness, food insecurities, loss of a parent, and medical challenges, just to name a few. We all know that Birth to Three is a successful program that greatly impacts families, but it's also a business that requires funding to support the work. It is increasingly difficult to attract and retain qualified staff due to the inability to offer competitive wages when our rate does not even meet our regular operating expenses. The rate has not changed since 2017, while inflation costs have increased. The rate in Connecticut is currently 29% less than what it costs to deliver our services, and I don't think that that's a business model that can be sustained. We've already had one program close, and how would the closing of more programs affect the children and families in our state? So I please urge you to support the current proposal to increase the rate so that families, such as the one I described above, can receive the professional supports that are necessary to meet their needs to help their child grow and flourish to the best that they can be. So thank you.
Thank you for your perfectly timed. Thank you for your testimony. Any questions from members of the committee? Yes, Representative Comey.
Thank you. Thank you, Kathy, for your testimony. I was wondering, you mentioned you were a physical therapist, is that right?
Yep.
And I also see on the sign-up sheet that you're in maybe a management position as well.
Yes, I am.
Yeah. So my understanding in that is that it's super difficult to find staff for the Birth to Three programs, especially for physical therapists. Is that correct?
That is true. It is correct.
And how many do you have on staff?
That see children, we have 2 full-time and 1 part-time, and we have over 800 children in our program.
Okay. All right. Well, thank you for everything.
Sure.
And,
Thank
I
you.
appreciate you testifying.
Thank you.
Thank you, Representative. Other questions, comments? Seeing none, thank you for being here tonight. Kathy Flaherty, followed by Mike Doyle, followed by Christina Emery. Good afternoon.
Still afternoon. Good afternoon, I think.
We'll call it afternoon.
We'll call it afternoon. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project, and I'm here to offer support for 2 bills, 5374 and 5455. CLRP provides legal representation to DEMIS clients. Our clients depend on benefits from the Department of Social Services, and a lot of them do, share the experience that other people have of long waits to reach the benefits center. They can't necessarily access information online. I think there's a lot of move here in the state to transfer business to online, which is great. And I personally love it because it works for me because I don't have to interact with people, surprisingly. But for our clients who who lack access to technology, lack access to be able to do it, really need to be able to speak to staff, and they have very long waits. I was a little surprised when the commissioner reported this morning that they report the data publicly, because they did, but then they stopped. If you look, the last time they put data on was either October or November of 2023. So we actually don't know how the Benefits Center is currently doing. And I think you could strengthen the language of that bill to require ongoing monthly reporting of that data so that we know that if they address it 1 month and it's in really good shape, that they keep it that way. 5374 is really important because the nonprofit providers provide very valuable services, as I'm sure you've been hearing all day. Our clients, some of them receive their services in the community from state-operated local mental health authorities, but the vast majority really receive
their services from private nonprofit providers. And so much of mental health depends on building those trusting relationships and that therapeutic alliance. If they can't keep staff and staff is constantly turning over, they're not going to be able to build those alliances with people and rebuild their lives. And I really encourage you to think about having a process where there are regular increases in line with inflation for the nonprofit providers once we get them caught up on the funding that they have missed out on for the last decade. Thank you.
Thank you, Kathy. Are there other questions or comments from members of the committee? Seeing none, thank you for being here this afternoon. Next up, Mike Doyle, followed by Christina Emery, followed by Megan Alfiero.
All right. Good afternoon, Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. My name is Mike Doyle, and I'm a registered voter in Gales Ferry. I'm also the Recovery Unit Director at Reliance Health in Norwich. I'm here to support House Bill 5374, an act concerning indexing the annual inflationary rate adjustments for community nonprofits. I submit a written testimony, and I encourage you to take a look at it as it goes into some of the stuff that I'm going to talk about today in greater detail. As you probably noticed, staffing's been a pretty hot topic today. Programs that I have been affiliated with over the past year, either I've overseen them or I still currently oversee them, are currently 50% understaffed. That's directly tied to funding. I know that the individuals that have left, because I keep in contact with them, didn't leave because they wanted to. They left because they had to pay their bills. It's funny because I stay in touch with them, and a lot of times the texts that I will get are how unhappy they are at their new jobs. So there is definitely that. They didn't want to necessarily leave, but they had to take care of their family. And it's made hiring very difficult. There's a position right now that we've actually had to repost for the second time. It's actually 2 people have accepted the position, and then they have backed out before starting. In fact, one of the people backed out the day that they were supposed to start. And that's after doing all the background checks and things like that. So it's been really frustrating and tough to attract good, quality staff and to keep them. So MIT calculated the living wage in Connecticut. It's at $24.13 an hour, and that's for a single person with no kids. A single parent with 1 child is estimated at about $47 an hour. And being that our starting rate and most of the starting rates that you've seen here are around $18 an hour, you can see that there's a tremendous gap there. In my written testimony, I talk about the ripple effect that happens when there's a disruption in services or personnel for the people that we work with. One of the programs that I oversee is the Recovery Coach program. I currently have 3 recovery coaches, and we have a slot for a 4th, but that's been unfilled since May because, again, it's been difficult to attract and hire the right people. They've called recovery coaches the missing link in the treatment process. It's a combination. People have a combination of lived experience, and formal training. They basically form that walk the mile in your shoes bond with the person. All the people that work in my program, including myself, are in recovery, and they do it because they have a passion for working with people in recovery. They're all certified, and even that starting wage is $19.30 for a certified recovery coach, which is a little better than 18, but nothing really to sneeze at here. But the ripple effect with that for a lot of the people that we work with in recovery is that they're usually coming to us in their most vulnerable state. They're looking for support, connection. Might be looking for treatment, might simply be looking for Narcan, or just to put in touch with other people in recovery. In my 12 years in the field and 25 years sober, I've learned one undeniable fact. That is, the window for people seeking help is very small and stays open for a short time. The ripple effect that we worry about is
Sir,
that
time has expired. Can you please summarize?
Sure. So earlier you met Autumn. Autumn was one of my recovery coaches, and she talked about how she had to take extra shifts to make ends meet. That really shouldn't have to happen, especially in this stressful position like a recovery coach position. Unfortunately, we have 3 people doing the work of about 6 people because their caseloads are double where they need to be. So I'm just asking for you to support House Bill 5374 and index future funding against annual inflation rates. Thanks for allowing me to testify today, and I'll be happy to answer any questions.
I thank you for your testimony. Are there questions for members of the committee? Seeing none, thank you very much. Next, we have Christina Emery, followed by Megan Alfiero. Long time no see.
Good evening, Senator Lesser, Senator Seminara, Representative Cook, Representative Case, and distinguished members of the Human Services Committee. My name is Christina Emery of Brooker Memorial in Torrington, Connecticut, and I appreciate the opportunity to come before you once again to discuss HB 5459. For over 100 years, Brooker's been serving children throughout Northwest Connecticut. Since 1994, we have provided pediatric dental care, serving over 5,000 children last year. 80% of these children are on Husky and 5% are uninsured. Long before the Medicaid rate study, we have been keenly aware of the need for rate adjustments. Last fiscal year, we lost close to $22.50 for every visit at our facility for dental care. The recently completed Medicaid study reported that the delta between current rates for pediatric care compared to the 5-state benchmark is not as low as that for adult dental care. As a result, language in HB 5459 calls for adjusting rates to achieve parity. As you consider this as an important first step, I urge you not to increase reimbursement rates for adults at the expense of children. As we've already heard this afternoon, both rates are woefully inadequate, and we cannot continue to lose ground. Brooker is a unique safety net provider. Unlike the other 29 agencies, we are just one of 2 that is not an FQHC, hospital, school, or public health entity. Our average reimbursement rate is $24 less than that of the PPS rate, and approximately 65% of that of private insurance. To address this unique situation, I ask that you consider language that would create parity for private nonprofit safety net providers by increasing reimbursement rates for Husky patients to that of the PPS rate for dental care. In previous appearances here, Senator Lesser asked very valid questions regarding our ability to become an FQHC, which I'm happy to address in a bit more detail. While more consideration on this issue needs to be undertaken by our board, initial research shows that this would be a lengthy undertaking that would require a fundamental change to our mission, services, and governance structure. Brooker Memorial does not provide the full continuum of care required by FQHCs, which include medical and behavioral health, access to specialty and hospital care, and after-hours coverage. While FQHCs are allowed to enter into written agreements with other entities for services not directly provided, research shows that all of the Connecticut FQHCs currently offer the full array. In addition, our board, which have been careful stewards of Brooker's mission and finances for over 100 years, would need to be overhauled to ensure that 51% of directors are agency consumers. Finally, the opportunity to apply for Section 330 funding is extremely competitive and infrequent. I appreciate the opportunity to once again discuss our unique safety net services, and thank you for your time and consideration.
Thank you for your testimony and for keeping me from asking the question I've asked you now twice previously. So appreciate that answer. Are there comments or questions? Yes, Representative Cook.
So thank you, Mr. Chairman. So Christina, to your point about the FQHCs and the research you've done, what prohibits us at Brooker from qualifying as an FQHC?
Well, again, if we were not to provide the full array of services, we would have to enter into an agreements with other providers, and, expand our, hire a medical director, change our board structure. It's not something that we're unwilling to do, but we would just need to give it some more thought and consideration to see if it really fits in with our initial mission.
And if that's something that we thought would work to our benefit in the collaboration world, would that be a partnership with the FQHC on Midgeon? Would it be a different group? What would that look like for us? I
Ye-
hear the board and all the other
Yes,
structural issues,
sure.
but where would we look at?
Sure, this is, I'm answering for myself, but I believe the collaboration would be with our local FQHC. We already work very closely with them and providing pediatric dental care and refer parents in our program to them for adult care. So we have a long-standing partnership and collaboration with Community Health and Wellness.
Thank you. And thank you again for being here. I
Thank you.
greatly appreciate it in your work. Thank you, Mr. Chairman.
Thank you, Representative. Other questions from members of the committee? Seeing none, thank you very much.
Thank you.
Next up, we have Megan Alfiero, followed by Joe Pandolfo. No Megan? Joe Pandolfo? No Joe. Sandra Roberts? No Sandra? Daniel Fitzmaurice? Daniel, you need to accept the promotion. If you're on the Zoom and you're offered a promotion, you need to accept it or we cannot hear from you. Not accepting it. Okay. Please accept it. We want to hear from people. Next, we have Francesca Perez. Okay. Moving right along, we got Thomas Burr. I saw Thomas in another committee earlier. He didn't think we would get there that fast. Well, we will wait a minute for Thomas to get back in the room, but meanwhile, is Lisa Otto around? Wow.
I feel like I should know bingo. Something from Rocky for sure. Good evening, and thank you all so much. Thank you for the long, long hours you're putting in, listening to all of us describe the human services we're providing right now. My name is Lisa Otto, and I serve as the CEO of Child and Family Agency of Southeastern Connecticut. Child and Family employs 260 staff to provide behavioral health, medical, and supportive services to over 10,000 children, families, and adults in New London, Middlesex, and Windham counties each year. I'm here to join my colleagues in testifying in support of HB 5374. This important bill would immensely help us to stabilize our budgets and provide additional services to the state's most vulnerable populations. I'm deeply appreciative of the increases that you all have been able to provide over the last few years, but they haven't been enough to meet the needs of the people we serve. We continue to be hit by crippling increases in our costs, due in part to increases in inflation that far outpace the rate of increases the legislature has provided. I just wanted to add a few data points specific to Child and Family Agency regarding the impact of that inflation. Our health insurance costs have increased by 15% since 2019, and we were recently told by our broker to expect an increase of approximately 20% in the upcoming fiscal year. The cost of our electronic health record has increased from about $145,000 in FY 18-19 to $356,000 in this fiscal year, an increase of 245%. Our outpatient psychiatric clinics for children in Groton, New London, Pawcatuck, and Westbrook have seen a staggering 56% increase in expenses since FY 14. These increases, primarily driven by rising salaries, fringe benefits, and health insurance costs, far outpace the 11% increase in grant and fee revenue we've seen during the same period. As a result, most of the services that we deliver now function at a deficit. We anticipate facing a deficit of over $875,000 for our 4 outpatient clinics this year alone. We've employed a range of strategies to attempt to manage the devastating impact of inadequate funding while protecting our vital safety net services. These include selling agency assets, including 3 buildings in the past 4 years, and closing and reducing services. We were forced to close the final ICAPS program serving New London County after 10 years of program deficits. We have restructured leadership and reduced the size of our team, resulting in daunting increases to the workloads of each of our directors. If the rates the state pays for our services had increased along with inflation since 2007, we would have been able to maintain competitive salaries to retain our skilled and highly trained workforce. With competitive salaries, we would be able to fully staff our outpatient and intensive in-home programs. With adequate funding and adequate staffing, we would be able to expand our in-home programs and reintroduce ICAPs to meet the ever-increasing community needs. I urge this committee to support HB 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers. Thank you all so much for your time.
Wow.
That's good.
Yes, you've done this before. I thank you for your testimony and appreciate hearing your story. Are there questions or comments from members of the committee? Seeing none, you.
Mr. Chair,
Oh,
you said 874,000 you lost this year?
That's the deficit we're anticipating for just our 4 outpatient clinics this year.
This year?
Yeah, and on June 30th.
Okay, thank you.
Last
Do you
year
know what it
up
was last year?
Slightly over $1 million.
Okay, thank you.
Thank you. Any comments? Not seeing none. Thank you for being here. Mr. Burr is back with us virtually, I believe. Thomas, are you there?
Yes, I'm here. Good afternoon, Senator Lesser. It's still afternoon, barely. And Representative Gilchrist and members of the Human Services Committee. My name is Thomas Burr, and I'm the Public Policy Manager of the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. I am testifying today in support of the following 2 bills, HB 5374 and HB 5455. Regarding 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers. You already have my written testimony, and you've heard a lot of people weigh in on this. I'll just give you kind of my own personal experience. When I joined NAMI as an employee back, oh gosh, it's 13 years now. They offered me the job, and I said, I really want to take this job, but I need an accommodation because I can't afford to live on what you're paying me. But if it's okay, I work a second job, then I can say yes to this. And they said, oh yeah, no, you can work a second job. I didn't realize that the joke was on me, and that most of the nonprofit provider world, the employees work 2 jobs or they work double shifts. There's no way to live on what the nonprofit world pays. I literally make 1/3 of what I used to make in my corporate days of 20 years ago working for the nonprofit. It's just ridiculous. And the legislature really needs to do the right thing by the people and fund the nonprofit world in a sustainable fashion so that people don't have to work these crazy hours, don't have to work 2 or 3 jobs, and can, have a living wage. Regarding HB 5455, an act concerning the efficiency of the Department of Social Services in determining eligibility for medical assistance or responding to requests for information or assistance. I'm sure you already heard the really compelling testimony earlier today by Sheldon Tubman, who I'm sure was much more eloquent than I would ever be. So I just want to echo his concerns about 5455. We really do need to get this information from DSS regarding the performance of their call centers. I know I listened to the commissioner's testimony earlier this morning, and I know that she believes that they're doing a really good job in reporting here, but the reality is they're not. And that just needs to change. The only way we can be sure that this is happening and that people are getting service in a timely fashion is to get the numbers and get them on a monthly basis and hold them accountable to what they're supposed to be delivering. So with that, I will end my testimony, support these 2 bills with the additional additions on 5455, and I would take any questions that you should have. Thank you.
Thank you. And thank you for taking that pay cut and serving the general public.
Well, I do it because I love the work, and it's important work that we do. And I thankfully I can afford to do it and work 2 jobs, but it's not fair. It really isn't fair.
Are there questions or comments from members of the committee? Seeing none, thank you again.
Wonderful. Have a great evening.
You too. Next up, we have Cooper Westerkamp, followed by Victoria Kozar.
Good evening. My name is Cooper Westerkamp, and first off, I would like to thank all of those who have provided testimony today. I've learned so much from your sharing, and keep up the great work. I'm a resident of the 12th District who has had type 1 diabetes and been insulin dependent for the past 26 years. I wanted to express a little dissatisfaction with the current language of SB 8, an act concerning drug affordability. Please don't misconstrue my displeasure with the bill's overall direction or idea. It would be best to minimize out-of-pocket costs for prescriptions for state workers, as well as all of your constituents. That being said, all people with diabetes in Connecticut are subjected to some of the most overt pharmaceutical price gouging over the past 20 years. With my previous insurance plans, I had been forced to pay $1,200 for a month's supply of insulin that my life literally depends on. Imagine paying rent or your mortgage twice a month just to appease a high deductible healthcare plan. Not to mention, the cost of insulin production has remained low and unchanged despite the price increases. Importing affordable insulin from Canada only slaps a Band-Aid on the problem while doing nothing to address the systemic bleeding. As someone who attained a master's degree in healthcare administration from a Connecticut university, please believe I brought receipts. According to calendar year 2021 DPH data, 10.8% of all Connecticut residents have diabetes, with 19,000 new cases diagnosed every year with numerous undiagnosed individuals. That accounts for almost 11% of every constituency on this committee. There's also a disparity with our Medicare and Husky recipients, where 30% have diabetes compared to 10%. SB 8 does little for access and equity outside of our state workers. Age-adjusted hospitalization rates, AIDS-adjusted mortality rates, and years of potential life lost all impact BIPOC communities disproportionately. The final draft of SB 8 needs to go further than state employees and include all residents of Connecticut. In calendar year 2018 alone, the total charges for inpatient hospitalizations with diabetes listed as any diagnosis was $3.9 billion. Increasing access to affordable insulin would shift some of the financial burden away from residents and our healthcare system. Minnesota Bill HF 3100, or the Alex Smith Insulin Affordability Act, has been very successful in its short run, shifting the cost burden onto insulin manufacturers instead of the state. Their law provides a framework of collaboration between manufacturers, pharmacies, and oversight committees to offer residents life-saving access to insulin at a capped price. Why are we not trying to build on Minnesota's proven model while increasing access to all Connecticut residents? Connecticut has been a paragon of innovative legislation that has served as a model for the rest of the United States. Just recently look at HB 6515 or the Crown Act. Why not solidify our state as the champion of access to insulin is a human right, as mentioned in earlier testimony today? The desire and solutions are there. We just need the legislator to make good on their promises. You would save lives if you chose to right the ship and deliver access to all Connecticut residents. You would garner national attention by solidifying SB 8 as Connecticut's answer to equitable and affordable insulin with the potential for nationwide scalability. Thank you very much, and I appreciate your time. Please feel free to look into my written testimony for more in-depth nitty-gritty figures, and if there are any questions, please feel free to reach out, and I'd be happy to discuss.
Thank you for your testimony. And I will review your written testimony. I haven't had a chance to read it yet. I apologize. But so are you, I understand what you're saying about limiting it to state employees. I think the intent is to help a lot more folks than that. But is there one question about the amount that you're spending out of pocket, or you were spending? We did pass a cap on insulin costs for insured residents a few years ago at $25 a month in this state. Was your plan not compliant with that, or was that before that law went into effect? I mean, there are some exceptions as well that doesn't cover all different types of plans due to the way the insurance is regulated.
A little bit of all of the above. So some insurance plans have decreased that cap by themselves, mostly due to a lot of grassroots organizations who have just appealed every large claim that they've put on to people for those large prices. So yes, there has been certainly a scaling back as far as people who can afford health insurance coverage. So there's a huge swath of individuals who may not be covered, who are either underinsured or uninsured.
And so the alternative idea that you have is that we pass the Minnesota Alex Smith law?
I would say that that would be a great starting point. I believe that there is opportunity for more equitability in Alex law as well. And if we wanted to be the tone setters for the United States, I think that would be a great place to start.
Well, we wouldn't. We'd just be copying Minnesota, but that's okay. I'm not against that.
No, I understand. I meant improving on Minnesota's proven model by making it more accessible.
Gotcha. Okay. Any questions or comments from members of the committee? Seeing none, thank you very much. We did skip over Daniel Fitzmaurice before, but I think he had some technical issues, but is now back with us.
Yep, I got the button pressed.
Great.
I'm Daniel Fitzmaurice, the Director of Advocacy at the United Way of Connecticut. My pronouns are he, him, and I live in Orange. Thank you to all of you, legislators and staff of the Human Services Committee, for hosting this public hearing for so many hours. I also want to very specifically recognize everybody working tirelessly behind the scenes, from the Zoom tech that helped me get here to the folks who keep the building clean every night. Your contributions ensure that these hearings and our communities run smoothly. Today, I'm here on behalf of many who go unnoticed, the 500,000 ALICE households across our state. ALICE stands for Asset Limited, Income Constrained, and Employed. These are the cashiers, teachers, security guards, and countless others you meet every day who form the backbone of our communities. But they're living paycheck to paycheck, barely affording basic necessities. These families deserve to thrive, and that's why we strongly support House Bill 5374 to finally stabilize funding for the critical services ALICE families and countless other neighbors in our state rely on. This bill offers a simple, powerful solution. Indexing their funding to inflation will allow these organizations to focus on serving our communities, not constantly struggling to keep their budgets afloat. Furthermore, this allows these nonprofit organizations, as was just mentioned, to offer wages that keep up with inflation for their workers. Remember, many of these dedicated individuals that provide critical services themselves are living paycheck to paycheck. This, in turn, strengthens our local economy. Studies show time and time again that low and middle income workers spend all the additional income they receive right away. This means more money circulating in local businesses, more bills paid right on time, and more fresh fruit on the table. Right now, we're facing a perfect storm. ALICE families and too many others need more support than ever from these community service providers. The organizations and their workers, though, are struggling to meet the growing demand while battling rising inflation and insufficient funding, as I know you're hearing. House Bill 5374 is a common sense solution to help close this gap. Thank you for your time and your leadership on this issue.
Thank you for your testimony. Questions or comments from members of the committee? If not, thank you very much. We also have someone else that we skipped over, Joe Pandolfo.
Good evening, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the committee. My name is Joe Pandolfo. I'm speaking on behalf of the Connecticut Society of Acupuncturists. And we'd first like to thank you for your service on the committee, and especially for the committee's work a few sessions ago incorporating the services of licensed acupuncturists into the Medicaid program. Our practitioners report that the Medicaid participants are among their most appreciative and conscientious patients, and especially with respect to patients who come for pain treatment. The patients are profoundly grateful for the ability to get acupuncture treatment for their pain and to reduce and in some cases even replace opioid pain prescriptions. In the broader sense, there's more and more data showing that care by licensed acupuncturists, the fully credentialed, fully trained acupuncturist, is having the effect of reducing the use of opioids in various health programs. The VA uses acupuncture care extensively. There are other state Medicaid programs that have done studies, pilot studies, and so on the use of acupuncture as a pain treatment and its effect of reducing the use of prescription painkillers. And Medicare now recognizes acupuncture as a covered service for that very reason. Our practitioners in the Husky program also report that the fee schedule, as you've heard from other professions here, is outdated and is significantly lower than the rates and benefits that other patients can bring from other benefit programs, such as the state employees, state retirees plan. And the Husky rates are even significantly lower than the Medicaid CMS rates. Excuse me, the Medicare CMS rates. So our request here tonight is that in your review and updating of the fee schedules for professionals, that we update the acupuncturist fee schedules on an accelerated timetable and bring it into this year's updates. I think that the benefits of the services that the acupuncturists are providing are extremely valuable to patients, but also valuable to the system overall, especially again, and with respect to their ability to reduce the use of costly opioid prescriptions, direct and indirect costs. And that's the extent of my comments. I do have data that I'd be happy to forward to committee members regarding the rate comparisons to Medicare, for example, and also data from pilot studies and other state Medicaid programs and other cost effectiveness studies. So I'd be happy to forward those to committee members as a follow-up to my testimony, and I'd be happy to try to answer any questions that you might have. And again, thank you very much for the opportunity to comment.
I thank you for that offer and appreciate your testimony. And if you could, instead of directing it directly to the members, if you could send it through the committee clerk, she can then work to make sure that that gets out to the members.
I will do that. Thank you.
Thank you. Are there other questions or comments from members of the committee? Seeing none, thank you very much.
Thank you.
Next up, Victoria Kozar, followed by Jim Schmerling. No Victoria. Jim Schmerling.
There we go. Thank you, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. Thank you for the opportunity to share my support of House Bill 5459, an act increasing rates of Medicaid reimbursement for certain providers. My name is Jim Schmerling, and I'm the president and CEO of Connecticut Children's Medical Center. As our state's healthcare safety net for children, Connecticut Children's devotes significantly more care to patients who rely on Medicaid than hospitals whose primary focus is on adult medicine. More than half of our patients who require inpatient care and nearly 2/3 of children who require emergency care rely on Medicaid. This fact, combined with our lack of Medicare funding, means that Connecticut Children's payer mix looks much different than other hospitals. Connecticut Children's also stands apart because our patients are sicker. We have the highest Medicaid case mix index in the state, 1.85 versus the statewide average of 1.38. Given that children who rely on Medicaid comprise such a significant percentage of our total patient population, low Medicaid payments have a more dramatic impact on our financial viability. We also do not participate in the hospital settlement, and consequently, we do not benefit from the annual Medicaid rate increases. Our Medicaid reimbursement must be sufficient to sustain our mission of providing the care that children and families deserve. Section 3 of this bill would make progress toward that sustainability goal for Connecticut Children's. Our organizational Medicaid shortfall is further exacerbated by the fact that pediatric medicine generally costs more than adult services. One reason why pediatric services are predictably and appropriately more expensive has to do with the age range of our patients. About 50% of the inpatient care we provide is for children under the age of 1, and about 70% is for children under the age of 6. Much of this age profile is driven by the typically long lengths of stay in our NICUs and providing care for very young children, which requires more staff per patient than in adult medicine. While regularly managing variability in our costs, we maintain a continual improvement mindset, which is left to streamlined internal processes and cost efficiencies. According to a 2023 study by the Children's Hospital Association, in 2021 and 2022, Connecticut Children's had the 6th lowest operating expense per adjusted patient day out of the 37 children's hospitals surveyed nationally. Even with our focus on innovation and efficiency, Without a longer-term revenue solution, Connecticut Children's Medicaid reimbursement structure is absolutely unsustainable. To sustain the quality of and access to our services while maintaining long-term financial sustainability, Connecticut Children's annual Medicaid cost coverage needs to increase to 62%. In fiscal year 2024, achieving 62% cost coverage would require an additional $42.1 million per year in Medicaid revenue. State leaders must treat children equitably by recognizing their unique needs and costs in Medicaid through pediatric-specific program design and financial investment. Section 3 of this bill is a step in the right direction. By strengthening the Husky program, state leaders can ensure that all children have access to the healthcare services they deserve, regardless of their zip code or their caregiver's income levels. That concludes my testimony, and I'd be happy to answer any questions. Thank you.
Thank you for your testimony. You know, I've been generally aware that CCMC did not participate in the hospital settlement, but do we have, and I absolutely should know this, but can we see side-by-side comparisons of what you receive in Medicaid rates versus what participating hospitals do? Is that something is that data that we have available?
Yes, I believe that was in the written testimony that we provided, but I could share with you briefly. Connecticut Children's, let's see, cost covered. The average hospital in Connecticut is about 62%. We're recovering about 57.5%. And that has to do, and I know that the state has some differential payments. We get a supplemental line item. But when we compare our costs, which are necessarily higher, when we're taking care of children who are in the newborn intensive care unit or ICU, which is almost half the patients we care for, it requires 1-to-1, 1-to-2 nursing, which is a much higher staffing ratio than you find in adult hospitals. The cost of labor is much higher. And then the cost of supplies, because we see children who weigh 1 pound and have tiny little blood pressure cuffs, all the way up to a 200-pound 15-year-old who has a fractured femur. The supply cost to take care of children, because of the wide range of ages and sizes, costs more. And so our cost recovery is lower than the cost recovery of the other institutions, even while we're getting some supplemental payments. Even with those, we're still way below what the adult hospitals are receiving as a percentage of their total cost.
And is there a way to compare apples and apples? You know, obviously there's labor and delivery beds at there are children's healthcare services provided at other hospitals in the state. So
there are. Yes, sir. You're exactly right. It's really not that they provide those services, but it's a percentage of what they do. So it's a much smaller percentage of their total business. So their average acuity, which is the severity of the illness, is much less overall than the acuity of patients that we're caring for. And they have Medicare and commercial payers. We have, I think it's around 2% of our patients are Medicare, which pays 30% more than Medicaid. So they have a much different payer mix, which pays more on a per patient basis.
And how about Yale Children's Hospital?
Yale Children's, well, there's not really a Yale Children's Hospital. It's a service line of Yale University, and their cost structure for pediatrics is not broken out separately. It's integrated with the whole system. It's about 10 or 15% of their total volume. So the losses they may incur with Medicaid and pediatrics is more than offset by the commercial and Medicare payments that the system receives. And their percentage of Medicaid at Yale University hospitals are significantly less than the Medicaid percentage. We have the highest Medicaid percentage of any hospital in the state.
Thank you very much.
Thank you.
That is very important information for us to get. Are there questions or comments from members of the committee? Representative Gilchrist. Oh. Thank you very much, sir.
Thank you.
All right, next we will hear from Victoria Staub, followed by Dr. Kenneth Stone.
Hello. Thank you for the opportunity to testify today in support of Section 1 of HB 5459. My name is Victoria Staub, and I am here representing the ICAPS network across the state of Connecticut. ICAPS stands for Intensive In-Home Child and Adolescent Psychiatric Services. and we treat the most acute families across the state. On average, we serve about 2,000 children and adolescents and are primarily Medicaid fee-for-service funded, which means we receive no additional grants. About 6% of the kids that we work with are private insurance, so it's really primarily Medicaid. And since the pandemic, we've seen multiple site closures due to 2 decades of flat funding for our Medicaid rate, leaving no coverage in Windham and New London County. Both of those sites had lengthy wait lists when they closed. And there's really a gap in services for children and families who are in the most acute need. We're a team-based approach. Our work takes place in the home, in the community, and in the school. It's really wraparound. We work with both child and parent mental health, and many of the families that we work with are struggling with the long-term impact of complex trauma. A large part of my job is listening to the stories of children and families who are in the program. We now have 16 sites from 20 and well over 500 families on the wait list, a clear indicator of the ongoing stressors impacting the most in need. The many stressors that have disrupted families during and after the pandemic have also impacted our workforce, leading to staffing shortages and folks just dealing with the most unprecedented psychiatric acuity, chronic suicidality, school absenteeism, isolation, substance use. And this is not just for the children and adolescents, this is for the parents too. We're seeing children coming into the program younger, and especially as there are less services for the youngest children, we see those kids as well. Wait lists are impossibly long across the state. Outpatient clinics, it takes months. For in-home services, our longest wait lists are up to 5 months in our urban centers, Hartford, Bridgeport, Waterbury. And this is unacceptable for a program that is supposed to be working with families who are in the most acute crisis. Obviously, the waitlist gridlock really erodes families and children's trust in mental health systems and institutions. And this chronic underfunding has made it difficult to access services at exactly the time that they are needed the most.
Victoria, your time has expired. Can you please summarize?
Sure. ICAPS, I think ICAPS works with the most vulnerable part of Connecticut, and I think it should receive priority in terms of a Medicaid rate increase. Thank you for your time.
Thank you so much, and thank you for the work you do and for being here and sharing that with us. Senator Seminara.
Hi, Victoria. Thank you so much for coming to testify. A theme I've heard all day long now is that ICAPs are unable to provide, providers are really closing in an unbelievable rate, and you're not able to provide services. And I just want to address you and say thank you so much, because I do agree with you that there's a very, very vulnerable population out there that we're clearly not meeting the needs, because quite frankly, we just don't have people capable of servicing them. And my concern level has risen greatly from this this testimony today. So hopefully we can take a look at that and improve that service area. But I thank you so much for what you do, and please recognize I think we all here recognize the difficulty of your job. So thank you so much.
Thank you.
Representative Hughes?
Thank you, Madam Chair. Thank you, Victoria. You mentioned wait times of 5 months of these kids and their families in crisis. What happens to them while they're waiting?
Some stay on the wait list, some will go into IOP for a period of time and wait. Some fall off and go back to the ED, some get rehospitalized. We see all of the above. Some get disconnected for a period of time until they end up back in the emergency room and get re-referred.
And just one more question around that. Do you know how many are staying in school? Are they just home with their families, just in a holding pattern? What's happening there?
So I don't have exact data, though I could maybe work on getting it for you, but we see a significant amount of school disconnection. This is actually one of the things have some evidence base of being somewhat effective at reducing, but these problems have just become more entrenched since the pandemic.
Okay, thank you. That's helpful.
Representative Dathan?
Thank you so much, Madam Chair, and thank you for your testimony and your work. One of the things that I was thinking about was IOP programs, and you happen just to be bringing that up today. In terms of organizations like yours, what sort of IOP programming is offered? And is there Medicaid reimbursement for such programs? Because that's one way to at least get some of these young people working in group therapy.
So we're an in-home program. We provide kind of 6 months of wraparound family psychotherapy for both parent and child, usually after 6 weeks of IOP. And this with the kind of very clear idea that 6 weeks, can stabilize some, but oftentimes families are needing much kind of longer term support to address some of the chronicity and the trauma that we're working with. So we're at 16 different agencies across the state, and some have IOPs and some do not.
That's really helpful, and I appreciate that. I didn't know if you had something. I understood you were working a lot in-house, but I didn't know if there were maybe some community-based programs that you do as well. So thank you so much for your testimony, and thank you, Madam Chair.
Thank you, Representative Dathan. And thank you again, Victoria, for your testimony and the work you do. Have a great night.
Thank you all.
Next is Dr. Kenneth Stone, followed by Francesca Perez.
Thank you, and good evening. My name is Kenneth Stone. I'm an anesthesiologist. I'm a member of Woodland Anesthesia Associates, and I work primarily at St. Mary's Hospital in Waterbury, representing the Connecticut State Society of Anesthesiologists regarding House Bill 5459 Medicaid reimbursement. Anesthesiology is uniquely undercompensated by Medicare and Medicaid in a manner that is disproportionate to all other medical specialties. A GAO report in 2020 found that anesthesia payment rates were 28% of commercial rates compared to 74% for all other physician specialties. In Connecticut, Medicaid payment for anesthesia services is 17% of commercial. The disparity in payment for services by Medicare compared to all other specialties is a result of a deeply flawed methodology in calculating anesthesia reimbursement by government payers when the current system was created 40 years ago. Many physician practices, particularly in some specialties, are satisfied with Medicare payment. Anesthesia practices lose money with every Medicare and Medicaid payment. Payments by these government programs do not cover the cost of providing care. In the recently published DSS report on Medicaid reimbursement compared by Myers and Stauffer, 5 states were selected for comparison. No reason was given for why those states were chosen, but certainly not geographic, since Oregon was included. They found that Connecticut anesthesia unit rates are 85.6% of the 5-state average. A similar survey of Medicaid unit rates by our national society, the American Society of Anesthesiologists, collected data on 27 states by searching publicly accessible websites. They found that Connecticut Medicaid rates are only 71% of the average. And more importantly, of these 27, 24 states are higher than Connecticut's rate. Only 2 states are lower. Raised Bill 5459 proposes 2 methods to adjust Medicaid rates, either a percent of Medicare or a percent of the 5-state average. Even an adjustment to 100% of those benchmarks would leave anesthesia services significantly underpaid and well below the cost of providing care, and disproportionately undervalued compared to all other physician specialties. The difference is made up by higher commercial rates and financial support from hospitals or other surgical or procedural facilities. This puts added stress on hospital economics, which already face a challenging fiscal environment. This then adversely impacts those communities that disproportionately rely on Medicaid for their healthcare services. A great majority of anesthesiologists and anesthesia practices provide care to all patients without regard to insurance, Medicare, Medicaid, commercial, or uninsured. We do not select our patients, and we willingly provide care to all comers. However, provision of services that are compensated at a level that is significantly less than the cost of some services is not sustainable. As the committee considers this bill, I ask that the unique circumstance of our specialty be considered and that an effort be made to address the disparity. I thank the committee for the opportunity to submit this testimony.
Thank you, Dr. Stone, for being here and your testimony. I don't see any hands. Thank you very much.
Thank you.
Next, we'll go to Francesca Perez, followed by Sabrina Trocchi.
Good afternoon. My name is Francesca Perez. I'm a parent, and I've had 2 kids in Sarah Inc. Kid Steps program. I thank you for the opportunity to testify today. I am here to request that you support additional funding for the Office of Early Childhood. This will allow families like mine to get the support they need to help with their child's development. When my family and I first started Birth to 3, I was a first-time newly single mom to a 2-year-old, 1-year-old, and a 3-month-old. This program has helped my family immensely within the years of being in the program. My daughter was the very first one to join the program at 15 months old, and at this time she wasn't speaking, didn't really want to engage with anyone, and was having 2 to 3 hour meltdowns. I am proud to say she is now engaging in school and at home, speaking 4-word phrases, loves to sing out loud, and can count to 20 when she's upset to calm herself. This program allowed us to become closer as a family and guided us on how to connect with each other. And even though I only had 2 kids in the program, it has helped all 3 of my kids learning ways to include each other and ways that we all were comfortable with playing in more. My youngest is currently in the program right now and has grown and progressed so much because of this program. With his speech, eating, regulation, interactions with others, I am so proud of my kids and thankful for this program. I wouldn't be the parent I am today without it. They have taught me so many skills, gave me so much knowledge, and guided me through it all. I am better equipped to deal with anything that comes my way, and my kids are also better equipped to deal with their emotions better.
Thank you so much, Francesca. I don't see any questions. Thank you for being here tonight. Next, we have Sabrina Trocchi, followed by Christy Koval. Is Sabrina with us? Okay, how about Christy? She was here earlier. Okay. Yeah. Okay. Claudia Grantham. Yes, she's on. Claudia, you're muted, so you just have to unmute.
There I go. Can you see me?
We can see you and we can hear you. Go right ahead.
Okay. Well, first of all, let me say thank you to all of you on this committee for what you have done today to listen to our stories. They're incredible stories, and I'm totally touched. And thank you for letting me testify. I'm Claudia Grantham. I'm a longtime board member of the Children's Center of Hamden. And the Children's Center of Hamden is a private nonprofit multi-service agency. We've served children for 190 years, and we would like to continue that. I am here in support to testify for the bill number HB 5374, an act concerning annual inflationary rate agreements for not-for-profits of human service providers. This important bill that would immensely help community providers stabilize their budgets and provide additional services to the state's most vulnerable populations. We serve children from the ages of 6 to through 6th grade through 12th grade. I deeply appreciate the increases the legislature has been able to provide over the years, but they have not been enough to meet the needs of the people we serve. We continue to be hit by crippling increases in our costs due to, in part, to the increased inflation and that far outpace the rate of increases the legislature has been able to provide. We have a very committed group of employees, some of us being with us for 30 years, but we have not been able to keep our amounts up to be able to hire them. You heard that earlier this afternoon, and give them a livable wage. They're there because they love what they do and they love the children. We have closed programs and we have waiting lists. That's not what we want. We have a beautiful facility and we want to be able to increase the programs to help children. If the rate the state pays for our services had increased along with the inflation since 2007, we wouldn't need to be at the legislature every year asking for fund hundreds of millions of dollars in the state budget to keep pace. Inflation on the cost of our services since 2007 is 45%. And the legislature has only been able to provide increases equal to about 13% this last year. Our last years of budget meetings have been furiously incompetent, and I'm seeing too many deficits to be comfortable in this situation. At that rate, if the rate was increased by a few percent each year, we could open new programs and increase our population and the size of existing programs to meet the critical needs of the youth of Connecticut. With the stagnant funding currently existing, we on the board are very hesitant to open new programs. As a state, we would like to help because it's what we do. And the takeaway of existing programs is just not possible. We are an agency that has met the needs of the state's neediest population and worked with the state to do this and want to continue our mission for the next 190 years. Thank you for letting me testify, and thank you. If you have any questions, I'll be happy to try and answer them. Thank you so much.
Thank you, Claudia. Thank you for your kind words and for serving on the board and for being here to testify tonight.
Thank you.
Next, we'll hear from Chris Grant, followed by Emily Morrison. Chris, you're still on mute. Can you unmute yourself?
Hello?
Yep, now we can hear you. Go right ahead.
Thank you very much. Good afternoon, Senator Lesser and distinguished members of the Human Services Committee. My name is Chris Grant, and I am a scientist working in genetic engineering at Boehringer Ingelheim Pharmaceuticals. I am also a volunteer for the American Cancer Society. I hope that my perspective as a researcher may offer some unique insight on the significance of biomarker testing and why it should be covered for Medicaid cancer patients. So to begin with, biomarkers it's an umbrella term that we use to classify biological identifiers like genes, small molecules, and proteins that we know to be precursors to disease. Some genes uniquely characterize specific cancer types when mutations occur, and we can target those mutations with therapeutic drugs to treat the disease. In the case of breast cancer, there are about 28 different genes that can lead to this cancer type. The most prevalent and highly characterized genes associated with breast cancer are, in fact, the BRCA1 and BRCA2 genes. However, any single or combination of those genes can cause breast cancer, and results of a biomarker test could show that a patient's cancer has a certain biomarker that is targeted by a known therapy. Cancer drugs work in different ways, as we all know, and biomarkers tests have allowed for a better understanding of the disease model. And to wrap up my testimony, I just want to say that the tumors can actually have a sequence of DNA mutations separate from DNA sequence of normal healthy cells in the body. And biomarker testing is a technique used in precision medicine that would allow for targeted detection of those mutations and identify which drugs would be more effective against cancer types with a specific set of mutations in comparison to other drugs. Most cancers do accumulate new mutations as they grow, and some of those mutations can make the cells resistant to chemotherapy and therapeutics. So cancer drugs are often used in combination. Since there is less resistance to 2 or 3 drugs at the same time, treatment may also change over time, and drugs may work well for a period until evidence of resistance. Then a new drug is introduced and given to the patient until it stops working and the cycle is recycled or repeated. Targeted therapies can lead to increased survivor probability and better quality of life for cancer patients. And I just want to leave you with this takeaway that I found a 2023 study that screened over 21,000 patients with a median age of 69 years, and they were all diagnosed with advanced metastatic non-small cell lung cancer. That study had showed an adjusted hazard of death was 30% higher in patients who never received biomarker testing, and 12% higher in patients who did not receive biomarker testing before the start of the first line of treatment. So thank you for allowing me to testify tonight, and I appreciate your time. Thank you.
Thank you, Chris, for being here and for your testimony. Senator Seminara.
Thank you. Thank you, Chris. Thank you, Madam Chair. Thank you, Chris. I had a question. Do you have any data on the medical savings that or the savings that would happen as a result of using the biomedical
the biomarker testing, you mean?
Yeah, biomarker. Sorry, it's a long day. It's been a long
That's
day.
okay.
The biomarker testing.
I do not have any financial statistics showing a cost savings benefit for that. I was really approaching it from a more of a life-saving perspective.
Yes, and I certainly can appreciate that. I just was wondering if there were, I'll go out and do some studies, find out if there's some studies by using the biomarking, or is there any long-term cost savings, which I would imagine there would be, but wasn't sure if you offered that, your place offered that.
So I work in a genetics lab. I am not the one that really sets the price of these treatments. I do not run the clinical trials. I am really doing the drug discovery type of programming. And so I would imagine that there are a lot of cost saving benefits to this type of therapy because the quality of life would increase. They are not being introduced to unnecessary testing or further testing where the disease worsens and progresses. So I can see how there is a cost-saving benefit if we were to catch aggressive cancers early enough that there can be some kind of treatment plan put in place that would allow them to really live a higher quality of life.
Well, keep doing that great work that you're doing, and thank you so very much.
Thank you very much.
Representative Hughes.
Thank you, Madam Chair, and thank you for your research and also giving us a little bit of context with how the research into new targeted therapeutics can be used with biomarker testing. And I know you probably don't know, but do you see that the biomarker testing cost per test is going down in the span of the research that you're doing, or you don't know?
That is a great question. We usually see a trend of reduced costs in pharmaceuticals with the increase of technology as it gets more advanced. It's more of a cost that pharmaceutical companies tend to eat themselves when technology becomes more widely used and more advanced. So they invest more in the technology to get more state-of-the-art, more cutting-edge techniques in the lab. And so that is not necessarily passed on to the consumer. However, the the prices of pharmaceutical therapeutics tend to increase with the economy fluctuations.
Okay, great. And your headquarters are in Danbury, right? Where are they?
Yes, in Danbury.
Thank you. All right, great.
Great. Thank you, Representative. Thank you, Chris, for being here and for the work you do. Have a
Thank
wonderful
you. You too.
Next, we'll hear from Emily Morrison, followed by Kelly Ryan.
Good evening, members of the Human Service Committee. My name is Emily Morrison. I'm a Putnam resident and Director of Development at United Services Incorporated. United Services is a nonprofit certified community behavioral health clinic. We serve 21 towns in northeastern Connecticut and operate more than 30 programs under our one administration. These include outpatient mental health for adults, children, and families, substance use treatment, including medication-assisted treatment for alcohol, opioid, and tobacco use disorders, crisis services, parenting programs, and family programs, primary care, prevention programs, and the region's only domestic violence program. Thank you for the opportunity to testify in support of HB 5374, an act concerning annual inflationary rate adjustments for nonprofit human services providers. This is an important bill that would immensely help community providers stabilize their budgets and provide additional services to the state's most vulnerable populations. I deeply appreciate the increases the legislature has been able to provide for the last few years, but they have not been enough to meet the needs of the people we serve. Inflation on the cost of our services since 2007 is 45%. The legislature has only been able to provide increases equal to about 13% in the last few years. To put it into clearer perspective, in 2023, we delivered 132% more services than in 2007. And we have done so with funding that is 32% behind. Imagine what we could do if we were made whole. This is not sustainable. After so many years of underfunding, United Services and many other nonprofits are not able to pay salaries that can compete in the labor market. This affects our ability to recruit and retain staff and to continue to meet the tremendous community need that we are seeing. Each clinician we can't hire means people that don't get served. If the rates the state pays for our services has increased along with inflation since 2007, we wouldn't need to be at the legislature each and every year asking you to find hundreds of millions of dollars in the state budget to fund critical health and human services that keep people out of the hospital and out of jail. I urge this committee to support HB 5374, and thank you so much for your time and consideration.
Thank you so much, Emily. I don't see any hands. Thank you for being here and the work you do. Kelly Ryan, followed by Elizabeth Wilke or Wilkie.
All set? Everybody hear me?
Yep, go right
Great,
ahead.
Thank you so much. Good evening, members of the Human Services Committee. My name is Kelly Ryan, and I'm here on behalf of innovative biopharmaceutical manufacturers to express pharma's opposition to Senate Bill 8. Especially sections 10 through 14, which would establish a prescription drug affordability board or a PDAB with the authority to set prices on medicines throughout the supply chain in Connecticut. We also echo the concerns raised by others today with respect to the importation provisions in sections 1 through 9. We just do not believe that these proposals are the best way to serve patients. I did submit a detailed statement, and I'll just summarize key issues today. I know it's been a very long day. The bill would establish a board that's comprised of 5 members appointed by the governor. And this board is empowered to conduct detailed analyses of specific drugs and set prices for those medicines. We know from other state PDABs that this is a long, complicated, and resource-intensive process. To date, no state PDAB has yielded any savings for patients, despite considerable time and expense. Price setting also raises legal questions when a state sets prices for patented medicines or attempts to regulate transactions that occur out of the state. It also raises serious practical questions for providers and patients within the state. For example, what happens when a pharmacy purchases a medicine from an out-of-state wholesaler, but must be reimbursed at a UPL that is lower than the purchase price? In fact, there's language in this bill that would actually prohibit the Connecticut pharmacy from purchasing that medicine. And so then what happens to patients when pharmacies can't stock the medicine? And we've talked a lot about precision medicine today, especially with the biomarker bill. And it's important to note that the board is also tasked with determining what is, quote, cost-effective, innovative, or best for patients as compared to therapeutic alternatives. Reliance on cost-effective analyses like these raises some real concerns and moves in the wrong direction with respect to health equity. Single, centralized cost-effectiveness determinations do not reflect important differences among patients or the needs of real-world decision makers. Basically, the PDAB and not the patient's prescriber would decide what is innovative or best for patients.
Earlier this year, the benchmarking committee was presented with data identifying retail pharmacy as the fourth lowest of 5 categories and contributing to per member per month spending growth from 2017 to 2022. Further, that same presentation indicated that commercial spending on physician-administered drugs was driven more significantly by utilization than by changes in price. This is consistent with the most recent benchmarking annual report released last March and data we see nationally. In fact, total spending growth for other healthcare is projected to grow more than 7 times that of prescription medicines through the next decade. And we know that the appropriate use of medicines can generate significant savings elsewhere in the systems. Net prices for brand medicines have stayed flat, averaging 0.0% growth in 2022. This bill also does not meaningfully address the impact of supply chain actors. It's true there are a few nods to out-of-pocket costs, but the focus is squarely on manufacturers and indeed individual medications and not needed broader systemic reform. We continue to believe strongly that there are policies that will meaningfully help patients at the pharmacy counter and address distorted incentives in what is honestly a broken system. But price controls with unaccountable appointees deciding what's valuable or worth it for patients is not the right way to go. And I'll stop there. I'm happy to take any questions.
Thank you, Kelly.
Sure.
I don't see any questions. Thank you so much for being
Thank
here
you.
and your testimony. Next, we'll hear from Elizabeth Wilkie, followed by Melanie Wild Lane.
Thank you. Good evening, Madam Chair and esteemed members of the Human Services Committee. Thank you for this opportunity to testify this evening. My name is Elizabeth Wilk. I'm an occupational therapist and team manager at Kids Steps Birth to 3, a nonprofit provider for Connecticut's Birth to 3 system. I signed up to testify today to express my support for House Bill number 5459, an act increasing rates of Medicaid reimbursement for certain providers, specifically Section 4 of this bill, which calls for the reimbursement rate for professional services provided under the state's Birth to 3 program to increase as of July 1st of this year. The proposed increase is consistent with the results of a rate study that was conducted by Public Consulting Group several months ago. I was able to listen to some of the testimony earlier today opposing this bill as written, calling for a longer-term, more systematic approach to studying and adjusting Medicaid reimbursement rates accordingly. As a Birth to 3 provider myself, I can testify to the fact that our state's Birth to 3 system cannot wait for additional funding after stagnant reimbursement rates for 7 years. I ascended into a management position at Kids Steps as a result of our organization's restructuring, which was secondary to our ever-growing list of referrals and total number of children and families served. When the team I currently manage was created, a listing for a full-time licensed behavior analyst had already been vacant for approximately 6 months. For those who may not know, the expertise of a licensed behavior analyst is critical for providing evidence-based supports for children with a variety of developmental needs, particularly autism spectrum disorder. Despite having this position posted and our agency's best efforts to recruit and interview qualified candidates, we were unable to fill this position for almost 2 years. Similarly, upon resignation of my team's speech-language pathologist, the agency posted a listing for a new full-time speech-language pathologist. However, this position remained unfilled for almost 1 year. Having taken an active role in the process of interviewing candidates for both the licensed behavior analyst and speech-language pathologist positions, I saw firsthand how our agency's inability to compete with the salaries and benefits that other practice settings offer these professionals hindered our ability to fill these job openings. For every unfilled job opening in Birth to 3, there are dozens of children unable to receive the specific services they need during this critical period of their development. Birth to 3 needs this rate increase to recruit and retain the qualified professionals that make up our workforce and ultimately to continue providing services to our children and families in a sustainable way. I understand that there are a lot of voices asking for more funding. I urge all the members of this committee to consider who could be more deserving of these funds than our youngest, most vulnerable children and the people who serve them. If not now, when? Thank you, Madam Chair, and all members of this committee for the opportunity to testify this evening in support of House Bill number 5459.
Thank you, Elizabeth, for the work you do and for your testimony tonight. Next, we'll hear from Melanie Wild Lane, followed by Paul Neubauer, Dr. Paul Neubauer.
Good evening. I'm Melanie Wild Lane. I am the Executive Director of the Connecticut Association of School-Based Health Centers, a statewide organization supporting over 315 school-based health centers, the majority of whom are sponsored by federally qualified health centers. I come before you today to testify in support of HB 5456 and 5459. I follow in a long line of FQHC representatives who have testified before you today, as well as CHC Act. So nothing that I will say differs from anything that they have said. We are in full support of 5456. Section B1 being removed, those parameters of an FQHC being mandated to provide multiple services on the same day. That current process has been detrimental to the way organizations have needed to perform and compromises the quality of care and treatment patients receive. We are also in full support of rebasing each federally qualified health center's encounter rates. This has not occurred since I think 2001, if I have that date right, could have been longer. And having a standard process for rate review will allow consistency. Lastly, Section 3 of that bill, we would like to offer new language. This is nothing you haven't heard today. As of January 1st, 2024, the Commissioner of Social Services shall increase Medicaid rates of reimbursement for federally qualified health centers on January 1st of each year by the Medicare Economic Index that has been announced for that calendar year in the Federal Register. We are also in support of HB 5459 with some recommendations. We would like to recommend a change to Section 5. We would recommend that it state, and I think you heard this from CHC Act as well, from CHC Act, from the two staff who testified. The Department of Social Services from the general fund will appropriate $10 million by June 30th of 2025, $20 million by June 30th, 2026, and $30 million by June 30th, 2027 for the purpose of increasing Medicaid rates of reimbursement for medical and dental services provided by FQHCs. This will allow a gradual, quote unquote, increase over 3 years, effective at the end of the year 3, providing an increase of $30 million in the Medicaid budget for FQHCs. Furthermore, we are in support of Section 8 of this bill, electronic consultation, to allow consultation between primary care providers and medical specialists through internet-based secure messaging platforms, something that our school-based health centers do routinely. This allows for timely consultation and is highly cost-effective. Both bills will allow our FQHC organizations that sponsor our school-based health centers to continue to offer support to young people who can continue to thrive and remain in school. This is critical for their future. Thank you for supporting school-based health centers and for hearing my testimony today. Have a great night.
Thank you, Melanie. Thank you for your testimony and for being here tonight.
Take care.
You too. Dr. Neubauer, followed by Peter Roos.
Hi there. Good evening, honorable co-chairs, Senator Lesser and Representative Gilchrist, and other distinguished members of the Human Service Committee. My name is Paul Neubauer. I'm an otolaryngologist, or an ENT doctor, practicing in Stamford, Connecticut. I'm speaking on behalf of over 800 physicians and physicians in training in the medical specialties of ENT, ophthalmology, dermatology, and urology. I'm here today to urge you to increase Medicaid reimbursement for physician services, a matter of great importance to the healthcare community and to the people of Connecticut. As a physician, I've seen firsthand the challenges that healthcare providers face in delivering quality care to those in need. Despite our best efforts, too many of our patients struggle to access the care that they require due to a lack of resources and support. This is particularly true for those who rely on Medicaid for their healthcare needs. Despite the vital role that Medicaid plays in providing healthcare to those who need it, most physician reimbursement rates under Medicaid are often woefully inadequate. As noted in the recently released and previously referenced Myers and Stauffer Medicaid Phase 1 study, physicians receive an average of 56% of Medicare reimbursement for the most commonly billed surgical CPT codes and 65% for outpatient services provided to patients on Medicaid. For many common codes, the reimbursement is even worse. For most office-based evaluations and procedures, the overhead, in other words, the amount of money it costs to deliver that service, exceeds the amount that Medicaid reimburses. Therefore, current Medicaid reimbursement rates result in physicians providing medical care often for a loss. In a time of pressure on medical practices and high inflation, such as a reimbursement scheme that is not sustainable and strongly disincentivizes physician participation in this critical program for many Connecticut citizens, this effective penalty for caring for Medicaid patients has led to a shortage of providers willing to accept Medicaid patients. Those providers who do are like myself, are overburdened. There's a shortage of physicians in Connecticut. Compounding this is the ever-increasing presence of private equity models that focus on profit over patient care. The most vulnerable Medicaid population is at highest risk for delayed and fragmented medical care, resulting in widening healthcare disparities. The situation is dire, and it puts further strain on emergency departments, large health systems, community health centers, all of which are still recovering from COVID-19. Increased Medicaid reimbursement for physician services would incentivize more providers to participate in the program and provide much-needed preventative and timely medical care for those patients, which will ultimately help reduce expenses to the healthcare system. I understand that the issue of healthcare funding is complex and multifaceted, but I implore you to consider the critical need for increased Medicaid reimbursement for physician services. Our patients deserve access to quality, affordable care, and it is our responsibility to ensure that they receive it. Your leadership on this matter will have a lasting impact on the health and well-being of citizens for years to come. Thank you for your time and consideration.
Thank you, Dr. Neubauer. Thank you for being here tonight and for your testimony.
Thanks.
Next, we'll hear from Peter Roos, followed by Deborah O'Brien.
Thank you. Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the committee. Good evening. I know it's been a long day for you all. You started at 11 o'clock. I think I'm number 108 out of 160. So the optimist would say you're 2/3 finished. So good for you. I'd like to speak in favor of House Bill 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers. My name is Peter Roos. I live in Madison, Connecticut. I recently retired from Wells Fargo's corporate and investment bank after 34 years. And I joined Vista's board about a year ago. Vista's mission statement reads, Vista provides training, support, and resources that empower individuals with disabilities to achieve personal success and belonging throughout their lives. Allow me to highlight just a few of those words in this statement: empower, achieve, success, and belonging. As a volunteer at Vista, I see these words become reality every day. In addition to my board activity, I work shoulder to shoulder with several of its members in numerous activities and watch the joy and pride that these men and women experience for performing a job well done. During all my volunteering activities over the years, I've never experienced an organization that fills me up the way Vista can. I urge you to come visit us someday, and I know that you will feel the same once you've seen our operation. Nonprofits continually fight upstream as other employers offer their workers better salaries or less stressful work. The state too often has frozen reimbursement rates so that even though costs increase, state funding does not. We need this bill so that nonprofits like Vista can pass along higher wages to those gifted and hardworking staffers who every day work to help our students and members fulfill their promise. House Bill 5374 would take several steps in the right direction to address the current situation. State agencies would be required to adjust rates for each year for inflation. Since most expenses do go to personnel and salaries, this will help employees earn just a little bit more. Your committee has a long-standing tradition of advocacy for the underserved and challenged in our state. House Bill 5374 will continue that tradition, and I strongly support your efforts in this regard. And I want to thank you for allowing me to testify this evening. Thank you.
Thank you, Peter. Thank you so much for your testimony and for the work you do. Next, we'll hear from Deborah O'Brien, followed by Valerie Reyer.
Good evening, Madam Chair and esteemed committee members. Thank you for the opportunity to testify in support of House Bill 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers. My name is Deborah O'Brien. I am the President and CEO of Community Resources for Justice, representing our Family Reentry Program. Family Reentry has been a part of the Connecticut social services community for over 40 years. Our 117 staff provide a multitude of programs and services across Connecticut, including the only residential reentry program for individuals with severe and persistent mental illness, programs to treat the perpetrators of domestic violence, over 1,000 people a week, community reentry services for men and women, mentoring for children and adolescents, substance use and mental health services, including medication-assisted therapies, and just this month, we have opened a recovery community center in Bridgeport. Through these safety net programs located in Bridgeport, New Haven, New London, Waterbury, and Norwalk, we have served over 2,000 individuals this fiscal year so far. While I appreciate the increases the legislature has been able to provide over the last few years, they have not been enough to meet the needs of the people we serve. How has this affected the work that we do? We don't have enough funds to recruit and retain staff at all levels, but this is particularly true for clinically licensed staff, especially those that are bilingual and bicultural. In addition, we have seen food, rent, and utility costs increase over the last couple of years. This has reduced our ability to maintain and improve our facilities, resulting in leaky roofs, water damage, HVAC dysfunction, and security issues. This has affected programming. We've had to close programs for days at a time in order to take care of some of these items. As the opioid epidemic continues to claim the lives of our children, friends, family, neighbors, and community, and despite funding shortfalls, we have continued to try to open new programs to meet the increasing need for mental health, substance use treatment, and recovery services. Our hope is through this bill, by keeping pace with inflation and having the necessary funds in the upcoming fiscal years, we can continue to grow programs that will provide life-saving, hope-providing programs to people so that they can be successful in the community, rather than us being forced to reduce or close programs. I urge you to support House Bill 5374, and I thank you for your time and consideration this evening.
Thank you, Deborah. Thank you for your time this evening. Thanks for testifying. Next, we'll hear from Valerie Rayer, followed by Allison Whitney.
Good evening, members of the Human Services Committee. I'm Valerie Rayer from the Kennedy Collective, a nonprofit organization providing employment, public transit training, independent living, transportation, adult day support services, and other community residential and rehabilitative services to over 1,200 individuals with disabilities across the state of Connecticut. The Kennedy Collective employs 444 individuals, of which 89% directly provide support services to individuals in their homes, communities, and employment locations. Thank you for the opportunity to testify in support of HB 5374, an act concerning annual inflationary rate adjustments for nonprofit human services providers. Inflation is an issue that impacts so many, but for nonprofit human service providers, this is becoming the death knell. There are costs to operating any business, and those costs are no different for those operating a nonprofit. You've heard throughout today various testimony around the differing expenses and costs that go along with it. And I want to say that we are in the same predicament. As a state contractor, it is expected that we provide high quality services in livable and desirable environments, provided by competent, capable, and caring employees to meet the mission and goals of the state agencies we are contracting with. We're required to provide services in people's homes, community, and/or their place of work, and we're required to follow very specific guidelines and protocols. None of these come without a cost or additional burden. The cost to operate our buses and vans used for services increases year over year, and there's no money available for vehicle replenishment. The federal mileage reimbursement rate for employees who use personal vehicles to deliver their services has increased by 2.3% in January, an expense that we never get added into our service rates. Our healthcare coverage has significantly increased year over year, ranging from 28% to nearly 54% over the past 5 years. In addition to utility expenses, general programming, escalation in rents for leased space, the cost of IT resources to meet the federally and state mandated compliance requirements, non-billable time when we're traveling from one location to another, providing individualized services, increased liabilities, workers' comp, and other administrative expenses. I've detailed certain elements in my written testimony, but what I want to say is the biggest impact is that we used to serve 2,400 people a year prior to the pandemic. At this point in time, we're only at 1,200. We have not been able to bring back people. We are not able to do what we need because the cost is just too much. We are currently running at a deficit of $200,000, and we anticipate that to increase to over $300,000 by the end of the fiscal year. We need you to support this act. We need you to add this into the budget and take all of us as part of the vital services that you're looking for us to provide to your most vulnerable population. Thank you for your time and your consideration.
Thank you, Valerie. Representative Hughes?
Thank you, Valerie. I'm very, very familiar with all your services. When you compared the increase in cost and the decrease in numbers of clients that you're serving, and you're running at, you said, a 300,000 deficit for this year, you're expecting, if you could serve the folks that you were serving up to 2,400, which I assume are still sitting at home needing services, right? They haven't gone anywhere, right?
Right, correct.
Yeah. So they've been sort of sloughed onto some wait list, I suppose. What would that look like in terms of reimbursement rate for you to resume serving all those folks out in the community that were prior to the pandemic coming into day programs or whatever, job coaching, whatever?
Yeah, so, in essence, we always think there's a proportionality. You bring in more people, it would reduce your deficit. But the reality is that we need to be able to hire competent employees that are committed to our individuals. And so that's been number one. That the workforce crisis that you've heard from so many organizations, it just runs rampant. People want a higher wage. I mean, we have individuals that are highly behavioral. Our one-to-one rate, which has been provided via other testimony, it doesn't cover the full expense. We are funded based on a 30-hour programming week. People want to work 40 hours. They want full-time wages. They want benefits. They want paid time off. They want the holidays. And we aren't able to compete with that. One of the other presenters talked about what a janitor makes and what a DSP is making within our service industry. Those disparities really are what impacts us being able to open up our doors. We have posted positions. We're doing everything we can. But even transportation, I want to emphasize that vehicle replenishment, we counted on the nonprofit grant program to replenish our vehicles. There's no dollars baked into our rate structure that builds that in. The money that is aligned with that reimbursement barely covers the driver to transport people, let alone to purchase the vehicle, to maintain the vehicle, and to operate the vehicle throughout. Those expenses just increase year over year, and it depreciates immediately the minute you take ownership of it. So everything that we can do to increase, we are still faced with these ongoing year over year expense increases, and we don't see our rates adjust accordingly.
Thank you. Thank you so much. Thank you, Madam Chair.
Thank you, Representative. And thank you again, Valerie, for being here and for your testimony.
Thank you. Have a good evening.
You too. Next is Allison Whitney, followed by Fahmi Mamuya.
Hi, can you hear me okay?
Yes, we can. Go right ahead.
Hello, my name is Allison Whitney, and I thank you for the opportunity for hearing all of our voices today. I am one of the regional operations managers at KidStep's Birth to Three program. My role in the agency is to support teams in running efficiently and at full capacity so we can provide the highest quality early intervention services to our families. I'm here to support the proposed Connecticut House Bill 5459 that supports increasing rates of Medicaid reimbursement. Birth to Three staff have one mission. We want infants, toddlers, and their families in Connecticut to receive the best possible evidence-based, equitable services available to their children. This work is not possible without proper staffing across our agency. As my colleague spoke to earlier, the reimbursement rate has been flat since 2017. This lack of movement has caused significant challenges when hiring new staff and retaining current staff. Candidates that are applying for positions are seeking salaries we simply cannot match. Current staff are feeling stressed, overwhelmed, and are seeking employment opportunities that will better meet their cost of living expenses. In recent months, one region within our agency experienced significant changes when 2 full-time employees resigned to seek other employment opportunities, which provided more pay. This left me and the team manager calling over 60 families to inform them that we didn't have a provider to support their child's current plan of care. Imagine your child has been found eligible for early intervention services because of an identified delay, and their services suddenly felt disrupted because of a change in personnel within the agency. You're left with the strategies in which you have gained, but are looking for continued support in which you're owed. What do you do now? So as an agency, our next step included partnering with local birth to 3 providers to fulfill our commitment and obligation to their family's contract, as our internal capacity was limited. Each of these obligations requires resources, both personnel and financial, as this has been done under circumstances where programs are facing immense financial pressure, which strains our ability to maintain staffing and supervision. It's important to highlight that this staffing change was not an isolated occurrence. We are experiencing this across our agency and across the state within other Birds of 3 programs. It is my hope to never have to call another family again and to share that their child's services could be impacted due to our staffing challenges. Programs like ours earnestly strive to give families the high-quality services they deserve, and to do that, we need your support. I respectfully request that you show your commitment to Connecticut families by increasing the reimbursement rate. Thank you for your time and have a good evening.
Thank you, Allison. Thank you for your testimony tonight. Next, we'll hear from Fahmi Mamuya, followed by Karen Cardy.
Thank you, Madam Speaker. Can you hear me?
Yes, we can. Go right ahead.
Yeah. So thank you very much for allowing me to testify today. And I really admired by the focus you guys have had since the morning till this time. I'm a member of American Cancer Society. We were there this morning. Some of us are still there, but some have left. Little introduction about myself. I am a cancer researcher at UConn Health technology program, and I am also a act lead for the American Cancer Society. And today I'm here to actually support the Bill 307 for making sure that Medicaid patients can get biomarker testing and that this stays and it's not going to get reversed. So I'm not going to talk about biomarkers because Chris Grant from BI did a very good job explaining about biomarkers. So it is absolutely, undoubtedly that the biomarker testing is more efficacy than any other preliminary cancer approaches we did in the past years. However, what we are seeing is that if you look at the survival rates of patients from, let's say, 2000 up to 2020, we are not really seeing that increase in survival rates that reflecting to this revolutionized medicine. And I think the reason is because not everybody is receiving biomarkers. I myself is a cancer survivor. I was lucky that I was treated due to my cancer being detected early, but I know how it is to be in that battlefield, especially with my fellow patients who actually did not make it. So what I'm thinking is that the reason we are not seeing this increase in survival rates, despite of all this good news about treatment, is because this service is not provided to everyone. And I think this Bill 307 is the beginning of making sure that this is going to be there, is going to stay, and not only for cancer, but for other diseases that require biometric testing. Thank you.
Thank you. Thank you so much for being here and for dedicating your work to such an important cause. So thank you.
Thank you.
Next, we'll hear from Karen Cardy, followed by Ben Shaken. Is Karen Cardy with us? No. Okay. Ben, you're up.
Good evening, Madam Chair, members of the committee. Thank you for having me this evening. I'm Ben Shakin. I'm the Director of Government Relations at the Connecticut Community Nonprofit Alliance. I'm here to testify in support of House Bill 5374. You've heard from a number of our members already today, and there's more after me. So I'm going to try to not repeat too much of what folks have said. I just want you to know this bill is one of the Alliance's top legislative priorities for this year. It would finally index nonprofit funding to increase automatically every year, or as automatic as things can be in the Connecticut state budgeting process. As folks have said, nonprofits have been crushed by inflation, and their funding hasn't caught up. I want to just try to put some overall sort of numbers on it for the industry. According to a survey that we did of our members in December, 23% of nonprofits are reporting that their expenses grew by 30 to 40% in the last 5 years, and an additional 30% are reporting expense growth of 20 to 30%. As folks have said, obviously, that you know the legislature has provided about 13% in increases over that same time period, and that doesn't even include the period between 2007 and when those increases began. Every American's been touched by inflation. We all have, but nonprofits and what drives the costs in their budget have really hit the areas of the economy that have been hit hardest by inflation. The biggest and most significant factor is wage growth, as you've heard, particularly in the healthcare sector, but also things like cost of health insurance, real estate, vehicles, energy, heating, those kinds of things, food. Those are all major cost drivers in nonprofits' budgets, and that's the part of the economy where inflation has grown the most. I wanted to make sort of two other points. One is that there's other parts of the budget and other parts of the law that do have these inflationary increases built in. The most relevant recent example, you've heard it from some folks already, is the new state minimum wage. This year it went up by inflation for the first time ever, a 4.6% increase on January 1st to $15.69. Not every nonprofit is paying wages that are close to minimum wage. Some are hiring master's clinicians at more middle class level wages, but for those that are, and even for those that are paying higher wages, if the inflationary rate that drives minimum wage goes up by just 3.5%, so less than it went up this year, each of the next 3 years, on January 1st, 2027, the minimum wage is going to be $17.40. And that would mean that before the end of the next biennium, the middle of the second year of the next biennium, the minimum wage in Connecticut would exceed the rates that the Department of Developmental Services pays community nonprofit providers as the starting wage rate in their rates for the services that they provide. Minimum wage is not the only part of the law that increases automatically each year. I'll say this with a smile on my face, and I don't mean anything by it, besides to point out that legislator and constitutional officer salaries also now increase with inflation every year, as do the Citizen Election Program grant funds that fund everyone's elections across the state. And I will close by just saying that we think also passing this bill would help you. Not everyone here serves on the Appropriations Committee. Some of you do. You know that you're starting when the OFA and OPM make budget predictions. They base them on what the current statutes say will happen in the future. Right now, there's nothing in the current statutes about what happens to nonprofit funding, so the base is flat. We know how difficult it would be to get us all the way back to where we were in 2007. It would be at least $750 million in one shot. It's why we don't ask for that much. We know it's an unrealistic thing, but we can at least look forward and try to ensure that we're breaking this sort of never-ending cycle of flat funding and then the legislature having to fight to find money to increase the budget. And so we encourage you to pass this bill, send it where it needs to go, and hopefully it can be incorporated into law this session. Thank you.
Thank you, Ben. And thank you for being here, but thank you for also working with your members to have them be here, because it's been very helpful to hear what it actually looks like in the field. What's going to stick with me, and I still see him here, is 31 years ago, a caseworker was getting paid $12, and today they get paid $18 to start. It's been a long time, so that's not that much of an increase. And yeah. So, Representative Hughes.
Thank you, Ben. Thank you for representing us through the decades. I was one of those caseworkers that came up here with my clients from the group home in the early 90s, saying, like, you know, with our signs out there in front of the Capitol with, I don't know, fund our future, or we're worth it, or we had all kinds of cute slogans. But obviously that didn't work, because here we are, only I've gone from caseworker to legislator, but yeah, definitely see that in the trenches, we have not updated. And I'm really happy that you named the $750 million, because let's talk about really what these services are owed, because you took on the services that the state previously had done. So we schlepped that off onto the nonprofits and, the community providers, but didn't continue to pay them for the services that they were now taking on the state's behalf. So I guess I just want to acknowledge that indexing it would be a partial way of addressing that disinvestment since the early 90s, but it's not enough. So if you could figure out a way to address that, what would that look like?
Well, I mean, I think, so this isn't the Appropriations Committee, and we've made some arguments in front of them. I think that the reality is that Connecticut has the resources right now to address a significant portion of this problem. We are now entering the 7th year of a budget surplus. And so if you're keeping track, we're nearly at the point where we have had as many years of budget surpluses as we had of budget deficits during the Great Recession. So I know it doesn't always feel like we're in really great fiscal times, or it feels like the Great Recession is still very much looming in all of our minds. It certainly is, just personally for a lot of us, right? But the reality is this is now the 7th year of budget surplus, and OPM and OFA are predicting budget surpluses in excess of $500 million each year that they do out year projections. So each of the next number of years. And so we at the Alliance think that the legislature needs to take a hard look at how the state is allocating its resources, and those resources. We have been making a choice to pay off many billions of dollars in debt that the state has. We don't think that's a bad idea, but we think you can do both. And so our encouragement for all of you as you're considering what will happen in this state budget and in future state budgets, in addition to indexing here, would be to look at modernizing the fiscal guardrails to make sure that you're able to take care of needs that are facing residents of the state today while continuing the sound fiscal policy of paying off the state's long-term debt.
I couldn't agree more. Thank you, Madam Chair.
Thank you, Representative. And I would just add to what you were saying, Ben, that we've also made the choice not to pay our costs. And now it's become clear today that we're making the choice not to provide much needed services. So we might want to make different choices. So thank you for being here.
Thank you. Thank you very much.
Next, we'll hear from Linda Iovana, followed by Jan Ponchen. Is Linda with us? Oh my God. Sorry, long day.
My name is Linda Iovana, and I'm the CEO of CCARC, which is a private provider of residential, day, and employment services for adults with intellectual and developmental disabilities. We serve Central Connecticut and the greater New Britain area. We have over 270 employees and serve over 200 people. Thank you for the opportunity to testify on House Bill 5374, an act concerning annual inflationary rate adjustments for nonprofits. Each year, CCARC, like other IDD providers, must submit a board-approved budget to DDS by the end of June. We estimate expenses increases based on inflation, yet we are not able to estimate increases in revenue. We cannot accurately forecast the financial outcome of the coming year. This typically means we cannot make budgeted staff wage increases, and in fact must reduce line items and make budget cuts to stay within the expected flat funding owing to the estimated inflationary increase in expenses. We lack revenue stability and are not able to plan for expansion of existing programs or to bring on innovative new programs. I recognize the work the legislature has done in recent years to increase funding to nonprofits, and we are appreciative. Yet it has not been enough to keep pace with the rate of inflation. All of our expenses have increased. At present, Our year-to-date expenses have increased, this is an average, of 6.24% over last year at the same time. The 2.5% increase we received in fiscal year 24 was tied specifically to wage adjustments for our staff. And although we did receive a 4.5% provider bonus, it has not been annualized. Furthermore, we had annual increases in expenses with no rate increases for the decade prior. So as you can see, the expenses are increasing at a rate that exceeds the increase in funding. As Valerie was saying earlier, I too have a fleet of vehicles, all of which are in need of repair and several that actually need to be replaced, yet we cannot afford it. We make every effort to bring the people in our programs out into the community as often as possible, but with the lack of vehicles, not to mention the staffing crisis, we're frequently not able to make that goal. One of our 11 group homes is home to 5 gentlemen who are all deaf or hard of hearing and also have an IDD diagnosis. This house, as of the calendar year end, had a loss of more than $100,000 and on target to have a loss of $200,000 by the end of the fiscal year. The staffing ratios are as lean as can be safely, and all expenses have been analyzed and reduced wherever possible, and we cannot sustain this loss. Where will these people go if we are forced to close this home? Last week alone, we lost 4 direct support professionals, all leaving higher paying jobs. We start people at $18.46 and they left for positions that pay $21 and $23. And now with the PCA rate increases to $23 per hour, I have no idea how we will attract and retain employees. Our staffing crisis is returning to the levels post-COVID. I know my time is up, so I will start there. Any questions for me?
Thank you so much, Linda. Any questions? Thank you again. The information of what it looks like in the field is very helpful. Thank you.
Thank you. Good night.
Jan Pochin, followed by Tanya Maurer.
Hello, everyone. Here's Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and other esteemed members of the Human Services Committee. I am Dr. Jan Ponson, a child psychiatrist and vice chair for clinical affairs at the Yale Child Study Center, and I am here on behalf of HB 5459, an act increasing rates of Medicaid reimbursement for certain providers. The Yale Child Study Center is a multidisciplinary research and clinical setting. And in our clinical setting, we serve 60,000 visits annually, of which 30,000 visits are Medicaid enrollees. We also serve as the child psychiatry arm of the Yale New Haven Children's Hospital. We provide services, including staffing our intensive outpatient program. One very challenging thing for us, and I would never want to say this directly to a client, and hopefully there are no clients listening right now, but we pay to see patients. We run a deficit. We've been running a deficit. We've been saying that the Medicaid reimbursement rates have been too low for years. And I'm glad this bill is being proposed because it's very, very cold. We're freezing. And the notion of waiting a little longer to start resolving issues is like waiting for your toe that's already been amputated because of frostbite to get more pieces of frostbite on your body. We need to take action much sooner. The DSS Medicaid rate study had some elegant description of well-considered methodologies to get the rates moving. And I think they need to be, of course, considered in a thoughtful, systematic way. But I think that we have been seeing signs of the canary in the coal mine for quite some time. And you've heard many, many services describing their dire straits in which they find themselves in order to continue to ensure services. So I certainly hope that, so I thank you. That's the end of my testimony, and I thank you very much for your time this evening.
Thank you, Dr. Ponson, for being here and for your testimony. Next, we'll hear from Tanya Maurer, followed by Daniel Osborne.
Hi there. Can you hear me?
Yes, we can. Go right ahead.
Great. Thank you.
Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name's Tanya Maurer, and I'm a volunteer with the Alzheimer's Association, the Connecticut chapter. I know it's been a really long day, so thanks for sticking it out. I'm here to speak about Bill 307, an act concerning Medicaid coverage of biomarker testing. My journey begins in 2015 when my mother made the decision to move from Vermont back to Connecticut to live closer to myself and my husband. That year, she sold her home, purchased a house next door. She moved in with us while we renovated her new house, and she moved into her home in 2016. During that time she lived with us, my husband, myself, and my mother all noticed some changes in her behavior, be it engagement and in executive function skills. In 2017, Mom invited me to one of her doctor's appointments, and let me tell you, that is a very lucky thing because it's very rare for adult children to be invited to such appointments. In that appointment, she was diagnosed with Alzheimer's. Afterwards, Mom started to share the names of relatives that likely had the disease but were never diagnosed. You see, Mom was a nurse and she was a social worker, so she knew something was wrong. Since 2017, a lot has happened. I'll touch on a couple. One, I lost my job during the COVID layoffs in 2020, and I made the decision to be a full-time caregiver. That was the best decision I ever made. In July of 2022, Mom moved into an assisted living community. In November of 2022, she decided she had enough and walked out of the doors at 9:30 at night in 30-degree weather. Luckily, she arrived at our house at 11:10 p.m. and I was able to wrap my arms around her. We're fortunate, other people are not. In February of 23, she moved into a memory care community where she's thriving. She's also living in every moment, and that's just the point. Every moment counts. Now my sister, myself, my cousins are all now at higher risk for Alzheimer's based on our family history. This said, the need for more accessible and affordable and quick biomarker testing is needed so that we can work towards being tested with our primary care doctors so that we can prepare for our futures. In the event that we are diagnosed with Alzheimer's, we want to be able to look to leverage new treatment options because all we want is more time with our loved ones and to live our best life. In closing, we need to get to a world where diagnostics for Alzheimer's and other dementias is as common as a EKG or blood work for high cholesterol instead of a stop the heart kind of moment that it is right now. Continued progress around blood-based amyloid markers is likely to lead to new Alzheimer's diagnostic tools coming to the market in the next couple of years, and this is medically necessary. Thank you so very much for the opportunity to provide a comment today. It is an honor as a caregiver because we're collectively shifting toward diagnostics and treatment, and it is an exciting time, and I hope you'll support this bill. Thank you so much.
Thank you so much, Tanya, and so glad your mom did make it home that night. Thank you for being here.
You're welcome.
Next, we'll hear from Daniel Osborne, followed by Courtney Seeley.
Good evening, members of the Human Services Committee. My name is Dan Osborne, and I'm the CEO of Gilead Community Services. We've provided high-quality mental health and addiction treatment services for over 50 years. We serve about 2,000 individuals per year and employ about 350 dedicated staff. Thank you for the opportunity to testify in support of House Bill 5374. I'd also like to share my support of increasing Medicaid rates, which relates to House Bill 5459. You have my written testimony, so I'd like to just share some additional thoughts on why these bills are so important. The chair of my board, the Gilead board, reminds me often of a popular quote that says, "The things we don't change, we choose." For those of us in leadership roles in different parts of our life, this quote is a helpful reminder that we are responsible even for the, quote, way things have always been. The state legislature has an opportunity with House Bill 5374 to change the inequitable funding strategies of the past by taking a logical approach to funding nonprofits that says if the costs go up, our rates go up. Trying to make sense of how we got to the current funding structure, I sometimes wonder if perhaps at some point a long time ago, nonprofits were viewed simply as charities. And perhaps the idea back then was that we, Connecticut, should make sure that all of our real bills are paid and then decide how much to give to charity. Maybe that's how it was. We don't really know. What we do know is that that's not how it should be anymore. And yet that's how it often feels. Nonprofits are actually businesses that partner with the state to provide services that are mandated by state statutes. Nonprofit services fulfill state obligations, as has been mentioned earlier tonight. Therefore, we are a contractor who requires a consistent process of equitable payments. So what happens if we choose to keep things the way that they've always been? Who suffers? I was at a legislative event in Middlesex County a few weeks ago. At this event, a young woman stood up to share her story of trials and sacrifices. She shared her hardships, her resiliency, her experiences on the brink of poverty. This woman was the staff member of a nonprofit, forced to work multiple jobs and sacrifice time with her family to maintain her commitment to the mission of the organization that she believes in. Who suffers? She does, and thousands of employees like her. In addition, the lack of consistent increases to keep up with inflation impacts organizations profoundly in many ways. Because of the way we're currently funded, most organizations have experienced crisis levels of vacancy, ongoing recruitment and retention challenges, annual deficits, and the need to develop other funding strategies to subsidize inadequate state funding in order to avoid the closure of services, programs, or even agencies. Who suffers? The organizations that provide these life-saving services. Adding to this, we all saw the results of the Medicaid rate study that confirmed what we've known for years. Connecticut Medicaid rates are not adequate. The fact that they are less than 50% of the 5 comparison states sends a clear message that we must do better. What we don't change, we choose. Thank you.
Thank you so much, Daniel, for being here and for your testimony. Senator Seminara.
Thank you, Madam Chair. Good evening, Daniel. Thank you for your testimony. Unfortunately, I did want to let you know that that discussion or that point that you raised earlier, that many people feel that nonprofit organizations are charities, is alive and well. You said that that was the thinking years ago. I assure you it is the thinking now for certain people that that they do believe that it is a charity, and who are we to designate money to charities. So I encourage you to continue to fight the good fight and know that we are hearing every word you say. And I encourage you and also all the nonprofits to continue to try to dispel that fact and continue to educate people. I know I do it on a regular basis, but I every time I'm in front of nonprofit organizations, I make sure that they are aware that that is still there. So we have to dispel that as much as we can. But I thank you. I thank you for your testimony, and I especially thank you for your services.
Thank you. I appreciate you saying that and honestly expressing that. If I could just add, I think that moving this bill forward might be one way of communicating loudly that's no longer the case, and that this committee views that differently and would strongly urge you to do so.
Thank you, Senator. Thank you so much, Daniel. Have a great evening.
Thank you.
Next is Courtney Seeley, followed by Campbell Mitchell.
Hi.
Hello, go right ahead.
Thank you. Good evening, senators, representatives, and members of the Human Services Committee. My name is Courtney Seeley, and I'm the Managing Director of Behavioral Health Services at Child and Family Agency in New London. I'm here to express my strong support of House Bill 5459, which aims to reevaluate and adjust Medicaid rates for behavioral health service providers like ours. At Child and Family Agency, we serve the children of Eastern Connecticut through outpatient, in-home, and school-based mental health services, in addition to our medical and supportive services. Earlier today, we heard from Connecticut's child advocate, Sarah Egan, who spoke about the overwhelming number of children in hospitals who cannot be connected to care. I'm speaking today on behalf of our 4 outpatient clinics who share in this burden. Our outpatient clinics are considered enhanced care clinics, and what that means is that no child on Medicaid will be turned away from our outpatient level of care and are guaranteed to be seen within 14 days, if not sooner. The children Sarah spoke of who are stuck in hospitals for days and even weeks, who can't otherwise access the appropriate levels of step-down care with 600 family wait lists, end up coming to us to be seen at a much lower level of care than they need. You can imagine the challenges this poses to not only our system, but to the care these children receive. Over the past 5 years, we've experienced a 51% increase in new clients being served by our outpatient clinics. Despite this increased demand, our bottom line has been deeply impacted. And just last year, our outpatient budget suffered a deficit of over $1 million. To say that this type of loss is unsustainable would be a vast understatement. As we work to meet the rising needs of our community, we continue to take a greater loss, mainly due to the low reimbursement rates for services. The burden on our staff has been immense. Our clinicians are each serve an average of 40 to 45 clients, most of whom are experiencing needs far greater than anything we saw 5 years prior. The consequences of this heavy workload are clear: increased burnout, staff turnover, and compromised quality of care. We have lost valuable team members due to these conditions and our inability to pay competitive salaries. As a result, the 3 vacancies we currently have remain unfilled, putting an even larger burden on the staff we do have. Our commercially insured families have also been impacted. They have been put on lengthy wait lists to ensure availability for our Medicaid insured children. We are admitting an average of 20 new children per week, reflecting the critical need for our services in the community. The children we're serving present with the highest level of need we have seen in our outpatient clinics since the closing of vital in-home services like ICAPS and the staggering wait lists of remaining programs aimed to support families most in need of higher levels of care. Our intake ratings that indicate a severity of need have risen steadily, with 54.7% of our clients scoring moderate to most severe at intake. That's 27% higher than it had been the last fiscal year. We have moved far behind the point of crisis, and I urge you to support the House Bill 5459 to improve Medicaid rates for behavioral health service providers. By doing so, you will not only invest in the well-being of our community, but also ensure the sustainability of organizations like Child and Family Agency, allowing us to continue providing critical support to those who need it most. Thanks for your attention and your commitment to addressing this pressing issue.
Thank you very much, Courtney. As you were talking, I pulled up the website, and the first thing I see is Urgent Crisis Center, same-day evaluation and connection to treatment for mental health crisis, which is what we as a legislative body keep talking about is so needed based on what we're hearing. And so
Yes.
you are offering that, but you're telling us you're offering it and then have a $1 million deficit because you can't actually afford to be offering these types of things.
Exactly.
Paying you.
Correct. Exactly. I mean, we've seen more clients than we ever have, and we're unable to make any headway financially. And we've been continually advocating for additional funding, especially for that urgent crisis center as well.
And then I also see walk-in counseling hours. So folks can just walk in the door and receive counseling.
Yes. Mm-hmm.
Which
Our
again,
Medicaid clients especially, yes.
yeah, which again is an ideal, but now you all, we're not paying for that service, but
Right. And there's really nowhere else for the clients coming out of even hospitalization to go. And as an enhanced care clinic, we are required to take those clients, which, we know is a need and we want to be there to do that. But it does make it challenging when there really isn't any ability to control that flow.
well, I appreciate you being here. Thank you very much.
Thank you.
Next we'll hear from, is Campbell Mitchell? Yes. You're in person, followed by Sherry James.
Good evening. Thank you, Representative Gilchrist, members of the Human Services Committee. My name is Campbell Mitchell. I'm from Ridgehill, Connecticut, and I've had type 1 diabetes since 2007. I'm policy lead for the Connecticut chapter of Insulin for All, a master's student at the Yale School of Public Health in the U.S. Health Justice concentration, a research assistant on NIH project on disability stigma, and author of a recent publication on type 1 diabetes in the American Journal of Public Health. Don't worry, I'm not here to bore you with my research and how it relates to SB 8. If you're interested in that, you can refer to my written testimony. Instead, I'm here to tell you about my Saturday. This last Saturday was the first day of my spring break, and so instead of public health classes, I spent the morning on Zoom calls about how SB 8 would improve health equity and reduce barriers. We heard from chapter members who had personal experience as insulin users or as clinicians with the tragic consequences of insulin and diabetes care being unaffordable and inaccessible, especially for those on plans that currently exist within loopholes Connecticut's coverage requirements, which SB 8 has an opportunity to close. Immediately after this call, I went to pick up my own insulin. Because of a lack of uniformity in our laws, there was some confusion at the pharmacy. In the space of an hour, first I was told that they couldn't give me insulin, then I was given the wrong kind of insulin, then the right insulin in a form I couldn't use, then told I would be charged a copay above the legal maximum, told they could only give me a 10-day supply, and finally told to come back next week. On getting home, I just grabbed a snack to keep my blood sugar stable when I got a call from a friend. She was stopped at a gas station, throwing up from diabetic ketoacidosis. She had insulin at home, but because of cost and chronic uncertainty with her health insurance, she felt the need to ration supplies anyways. My friend survived, and I'll get back to the pharmacy later. My point here in sharing this whole saga is that if there was anyone you would expect to be able to navigate this system, it would be someone like me. I'm a professional health researcher, and I can't get results consistently. Connecticut patients, families, and small businesses deserve better. The system should not require a master's degree to get life-saving medication at an affordable cost. And I'm grateful to see that the committee seems to agree. As policy lead of Connecticut Insulin for All, as a public health student and researcher, as a person who needs insulin, and a person who loves people who need insulin, I urge the members of the Human Services Committee to move forward with SB 8 and language that extends protection for drug costs and insulin access for as many of our neighbors as possible. Thank you for your time and consideration. I welcome any questions on the topic.
Thank you so much for both submitting written testimony that will give us more of the research aspect, but sharing your personal experiences. It really helps to inform what is going on out there. So thank you. Representative Hughes.
We both want to know what happened to the pharmacy.
Waiting to hear back.
Still.
Yeah. I wish I knew what the problem on their end is. But it's a back and forth. I think there are some formulary issues involved. The one that they prefer is one that I'm allergic to. So the text of the statute is written says medically necessary insulin drug is supposed to be covered, but I guess we have different readings of that.
I was going to say, Madam Chair, is I thought we addressed this last year in the formulary change in that bill. So I'm sure Senator Lesser will be very keenly interested in your story. So thank you for waiting all day to share it with us. I appreciate it.
Yeah, I mean, I get this medication or I die. So if I have to wait here for 10 hours to testify in order to make that happen, that's what I do.
Good point. Wait, Representative Dathan.
Thank you so much. And probably one reason you may have had an issue is the legislation that we put forward, I guess it was a couple of years ago for the capping the cost of insulin was in the Insurance Committee, not in the Human Services Committee. And that bill only covers Connecticut-based plans, not all insurance plans, because we can't regulate plans that are out of our state. So that could be one of the reasons. But saying that, going back to your friend, I'm terribly sorry to hear what happened in the Insurance Committee a couple of years ago. We heard a very similar story, and unfortunately, the young person didn't have as good of an outcome, and their dad came to testify about the loss of his son, who was a young man who was also trying to regulate how much insulin he needed, so that he was, keeping his cost where he thought they could be. Unfortunately, we can't do that with life-saving medication, as we've heard from so many people today. But I appreciate your work on this, all your work in committing yourself to study public policy. I'm an accountant by trade, and I can't navigate some of these things, even though I know numbers. So it's really hard for folks. So thank you so much. And thank you, Madam Chair.
Thank you. Thank you again for being here. Have a great evening. Next is Sherry James with us. Okay, nope. Bruce Stovall, followed by Paul Rimmer.
Can you hear me okay?
Yes, we can. Go right ahead, Bruce.
Good evening, Representative Gilchrist, Senator Seminara. My name and the other representatives of the committee. My name is Bruce Stovall and I represent Oak Hill. We were established in 1893 and we're the largest private provider of disability services in Connecticut. We operate about 65 group homes across most of Connecticut. We have an accredited special education school. We run an assistive technology center, as well as a couple of camps and specialty clinical programs. Here to testify, obviously, we are pro-index. Obviously, you've heard a lot of the stories from Heather Gates and other CEOs. I'm going to give you a little bit of kind of the facts on the ground for us. Essentially, frankly speaking, we've got 1,700 staff. We're carrying 200 vacancies right now. Most of those in our direct care programs. Of those homes, 4 are vacant and shuttered right now. We have 45 open beds across our system. As we've testified before at appropriations, there's well over 1,000 people on the waiting list. We simply can't attract staff at the current wage rate. I've never seen it worse in all my years. You've heard it before, so I don't want to beat it down. Our deficit is increasing. We do use pool staff to cover these vacancies. That literally puts us into the red every month in a way we've never experienced before. What I'd like to kind of ask the group here is we're just looking for a fair shake. The governor recently offered a COLA and a step to 45,000 of our state workers. Again, we do not begrudge that. The PCAs, as we've heard before in testimony, will be making $23 in a couple of years. And again, we don't begrudge that. They deserve that. Again, when I met with my parent and guardian group, and 5 or 6 of them came down to testify at appropriations before, kind of the feedback was, wow, we've got to go literally kind of beg for money every year, Bruce. And it's a little bit demeaning. So again, I know you've been out to our homes. You get our mission. You're on our side. So I do want to recognize that. But if we were indexed, you wouldn't have to stay late at night all the time. We wouldn't have to come down here as well. Again, looking for a fair shake. Just want to be treated like everybody else and try to catch up over the years. Again, I want to thank you for your time, and we do appreciate you staying so late. Thank you very much.
Thank you, Bruce. And yeah, you're making me kind of follow the stream from earlier by having you all come here and beg, right? It really is that more so like charity frame versus like your state contractors.
A little bit.
You should
Yes.
pay what you're owed through the state contract. Yeah. So thank you. And yes, it's been great to learn through seeing. So I appreciate you having me out to various sites. Representative Hughes.
No, thank you, Madam Chair. And say hello to Barry for us.
We will.
I just wanted to acknowledge and comment that you are representing a workload that really spans all of our districts. And I think that if we take the Human Services Committee takes one thing back to the general legislature, the entire legislature, is that these services are in every district, and the wait list and the need is in every district, and the workforce is in every district.
It is.
And therefore, we need to equitably invest across our state in this sector. And we have a few bills in front of Finance, Revenue, and Bonding that do just that increase some revenue and some flexibility with our spending cap to really equitably invest in what we've been disinvesting for decades. So thank you.
Thank you for your kind words. And I know one of our members tonight, I was at their press conference and I still remember the quote, "We are creating the working poor here." And it really struck me. So again, we're in all your districts on all levels with employees, and we appreciate your sympathetic ear tonight.
Thank you, Bruce. Have a good evening. Next, we'll hear from Paul Rimmer, followed by Carrie Dyer.
Good evening. Can you hear me?
Yes, we can. Go right ahead.
Hey, good evening. Good evening, Senator Lesser, Representative Gilchrist, Senator Simonara, Representative Hughes, Representative Kane, and members of the Human Services Committee. My name is Paul Rimmer, and I'm the Director of the Supported Employment and Options Programme over at Horizons in South Wyndham. I've been with this fabulous agency now for close to 23 years. Our adult services program, which we call Supported Deployment Options, currently serve 160 individuals year round. 90 of these individuals we support in their places of employment, which includes UConn, Eastern Connecticut State University, Groton, Subbase, the Coast Guard Academy, Big Y, just to name a few. And our program runs 7 days a week. We support people first shift, second shift, and weekends to help them be part of their community and part of the workforce. And all the individuals we support in employment are all very appreciated by their employers. On a weekly basis, I field many phone calls from desperate parents of children either graduating or that don't have any kind of day program, and they are really desperate, looking for something for their child. And I'm the one that gets the unfortunate kind of task of letting all these parents know that our program is right now at capacity, and we would love to take on some new individuals, and it's what we do. We love taking on some of our guys. They're great people to work with, but unfortunately, our staffing situation doesn't allow us for. When the state gave the 3% increase, which we were all really appreciative of, it also created a compression to where when new staff came in, they were starting at $18 an hour. And many of our seasoned staff that some have been there 10, 15 years are making maybe $1, maybe $2 more per hour. So as you can imagine, the result in this is we lost a lot of staff over the last couple of years, and a lot of really talented staff. They went out to find other jobs where they don't have to be med certified. They don't have to receive training in CPR and first aid. They don't need to know behavior management. They don't need to be trained in dysphagia. And that's just to name a few of the trainings that we provide. I think it's any new staff coming in and yearly trainings total around 15 trainings a year that they have to do. So the people we support, they thrive. They thrive when staff remain. Kind of, it's the very lifeblood of what we do. Our individuals need staff that stay invested. Our whole basis is based on relationships, and that's how our individuals thrive. I've spoke with many kind of staff over the last few years, and they've let me know that they will be actively seeking new employment with less responsibility unless the state recognizes their value and improves pay and starts off an indexing so they can have some financial stability moving forward. The constant staff turnover is demoralizing to our dedicated staff, and it's also disheartening to the individuals we serve. Who I say they thrive on relationship building and people that like to stay and remain in their lives. I hope the testimonies you've heard here today shine a light on the desperate need to increase our funding and index wages, as we're losing many quality support staff, and we can't continue to do so and still have the people we serve thrive in their lives. Thank you.
Thank you, Paul. And wow, 3 minutes. Well done. That was very good testimony. Thank you for being here tonight.
Okay, thanks a lot. I appreciate having you guys do.
Thank you. Is Carrie? Yes, Carrie Dyer. Followed by Paul Kidwell.
Good evening. My name is Carrie Dyer. I've been here all morning listening to everyone. I am the CEO at Reliance Health. We are a mental health agency serving all of Eastern Connecticut. We have about 250 employees. We serve about 1,500 people. I will say I know that we have friends in the room. I know that on the 26th, we hosted a press conference and many of you were there. So I know that this is a familiar topic. There's not a lot more that I can add. Dan and Heather and everybody before me has said what needs to be said. But I will go off of what you had mentioned with regard to what Mike had talked about when he first entered the field. I came in shortly thereafter. Also, direct care, I needed to pay my student loans, and I was really just called to this type of work. At that time, we were making about $13 an hour. So at that point, we were seeing cost of living increases. That tracked through. I remember at that point, you know, I was just out of college. I didn't know anything about this process. And we were told you would periodically get a cost of living increase. And that abruptly stopped in 2007. At the time, we didn't know that it was going to be a freeze. From that point on, we were working with less, but we were asked to do more. And as Mike outlined, not only was it frozen, but it was cut by 5%. So the struggles that we have had as businesses, not as charities, cannot be bolstered by bake sales and 5Ks, all of the things that, you know, the cost standards tell us we're not supposed to be fundraising, we're not supposed to be writing grants on our work time for state contracted services. So we're in this really bizarre situation. And it gets worse. We have 3 properties that we lease from the state of Connecticut. Those properties have built-in increases to those leases, and yet our state contracts don't increase. Right, you laugh, but it's not funny. I don't know how we're supposed to address these things. We bring them up, we have our signs, we come to the rallies, and it just continues to be something that we point out the ludicrousy. And we just have to keep coming year after year. This is the first time I've seen anything that's given me any hope that there might be something that addresses this long-standing issue that none of us are allowed to do. We each have to have a budget every single year. We have to address the new things that come along. From 2007 to now, we have iPhones, we have cybersecurity insurance. Wouldn't have even known what that was in 2007. We have to build something in, and we have to recognize that we are businesses, we have overhead, we need to attract people who want to do this work. And if all we're doing is coming up here and begging for money, who's going to want to come and work for us? Nobody. And it's demoralizing, it's demeaning. The fact that we come and parade people around, we've brought people up here to tell their story, that's humiliating. But that's what we're being asked to do. And I hope, please support this. It is truly a step in the right direction to address something that has longstanding been in arrears, and it doesn't make sense. So thank you.
Thank you, Carrie. And I think, you know, one of the most important things you said is you were, you know, like called to this work. And yeah, those are the people we want in these jobs, and they can't afford to be in them. So thank you. And again, it really is helpful when the picture is painted, painful, but helpful. Thank you. Next, we'll hear from Paul Kidwell.
Good evening, Representative Gilchrist and members of the committee. My name is Paul Kidwell. I'm the Senior Vice President for Policy at the Connecticut Hospital Association, here to support HB 5459 and act increasing rates of Medicaid reimbursement for certain providers. Can I just, before I start my more formal remarks, it occurs to me over this long day that one of the takeaways is if the continuum of care doesn't work, so if community providers don't have what they need, if hospitals aren't able to provide what they need, if behavioral health providers aren't able to provide what they need, patients get lost in the system and bad outcomes occur. So the continuum has to work together in order for this all work for patients. And for me, that was sort of the takeaway of today. Let me spend my time just talking a little bit about what are the consequences to Medicaid underinvestment over these years? What actually is happening because of it? So first, for Medicaid beneficiaries, they have poor access to relative to their commercially insured counterparts. They have poor health and healthcare outcomes, and they experience preventable health disparities related to income, race and ethnicity, disability, sexual orientation, and gender identity. For employers and employees, commercial health insurers pay higher rates to make up for Medicaid underpayment, and this cost shift amounts to a hidden tax on employers and their employees who ultimately bear the cost of these higher rates. There's a fiscal consequence for the state. By consistently underspending on Medicaid relative to our Northeast peer states from 2017 to 2022, Connecticut left more than $7.5 billion in federal revenue on the table. That's revenue that could have strengthened the care delivery system, driven better health outcomes for Medicaid beneficiaries, reduced pressure on commercial prices, and contributed to the broader economy. Connecticut Medicaid's annual rate of growth on a per member per month basis has been among the lowest in the nation. For too long, DSS has touted as an accomplishment the annual rate of growth of 0.4%. That is not an accomplishment. That means people are not getting services. Certainly, we would like to see the under reimbursement for hospital services, which is among the lowest in the state, addressed. According to the most recent OHS report, the state reimburses hospitals just 62 cents on the dollar for care provided to a Medicaid beneficiary. Again, the remaining 38 cents in unreimbursed cost is shifted to commercial payers, employers, and employees. Hospitals have to make up the difference. Connecticut hospitals also pay a significant provider tax, which generates funds to help support the state share of the Medicaid program. In 2022, Connecticut hospitals paid $850 million in taxes, which when combined with the federal matching dollars was nearly sufficient to fund Medicaid hospital coverage in its entirety. I'll just close by saying Connecticut's chronic underfunding of its Medicaid program in general, and for hospitals, services in particular, drives higher commercial prices. It creates access issue for patients, and it should be addressed. Thank you.
Thank you, Paul. And we're all kind of taking notes. That's very helpful data that you had in your testimony.
And all of it's in our written testimony, and we're certainly happy to provide additional information. OHS has a wealth of information that they release every year. So these are state-driven numbers.
Great. Thank you so much.
Thank you.
Thanks for being here all day.
Thank you.
Melissa Myers. Is Melissa Myers with us?
Yes, good evening.
Hey, wonderful. Go right ahead.
Thank you. Yes, so I'm Melissa Myers, the CEO of Generations Family Health Center, and I want to thank the entire committee for this opportunity to speak on House Bill 5456. I've also submitted written testimony. At Generations, we provide care to over 18,000 patients a year in rural Eastern Connecticut and have done so for the last 40 years. Of our patient base, about half have Medicaid coverage. Our mission is to provide high quality of care to all of our patients, but that care comes at a cost. And our costs at this time are achieving such a gap between them and Medicaid rates that it has become untenable. As you're aware, you've heard from others, FQHCs were not included in phase 1 of the Medicaid rate study. But waiting for rates to change until as late as 2025 or 26 is just unimaginable for us. So our association's national expert provided a comparison of Connecticut rates to the rates of other states, as well as to FQHC costs. And that data is included in my written testimony and has been provided to DSS. And you've also heard at this point that the data shows that in 2022, health centers lost over $75 million due to insufficient Medicaid rates. Specifically at Generations, our gap was more than $1.8 million in 2022. That loss severely impacted our ability to recruit and retain clinicians, and thus our ability to provide access to care. In the data, you'll also see that Connecticut's average rates are some of the lowest in the country. They are the lowest in New England and across the rest of the Northeast. So rebasing rates to reflect 2023 costs, allowable costs at that, would have an immediate impact on the viability of health centers and also access to care for Husky enrollees. Now, regarding access to dental care specifically, we also seek to have language repealed, which was included in Public Act 22-118, Section 239. It prohibits payment for a second visit in order to complete dental cleaning and other non-emergent services, despite the dental provider or the patient deeming it necessary. This has elongated preventative visits for patients, as they now must stay for the dentist's exam in addition to the hygiene procedures they've already had, and it diminishes the dentist's availability for restorative care with other patients. At Generations, we've now tracked a loss of more than 1,000 dentist visits and partially closed a dental clinic of ours specifically due to this language going into effect in July 2022. Combined with diminished dental workforce capacity and low Medicaid reimbursement rates, this policy has led to an alarming decrease in the ability of health centers to provide dental care to Husky patients. And we very much appreciate the committee's consideration of this repeal. Thank you very much.
Thank you so much, Melissa. And again, wow, you timed it perfect. 3 minutes. Thank you for being here and thank you for the work you do.
Absolutely.
Have a great evening.
You too.
Joseph Short, followed by Jennifer Granger.
Yes, good evening, members of the Human Services Committee, and thank you for allowing me to testify tonight. My name is Joseph Short, and I support SB 308 with the amendments proposed by the Connecticut Wheelchair Reform Coalition. I was injured by a drunk driver in 2002, which resulted in quadriplegia. And for the last 21 years, my wheelchair has been an extension of my body that provides both mobility and independence. This is a complex rehab wheelchair that is custom fit for my specific needs. When I first got this wheelchair 2 years ago, there was an intermittent problem with the lift actuators. This was an issue that needed to go through warranty and has still yet to be repaired. Every time I've had other repairs on my chair, I check the status of this warranty issue and continually get different responses from Demotion as to what the delay is. Here it is 2 years later, and the intermittent issue has now become a permanent problem. My wheelchair is now stuck in one position, no longer able to lift, no longer able to tilt, no longer able to elevate my legs. What's worse is that I recently got a pressure sore on my bottom and need to be able to recline for pressure relief in order to heal and prevent the pressure sore from getting any worse. It's been 2 years that I've been requesting this repair, and now this delay has stripped my independence and is causing a major health concern. Waiting weeks, months, and sometimes years for their equipment to get fixed is the type of service that many of the 5,000 wheelchair users in Connecticut have been subjected to because there are only two companies, NewMotion and NSM, and that provide repairs, and both are critically understaffed. SB 308 can make significant progress in resolving this serious problem, especially through the included all of the amendments proposed by the Connecticut Wheelchair Reform Coalition. One key point is to provide Medicaid coverage for annual maintenance of a consumer's primary wheelchair and for a backup wheelchair, which is much more cost effective than paying medical care for injuries caused by using broken wheelchairs. SB 308 will also establish a timeline for repairs to be completed and authorize the Department of Social Services to penalize violators. NewMotion's reps stated countless times during task force meetings that they are fully staffed, yet whenever myself or multiple other wheelchair users spoke directly to NewMotion technicians in the field, we were told that they only actually have 4 techs. This is an example of why they cannot be trusted and need a mechanism for compliance. Additional amendments include overnight and expedited delivery of wheelchair parts and require DSS to seek maximum federal reimbursement for these policy changes. Thank you for your time to address this serious issue, and with your support, SB 308 could drastically improve the lives of so many wheelchair users across the state. Thanks again for sticking through it. It's been a long day, I'm sure.
Well, thank you, Joseph. And thank you also for serving on the task force.
No, it was a pleasure. It really was getting everybody together from all sides of the. I'm sorry, I have a puppy that's barking in the background. Getting everybody. We definitely didn't agree on everything, but getting everybody's point of view out was great.
Fantastic. Thank you so much. Have a great evening. Next, we'll hear from Jennifer Granger, followed by Laura Chaplin.
Good evening. Thank you, Representative Gilchrist and committee members. My name is Jennifer Granger, and I am the president and CEO of United Community and Family Services, UCFS for short. I'm here tonight to support House Bill 5456, an act concerning federally qualified health centers. On behalf of UCFS, I thank the committee for the opportunity to provide this testimony, which I've also uploaded to the website. UCFS is a nonprofit organization serving 16,500 of the most vulnerable residents in over 900 square miles in Eastern Connecticut through our 5 federally qualified health centers and 9 school-based health centers. With nearly 10,000 of our patients enrolled in Husky, we give our full support to HB 5456. This bill addresses the synergistic harm that low Medicaid rates, workforce shortages, and practice restrictions are having on access to care for Husky enrolled people. I'll first focus on Section 1. This section repeals the harmful language that was included in Public Health Act 22-118, Section 239, which led to the issuance of a policy bulletin 2022-45. That policy prohibits payment for a dental cleaning and other non-emergency dental services if they're provided in more than a single visit. Sometimes legislation enacted in good faith has unanticipated negative consequences. This is a perfect example. When a patient is determined to need multiple dental services but cannot stay beyond the duration of the scheduled visit, they need a second appointment. UCFS must and does accommodate second appointments when a patient is unable to stay. However, there is no payment to UCFS for that second visit. The current regulation makes an exception for medical necessity, but provides no consideration for social determinants of health, such as missed time at work, childcare constraints, and transportation barriers. These are common challenges that drive patients to ask us to schedule remaining services on a separate day, and I argue are as important as medical needs. As a direct result of this act, UCFS has had to suspend our services in our Griswold dental practice. This practice opened only 5 years ago and has but a single dental operatory, and it is not possible for a dental hygienist and a dentist to work at the same time. Our Griswold dental patients, therefore, must now travel 10 miles, if they can, to our Norwich dental clinic. However, our once thriving 12 operatory dental practice in Norwich now has just a single dentist and a wait list of over 900 people. Rebasing our Medicaid rates, as stated in Section 2, would help. UCFS loses $167 on every Medicaid dental visit. This is a loss of $1.2 million annually and impedes our ability to hire providers and provide dental care that we are seeing in Norwich. Section 2C provides an improved methodology for health centers to apply for increased rates. Connecticut's process is vague, inconsistent, and does not follow federal law. DSS has a long history of arbitrarily denying legitimate requests.
Jennifer, your time has expired. Can you please summarize?
I will. This is not about rates. It's really about access. It's the responsibility of the state to adequately fund and operate the Medicaid program rather than passing that burden on to providers and patients. So thank you very much for your consideration, and please feel free to reach out with questions.
Thank you so much, Jennifer, for being here and for your testimony. Have a great evening.
You're welcome.
Next, we'll hear from Laura Chaplin, followed by Lindsay Kelly.
Good
Laura,
evening,
go ahead.
legislators and members of the Human Services Committee. My name is Lauren Chaplin. I'm the Director of In-Home Services at Child and Family Agency of Southeastern Connecticut. Thank you so much for this opportunity to testify in support of HB 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers. Among many other important services, Child and Family Agency provides in-home behavioral health services to children, adolescents, and adults across Southeastern Connecticut. Our programs specialize in addressing targeted mental health and behavioral health needs. These programs significantly reduce or eliminate the necessity for hospitalization or outplacement of Connecticut's youth. We continue to be hit by crippling increases in our costs, due in part to increases in inflation as well as inadequate Medicaid funding that far outpace the rate of increases the legislator has provided. Inflation on the cost of our services since 2007 is 45%, whereas the legislator has only managed to provide increases of about 13% in the last few years. Inadequate Medicaid reimbursement rates have significantly impacted child and families in-home behavioral health programs and our ability to serve our communities. Waitlists for our in-home programs continue to grow each day, exacerbating the post-COVID mental health crisis affecting our youth and families. For instance, Child and Families Functional Family Therapy Program, dedicated to at-risk youth and their families, currently has a waitlist exceeding 6 months in New London County. We consistently have 35 to 50 families on the waitlist at any given time. Our MDFT and IPV FARE programs, which run consistently at or above capacity, are forced to turn away referrals daily, which is particularly concerning for populations who are affected by intimate partner violence and substance use disorders. In January 2023, Child and Family closed our ICAPS program in New London County due to the ongoing budget deficits, despite the high community demand. There were 36 families on the waitlist at the time of closure, who were then referred to alternative programs and waitlists. Further, recent staffing cuts due to inadequate funding in our IPV FARE and our reunification and therapeutic family time programs have further reduced our community reach to extremely vulnerable populations. Further, the lack of resources to provide competitive salaries to our talented workforce contribute to extended wait times, staff burnout, turnover, and overwhelmed emergency departments. Your support to increase Medicaid rates and adjust inflationary rates to nonprofit service providers will enable us to continue to provide the essential services that the youth and families of Connecticut so desperately need and deserve. Thank you so much.
Thank you so much, Lauren, for your work and for being here tonight.
Thank you.
Next, we'll hear from Lindsay Kelly, followed by Tracy Wodach.
Hi, everyone. Good evening, distinguished members of the Human Services Committee. My name is Lindsay Kelly, and I'm here to speak on behalf of the Jackson Laboratory. I'm a certified genetic counselor. I hold a master's degree in public health, and I serve as the Associate Director of MCGI, which is an initiative at JAX to ensure access to biomarker testing and personalized medicine for rural and underserved cancer patients. I'm grateful for the opportunity today to testify on Senate Bill 307, an act concerning Medicaid coverage of biomarker testing. At JAX, we believe the future of medicine is personalized. Biomarker testing allows us to understand a disease at an individual level so that we can move from the historical one-size-fits-all methodology to one in which we treat patients as individuals. Biomarker testing can be used to help identify those who are at an increased risk for developing a disease, monitor if a disease is developing, identify the most appropriate treatments for disease, and then measure response to treatment or to measure for reoccurrence. Biomarker testing is becoming increasingly important in the realm of cancer treatment. 60% of all cancer drugs approved in the last 5 years required biomarker testing before use, and the majority of current oncology clinical trials involve the use of biomarker testing. Through our initiative at JAX, we've seen countless examples of patients whose biomarker testing has opened new doors for them for treatment options. One patient in particular, who was a relatively young patient with pancreatic cancer, had biomarker testing that identified an FDA-approved targeted treatment that she was able to stay on for many months. Then, based on a different biomarker, she was able to enroll in a state-of-the-art clinical trial at the NIH, looking at new ways of harnessing a patient's own immune cells, training them in the lab to target a specific biomarker in the tumor, and then injecting them back into the patient to specifically fight that cancer. Finally, this patient is now looking at enrolling on another clinical trial at her home oncology clinic to target yet another biomarker that was identified in her tumor. This patient is still living with pancreatic cancer over 2 years after being diagnosed, and even recently finished a hike in the White Mountains. For the Medicaid population in particular, having health coverage that lags behind scientific progress and does not allow the same access to treatments we know to improve patient outcomes can exacerbate underlying health equity issues currently being experienced by low-income, rural, and other underserved populations. We're grateful to the Human Services Committee for its foresight in raising this concept in SB 307. You have an important opportunity to limit the barriers to biomarker testing and personalized medicine, improving the lives of Connecticut citizens regardless of gender, race, ethnicity, or location. Thank you.
Thank you, Lindsay. Good to see you again.
Good to see you.
Representative Hughes.
Thank you so much. Thank you, Lindsay. Do you happen to know what the cost is per biomarker test? Just curious.
Yeah, it's quite a range. So biomarker is a very large umbrella term. It can be anything from a simple blood test that's measuring things like a PSA level, which is relatively a low cost, to NGS tumor profiling, which it costs more, but it's certainly coming down given that technology is improving. But I'm not a physician, so I don't know the cost to ordering, unfortunately.
No, I appreciate that. I'm just curious because it sounds like your experience with the technology and the research is advancing. It seems like that cost is coming down, but I don't know. That's just anecdotal.
Yeah, it certainly is coming down. I think, when this technology for NGS, like next generation sequencing of genomes for anything first was discovered, it was out of reach for the average person, and now it's certainly within reach. So I know it has come down, but to the exact amount, I don't have any.
That's okay. That's helpful. Thank you, Madam Chair.
Thank you, Representative Hughes. Thank you, Lindsay, for your work and for being here tonight.
Thank you.
Next, we'll hear from Tracy Wodach, followed by Marcy Russo.
Good evening, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Tracy Wodach, President and CEO of the Connecticut Association for Healthcare at Home. I'm also an RN with 40 years experience. The Connecticut Association for Healthcare at Home is the united voice for our licensed home health and hospice agencies, as well as several non-medical homemaker companion agencies. Together, our members provide services that foster cost-effective home care for Connecticut's Medicaid population in the setting they prefer most, their own homes. I'm here tonight to testify in support of HB 5459, an act increasing rates of Medicaid reimbursement for certain providers. First, I'd like to thank Senator Lesser for his comments today and often, as he recognizes the acute needs of our Medicaid providers, along with the tremendous underfunding and lagging way behind other states. We appreciate your understanding and acknowledgement of our critical situation and challenges causing workforce shortages and access to care issues. With that said, let me begin. Aside from designating ARPA funding, home health and non-medical home care, like so many others, have experienced 16 years of flat funding combined with the added inflationary impact. Our agencies have limited ability to continue providing care into the future for the Medicaid population in the absence of correcting this chronic underfunding. Further exacerbating these challenges, our agencies have no ability to invest in any future unfunded mandates imposed, no matter how well-intentioned, including necessary safety measures that our staff deserve. I know there are other bills being raised for funding for that, so we appreciate that. We recognize that this bill is the result of a two-part study on Medicaid rates that this legislature directed to be undertaken, and we expect that our sector will be subject to that study later this year. However, our providers are not able to wait another 2 years for rate relief. This chronic underfunding for almost 2 decades has created critical workforce shortages in our sector, which is further exacerbated by the recent self-directed PCA contract agreement that gives wage increases to the self-directed that far outstrip our ability to compete for this workforce. All of this ultimately is resulting in reducing access to care in the home. We are asking the committee to restore Medicaid admin rates to the 2016 level, implement consistent annual provider Medicaid home health, MedAdmin complex care, and non-medical home care rate increases indexed to the federal CPI. We also have continued to ask for a Medicaid home health social work rate. The underfunding of much needed cost-effective Medicaid home care services must stop, or there will be no one to care for the tens of thousands of people who want to receive care in their homes. We urge you to invest in this much needed, cost-effective, and more desirable level of care this year, because we don't need to wait for a study to tell us what we already know. This system cannot be sustained without immediate rate increases that keep up with inflation year over year. Thank you very much for your support.
Thank you, Tracy, for your ongoing advocacy and for being here this evening.
Thank you.
Next, we'll go to Dr. Marcy Russo, followed by Paul Pescatello.
Good evening, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Marcy Russo. I'm a resident of Middlebury, Connecticut, and I work both in Watertown and Bethlehem, Connecticut. I'm here today as the chair of the Legislative Committee for the Connecticut Psychological Association. Our organization represents the licensed psychologists in Connecticut and the patients that we serve. We thank your committee for a long day and listening to everybody, and thank you as well for taking my remarks. I'm here in strong support of House Bill 5459, which is an act increasing the rates of Medicaid reimbursement. And as you may know, psychologists who are licensed in Connecticut are continuously turning away from joining the covered provider network for Medicare, primarily due to the high regulatory demands and the low overall reimbursement rates. For a single 60-minute individual therapy session that a psychologist would provide to a Connecticut resident, that psychologist would be reimbursed only about $119 from Medicaid, compared to almost twice that amount from the reimbursement rates of private commercial insurance companies. This low Medicaid reimbursement rate can lead to a disproportionate amount of behavioral health providers to close their services to Medicaid patients across the state. This can unfortunately contribute to the increased difficulties with access to an outpatient provider that many citizens across Connecticut unfortunately experience. Behavioral health providers are faced with high business costs that also include high licensure costs, increased malpractice insurance rates, increased costs in rents and utility, just to really name a few. Many behavioral health providers would actually like to provide services to individuals covered under Medicaid, but the reimbursement must be a substantial option for our private providers to survive. Currently, many Medicaid patients are forced to receive services from our overburdened local nonprofit organizations that also might be eligible for state and/or federal grants to supplement their overall funding. Increasing the Medicaid rate across the board for behavioral health providers can result in increased provider network for Medicaid and outpatient treatment options for patients seeking care. Finally, this proposed increase within House Bill 5459 would actually restore a past Medicaid reimbursement rate to psychologists and would be a welcomed return to a once agreed upon rate. It is for these important reasons that I do ask for your support for House Bill 5459. I truly appreciate your listening, and please reach out with any questions that you might have. Thank you very much.
Thank you, Dr. Russo, for your testimony and for being here.
Thank you.
Next is Paul Pescatello, followed by Marlene Bodner.
So good evening. I'm Paul Pescatello. I'm Senior Counsel at the CBIA, and I'm Executive Director of its Bioscience Growth Council. I'm also Chair of We Work for Health Connecticut. Again, thank you so much for this opportunity to speak before you. Thank you all for staying so late. You have my prepared remarks, so I'm going to go a little bit off script tonight. I'm here today to speak on two bills. Senate Bill 307, the Biomarker bill, which I'm speaking in favor of, and SB 8, the Drug Affordability bill, which I'm speaking in opposition on. SB 307, the Biomarker bill, it just makes common sense. It's good for patients, and it's good for our Medicaid patients especially. They shouldn't be excluded from this very good thing, the biomarker technology. 307 is also good for our healthcare system. It's about targeted therapy. It's about cutting down on unnecessary tests. It saves money for the system ultimately. Now, SB 8.
Yeah, oh yeah. Wait, I have.
I'd like to tell you why Canadian importation won't work and how why it won't work is connected to how to really, truly, authentically bring down drug prices in the United States. The Canadians won't allow export of drugs because there's barely enough supply of drugs for Canadians. The supply is so tight because Canada only pays biopharma companies for the cost of manufacturing a drug, plus a small profit on the manufacturing cost. But the huge bulk of the cost of medicine is in the research and development, in the R&D, in figuring out the recipe. Once the recipe is figured out, the cost of mixing the ingredients, so to speak, is relatively little. You've heard me say many times, it's absolutely true. It takes $2.7 billion to bring a medicine from concept to FDA approval. The great bulk of that $2.7 billion is pre-manufacturing cost, clinical trials, R&D. The way to reduce costs isn't the price controls that are in SB 8. It's the measures in SB 8, the Drug Affordability Board, the price controls, they will be counterproductive. The real way to bring prices down, if that's the authentic focus of this committee, is to have other developed countries, the UK, Germany, Japan, Singapore, Australia, all the developed privileged countries, pay more of their fair share for R&D so that we can pay less. Unfortunately, that battle is an international relations battle. It's a federal issue that cannot be solved at the state level. So with that, I'm happy to take any questions you might have.
Thank you, Paul. Thank you for being here all day. Senator Lesser.
Thank you, Paul. Thank you, Madam Chair, and thank you, Paul, for your testimony. Just with regard to that question, as I read SB 8, it seems there are different types of drugs. They're the new drugs that are on the market that have patent protections, that are clearly a place where innovation is taking place. And I think everybody here would agree that we want to make sure that companies can recoup their investments and turn a profit and do what they will with that, or their shareholders, whatever they want to do. But then there are also products that have been on the market for many decades and through a variety of reasons, some of which are regulatory. Those drugs that have been on the market sometimes also increase in price over time, and rather than decrease as you would expect. And so do you see those as being differently situated? It sounds like in your testimony, you're sort of comparing, you're conflating the two.
Well, so in my formal remarks that you have, I address that to some degree. I would just say that another issue we have with SB 8 is that it's so focused on one industry, the biopharma industry, and it doesn't ignore, but it doesn't pay the full deference it should to the other players in the system. So drugs are truly about 15% of our healthcare spend. 85% is something else. It's hospitals, doctors' visits, home health care. And so to focus on just the biopharmaceutical industry is, kind of not focusing on the full part of the equation. As to generics, remember that most drug projects fail. So only about 1 in 1,000 new ideas will pan out. It's very good research, but they will not pan out. So the drugs that are successful have to pay for all the drugs that don't work out, all the research that's privately funded that doesn't work out. So that's partly reflected in the price of generic drugs. I would also say, just as I'm sure you've heard all day long, the pharmacy benefit managers, the middlemen in the system, insurance plan design has a lot to do with the price of those generics.
I thank you for that. I don't mean to belabor it, but I didn't hear an answer to my question. And so there certainly are innovators in biotech, bioscience who are doing important research and development, taking wrong risks, bringing products to market. And then if you remember, there was that Martin Shkreli fellow who came in, purchased a drug, jacked up the price, did absolutely no innovation, but was simply, I think the term in economics is rent seeking. You seem to not be disaggregating.
He was one bad actor. I mean, there are thousands of drugs. That was one drug, and actually, in that case, arguably that was the fault of the FDA, in the sense that the time has come down, but it takes so long to get approved. It took so long, and it still takes a long time to get approval from the FDA for all sorts of very valid safety concerns to approve a new manufacturing plant to make a generic drug. And so in that case, Shirelli, he had a monopoly, and other actors couldn't come in. They couldn't get approval, and he knew that, to produce a generic version of his drug, another generic version, a competitor version.
But just to be clear, it's your position and CBIA's position that there is absolutely nothing that this legislature, the state of Connecticut, can do to bring down the price of generic drugs, because we are concerned not about generic drugs, but about fostering innovation for new drugs that are not generics, that are, patent.
I mean, I would look to insurance plan design and the middlemen in the equation.
So you support so you're saying that you do support regulations of pharmacy benefit managers? Is that what you're saying?
I'm saying that you definitely should look at that at that part of the equation, and how much of the cost of a drug is being siphoned off to the middlemen in the drug supply chain.
I totally agree with you. I think we should regulate pharmacy benefit managers. I did not realize that was the position that CBIA has advocated. I certainly haven't heard that.
It's a
insurance
Bioscience
committee,
Growth
right?
Council, which is a separate committee of the CBIA.
Thank you very much.
Thank you.
Thank you, Senator, and thank you, Paul, for being here. Next, we will hear from Marlene Bodner, followed by Diane Manning.
Good evening, Madam Chair, members of the Human Services Committee. Thank you for the opportunity to testify in support of HB 5374 concerning annual inflationary rate adjustments for nonprofit human service providers. I am Marlene Bodner, and I'm here today as an employee for a nonprofit, the Kennedy Collective, as well as a parent and legal guardian of an adult with intellectual disabilities who receives services through 2 other nonprofit service providers in the state of Connecticut. You heard from my colleague Valerie Breyer earlier, who provided detailed facts and figures related to the Kennedy Collective and how the lack of necessary funding is impacting the Kennedy Collective's ability to bring people back. I have seen and felt the impact the lack of funding increases aligned to inflation has had across multiple agencies. Nonprofits such as the Kennedy Collective offer housing, day programs, in-home supports, employment opportunities, and many other services for adults with disabilities. There are utility costs, electricity, heat, water, sewer, septic, maintenance costs associated with all these areas. Vehicles are needed to transport individuals to work, to day programs, to volunteer sites, to internships, and other community locations. The increased cost of vehicles, gas, maintenance of vehicles, insurance for vehicles far exceeds the funding from the state of Connecticut. And has been mentioned today, not only is it difficult to find employees who will work at the current non-competitive wages, but there are additional costs such as health insurance. The cost of medical insurance, as we all know, has increased exponentially, and these are costs that the nonprofits and their employees are shouldering. All of these additional costs impact the ability for nonprofits to provide services. The impacts are waiting lists, less opportunities to be in the commuting, aging transportation fleets, and staff vacancies and higher turnover. This is having a ripple effect in many cases. Caregivers often have to stay home and are unable to work while their loved ones remain on wait lists to receive services. This means that household has less income, which means they have less to spend in our state. Currently, the state is not providing the funding increases necessary to maintain services while nonprofits try and shore up the crumbling financial situations that they are facing. So I asked you today to provide annual inflationary rate adjustments for nonprofit human services providers who contract with the state. And I do want to thank you today for all your work and for providing opportunity to testify today, and say that this has been a wonderfully informative day listening to all the speakers and your excellent questions. So thank you.
Thank you so much for your testimony. And yes, it has been wonderfully informative. Are there any comments or questions from members of the committee? Seeing none, thank you for being here tonight. Next, we have Diane Manning, followed by Jeffrey Gagan. No Diane? Okay. Is Jeffrey Gigan there, please? No. Is Sabrina Wood there? Great.
Hi,
Good evening.
I'm Sabrina Wood, and I'm a member in Reliance Health. I'm here today to advocate for, hold on, sorry. Just give me a second.
Take your time.
Sorry. Yeah, I'm here to speak on Bill 5374. We definitely need more funding for residential programs and mental health, behavioral health in general. A little background on me is I'm 30 years old and I've been in the mental health system since I was 17. And time again, like I'd be like on waiting lists and whatnot for various programs, and like the availability is really low for your average person struggling with mental health. I came to Reliance Health in February 2023. I had spent over 4 years inpatient because there was nowhere else to send me, at CVH for 2 years, then Greater Bridgeport Mental Health Center for 2 years. And at first, I was worried that I would not succeed living out in the community. I was very lucky that we found Reliance Health, because most of that 4 years inpatient was spent waiting for somewhere to go, like anywhere. And however, the services that I have received, especially in Reliance Health, have been extremely helpful to me. Before I came to Reliance Health, I never had any success in any program that I was part of. I always dropped out or failed to meet my goals for treatment. Here at Reliance Health, I've been given the opportunity and chance to grow spiritually and psychologically, and the staff has always supported me. Even when I had a few relapses in my addiction, they refused to give up on me. They do everything from bringing us on recreational outings to helping us receive services for psychiatric support and psychotherapy. They teach us life skills, everything from cleaning to cooking to setting up our own appointments. They transport us to and from our recovery meetings and encourage us to participate in Alcoholics Anonymous and Narcotics Anonymous, as well as any other groups they think are beneficial for us. They encourage me to expand on my creativity and artwork, as well as encouraging me to exercise and spend time outdoors. A lot of the staff are amazing. There's this one staff, he just recently became a recovery support specialist, and he used to work, I think in some detox somewhere. And he used to be paid so much more, but now he moved to this job working at our residential program in Montville. And he took a serious reduction in, his income, because he wants to help us. He's doing what he loves, but he's not getting paid what he should. And that's the story for everyone. All the staff, they're all very great people. But I know at least 3 staff at my program who have to work our job, like the job at our house, plus another job just to make ends meet. And a lot of them have kids. A lot of them like have a lot going on. So yeah, with that, I fully support Bill 5374.
Thank you. And I have a question. Is this the first time you've testified in front of the Connecticut General Assembly?
Yes.
Well, you're a rock star. Thank you for being here tonight.
Thank you.
And you said in your testimony that you were lucky that you found Reliance. I think
Absolutely. It was like, that's why I was sitting in the psych ward for 4 years. And time and time again before that, I had shorter hospitalizations, and then they would just send me to an IOP or a PHP, and that never worked for me because I needed more care than that.
Well, I think that in addition to you being lucky to find them, I think they're lucky they found you.
Thank you.
You're a good advocate. Yes, Senator Seminar.
Thank you, Mr. Chair, and thank you so much for coming to testify and being so patient and sitting, because you've literally sat across from me for the last, I don't know, 10 hours now.
Yeah.
So
I'm very nervous, but it's all right.
As Senator Lesser said, you are a rock star. You did a terrific job. Take a deep breath. It's over. And hopefully next time you come, because I hope there is a next time that you come and advocate, you'll feel a little bit more comfortable now that you've gone through the experience. But please know that your voice is heard, and we very much appreciate hearing your story.
Thank you.
And I'm so very sorry that you were forced to stay in an inpatient setting.
Especially, I know this is slightly off topic, but Connecticut Valley Hospital, they're very abusive to all their clients. But anyway, that's another topic for another day.
That is another topic for another day, but still very valuable for us to hear that feedback. So I appreciate you telling me that. But we never want people to be forced into a more serious setting or a more intensive setting than anything necessary. So I'm sorry you were forced to stay there and you are unhappy there.
Mhm.
And I'm so very happy to hear that you're settled now and you're getting the supports that you need and you're out in the community. And clearly you are a success story. So thank you so much.
Thank you. Have a nice night. Yep. Sorry.
Representative Hughes.
Oh, thank you so much for your testimony. I'm just really captured by your lived experience. How long have you been with Reliance Health?
Since February 14th of last year, Valentine's Day actually, and that was the best Valentine's Day present I've ever gotten.
And if you weren't in this right fit of the right care at the right time, where do you think you would be living now?
Probably on the streets using, relapsing constantly. They tried to send me to another program, Martin House, in Norwich, and that was a lot less supervision and a lot more freedom. And I like crashed and burned. And luckily, I was very fortunate that they gave me a second chance to come back to Montville from Martin House. They didn't have to do that, but they did, and I'm very thankful that they did, because otherwise I'd probably be back in CVH, and that would be horrifying.
Thank you, Mr. Chair, for indulging.
Thank you, Representative. Thank you so much, Sabrina, for being
Right.
here. Thank you.
Good night.
Good night. Jane Tendler, followed by Mark Thompson. Jane, you'd need to unmute. It's at the bottom of the screen near where you put on your video. There you go.
Yeah, thank you. Thank you. You can hear me now?
Yes, we can go right
Oh,
ahead.
Thank you so much. Good evening, Madam Chair and members of the committee. My name is Jane Tendler, and I am president on the board of directors for the Children's Center of Hamden. Thank you for the opportunity to testify in support of HB 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers, and HB 5459, an act increasing Medicaid rates for certain providers. These important bills would immensely help community providers stabilize their budgets and provide services to the state's most valuable population. Since its establishment in 1833, the Children's Center has been steadfast in its commitment to empowering youth from diverse backgrounds to realize their fullest potential. With over 190 years of dedicated service to the greater New Haven community, we have honed our approach to providing exceptional treatment, education, and care. Our aim is to ensure equitable access to these essential services, fostering an environment that is both safe and nurturing for children and adolescents. I've had the pleasure, and quite a pleasure, serving on the board of directors at the Children's Center of Hamden since 2018. And for the past year and a half, I have served as its president. Prior to serving as a board member, a board member, I worked in the human services field for a private nonprofit foundation as its HR director. From my background, I am aware of the requirements needed in the selection of hiring behavioral health staff. The center continues to have a serious problem in hiring and maintaining its staff due to the center's inability to compensate adequately. I have to say, a tremendous staff, a staff that cares, that are motivated, that want to do the most for our children in our community. And we need more staff to help them. They just can't do it on their own. And we need to maintain our staff. It's very important. And we can only but do this by paying them adequately.
Jennifer, your time has expired. Can you please summarize?
I sure can. Well, I just want to thank you and hope that, we can work together to ensure that our young people have the quality of care that they need and deserve. Thank you so much. My pleasure being here. Thank you.
Thank you so much. It's great to hear from you. Thank you for
Thank
being here
you.
tonight. Is Mark Thompson with us? Okay, great. Mark Thompson, followed by Dr. Robert Russo. Mark, you just need to unmute and then you can go right ahead.
I'm so sorry. Thank you.
You're welcome.
Honorable Co-Chair Senator Matthew Lesser, Co-Chair Representative Jillian Gilchrist, and members of the Human Services Committee. My name is Mark Thompson, and I'm the Executive Director of the Fairfield County Medical Association. FCMA represents over 1,000 physicians in all medical specialties. There is a direct correlation between the ability of Medicaid patients' access to timely medical services and the financial ability of physicians to provide those services. In 2007, Connecticut set the Medicaid reimbursement rates for most physicians at 57.5% of the Medicare rate at that time, other than for primary care and OBGYN physicians. The rates have not been broadly adjusted in over 17 years. The Medicaid rates were low in 2007, but they are untenable by today's cost of running a medical practice. We are particularly supportive of Section 1B2 of adjusting the physician specialist service rates to a fixed percentage of the Medicare rates for the same services. But the percentage needs to be sufficient enough to help strengthen the network of physicians who are able to participate in the Medicaid program. We are also supportive of Section 8A to amend the Medicaid state plan to adequately reimburse for electronic consultations between a primary care physician and a medical specialist through an internet-based secure messaging platform. Physicians want to care for all patients regardless of their insurance coverage. But the state Medicaid reimbursement rates are so low that many physicians can no longer afford to participate in the program. The legislature should seriously consider increasing the investment in the physician reimbursement rates to improve access to Medicaid services. An additional benefit to improving the patient reimbursement rates is that it will help with the recruitment and retention of physicians. Currently, Connecticut ranks 47 out of 52 states and territories in terms of physician retention. Thank you for your time, and I'll be pleased to answer any questions.
Thank you so much, Mark, for being here and for your testimony. Have a
Thank
great
you.
Dr. Robert Russo, followed by Zach Hardy.
Can you hear me?
Yes, we can. Go right ahead.
Yes. Good evening. Started with good morning. We're at good evening. Senator Lesser, Representative Gilchrist. My name is Dr. Bob Russo. Excuse me. I'm the Chief Medical Officer of the Connecticut State Medical Society. We represent 4,000 physicians and physicians in training in Connecticut. I, like Mark before me, I'm here to support House Bill 5459. I've actually learned a lot today while we were going through other testimony. One of the things that is really having an effect on the physician population in Connecticut is the inability now to have enough physicians in these Medicaid networks that allow us to give proper care. We've kind of pushed the Medicaid population towards primary care because there's very little access in the present network for specialists. It's been pointed out that the fee schedules are very low. They're back on 2007, but it's become even more than that. Over the years, as we've tried to build these networks to be able to provide services in the neighborhoods that they need to be in Connecticut, we found that the pool of physicians is shrinking. I've sat on some of your committees and study groups about the supply of physicians. What's happening is the pool is driving up. We have trouble recruiting in Connecticut physicians. We have trouble recruiting specialists since in private practice, the finances are driven by the physician. When the physician is cost shifting from Medicaid to other services, other commercial products, the practice doesn't make enough money to keep the staff. Like you heard from a lot of the mental health people and other groups earlier today, that shift, as it starves the ability of the practice to pay decent wages. You can imagine, and I can go back to 2007, which is the model year that we use, my staff costs have doubled, my rents have doubled, my malpractice insurance has doubled. There's just no mechanism that allows us to do a greater proportion of Medicaid than we've been doing in the past. So with the shrinking physician population, with the inability to recruit younger physicians, we're stuck in this sort of wheel that doesn't allow us to give the proper treatment. There's tremendous pressure against the federal health clinics, tremendous pressure against the hospital clinics to provide services and then get the specialists to come into the system. We need to do something about that. We need to do it now. I'm concerned that the study we're under is a two-part study. I know the physician part was done, but the truth is 2 or 3 years ago, the governor was talking about doing something towards Medicaid rates. We're way beyond talking and studying it. We actually need some relief, and we need it rather quickly. I can't say enough about all the people that spoke before me and their dedication to medicine and healthcare, but we need the state now. We need the funding, and we need the ability to be able to get these services out to the people in the proper area. We can't keep doing workarounds. We can't have out-of-state networks where people won't travel. Medicaid patients, as a rule, don't like to leave their own.
Your time has expired. Can you please summarize?
Sure. I think the point's been made. We need help. We need help now, and we can't wait. Thank you for your time and effort, and I appreciate the committee's endurance. Thank you.
Thank you. Thank you for being here tonight. Next, we'll hear from Zach Hardy, followed by William Darney.
Thank you. Good evening, Senator Lesser and Representative Gilchrist and members of the committee. My name is Zach Hardy, and I am a state government relations officer for the Michael J. Fox Foundation for Parkinson's Research. Thank you for the opportunity to testify before this committee on SB 307, which would require state Medicaid programs to provide coverage for biomarker testing. Founded in 2000, the Michael J. Fox Foundation has been singularly dedicated to finding a cure for Parkinson's disease through an aggressively funded research agenda and to ensuring the development of improved therapies for those living with Parkinson's today. To date, the foundation has funded nearly $2 billion in research programs worldwide. Biomarker testing is a crucial step for accessing precision medicine, including targeted therapies that can lead to improved survivorship and better quality of life for patients. While most current applications of biomarker testing are in oncology and autoimmune diseases, there is research underway to benefit patients in other areas, including neurological diseases such as Parkinson's. This past April, for example, the foundation announced that through the ongoing work of our landmark clinical study, Parkinson's Progressive Markers Initiative, also known as PPMI, a new biomarker had been identified for Parkinson's. This breakthrough was published in the scientific journal The Lancet Neurology and opens a new chapter for research, with the promise of a future where every person living with Parkinson's can expect improved care and treatments, and newly diagnosed individuals may never advance to full-blown symptoms. The foundation recognizes the importance of biomarker testing and how it will soon broadly benefit our community. There are estimated to be more than 1 million Americans currently living with Parkinson's disease, with about 90,000 more diagnosed each year. According to the Centers for Disease Control and Prevention, Parkinson's disease is the second most common and the fastest growing neurological disorder worldwide. In Connecticut, there are estimated to be more than 12,000 individuals currently living with Parkinson's, with direct and indirect costs to care for these individuals estimated to be $617 million annually. We believe these statistics on prevalence and economic burden to be undercounts. Improving access to biomarker testing and thereby access to targeted therapies is a strategy to reduce health disparities and improve outcomes for patients. This legislation would ensure that insurance coverage in state Medicaid programs keeps pace with innovations in testing, allowing patients to access this critically important healthcare tool when it is available and medically appropriate. The foundation strongly supports expanded access to biomarker testing as it leads to better treatments and therapies for patients. As a quick aside, I want to thank the committee for their dedication throughout today's proceedings. And on behalf of the foundation and the community that we support, we urge members to support SB 307. Thank you, and I'm happy to answer any questions.
Thank you, Zach, for being here. Senator Lesser?
Thank you very much. Really appreciated your testimony. My understanding is that the language before us limits, in some ways, the use of biomarkers for initial diagnosis, and yet that seems to be maybe I misunderstood. Is the major use in that the Parkinson's Foundation sees in I'm sorry, the Michael J. Fox Foundation, I apologize, for initial diagnosis, or is it for progression monitoring? Where do you see the real value to patients?
So thank you for the question, Senator. It could be used in both instances, whether that be to assist with the diagnosis of Parkinson's disease or to track the progression of the disease and see what treatments would be best appropriate for that individual. Unfortunately, where we are today, Parkinson's is a very individualized experience for every patient. There isn't one drug, there isn't one therapy, and symptoms can manifest differently in each person who is diagnosed. So biomarker testing and the research that is underway, the progress that has been made thus far specifically for Parkinson's continues to move, continues to lead to better outcomes. So we do see that biomarker as a tool can be used at several different points in a Parkinson's patient's diagnosis, and even later after their initial diagnosis. Biomarker testing still is critically important to our patients and our community.
Thank you.
Thank you, Senator. Thank you, Zach, for being here tonight.
Thank you all.
Next is William Darney. Is William Darney with us?
Yes, good afternoon.
Hello, go right ahead.
Good afternoon, members of the Human Services Committee. My name is William Darney, and I have been with Horizons for over 15 years. We are one of the private nonprofit agencies providing essential services to our citizens with developmental disabilities located in South Windham. We are beginning our 45th year and serve over 1,200 people with developmental disabilities statewide. I am here to speak in favor of HB 5374. I echo what my other colleagues have stated earlier, but I'd like to offer a different perspective. I am the Director of Technology, and my department only has 2 employees, with one of those being me, and we struggle to find and retain long-term employees. The Horizons IT department supports over 250 computers and mobile devices that enables our 250 staff to do the mandated work with our folks with developmental disabilities. We are responsible for everything from budgeting, designing, purchasing, installing, and maintaining hardware and software, large computer networks, cloud services, security systems like cameras and door access systems, Wi-Fi for over 500 people, and the cybersecurity that goes along with that. Having one other support person means the barrier of entry is naturally higher and requires more skills than your average help desk employee. But not being able to pay them enough leads potential long-term staff to view us as a stepping stone or a resume builder. I encourage the sharing of knowledge, and being able to accelerate someone's career path is rewarding, but it takes a significant amount of time to train IT staff and all the nuances that come with the territory, especially when staff rotation can happen on a yearly basis. It's even harder as the technology landscape can change in a moment's notice, leading to potential burnout quite quickly. Information technology doesn't fall into the if it ain't broke, don't fix it category. It's more akin to if it ain't broke, monitoring it 24/7 so nobody hacks it. A typical day for them could be troubleshooting why a computer doesn't connect to Wi-Fi, then figuring out why a printer is jamming, to helping a customer diagnose a not charging laptop while creating door access and key fobs, and email accounts for brand new staff, and then transitioning over to helping me teach a group of our staff how to use a new piece of software, in addition to helping me manage backups, valuable data, and following strict security practices. Or they can just stock shelves at Walmart. Indexing the salaries of private nonprofits will help stabilize our situation as a whole and allow us for potential future increases and creating more career opportunities. However, the current staffing crisis prevents us from expanding our services despite the daily growing demand for our support. The attrition rates are a direct correlation to wage stagnation. We need to index wages for the nonprofit sector. Again, I'm in support of HB 5374. I thank you for your time and the opportunity to testify.
Thank you, William. Thank you for your testimony and for being here tonight. Next, we'll hear from Anna Goddard, followed by Dr. Laura Dake. Yep, there she is.
Hi, can I start?
Yes, you may. Go right ahead.
Okay, thank you so much. Good evening, members of the Human Services Committee. Thank you for the opportunity to testify today or tonight in support of House Bill 5374, an act concerning annual inflationary rate adjustments for nonprofits. My name is Anna Goddard. I serve as the Managing Director of Medical Services for 22 school-based health centers and 2 outpatient medical clinics at Child and Family Agency in New London, Connecticut. I know you've heard from several of my colleagues here today. Our nonprofit organization employs approximately 260 staff working across New London County. We provide medical and mental health services for more than 10,000 children and families, including primary care delivery across 7 school districts in our school-based health centers in one of the state's service desert areas, Eastern Connecticut. Every year, we try to meet the needs of our community with less reimbursement and flat funding, resulting in a strain on our resources, challenges in recruiting staff, and a constant struggle to retain high-quality, mission-driven nonprofit employees to deliver this work, which I know and respect you've heard a lot of tonight. The pandemic altered pediatric care delivery across our state, resulting in significant disruption in care provision, clinical practices, immunization adherence, and different revenue streams. We became the essential workers in our community. We became recognized as the safety net for the community. And now nonprofits are providing the needed preventative care, vaccinations, and all of the other acute medical services for our students in our school-based health centers again, while also treating and triaging complex systematic trauma. And the nonprofits are again needing to find a way to care for our communities. An example I wanted to share in the last 18 months at our school-based health centers, 3,224 mental health screens for depression were conducted at primary care visits, with 47 youth identified in these mental health screens in primary care for past or active suicidal ideation. Our NPs not only provided these 47 students with the needed acute medical care and immunizations they needed to stay in school, but they also worked with their mental health partners, integrated the needs for these individuals to our urgent crisis center, to outpatient behavioral health services, and to in-home intensive therapy programs, just to name a few. Costs for medical equipment and supplies have increased by more than 3 times in the last 3 years. So have the regulations to deliver these services. Just for a quick example, more than $4,200 just for a unit to hold the immunizations. And these are just a small example of inflation and rise in costs that we need to absorb to provide care. This bill will help community nonprofits stabilize their budgets, retain their workforce, and provide services to the state's vulnerable and children and youth. Thank you so much for hearing me, and thank you for hearing everyone today. I appreciate the late hours.
Thank you so much, Anna, for being here and for your testimony.
Yes, thank you.
Is Dr. Laura Dake with us? How about Dr. John Satterfield? All right. Sheila Purushotham, followed by Brian Lynch.
Hello.
Hello, go right ahead.
Thank you. Good evening, Madam Chair and members of the committee. My name is Sheila Purushotham, and I'm the Vice President of Clinical Services at the Children's Center of Hamden. The organization has been servicing the state since the 1800s and has a long history of providing much-needed services. We continue that mission today through quality treatment and care. Generally, we employ 200 individuals. Since December, we have had 30 resignations. 50% of those left for higher paying jobs at the state or at private institutions. This makes it more challenging to service our current and future children. Please keep in mind that many of our children are being serviced through contracts from state agencies and rely on Medicaid reimbursement. The challenges we are facing are both hiring and retaining staff. Due to this, our wait lists have increased. Our long-term staff members are leaving due to the burnout of picking up extra workloads, and mandations are happening more frequently. Many times, a potential clinician has come for an interview only to hear what range we can pay and has declined due to being offered higher rates from private or group practices. Those are the entities that primarily does not serve the individuals that need the services in our community. To hire and retain, we need to be able to offer competitive pay. I met with one of our program's direct care workers yesterday. Direct care workers provide 24/7 coverage at our agency and comprise the majority of our staff. They are the boots on the ground with the children and families we serve. Sadly, over 50% of them have a second job just to make ends meet. One staff member has worked with us for over 30 years and shared she had to sell her home because she could no longer afford her mortgage, and due to this, she cannot retire anytime soon. With the cost of living as well as health insurance rates increasing, staff have reported that it's hard to buy the amount of groceries they need for their families. They are reaching max limits on credit cards, and many have reported needing to borrow from 401k accounts just to pay their basic bills. Another staff member reported struggling as she is sending her child to college, taking care of a sick parent, and dealing with raising rent costs. These are the same employees who show up every day to help this vulnerable population. They're passionate, prideful about their work, and genuinely have dedicated their lives to supporting the children of their community. They are our community heroes who deserve to be recognized, compensated, and heard. Though I spoke about the staff that work at our agency, please remember we are treating a population who is increasingly struggling with their mental health and traumatic experiences. Emergency rooms are inundated with children in crisis, referral lists have nearly doubled or tripled, and there are not enough community-based resources to help serve our children who are in immediate need. I have public school districts asking us to come help with additional crisis management. These are the same children who over the past few years experienced social isolation due to the pandemic, which has resulted in a decrease of their socio-emotional development and an increase of anxiety, depression, and unsafe behaviors. They need our continued help and support to maintain and sustain living in their communities. Please take our plea, as these children are our future. In addition to our children, the parents also need our support as they are feeling high levels of stress as they face the many obstacles of finding mental health services. I urge this committee to support HB 5374. Thank you for your service, time, and consideration.
Thank you so much, Sheila, for being here tonight and for your testimony.
Thank you.
Next is Brian Lynch, followed by Dr. Laureen Rubino.
Good evening, Senator Lesser, Representative Gilchrist, and the members of the committee. Thank you very much for giving me this opportunity to address you, and I salute your endurance tonight. I'm Dr. Brian Lynch. I'm an optometrist practicing in Brantford, Connecticut, and legislative chair for the Connecticut Association of Optometrists. I've been a Medicaid participating provider for the entire 42 years of my professional career. Optometrists are the primary eye care providers for the Medicaid population. They provide approximately 70% of all of the eye care administered to Medicaid enrollees. Patients enrolled in Medicaid have come to rely upon their local optometrists for both vision care as well as medical eye care. Doctors of optometry have always been their go-to for vision care, but they have also grown reliant upon optometrists to treat their glaucoma, eye infections, diagnose both ocular as well as systemic diseases as they affect the eyes. Physicians have become dependent optometrists to co-manage cataract surgery and identify complications with the patient's systemic diseases such as diabetes, hypertension, and complications from the medications that they're currently taking. Optometry's role as Medicaid's primary eye care provider has grown and will continue to grow. Expanded scope, new technologies, a shrinking number of ophthalmologists in practice, as well as ophthalmologists willing to participate in the Medicaid plan, will continue to push my specialty to the front lines in caring for Medicaid patients. For all of the reasons above, by definition, Medicare looks upon optometrists as physicians as well as specialists. It is my hope when you review reimbursements for physician specialty services in line 5, it will include optometry. Rate adjustments are essential to ensure access to eye care. It is my understanding that rates, as they affect my profession, have not been adjusted since '95. Yet the expenses associated with running a practice in Connecticut have risen sharply. My fears going forward, as we make more patients eligible for Medicaid and patients age requiring more care, the few of us who continue to participate in Medicare won't be able to meet their needs or afford to. So I support your efforts to bring Medicaid rates closer to Medicare's. Lastly, all commercial carriers and Medicare reimburse optometrists and ophthalmologists equally. As a matter of fact, it is illegal in Connecticut for them to do otherwise. Providers are reimbursed identically based upon procedure codes and not their degree. Medicaid, however, reimburses optometrists only 90% of what they reimburse ophthalmologists when using the same exact procedure codes and providing the same level of care. The same disparity existed between nursing midwives and OBGYNs until the legislature rectified
Brian, your time has expired. Can you please summarize?
It is my hope that in its final form, HB 5459 will remediate this disparity between optometry and ophthalmology, and again, view optometrists as physician specialists. Again, I thank you for the opportunity to address you and share our concerns.
Thank you so much, Brian. Thanks for being here tonight. Do have a hand raised. Representative Comey, go right ahead.
Hello, Dr. Lynch. How are you tonight?
Hi, Representative. Nice to see you again.
Nice to see you. Thank you for coming out. You brought up some excellent points, and you are, in fact, my go-to person. So thank you so much.
Thank you.
Thank you. Thank you, Dr. Lynch. Have a great
Thank
evening.
you again.
Dr. Laureen Rubino, followed by Denise Davio. Dr. Rubino, you just need to unmute.
Okay. Can you hear me now?
Yes, we can. Go right ahead.
Okay. Thank you very much for having me this evening. I commend your endurance to all of this and the long hours that you're putting in. I am a general surgeon in private practice, and despite the general surgery name, we are considered a specialist. With that, I'm endorsing the Medicaid review of our reimbursement because of the fact that we're having a very difficult time in our office maintaining not only just staff, which salaries range between $25 to $40 an hour, but seeing the numbers of Medicaid patients that come through our office. We do not discriminate in making appointments, whether patients have insurance or Medicaid or a traditional insurance plan. But I will tell you that the amount of time spent on the Medicaid patients is certainly more than what we usually see because they don't have access to health care. So we take a lot more time with those patients. And with that, and because of that, my office runs on a very slim schedule and salary. So I am not able to afford a physician assistant in my office, and I'm not nowhere near able to afford another physician in my office. So recruitment is pretty much out of the question because I do cater to Medicaid patients. Having said that, I know that I am a dinosaur in being in private practice, but I think that if we have any hope of recruiting physicians, we need to look at not only hospital-based physicians, but private practice physicians and support both entities. I will say that I did survey my staff and ask them what it was like to get pre-certifications through Medicaid. They said it was very easy, that the system was very well run, and that the people were actually very nice to deal with. The only problem that we were having was that when we have a patient that needs to be referred from my office to another specialist, like for Mohs surgery or some other type of specialist, we can't find physicians who will take these patients on. To be specific about this, if you consider the fact that if I take someone's gallbladder out who's on Medicaid, I get paid $300. If you consider what I get paid with traditional insurance, it's $1,500. There's a significant disparity there. So I think that if you could look at what our reimbursement is and bring it up to at least the Medicare benefits, we would all benefit from that, and so would the patients. Thank you.
Thank you so much, Dr. Rubino, for being here tonight and for your testimony.
You're welcome.
Next is Denise Daview, followed by Ian Mororu.
Good evening, Human Service Committee members. I am Denise Daview, the CEO of Sarah Inc. We deliver birth-to-3 services in 51 towns across 5 counties. And last year we served over 1,800 children and families. We also deliver day and employment service to adults with IDD. I want to thank you for the opportunity to testify in support of HB 5459, specifically Section 4, which states that effective July 1 of this year, the Medicaid billing rate for birth-to-3 services would be increased from $120 to $169 per hour. I am also thankful that this rate increase is included in the bill. It shows there is recognition that rates do need to be increased for birth-to-3 services, and that has not always been the case. In 2017, the payment structure for Connecticut birth-to-3 services was changed to a fee-for-service model. The service rates given at that time were, which we still have, were considered trial rates. It soon became apparent to birth-to-3 providers that the many indirect costs associated with high-quality birth-to-3 services, which our state is really well known for, were not paid for by the service rates. This issue has, of course, been brought up over the years many times, but we've been told we needed to wait. The funding isn't in the budget. We were told this even as other human service providers received funding increases in the last few years, but birth-to-3 wasn't included. And we are thankful for those that were, but again, birth-to-3 wasn't. Let's also not forget these past 7 years, we had a once-in-a-century pandemic, the highest inflation seen in decades, and the onset of a more challenging workforce environment. Where has this left the Connecticut birth-to-3 system? It is buckling under the pressure of an increase in demand for services, while we providers are unable to recruit and retain the staff due to our inability to offer competitive pay and benefits. As a result, our dedicated employees, of which you heard from several this evening, have been experiencing burnout trying to meet service delivery needs. And as hard as they work, the staffing vacancies are negatively impacting children and families. They can wait months for an autism assessment or have gaps in services when the clinician they need is not available. This means Connecticut's children are not consistently receiving the services needed at the most critical time in their lives when these supports have the most impact. Can you imagine being the child of a parent waiting for the services that you know you need at this precious time, knowing that you may be having not be able to realize your child's full potential? That potential is slipping away. I know I couldn't, because I am very thankful for the birth to 3 services I received from my now adult son. Ensuring the state's youngest citizens receive critically needed supports is not only a moral obligation, it's also fiscally responsible. It's been well proven that funding early childhood development reduces future special ed costs and helps children become healthier, more productive adults. As you have heard from earlier testimony, there was a recent rate study showing we providers are underfunded by 29%. No business can survive under those circumstances. And that is why one of the 19 birth to 3 providers had to leave and give up their contract. So I'm just now encouraging you, please make sure this year and not next, but we receive that rate increase we need for July 1. Thank you. I welcome any questions you may have.
Thank you so much, Denise, for being here all day with us and for your testimony. It's been very helpful to understand the impact it's having. Representative Hughes?
Just real quick, thanks, Denise. You said you did receive services for your son,
Yes.
who is now an adult. And what kind of services are we talking about in the birth to 3, just for?
In regards to my son?
Yes.
Yes, he received an evaluation because of his speech delay.
Okay.
Yeah, and it made all the difference for him and our family. And I couldn't imagine not making that. I couldn't imagine making that call and not receiving the services needed and receiving them in the continuity in which we did. And that's what's happening now to families, unfortunately.
Got it. And so you were able to get some early intervention services. And if families are waiting, like you're saying now, are we talking a year, 2 years, months? What are we talking?
It is a federal mandate that if you need a birth to 3 evaluation, you get it within 45 days. That is happening. But what the problem is, if you need an autism evaluation, those are taking much longer, 3 to 6 months or more, because we cannot find the clinicians. And there's the gap in the continuity of services. You may have the evaluation, but then you have to have those services you need to do, and we may not have the staff.
Right. Okay. That's helpful. Thank you.
Oh,
Thank you so much.
Thank you.
Thank you. Oh, one more person, Representative Comey.
Thank you, Denise. Actually, you did answer the question, which was the federal mandate about the services. That was my understanding. I just wanted to clarify. So you have to be evaluated within
45 days.
45 days.
Yes.
And then it's really just if a clinician is available, if a team is available, or if they do qualify?
Yes, and then the services are structured for that child based on their needs. And it's mainly working with the families, of course, to work with that child.
Right.
And we want to have continuity of services, seeing them on a continual basis. But if, say, for example, Northeastern Connecticut, which we have a very difficult time finding the clinicians we need, if you lose a speech therapist, it can take some time to rehire that person, that clinician that you need, and there may be a gap in the continuity of services. And I want to also say, when it was mentioned by another birth to 3 provider, when it comes to children on the spectrum, we are really lagging behind. The licensed clinical social workers we need for those evaluations, those ongoing services, we are not really able to hire them. We're all having difficulty. So those children in particular are waiting months for the service they need. And we all know this is the time when we can make the most difference for them.
Yes, it is. And how many positions do you have available?
We have now currently about a 24% vacancy rate, and we typically have, I would say, about 50 clinicians in the field and therapists.
Okay.
That's
Well,
a
thank
significant-
you.
That's a significant
And
rate.
Thanks for having your big team that you had pepper us throughout the day.
I am so proud of them. Yes, thank you so much. I'm so glad you noticed. Makes all the difference. Thank you so much.
Thank you so much. Ian Mararu, followed by Michael Taylor.
Hello, good evening. Senator Lesser, Representative Gilchrist, Ranking Member Seminar, Ranking Member Case, all the distinguished members of the Human Services Committee. My name is Dr. Yon Moraru, and I am a professor at the UConn School of Medicine and the director of UConn's largest research core facility that supports more than 300 million in extramural research grants from all campuses. I have been a faculty at UConn Health for 30 years, since 1994, and I'm currently the vice president of the UConn Health Faculty Union. What is this bill about? I want to thank you for the opportunity to testify in support of Senate Bill 367, which, as far as I know, there's only one other testimony from our CFO, Jeff Keegan, who unfortunately wasn't present, an act concerning a study to maximize Medicaid reimbursement for UConn Health Center. This bill, I believe, is essential so that legislature and the public can see in detail the disparity in Medicaid reimbursement burden to our state's only public hospital. I will not go over details which you can find in my written testimony and also in Jeff Keegan's testimony, but I would like to only highlight two elements. You probably heard our payer mix numbers: 25% Medicaid, 30% Medicare, 45% commercial insurance. But these don't tell the whole story because they are calculated based on collected revenue. And the reimbursement rates are twice as high on commercial versus Medicare and Medicaid. So if you translate dollars into services provided, it amounts to a staggering 70% Medicare and Medicaid component for UConn Health. Second, we are the only provider of specialty services at about 100% loss in the state. And again, this is detailed in the written testimony. But that's not the only reason why we have so many people coming to us. Why are they coming to us is because the quality and safety of care provided at UConn Health, which is the only hospital that's ranked in the top 10% in patient experience by health grades and straight A's on Leapfrog. So finally, to conclude, I would like to also mention the fact that the one other testimony that I have found that addressed this bill was the opening by Commissioner Barton Reeves, which had mentioned that perhaps this bill is not at the right time, given the fact that there is an ongoing study about UConn Health from a consultant, which is true, but that actually, I believe, makes it quite timely because the consultant report will come out at the end of this month and will give
Ryan, your time has expired. Can you
additional.
please summarize?
Yep, and it will give the additional information needed that this bill that asks for a commission to study UConn Health is quite the same. Thank you.
Thank you. Senator Lesser.
Thank you, Doctor. And I will say that I was a little offended that nobody testified on that bill, but it is very important in part because, as you note, UConn Health plays picks up such a huge percentage of the Medicaid cases that might otherwise go to other hospitals and primary care providers certainly in the greater Hartford region, but across Connecticut. So I think you make a good point. Are there particular things that you think we should be looking at with regard to the Medicaid program?
One of the issues that we think is a big outlier is the fact that our Medicare services have more than doubled over the past 6-7 years, and the component of the federal Medicaid reimbursement has been totally flat over these years. And I don't want to even bring up the dental services component, which we are like 80% of the entire state.
Yeah, it's just remarkable. When I talk to dentists, they say that if for many types of services, particularly surgery, that UConn Health is the only provider, period, for the Medicaid population. So.
And that's true for other specialty surgeries. If you have no insurance and you need, life-altering, not life-saving, everybody provide, many places provide life-saving procedures, but specialty surgery for neurosurgery, we will do it at 100% loss to the business side of the house.
Thank you.
Thank you, Senator. Thank you, Ian. Have a great evening.
Thank you.
Next, we'll hear from Michael Taylor, followed by Chris McNabo.
Good evening, Representative Gilchrist and Senator Lesser and other distinguished members of the Human Services Committee. Thank you so much for your dedication to the residents of Connecticut and for your endurance today. It's been a long day for you, so I appreciate that and appreciate your willingness to hear my testimony, which is in support of House Bill 5456, an act concerning federally qualified health centers. I did indeed submit written testimony, but want to focus in the brief time I have this evening to give you some context for my support of that bill. I am the CEO of the Cornell Scott Hill Health Center in New Haven, Connecticut. We are the state's oldest community health center, and now it's second largest, serving more than 55,000 Connecticut residents annually. And 34,000 of those 55 are Husky recipients. And quite frankly, I am concerned for our continued ability to care for those 34,000 and even our broader patient population, unless there's consideration given to reasonable Medicaid reimbursement rates. As you have heard from a number of my colleagues, Medicaid reimbursement rates were established for Connecticut's health centers back in 2002 and have minimally been increased minimally for the past 20 years. And we've now, certainly at the Cornell Scott Hill Health Center, become as efficient as we can and pull that rubber band as far as we can. And I'm very concerned on behalf of our patients that rubber band is going to pop. As it currently stands, my health center loses $54.22 for every Medicaid medical visit that we provide, for a total of over $6 million in losses annually, and an additional $90.23 for each dental visit that we provide to our Husky recipient, for an additional loss of $1 million. Collectively, we lose, for the provision of medical and dental services to Husky recipients today, in excess of $7 million a year. I don't know of any business that can be self-sustaining, losing that much money on 61% of its customers. So I implore members of the committee to hear me when I say I am very concerned for our patients and our ability to continue to service them at the level that we have before. And I'm very concerned over the future without some support on our ability to maintain the capacity to serve all of those patients. I implore you to do two things: to consider a rebasing of our rates based upon current reasonable costs, and secondly, as well, to rectify or fix the scope of change process. It is broken. It does not work. We have applied for a rate increase with DSS. That rate increase after 6 months was denied. I still have no remedy, and I care deeply for the 54,000 patients who have entrusted the Cornell Scott Hill Health Center with their health. Thank you for your consideration. Happy to answer any questions.
Thank you so much, Michael, for being here and for the work you do. Have a wonderful
Thank
evening.
you.
Is Chris Mac? Yes. All right. Go right ahead.
Here I am. Good evening, Senator Lesser, Representative Gilchrist, Senator Samarara, and members of the Human Services Committee. Thank you all for your attention today. I'm Chris McNabo, CEO and founder of Horizons, one of the private nonprofit agencies providing essential services to our citizens with developmental disabilities. We are beginning our 45th year and serve over 1,200 people with developmental disabilities statewide. I submitted my full testimony, and I've rewritten my testimony about 8 times today, so not to repeat anything, but you heard from my board members, parents, and staff. You heard from Simon, our chief of staff, how DDS custodians earn what our 20-year veteran staff earn who have med certification, PMT, dysphagia, behavior management training, and so much more. You heard about hospitals and doctors losing hundreds of millions of dollars because of the chronic underfunding and ancient Medicaid rates. We too are underfunded, so we cut services, tell parents their loved ones no longer have services, and we fundraise. I know about the fiscal guardrails, and I know the revenue the state is taking in and will continue to earn means Connecticut can safely spend is more than the revenue cap anticipated. Let's invest that now in indexed wages for all nonprofits. I'm not telling you anything you don't know, but it's the 260 staff at Horizons that are counting on me to keep this issue on the top of your priority list. By paying down the state pension and teacher retirement liability, we saved $700 million in interest payments, but we can't spend it due to the guardrails. May I suggest we invest that savings in catching us up to current day costs? Something Carrie said at the last testimony has really stuck with me. And that's when she asked her staff to come here and talk to you about the need for higher wages. One person declined, saying she was embarrassed to admit that the work she does forced her to say that she is poor. Our staff too are on food stamps, energy assistance, and other state programs. You vote on thousands of bills annually. Please vote to pass this indexing bill this year and get things going in the right direction. Thank you very much.
Thank you, Chris, and thank you for sharing your team with us today to educate us. Thank you.
Thank you.
Senator Seminara has a quick.
Oh, I don't have a question. I just want to say hello, and it's good to see you, and thank you for your patience to testify in front of us. It's certainly been a long day, and you've been there a very, very long time. So it's good to see you again. I can't say more that good things about Horizons and the work you do there, and your staff. So we hear you, and we'll continue to try to work at it. Thank you.
Thank you so much.
Thank you so much. Next, we'll hear from Todd Johnston, followed by followed by Sue Caplet.
Hello, my name is Todd Johnston, and I live in Portland, Connecticut. I'm a paraplegic, which happened in July of 1983 from a motorcycle accident. I'm here today as the Vice President of Advocacy for the United Spinal Association Connecticut chapter, advocating for those who use complex rehab technology, and I'm proud to work at the North Central Area Agency on Aging, where I counsel older adults and people with disabilities. Let me review my past power wheelchair repair and the issues I have with the process that made my repair time unacceptable. On August 23rd of 2023, an evaluation of an issue was that I needed a new retractable docking pin. On September 1st of 2023, the order request was sent to the vendor, who estimated delivery of the part in October of 2023. The actual delivery of the part was in November 17th, 2023. In December of 2023, a new motion technician came to my home and installed other parts, including a leg rest and a new joystick, but was unable to install the retractable docking pin. I was told I would have to have it done in the New Motion building in Rocky Hill, Connecticut. The earliest date for when the only New Motion van, which can accommodate picking up my chair, was February 8th, 2024. The business days from when New Motion received the part to the first available date for my power wheelchair to be picked up for repair was 59 days. Then on February 8th, I received a text, a New Motion technician will be at my house between 1 p.m. and 5 p.m. I called New Motion. I said, will he be able to pick up my chair, fix it, and deliver it within that time frame? I was told he will do it in my house. I said, a New Motion technician tried that a couple of months ago and couldn't do it. I said, the power wheelchair must be picked up and taken to Rocky Hill. Then a new date was set up where they picked up my chair, they fixed it, and they delivered it, and that was done on February 14th, 2024. The total business days from when New Motion had the retractable docking pin part to having it installed was 63 business days, or think of it as 13 and a half weeks, or almost 3.5 months. I support SB 308 with the amendments proposed by the Connecticut Wheelchair Reform Coalition as are attached to Jonathan Sigworth's testimony. Thank you so much for your time.
Thank you so much, Todd. Many of us are just sitting here like we can't even imagine. So thank you for being here and sharing your experience. Senator Seminara.
Thank you, Todd. I wish I can say that your story is a sole incident, but as you know, I sat on that task force and heard story after story. I do have one question for you. The part that you were, was your wheelchair, not that I'm condoning the 63 days to repair. I just wanted to know, were you unable to use your wheelchair for 63 days?
Well, I could use the chair, but the docking pin, the retractable docking pin, is what I use to lock in and be secure to drive my van. Now, I drive back and forth to work 4 days a week. So for a period of time, I was unable to lock into that docking pin or into the easy lock of my van. So it was very important to me. So you can imagine, in one way, the chair works. I can move it back and forth and move around the house. But the idea is to drive safe and secure when you're driving a motor vehicle.
That is for sure. And I'm sorry that you had to endure that. I'm sure that must have been a scary experience and not something you wanted to have to do. So thank you very much for your testimony, and we're going to work on that too. Thanks.
Thank you.
Thank you, Senator. Thank you, Todd, for being here.
Well,
have a good night. Next, we'll hear from Sue Caplet, followed by Jenna Tenor.
Hello, my name's Sue Caplet, and greeting to you legislators. Thank you for the opportunity to add my voice and my strong support to this legislative budget process in support of House Bill 5374, an act concerning annual inflationary rate adjustments for nonprofit human service providers. Thank you for taking the time to listen to all of these testimonies. I work at Reliance Health, a nonprofit agency that for 48 years has provided essential mental health and addiction recovery services to people in the greater Norwich area. My role at Reliance Health is property manager of our 18 buildings. So I add my voice. People have talked about increasing wages, about benefits going up, costs going up, insurance going up. My voice is to say that the price of upkeeping properties also goes up tremendously. We have small maintenance, which is fixing bathrooms, toilets, getting appliances, maintaining vehicles, and big items like fixing roofs and decks and replacing septic systems. And these costs just continue to rise. My message is short and simple. If nonprofits do not receive annual funding increases that are indexed to inflation and the increase in the cost of living, then in essence, our funding is being cut every year. And how can we run our agencies on funding that does not keep up with the cost of living? We had no increases for 14 years between 2007 and 2020. And in 2017, our budget was actually cut by 5%. We continue to be hit by crippling increases in our costs. All nonprofits do tremendous work in this state to care for Connecticut's most vulnerable people. Please show that you value what we do by passing House Bill 5374 for the annual inflationary rate adjustments for nonprofit human service providers. I conclude my message with this point. The state continues to contract with nonprofits, and that means the state is responsible to be sure that we are adequately funded so that we actually can do the work to help people. Thank you for your time.
Thank you, Sue, and I couldn't agree with you more. Thank you for being here and for your testimony.
Okay, thank you.
Next, we'll hear from Jenna Tenore, trying it two different ways, followed by Cindy Jackson.
Good evening, members of the Human Services Committee. I am Jenna Tenore, a Wethersfield resident and Director of Child and Family Services with Sarah Inc. Kid Steps. We're a birth to 3 early intervention program serving babies, toddlers, and their families and caregivers in 51 towns and cities in Connecticut. I'm here to speak in support of House Bill number 5459, specifically Section 4 that supports increasing rates for Medicaid reimbursement. As you know, birth to 3 services are provided in a child's home or community setting that is part of the child's everyday life. I want to share with you a story about one particular little boy. He could be your neighbor, child, or your friend's child. He went to his pediatrician for his 24-month well child visit with his dad. The doctor interviewed the parent about developmental milestones. The dad was reluctant, but shared that his son was only using 5 words. The doctor then explained about referring the child to birth to 3. Dad followed through, and 2 providers came out to the home to evaluate his son. The speech language pathologist and the developmental therapist arrived at the home. They took off their shoes by the front door, and they followed the parent into the living room. One provider sat on the couch with her laptop perched open, while the other provider sat on the floor and began to take out the materials from the test kit. While one provider interacted with the child, the other was asking Dad questions about his son's development. At first, the little guy didn't want to play with the new people in his home, but after 10 minutes, he appeared to gain confidence and he started to play with these new people. His dad thought that by the end of this evaluation visit that the assessors had seen an accurate picture of his son. The 2 providers efficiently compiled the scores, and they were able to immediately share with the dad that his son would qualify for birth to 3 services based on the scores. The providers engaged in conversation with the dad about next steps. They explained what an individualized family service plan was and how they would work with dad to develop this IFSP to help his son in the development of his skills within the realm of the family's everyday routines. The IFSP was developed and the little boy received those birth to 3 services. As he approached his 3rd birthday, he was speaking in short sentences, and he did not continue to require special education services through his public school district. We all understand that early intervention services are mandated under IDEA and will be provided. I just want to shed light on the incredible staffing challenge that birth to 3 programs are facing. The current rates were implemented in 2017, 7 years ago. A year ago, the OEC commissioned a comprehensive cost and rate study through Public Consulting Group LLC. The study indicated that as of last year, those birth to 3 rates were 29% below the actual cost of providing these services. An adjustment in rates to the level determined through the rate study would ensure that the birth to 3 programs could recruit and retain skilled staff and continue to provide quality services to the youngest children and their families in Connecticut. These children and families are connected to all of us. They are our children, our grandchildren, our neighbors, our relatives, and our friends. Thank you for your support of House Bill number 5459.
Thank you so much, Jenna. Thank you for being here and for your testimony. Next, we'll hear from Thank you. We'll hear from Cindy Jackson, followed by Dr. Miriam Hakeem Zargar.
Good evening, Senator Lesser, Representative Gilchrist, Senator Seminaro, and distinguished members of the Human Services Committee. Thank you for the opportunity to testify in strong support of House Bill 5459, enacting increasing rates of Medicaid reimbursement for certain providers. My name is Cindy Jackson, and I am a birth to three provider in 18 towns and chairperson of the Birth to Three Interagency Coordinating Council. I am commenting on Section 4 of the bill, which states that the Medicaid flat billing rate for professional services under Birth to Three program be increased from $120 to $169. As you are aware, through a rate study commissioned through legislation last session. So why do we need this rate in this session? Our infants and young children can't wait. Families have a very short amount of time in birth to three. I think it's about 10 to 12 months. And it is imperative that the providers are available and we have appropriate qualified staff to meet the child's needs no matter what town they reside in. While referrals continue to rise, the number of clinicians available in birth to three system continues to decline due to the lack of ability to offer comprehensive salaries and benefits. We are required to staff with licensed physical therapists, occupational therapists, clinical social workers, speech language pathologists, board certified behavior analysts, and special educators. These seasoned therapists are leaving for higher paying jobs in schools, private clinics, and hospital settings, while new therapists are not choosing to join birth to three, especially with newer concerns about safety and home visiting and increasing training requirements. Another reason is Easter Seals, a longstanding birth to three agency, closed their program due to financial constraints based on these antiquated billing rates. I'm concerned that the remaining 17 agencies will not be able to continue at these rates and more will drop out. The rate study showed that 44% of the birth to three programs operate as a deficit. In the fall of 2024, OEC will again issue an RFP for birth to three. Will quality programs submit proposals when they know the contracted rate is 39% below what it costs to do business? So why birth to three when I know you've heard, and I've listened all day to the needs of so many people across the state? Birth to three is really an effective and efficient investment of state dollars. We cast a wide net over many vulnerable families and children. 22% of our services support children with disabilities in childcare, so parents can work and childcare centers have the support to keep the child in the program. Most infants and toddlers in DCF who are suspected delayed to trauma, neglect, neonatal abstinence syndrome, which is born addicted, are referred to birth to three. We support foster parents as well as coaching biological parents during reunification. Sarah Egan stated in her testimony today that early intervention for children with behavioral and mental health needs is crucial. It's crucial. This intervention and family support begins in birth to three. We have a really increase in the number of concerns of social emotional, and that has really been many of our referrals lately. Service coordination helps families access resources. We provide
Jackson, your time has expired. Can you please summarize?
Sure. So we support families wherever they are in the community, and 55% of the children enrolled in birth to three do not transition to preschool special ed. This is another cost savings. So I appreciate you listening throughout the day and supporting birth to three. Thank you.
Great. Thank you. Thank you for being here so late and testifying. We appreciate it. Next, we'll hear from Dr. Miriam Hakeem Zargar, followed by Heather Latora.
Good evening, Madam Chair, Senator Lesser, and distinguished members of the Human Services Committee. My name is Miriam Hakeem Zargar, and thank you for this opportunity to testify. I'm a solo private practice orthopedic surgeon in Torrington, where I've been practicing for the past 14 years. I'm here today on behalf of the Connecticut State Medical Society, where I serve as the Vice President, to speak in support of House Bill 5459 and the urgent need to increase Medicaid payment rates for physicians. I know you've already heard from Dr. Russo, and you've seen our written testimony and all the amazing testimony that we've heard so far about the Medicaid rates. And I apologize to Senator Lesser for having to hear this story again, but I just want to share a patient story with you that I think really highlights the complex, multifactorial really societal issue that our citizens here in Connecticut who have Medicaid or on the Medicaid system are facing. So give you an example. Anne is a 26-year-old mother of two. She works 3 part-time jobs, none of which provide health insurance benefits. She has Medicaid, and one evening she slips and falls in her kitchen, hurts her ankle, it swells up, it's painful. She can't leave the kids alone or go to the ER and can't afford a babysitter so that she could go get care. So she's hoping it will get better by tomorrow morning. She barely sleeps. It's painful. In the morning, it's twice as swollen. She can't walk on it now. She calls in sick to her work. She gets her kids off to school and starts calling doctor's offices to get an appointment. But either they don't take her insurance or the next available appointment is 2 or more weeks out. So she heads over to the urgent care center where she was evaluated and diagnosed with an ankle sprain, splinted, and told to follow up with an orthopedic surgeon. She calls several offices in her area, but no one takes Medicaid and she can't get an appointment. So then she calls the number on the back of her Medicaid card, and they're very helpful and they're able to find her a doctor, but they're 40 miles away. But they can see her on the same day. So she's happy, but she doesn't have a reliable car and she can't afford the gas for that distance. So she calls the medical cab, and by the time they arrive and get her to her destination, she's 15 minutes late and the appointment's already been canceled. So they reschedule her for 2 days later, but she's now missing 3 days of work because of this simple ankle sprain. Because she's missing 3 days of work, she won't have enough money this month to put food or groceries on her table for her kids and herself. Anne's cab fare that's paid by the state Medicaid system ends up costing more than 4 times what her doctor receives for providing her the essential care that she needs. Current Connecticut state Medicaid reimbursement rates don't cover the cost of a time slot in my office. I'm not aware of any other state employee or contractor who's doing the state's work at a net loss. If the physicians in Anne's community were paid a fair market price, she would have been able to get timely appointment in her own community in the first place and would not only have not incurred the cost of an urgent care center or the cab, she would have also not incurred 3 days of lost wages and the financial woes that creates for someone in her situation. Anne's story is just one of many illustrating the urgent need for systemic reform. By investing in fair reimbursement rates and prioritizing community-based care, we can ensure that Connecticut citizens like Anne receive the timely access to care that they deserve. And thank you again for this time and this opportunity to bring up this story and at least share this information. And I'm happy to answer any questions.
Thank you, doctor. Thank you for being here tonight, and thank you for your testimony. Have a great evening.
Thank you.
And I believe this is our final testimony of the night. Heather Latora, thank you for being here all day.
Thank you. Thank you for being here. Thank you for being there with your index t-shirt. I was hoping all day that they would still be here for tonight. And yay to my colleagues. I'm really here and smiling because the security guards are like, you're last when you're on, we're on our way out. This is great. So, but they're like, you're smiling and you're last, and I'm smiling because it would be awesome to see this annual inflationary rate adjustment for nonprofit human services. My name's Heather Latora. I live in Rocky Hill, Connecticut, and I've been working at my organization, Marrakesh, for the past 38 years. We've been talking about indexing with inflation for nonprofits for over 38 years. Since we were talking about salaries, I started out at $4.25 an hour. And, but we were receiving COLAs on a regular basis every year. I knew that was going to happen. I went into Mansfield Training School and met people and helped them move out into the community, into their own places, have real lives. I helped the state empty out institutions and other regional centers throughout my career. I made a very important culture of our organization to take anyone with a need and not say, hey, we can't help you. We help everyone with our colleagues 24/7, 365 days a year. That's what we do. And we helped people and we didn't say no, and we took them on immediately. I am embarrassed to say I have a parent waiting for 18 months on a waiting list for a place to live for her daughter. I never, ever saw that before in my years here. I'm embarrassed to say that people are waiting to get into day programs so their parents could go back to work and they could get a job. That has never, ever happened for me before. I've never seen that in my career here. And we support people with intellectual disabilities and with physical disabilities, people with autism, people that are unhoused, people with chronic mental illness. So we work with DDS, DCF, DSS, everybody, DEMIS. So can you just picture what happens when you give this group one bit of money and this group another bit of money? And then I say, oh, you staff, you're going to get a 2% increase on your already really low salary. And you're going to get a 2.5% increase. And yours is going to start July 1. I didn't see your money yet. So it just causes a nightmare. I have 650 employees. So it just causes a nightmare to manage, where it used to be that we had COLAs on a regular basis, almost every year till 2007. And then that ended, and everyone. So, I have 650 employees that work with me, and they're awesome. And we really need 750. So you can imagine how important our Glassdoor reviews are when people are looking for a job and they go on the internet and they go, how's Marrakesh as an employer? And, we count on our employees to be happy, and we work really hard for that. And last week we got a review that said, I've been at Marrakesh, been there a long time. They don't pay me what I'm worth. And, that immediately hurts me. I don't want anyone to feel that way. But I decided that day, that's not my review. That's the state of Connecticut's review. The state of Connecticut's deciding, oh, we're not going to give this group of employees 115,000 Connecticut residents. We don't really care if they get an increase. It will happen haphazardly, maybe if we have money. Well, we have had money. And it still doesn't happen. And it's not in the budget right now. So this indexing will just be like such a wonderful gift to not, you see us in your hallways, we fill them up. We support 500,000 people with all my colleagues in the state of Connecticut. And it's not only the rate of pay that's the most important, but it's also, I have a picture of my building in my testimony. Please don't show anybody. But I just had to show you that with deferred maintenance, because I didn't have enough money. Our fleet of vehicles, half of them are in the shop most of the time. It's just really hard. And we have changed medical insurance almost every year. And our employees are used to it. Oh, we're going to go to Connecticut this year. Oh, well, this year United's buying business. Oh, yeah, this year. And we used to have more we're going to do self-insurance for a year. We'll do anything so we could get our staff insurance. But I am happy that we're talking about this. And I really hope that you guys will fight for this really hard on behalf of so many people in Connecticut. All night long, we've just been talking about people. That's why I'm in this field. That's why you're all sitting here all night. You care about people. I saw you listening to the testimony. I know it breaks your heart when people are waiting, when families don't have hope. I had birth to 3 too. They came immediately and took care of my son immediately. That was 21 years ago. I didn't wait a day for service when that's your baby. It's so important to not make people wait. They're people. And I remember talking about this with Mansfield Training School and the regional centers and taking people out and painting their room. What color do you have your own room? And that's what's so important to me. And I know it's important to you. So please support this bill.
Thank you so much. Hold on. Senator Lesser.
Thank you, Heather. It's clear that you're passionate about your organization, your clients, your employees. When you were telling the story about what we used to do, I didn't serve here in 2007, and I don't think any of us did. Did this used to be in effect, this indexing, until you said there was a COLA that was in effect? So will we be restoring it to the practice that we had prior to 2007?
I don't know where it was written or how it was done, but I know every year, I actually have a list in my office of all the COLAs we got since 2000. And every single year had a COLA, and some years it was 7%, some years it was 5%. And we would be up here and say, we need it. And it was regular. And then all of a sudden it stopped. So I don't know the legal jargon about it, but yes, we did. We had a practice of a COLA. We were respected. the people we support were respected and our staff were respected.
Great. Thank you.
Thank you.
Thank you. And thank you again for your passion in the work and for being here.
Thank you.
Well, that concludes our public hearing. Thank you to everyone for sharing such important information with us. And I don't even know if I'm going to ask. I think we are set. And then our next meeting, we have a public hearing on Thursday. Same time, different place. We'll be upstairs. All right. Thank you. Good night, everyone.
Good night. Thank you, Madam Chair.